And this morning we're going to spend some time talking about cardiopulmonary disease. We're going to start out with an hour on emergency cardiology with cardiology. So we've got 2 hours every single day. So we're going to really be able to source of confusion. But for the most part, a lot of this on a basis. So just like with the GI section, I've really tried to high risk. I put it in red font with time or waste your time going through ACLS, but just make sure you know the algorithm. Start out with chest pain. Again, no big years ago, and certainly 20-something years ago when I did the boards and oral boards, everybody gets admitted, right? Everybody who shows up with chest pain, they said, you got to admit them. Well, that's gone. There are some quite outstanding and validated decision rules now that are well accepted as standard of care, which allow you to discharge low-risk patients home. So you don't have to admit everybody, and the decision instruments that are most highly validated are the heart score, the EDAC score, the ADAPT score. The heart score has really become, I think, kind of the darling of emergency medicine. So how many people here use the heart score in your practice? So gosh, just the vast majority, if not everybody here. So make sure you review the heart score if you're not already using this on a regular basis. The heart score has been endorsed by ACEP and AHA, and it's in the ACLS guidelines. So know the heart score. And if somebody meets low-risk criteria with the heart score, in other words, if they have a heart score of 3 or less, you are totally justified and within the standard of care to send that patient home to get some further outpatient workup. You're not washing your hands of them, but they're okay to go home and continue their workup as an outpatient, all right? I don't think they're going to ask you about ADAPT or EDACs, but definitely know the heart score. And again, it is okay if they qualify as low risk based on heart score to go ahead and send them home. Now, on the other hand, the guidelines, or most of the literature would pretty much say that if somebody's heart score is 4 or more, they're going to be coming in, at least to OBS for a workup, if not just a flat-out admission. And the workup is going to include either a stress test or coronary CTA. And that's the other thing. Coronary CTA is considered pretty much equivalent to a stress test in terms of the workup. I can't imagine they're going to ask you what type of stress test you're going to get, but just if they have a heart score of 4 or more, they're coming in, they're going to get a stress test, or if that's not available, you're going to get the coronary CTA, all right? You're not sending home people with heart scores of 4, 5, 6, or more. All right, acute coronary syndrome, the underlying pathophys, I'm sure that we've all learned, is a ruptured plaque followed by platelet aggregation and then thrombus formation. Well, that accounts for the vast majority of cases of ACS, but there are other ways that people can develop ACS and MI and STEMI also. If you look at national databases of all patients with STEMI, or all patients with ST elevation that get sent to the cath lab, about 7 to 10% will end up having clean coronaries. And so not everybody with ST elevation has a true STEMI. You can, in fact, develop a myocardial infarction with no atherosclerotic plaques. And these are some reasons you can have an MI even though your coronaries are pretty clean. Trauma, connective tissue disease, and vasculitis, DIC, TTP, thoracic dissection, which we'll talk about later on. Coronary artery dissection can cause an MI. You can have emboli, infiltrative diseases down there at the bottom, or infectious diseases. So, not everybody has that ruptured plaque. So keep some of these things in mind as potential causes of MI as well. I'm sure you're going to get questions about the ECG. You'll get ECGs, but you'll also get questions about the ECGs. One of the classic questions is, what's the first thing that you see in somebody who's having a STEMI? And it's important to remember that in about 4 to 6%, the first EKG can be completely normal. Now, if you get serial EKGs, that number drops, but the first EKG can be completely normal. If you do see an abnormality, what's the first abnormality you're going to see? Well, it's the hyperacute T wave. If you look over here, this on the left, actually I'll get rid of that. On the left, you see a normal painless EKG, and then the middle strip represents pain has now developed, and you'll notice that those T waves have become broad-based and taller in morphology, and then on the right later on, then you develop the ST elevation, and you may flip your T waves. And so, again, the hyperacute T wave is oftentimes the very first thing you see on the 12-lead ECG. Other things that you're going to be on the lookout for indicative of an MI, you're going to look for ST elevation in 2 contiguous leads. That's a no-brainer. Up here on this slide, it says 1 millimeter in 2 contiguous leads. There's actually the international guidelines suggest that in V2 and V3, It can differ based on age and gender. I'm not going to talk about that. I don't think you necessarily need to know that. Just look for ST elevation in contiguous leads. You can have ST elevation in the posterior leads or posterior STEMI. We'll talk about that. And also, you're going to need to know how to diagnose MI in the presence of a left bundle using the Scarbosa criteria. We'll get to that in just a bit also. If there's ST elevation in some leads with ST depression in others, in other words, reciprocal ST depression, that is much more specific for a true STEMI. So if you don't see reciprocal depression, be a little suspicious that maybe it's not actually a true STEMI. All right, I'm thinking on the board exam, they'll probably give you, if they want you to pick up STEMI, they'll probably give you an EKG that has reciprocal depression. So be on the lookout for that. T-wave inversions, I highlight that because that's not intuitive, but if somebody has a STEMI, you want them to flip their T-waves in the next few hours. Studies have shown that if you flip your T-wave 4 hours, it's a good prognostic sign. In fact, when you give thrombolytics to somebody, you want them to flip their T-waves because that's a sign of reperfusion. And by the way, especially for the new grads, what you're going to discover is that at ABEM General Hospital, the cath lab is always broken. So you're going to have to get comfortable with the idea of giving lytics when somebody qualifies. And we'll talk more about that in just a little bit. But when you give the thrombolytics, there's a few things that are going to be indicative of, hey, your thrombolytics worked. All right? And one of them, we'll get to that also, but one of them is you want to see the T waves flip. That's a good prognostic sign. And then what are significant Q waves? I'm sure a lot of people in this audience, myself included, have tiny little Q waves. They don't mean anything. Infarction Q waves, in other words, Q waves that mean you've had a previous MI, have to be at least one little box wide, or 40 milliseconds wide, and they should be at least 1/3 of the size of the whole QRS complex. If they're smaller than that, they're just nothing Q waves. They're insignificant. But you want to see that they are at least that big before you call this a prior myocardial infarction. All right? Now, there are a number of different things that produce diffuse ST elevation, in other words, ST elevation on both sides of the EKG, some limb leads and some precordial leads. There's probably 5 that you need to remember. All right? Number 1, a big STEMI can do it. Number 2, Prinzmetal's angina or vasospasm can do that as well. You could probably put those two together in many respects because they both are going to the cath lab for diagnosis, but that is one of the other causes. Pericarditis, ventricular wall aneurysm, aneurysms are still out there, and then benign early repul. This is probably the one benign disease that I think they will test you on. All right? I said yesterday, there's no way the diagnosis will be reflux, or the diagnosis will be viral syndrome in a kid with a fever, or renal colic in an elderly patient. Now it's always a AAA, okay? But I think they would test you on benign early repul. You need to know how to diagnose benign early repul because that's the most common reason why STEMIs get over and underdiagnosed. So I think they might very well stick a benign early repul EKG on that test and want you to diagnose it as the benign condition. All right. So what are the things that you can do to help distinguish true STEMI versus these other mimics? Well, things that increase the likelihood you're looking at a true STEMI as opposed to the mimics are, number 1, we mentioned already, reciprocal depression. And I think they'd probably give you reciprocal depression. So look for ST depression in some other leads. If you see ST elevation all over the place, but there's depression in a couple of other leads, like AVL. Nobody ever looks at AVL. You've got to look at AVL. Depression in AVL, or maybe just in V6, or just in 2 and 3, that points towards a STEMI because the other things on this list should not give you reciprocal depression. The only thing on this list that gives you reciprocal depression is a true STEMI. So I think you ought to be looking for that. What else? If they tell you that, or if they show you an EKG with horizontal or convex upwards ST elevation, like tombstones, that's a STEMI also. I'll show you examples in just a second. All right? And also, if they give you serial EKGs, then that points towards a true STEMI also. Now, on the board, I don't think they're going to give you serial EKGs, but if they describe it to you, that the EKG is changing with serial EKGs, then that's going to point towards a true STEMI also. Here's an example of that horizontal ST elevation. If you see horizontal ST elevation like that, think STEMI, not pericarditis, not aneurysm, or not pericarditis and not early repul. All right, think true STEMI. And this is an example of the convex upwards or tombstone type of ST segment elevation. All right, if you see that, again, think true STEMI. Notice also the other thing that nails your diagnosis of true STEMI, there's reciprocal depression. In V1, V2, V3, that's a no-brainer. All right. Now, what are the things that point toward vasospasm? Well, vasospasm can look just like a STEMI. It can give you any morphology for ST elevation. But a couple of things to keep in mind, vasospasm should not give you reciprocal depression. All right, a couple other things. Vasospasm usually is a bit more common in women and a bit more common in the early morning hours or in cold temperatures. When your body temperature drops a little bit, that's when you're at higher risk for vasospasm. You know, in the early morning hours, your body temperature drops a little bit and you're more likely, or in the winter time. All right. Most patients with vasospasm do have some coronary disease, but just not critical disease. Maybe they develop vasospasm on top of a 50% lesion, and then you can get a terribly ugly looking 12-lead EKG. All right? So this EKG can look just like a true STEMI, except there's no reciprocal depression on that board exam. I think that's your tip-off there. All right? What about aneurysm? Well, aneurysm can look awfully scary as well, but aneurysms also have no reciprocal depression. If you ever see reciprocal depression on an aneurysm patient, it means they're having a new STEMI. All right? That's a bad day. So look for reciprocal depression. Aneurysms will give you no reciprocal depression. The other thing to know about aneurysms are always associated with people that have had prior Q-wave MIs. All right? And so when you look at that 12 lead, you're going to see big Q waves. All right? Well-formed Q waves. If you look at this example up here, take a look. Big Q wave in V2, big Q wave in V3. These Q waves are large enough that this is not a fresh STEMI. This is probably an old STEMI, all right? And that's your tip-off. Those can be scary-looking ST segments, but look at this EKG. There's no reciprocal depression, and you already have giant Q waves. Think aneurysm on the board exam, all right? If they give you a true STEMI on the board, I think it'll be a fresh one, which means you're not going to see giant Q waves that look like this, all right? Big Q waves, and usually the Q waves are in the anterior or the V leads, the precordial leads. All right. Also, if you were to get serial EKGs on this, it's going to look the same. Nothing's changing. If you got an old EKG from a month ago, it's going to look the same. Nothing's changed. All right. Early repull. Be on the lookout for early repull. Early repull is kind of your diagnosis of exclusion. There's no reciprocal change. You're not allowed to have convex upwards ST elevation. Everything should be concave upwards. All the ST segments should be concave upwards, like a cup holding water. All right, everyone look up here for just a second. Your ST segments should be like this, all right? If they're like this, that's a STEMI. If they're like this and then T wave, that's a STEMI. If they're like this, it can be anything, including early repull, all right? So how do you diagnose early repull? Again, it's a diagnosis of exclusion. No reciprocal change is allowed. You really should not have Q waves, certainly not big Q waves. Minimal Q waves, if anything, all right? No Q waves are allowed. It shouldn't be evolving. And oftentimes, you will have these little fish hooks. If you look right up there, there's a nice little fish hook. It's a little J wave in V3. Marriott used to call these little fish hooks or notches right after the QRS, typically in V3, 4, 5, 6, maybe just in one of those leads. If they give an EKG that has a little fish hook like that, think about early repull. And again, notice in all of these leads that are being demonstrated up here, and in the rest of this person's EKG, all the ST segments are concave upwards. It's like a cup holding water. All right? So that's your tip-off that you're looking at early repull. And then everything I just said about early repull, except for the fish hook, applies to pericarditis. On the boards for pericarditis, look for PR depression. And we'll talk more about pericarditis in just a second. All right? Now, there's a couple of other things that we call STEMI equivalents on the 12 lead. In other words, on your 12 lead, there's no ST elevation, yet you're going to treat it like a true STEMI. Posterior STEMI is one example. All right? In posterior STEMI, the ST elevation is developing on the back of the heart. So on the EKG that's on someone's chest, it's going to look, instead of like ST elevation, you're going to see ST depression. And your money leads here are V1 and V2. In V1 and V2, maybe V3 also, instead of ST elevation, you see ST depression. Instead of inverted T waves, you see upright T waves. And one of the real big tip-offs is instead of Q waves, you'll see large R waves. And I think on the board exam, they'll probably give you big R waves. Now, most of the time, posterior STEMI occurs concurrently with an inferior STEMI. So here's a nice example of a patient with a no-brainer inferior STEMI. There's tombstones in for these, but there's also posterior extension, posterior STEMI. How do you know? Take a look at V1, V2, V3. There's ST depression, there's upright T waves, and there's kind of tallish R waves. Out here in V3, there's tall R waves. And if you were to repeat this EKG in a couple of hours, you'd probably see the R waves get taller and taller. All right? So this is pretty easy. Inferior posterior STEMI. Why do you need to know about posterior STEMI? Everyone's going to pick up the inferior STEMI here. Well, the reason we need to talk about posterior STEMI is because about 5% of all STEMIs are isolated posterior STEMIs. So the inferior leads are not helping you out. Take a look at this EKG up here. The inferior leads look totally normal, but this is an isolated posterior STEMI. All right? This is not. When I was in residency, I would look at this and say, hey, this is just anterior wall ischemia. There's ST depression, V1, V2, V3, V4, V5. What do you do for anterior ischemia? Give them aspirin and heparin, and back then we give beta blockers, and just admit them to the CCU. Cardiology will come in the next morning and take a look at them. All right, that's what you do for anterior ischemia. But now I know better. This is not anterior ischemia, this is posterior STEMI, which means you're not doing all those things and admitting. If it's 2 o'clock in the morning, you're calling cardiology right now, or you're giving this patient thrombolytics right now. So how do you know this is a posterior STEMI and not just plain old anterior ischemia? Well, what are the signs of posterior STEMI? V1, V2, V3, ST depression, V1, V2, V3, upright T waves, and V1, V2, V3, you've got pretty tall R waves. V1, kind of, but definitely, take a look at how tall that R wave is in V2 and in V3. And I think this is the type of 12 lead that they would give you. And they'll bait you into calling it anterior ischemia and just admitting them. If you see this, no, this is a STEMI, and you're going to need to give them thrombolytics or cath them if the cath lab's available. All right. Now, in real life, oftentimes we'll do posterior leads. I don't think they're going to give you posterior leads on the board exam. All right. So what are the indications for reperfusion? When do you need to give lytics or cath people immediately? Well, they need to have certain symptoms, chest pain, shortness of breath, whatever. And then they also have to have something on EKG. We've kind of talked about this a bit already. What are the things on EKG that indicate that they have a STEMI and need to go right to the cath or get lytics? ST elevation in contiguous leads. We talked about that already. Posterior STEMI. We just talked about that. And then the third thing that requires immediate cath or lytics is if somebody has a left bundle with the concordant Scarbosa criteria. All right, and I'm going to briefly run through that right now. But if you're not comfortable or familiar with the Scarbosa criteria, I recommend you Google it and just look at a handful of cases to get comfortable with the concordant Scarbosa criteria. Now, those of you that know Scarbosa criteria know that there's 3 original criteria that were published. You only need to know 2 of them because the third one turned out to be too nonspecific. Some of you may also know about a new revised, what's called the Steve Smith criteria. You don't need to know that for the board exam because it's not validated. All right, it's not externally validated yet. So I can't imagine that they would test you on that. So Scarbosa becomes pretty easy. You only need to know 2 of them. Let's talk first of all about what a normal left bundle is supposed to look like. This is a normal left bundle. You will notice something called appropriate discordance. What that means is a fancy term which simply means that in every one of these 12 leads, every time the QRS primarily goes up, there's a little ST depression. For example, take a look at lead take a look at lead 1. Lead 1, QRS goes up, so there's a little bit of ST depression. AVL, QRS goes up, so there's a little bit of ST depression. V5 and V6, QRS goes up, so there's a little bit of ST depression. That's totally normal. That's called normal discordance. All right? If you ever see the QRS go up and the ST is elevated in the same direction, at least a millimeter, you're done. That's a STEMI. Give them lytics or cath them. That's the first criteria. QRS goes down, it's normal to have a little bit of elevation. That's normal. Scarbosa found that if the QRS goes down and the ST is depressed at least a millimeter in the same direction, concordant, in the same direction as the QRS, you're done. That's a STEMI, give them lytics or cath. And that only applies to V1, V2, or V3. All right? So once again, in any lead where the QRS goes up, if the ST is elevated at least a millimeter, that's a STEMI. That's number one. Criteria number two, in V1, V2, or V3, where the QRS goes down, if the ST is depressed in the same direction, at least a millimeter, that's a STEMI also. All right? So again, if you're not comfortable or familiar with those, just Google it, YouTube it, or email me. I can send you some examples also. And what you'll find is those are the only two criteria that you ought to know. So let's look at two examples here. Take a look here. AVL, V5, and V6. Notice the QRS goes up, and the ST's elevated in the same direction, at least a millimeter. That's bad. That's a STEMI. And then second example, V1, V2, V3. Let's take a look at these one at a time. V1, V3, QRS goes down and there's ST depression, same direction. That's a STEMI. All right? And by the way, the Sgarbosa criteria are so good, you only need one lead. You don't even need two contiguous leads. Just one lead that meets either of those two criteria. For example, in this case, there's only one lead, V3. This is a STEMI. All right? So you've got to be on the lookout for those Sgarbosa criteria. Fortunately, you only need to know those two. Okay. So those are going to be the indicators for acute reperfusion, meaning lytics or cath. There's two other EKG findings that I think you're going to have to know based on the LLSA articles that we've had to read. One of them has to do with ST elevation and AVR. And the second one is something called the De Winter's T wave. Let's take a look at each of those. Now, with the ST elevation, AVR, and De Winter, those are not yet criteria for cath lab activation. They're not in the U.S. guidelines yet. Actually, they're in the European guidelines, but you're taking a U.S. test. So they're not going to be in the U.S. on the U.S. test because they're not in the U.S. guidelines yet. All right? But I think the type of question that they would ask you is, what's the vessel involved? Studies have shown that when you're looking at this very, very characteristic EKG, take a look everywhere. There's ST depression in a whole bunch of leads, and now you look up there in lead AVR, and you see significant ST elevation AVR. When you've got ST depression in a bunch of leads, and then you look in AVR and there's ST elevation in a symptomatic patient, what vessels do you need to worry about? The literature has indicated that this is highly predictive of an acute left main occlusion, all right? Or triple vessel, maybe proximal LAD. Those are the three potential vessels. Left main is the main one, all right? So you've got to worry about left main. I would picture them giving you a question like this and saying, Mr. Jones is a 65-year-old guy who's got some cardiac risk factors. He comes in with chest pressure and diaphoresis. Here's his EKG. And you say, hey, there's ST depression in a bunch of leads, ST elevation and AVR, and the question would be, what's the vessel involved? And they might say, left circumflex, right coronary, posterior descending, left main. It's left main, all right? So when you see elevation in AVR, and it's got to be in a symptomatic patient, and there must also be ST depression in a bunch of leads, what's the vessel you need to worry about? Number one, left main. Maybe triple vessel, maybe proximal LAD, but I'll bet you they'll ask about left main. All right? And then the second EKG finding, which has been published an awful lot, but it's not yet in the U.S. guidelines. I think it will eventually be, but it's not yet in the U.S. guidelines. And so I think they're going to ask you what's the vessel involved, is something called the De Winter T wave pattern. All right? Once again, it's a symptomatic patient, and they get a 12-lead EKG, and what you see is in the mid-precordial leads, V2, V3, V4, you see evidence of ST depression, red arrow, showing you that there's ST depression. Red arrow is pointing to the J wave, or J point. So there's ST depression shooting up into a big, tall, hyperacute, rocket-looking T wave. That's the blue arrow. When you see a symptomatic patient who has, in the mid-precordial leads, ST depression shooting up into a big, tall, rocket-looking T wave. all right? And in this case, you see it in V2, V3, V4, maybe a bit in V5. They'll probably ask you, what's the vessel involved? And your answer is proximal LAD. More specifically, it's an acutely unstable proximal LAD occlusion. And the reason this is so important to know about is because it's an acutely unstable proximal LAD. I think most everyone knows about Wellens. Wellens is not acutely unstable. Wellens is a subacute proximal LAD. This is an acutely unstable proximal LAD. A lot of these patients are going to turn into STEMIs over the next hour or two. And that's why I think we need to know about it, and that's why a lot of people have proposed that this should be in the guidelines. All right, so know the vessel. Your two questions where they'll probably ask you, what's the vessel? Again, ST elevation and AVR. What's the vessel? Left main. Maybe triple vessel also, or proximal LAD. And then the de-winter T-wave pattern, looking in the mid-precordial leads, ST depression, shooting them to a big, tall, hyperacute T-wave. What's the vessel? It's an acutely unstable proximal LAD. All right. Yep, quick question. There is ST elevation in AVR. That's a good pickup. And ST elevation in AVR has been noted to occur often with the de-winter T-wave as well. All right. Now, I mentioned Wellens a second ago. Here's your Wellens. Wellens has been around for quite some time. Wellens T-waves are also in the mid-precordial leads, V2, V3, V4, and they can be deeply inverted T-waves or biphasic T-waves. Take a look. There's a very nice biphasic T-wave in V2, nice biphasic in V3, nice biphasic T-wave in V4. The interesting thing about Wellens is this can occur in somebody who is asymptomatic at the time of arrival. They came in because they had chest pain earlier. Now they arrived. Now they're asymptomatic. And this is the EKG that you get. Maybe they're going to bait you into thinking it's no big deal because the patient's totally asymptomatic now. This is a big deal. When you see those biphasic T waves or inverted T waves, but biphasic tends to be missed more often, so I'll bet you that's what they'll show you. Biphasic T waves in the mid-precordial leads. What's the vessel? It's a subacute proximal LAD occlusion. Does this patient need to go to the cath lab right now? Well, no, they're asymptomatic. But they ought to be admitted, and they probably ought to get cath during that hospital stay. All right? So again, Wellens is not an indication for immediate cath because they're asymptomatic. Classically, they're asymptomatic. But they ought to be admitted and treated aggressively, meaning at some point during that hospital stay, they probably ought to get a cath. All right. So we've talked a lot about EKGs. Now, you're giving lytics because the cath lab's broken. They qualified for lytics. You give the lytics, and the lytics can sometimes take 45 minutes, 60, maybe up to 90 minutes. You give it up to 90 minutes to work. How do you know if the lytics work? Well, a third of the time, the lytics fail. 1/3 of the time, lytics don't work. But if they do work, what are the things that tell you, hey, the lytics have worked? High five. All right. Well, number one, their pain's getting better. Number two, the ST segments are normalizing. Number three, the T waves oftentimes will flip. Number four, there's something called accelerated idioventricular rhythm, which is a very, very important rhythm to be on the lookout for. Those people that are doing their second recert probably have a lot of experience giving lytics. I'm guessing that most of the new grads probably have never given lytics to a STEMI. But this is something that you're going to have to do because, again, at ABIM General Hospital, the cath lab is always broken. So you're going to have to give the lytics. And then this is what you're going to be looking for. It looks a lot like VTAC. It's a regular wide complex rhythm, but the rate is under 120. It's not VTAC. VTAC, by definition, has to have a rate of at least 120. Some people say 130. When the rate's under 120, don't call it VTAC. It's not VTAC. It's a reperfusion arrhythmia. What happens is the artery suddenly opens up and the patient will develop a rhythm that looks like this. Sometimes it lasts 5 or 10 seconds and goes away. Other times it may last 4 or 5 minutes, which is long enough for people to get an EKG and then panic. Because they look at this and say, oh my God, the patient's got VTAC. And your computer will always call this VTAC because your computer is programmed by people that want you to fail. All right? Don't ever believe your computer. And that's exactly what happened in this case. I'll tell you about it in a second. Computer called this VTAC. All right? What do you do when you see this rhythm? You put your hands in your pockets and step away from the stretcher. All right? If you're a real touchy kind of patient, you walk up to the patient and give them a high five. All right? Because it means their artery has opened up. The last thing you want to do is to treat this rhythm with lidocaine or amio or procainamide, because what those things do to this rhythm is flatline. It turns them into asystole. It's a very reliable kill. All right? So I'll tell you what happened here. This patient had an anterior STEMI, got thrombolytics, and about 45 minutes later is up in the CCU. The patient's just chilling. This is not a destabilizing rhythm. It doesn't make people develop hypotension or chest pain. The patient's just sitting there doing fine, reading a newspaper. And then the patient went into this rhythm, still doing fine. The nurse grabbed a quick 12-lead EKG, showed it to the cardiology fellow. The fellow looked at the interpretation at the top, which said VTAC, looked at this, didn't realize it's too slow for VTAC, and he called it VTAC. He put the patient on an amiodarone bolus, and about 2 to 3 minutes into the bolus, the patient bradied down and died. True story. All right? And I've got multiple other cases just like that. All right? If it's not faster than 120, don't call it VTAC. Just put your hands in your pockets and step away. But people tend to panic. And I would say if you really want to use a medication for this, you can use Valium on yourself. All right? But just hands in the pockets and step away. All right? And I think this would be a great question for the boards. If I were writing questions, I would put this on the boards, and I'm going to try to bait you into killing this patient. All right? I'm going to say, the patient just had an MI, got thrombolytics 30 minutes ago. Patient is stable, so I'm going to bait you into calling it stable VTAC instead of unstable where you shock them. Stable VTAC. How do you want to treat this patient? Lidocaine, amio, procainamide. Observe. Answer, observe. All right? It's a great question for the board, so be on the lookout for that. All right, cardiac markers. You guys know all about cardiac markers. Myoglobin, I keep it here on the slides, although nobody's using myoglobin anymore. Maybe next year I'll finally take it away. All right, CKMB has largely fallen off also, and it's become a troponin world because troponin is the one marker that correlates with prognosis. And so that's why we all use troponin. And also troponin has come so far that it starts rising pretty much as quickly as myoglobin does now. Within the first couple of hours, it starts rising. One thing to know about troponin is that once it goes up from a STEMI, it stays elevated for as long as a week, all right? Maybe even longer with troponin I. So it doesn't peak at 24, 48 hours and then fall. It peaks at 24, 48 hours and then stays elevated. CKMB peaks and then comes down. All right? So the only time CKMB, I think, nowadays is being used, cardiologists sometimes will use this because while they're monitoring the patient in the hospital, they want to see that CKMB fall. If it starts falling and goes back up, it tells them that the patient's reinfarcting. All right? Whereas troponin is just going to stay elevated. It won't tell them that they're reinfarcting. So cardiologists still oftentimes use the CKMB associated with when they cath patients, but that's not your concern. On the board exam, I think any questions you're going to get are going to focus on troponin. All right, so just know those time courses there. Again, myoglobin was great because it rose early, but now that's pretty much gone, and everyone's moved over to troponin because it predicts complications and mortality. How do you treat MI or ACS? Well, simple. Give them oxygen if they're hypoxic. That's new compared to back when I was in residency, where everybody got high-flow oxygen. We now know hyperoxia is bad. It extends the infarct. So if somebody's not hypoxic or complaining of shortness of breath, don't put them on oxygen. All right? You don't need a pulse ox of 100%. If they're not complaining of shortness of breath and they're not hypoxic, don't bother with oxygen. Nitrates. Nitrates are great if there's no contraindication. What are the contraindications? Aortic stenosis, be very careful about that. If somebody's on an erectile dysfunction medication, all right, which I'm sure you won't find anywhere in this city, or if somebody is already hypotensive, be careful about nitro. All right, stay away from nitro. Aspirin. Aspirin for everybody, all right? Everybody gets aspirin, 325, they chew it and swallow. I don't care if the patient says that they took their aspirin, I don't believe them. I give them another aspirin. All right, you're not going to make anybody toxic. If the paramedics give aspirin, I believe it. All right, but when the patient comes in saying they took their aspirin, just give them another aspirin. You're not going to make anyone aspirin toxic. And the benefits of aspirin are so tremendous with such a low side effect profile. Do everything possible to give them aspirin. If they say, I can't take aspirin, I get a rash, give them Benadryl, then give them aspirin. If they have peptic ulcer disease, bleeding ulcers, give them a PPI, then give them aspirin. all right? And that's not me saying that. That's what the guidelines actually say, all right? So do everything possible, give them aspirin. Their family comes to visit, give them aspirin. Give them everyone, all right? Give the nurse aspirin. It's so important, all right? If they're on anticoagulants, give them more aspirin, all right? No harm, all right? Just do everything possible to give them the aspirin. Now, if they have a true allergy, like their neck swells up, their airway becomes compromised, something that they say that they've developed some reaction, yeah, fine. In that scenario, skip the aspirin and instead give them one of the, what I'm going to call the super aspirins, all right? So everybody gets aspirin. If it's true ACS, you're going to give them all heparin. Take your pick, unfractionated or low molecular weight. I don't think they're going to ask you any questions where you have to distinguish between the two. Beta blockers are largely out acutely. Beta blockers are really important. They decrease the risk of in-hospital VFib and VTAC. But the question is, do we need to give the beta blockers in the ED? And the guidelines now say, no, there's no rush to give beta blockers. Back when many of us were in training, we would give this magical recipe of metoprolol, Q5 minutes times 3, shooting for this heart rate of 60. That's gone, all right? What they now say is give the patient beta blockers orally at some point within the first 24 hours. So in other words, there's no rush to give beta blockers in the ED. We pretty much never give beta blockers for ACS unless they're in rapid AFib or extremely hypertensive. Just let them do it upstairs. It's fine, all right? And then the question then comes, when do you give one of these super aspirins? And I'm just going to, for simplicity, I'm going to use the term super aspirin to include G2B3 inhibitors, clopidogrel, ticagrelor, and prasugrel, all right? So everybody's got aspirin. When do you also give these other medications? Number one, they are only indicated in patients that are high risk. All of the studies that support use of these only included patients that are high risk. How do you define high risk? Positive troponin or ST segment changes. Not even T-wave inversions, but ST segment changes. All right? If somebody's not high risk, we're not even going to talk about super aspirins. If somebody is high risk, you've got a choice of a few of these. All right? So when do you use them? G2B3 inhibitors are great, but they are only indicated if somebody's going for invasive therapy. If they're going to be treated non-invasively with thrombolytics, for example, you don't use them. They're only indicated if someone's going to go for invasive therapy. Clopidogrel and ticagrelor are great. They can be used for invasive or non-invasive. And then prasugrel, you can kind of use with the instead of clopidogrel or ticagrelor. But the caveat here to know about prasugrel is that they should always be avoided if the patient has any prior history of TIA or stroke because of the risk of intracranial bleed. So even if they had a TIA, so one TIA 20 years ago, no prasugrel. All right, so I think that's worth knowing. All right. Now, the other thing to keep in mind about these super aspirins is the national guidelines are very clear, and they say they do not need to be given in the ED. So if somebody's high risk and you want to give them in the emergency department, that's fine. If somebody's high risk and you say, you know what, I want you to do it upstairs, I don't want to do it in the ED, that meets the guidelines also. All right. So either way, if they give you this as an option in a high-risk patient, yeah, sure, go ahead, take it. Right? But just be aware, there's no mandate from the national guidelines that say you have to do it in the ED. Thrombolytics versus PCI, all of the guidelines, all the data says that PCI is preferable if you can get them to the cath lab within 90 minutes. If you have to transfer, maybe you allow 120. But if you know ahead of time that patient's not going to make it to the cath lab within 90 to 120 minutes, you should have given thrombolytics. All right? What are the indications for thrombolytics? We've covered this already. You have to have some symptoms. All right? It doesn't have to be chest pain, but you have to be symptomatic, and then you have to look for the EKG criteria. What are the criteria? ST elevation, 2 contiguous leads, or posterior STEMI, or left bundle with either of these two concordant Sgarbosa criteria. And then also, if you're going to give lytics, it's because you're not going to be able to get that patient to a cath lab in time. All right? And I'm not going to go through this absolute and relative contraindications. I think it's worth reviewing the absolute contraindications. Relative, I can't imagine they would ask you about relative contraindications. I did highlight a couple things. Prolonged CPR, no one's ever defined what prolonged means, so that's a judgment call. And then uncontrolled hypertension, I highlight that because if you can control their blood pressure, they now qualify. So if somebody comes in with a blood pressure of 220 over 120 with the STEMI, you're not going to give thrombolytics, or even heparin for that matter. But Put them on a nitro drip. If you get their blood pressure down to reasonable numbers, then now they qualify. Go ahead. All right? So as long as you can control that blood pressure, you're fine. What are the complications of lytics? Well, probably 3 to 5% will develop serious bleeds. The bleed that we all worry about is intracranial bleed, and that's less than 1%. All right? It's much less than the intracranial bleed rate from stroke. Stroke patients have bad brains, they're at higher risk for bleeding. Acute MI patients don't bleed often, less than 1%, so it's a very, very safe medication. All right? And once again, when you give lytics, how do you know whether they work? Well, pain gets better, STs get better, and you're also going to hope they flip their T waves, and you're also going to hope to see a brief run of AIVR, accelerated idioventricular rhythm, that mimic of VTAC with the rate less than 120. Other complications that can develop with acute MI, you can develop arrhythmias, and this is just basic ACLS. If somebody has sinus Brady and they're stable, that's good. If somebody has sinus Brady or Mobitz 1 and they're unstable, give them atropine. If somebody has Mobitz 2 or third degree and they're unstable, skip the atropine, just go right to a pacer. All right? If somebody's having a STEMI and they have a new bundle or new bifascicular block, that's a predictor that they're probably going to end up needing a pacer also. All right? So pretty basic stuff there. Cardiogenic shock can occur in a number of patients. This has a very high mortality, about 85%. And the way I'm using the term cardiogenic shock, it implies that they're hypotensive, not perfusing, and they've got pulmonary edema. So don't forget the pulmonary edema. If somebody has true cardiogenic shock, hypotension and pulmonary edema, you're going to need to put them on vasopressors. Best data probably is for norepi, and that's kind of shaky data, but most of us are comfortable with norepinephrine, so just put them on norepi. And the most important thing you can do for these patients really is get them upstairs to a cardiologist. We can temporize them, but they need to go upstairs for a balloon pump, and that buys them a bit more time before they go to cath or cabbage. All right? Patients can develop papillary muscle rupture or dysfunction and develop acute mitral regurg. That will also give you hypotension and pulmonary edema. How do you manage those patients? Same thing. Support their hemodynamics and get upstairs. All right? If somebody reinfarcts, they develop recurrent chest pain, reinfarction, new ST elevations all over again. How do you treat that patient? You need to send them for cath. You never redose the lytics. So if they bait you into doing that, don't fall for it. You don't redose lytics. All right? If somebody reinfarcts, you need to ship them out to a cath, even if it's hours away. You need to ship them out. All right? Now, right ventricular infarction can mimic cardiogenic shock, but it's not true cardiogenic shock because even though they're hypotensive, they have clear lungs, and that's going to be your big tip-off. So if they've got clear lungs, you're not going to go to vasopressors. True cardiogenic shock with pulmonary edema, you need vasopressors. Right ventricular MI has clear lungs, you don't use vasopressors, you just give them IV fluids. Usually, right ventricular MI occurs in the presence of an inferior STEMI. So, for example, take a look at this EKG. Here's an inferior STEMI. This is a question that I would write. 45-year-old guy comes in with nausea, vomiting, chest pain. Here's the EKG. It's a no-brainer, inferior wall STEMI. But he also happens to be hypotensive with, in small print, clear lungs. How do you want to treat him? Epinephrine, norepinephrine, dopamine, dobutamine, phenylephrine, IV fluids. If the lungs are clear, go with IV fluids. All right? Right ventricular MI patients are very preload dependent. They need fluids. All right? The way I think of it, and this is probably not fair to the right ventricle, but the way I think of it, the purpose of the right ventricle is simply to pump blood to the left ventricle. So the left ventricle can produce a cardiac output and blood pressure. If you knock out the RV, the only thing getting blood to the left side is how much preload you have. So you need to increase the preload, give them more fluids so that the left ventricle can produce a good blood pressure. And the last thing you want to do is to give them nitrates, which are preload reducers. That'll really knock out their blood pressure. So maybe they'll give you a question where here's this patient and somebody gave a sublingual nitro and it really dropped their blood pressure. That's a tip-off that this is an inferior plus right ventricular MI. And as long as those lungs are clear, go heavy on the fluids. All right? So we talked about early complications, arrhythmias, cardiogenic shock. What are the late complications? If you have low flow and a poor EF, you can develop clots and embolize them. You can also develop pericarditis. There's two types of pericarditis. There's pericarditis that occurs a couple of months later, which typically is autoimmune. That's called Dressler syndrome. There's pericarditis that occurs in the first few days post-MI, and that's referred to as pericarditis that occurs in the first few days post-MI. All right? If you want to name it after yourself, you go right ahead. All right? Either way, you're treating them pretty much the same. They'll have similar things to look for in the EKG. Hopefully, they'll give you some PR depression. Very positional type of chest pain, and you're going to treat those patients with high-dose NSAIDs or high-dose aspirin. No big secrets there. I would probably just skip the steroids, even if you think it's Dressler's. For the most part, steroids are not necessary in the ED, and you can let the people upstairs decide whether you need to use steroids or not. All right? And then other late complications, myocardial rupture, papillary muscle rupture, septal wall rupture. In the real world, the vast majority of these patients die before they make it to the emergency department. But the patients in that community around ABEM General Hospital are really resilient. So they blow out their papillary muscle rupture, and somehow they walk in. All right? They blow out their septum, and they still are alive when they show up. So what are the things you need to look for? Usually, again, this is about a week or so after their MI. Myocardial rupture, they're going to be hypotensive, pulmonary edema. In fact, all three of these, hypotensive and pulmonary edema. How do you treat them? Support their hemodynamics and get them upstairs so that they can get a repair. All right? Papillary muscle rupture will probably give you an acute MR murmur. Septal wall rupture will probably give you a very loud, harsh, holosystolic machinery murmur all across the precordium. And I don't know that you need to distinguish between these because it really doesn't make a difference. All three of these you're going to treat the same way. Support their hemodynamics, ABC, and get them upstairs. All right? ABCU, airway, breath, sound, circulation, upstairs. All right. All right. All right, little mental break here. I'm not sure what city this is from. So, and this is from Hawaii. They're pretty harsh in Hawaii. Drowning prohibited. Violators get a $100 fine if you drown in Hawaii. That's really rough. And I love this one for anybody out there that has young kids. So, very appropriate. Okay. Let's keep moving forward. We got 10 minutes. Heart failure. Heart failure is simply defined as your body cannot meet your metabolic demand. All right? So you may have a normal metabolic demand and your heart's function has dropped. Well, that's pretty intuitive. That's what we would think most heart failure is due to. Your normal metabolic demand, but your heart function has dropped. So your heart cannot meet the body's metabolic demand. But you can also have high output heart failure. And in that scenario, your cardiac output may be normal, but your metabolic demand went up. That's called high output heart failure. All right? We'll talk about what are the things that cause high output heart failure. All right? There's three major determinants of stroke volume. There's preload, afterload, and contractility. And almost always when you're in heart failure, one of these three things went bad. Too much preload, too much afterload. You know, think about it. If somebody has an acute hypertensive crisis, their afterload goes through the roof, they're really clamped down, and now this weak heart's trying to pump against high resistance, you're going to develop heart failure. And then a drop in contractility. So too much preload, too much afterload, and a drop in contractility. How do you treat patients with heart failure? Decrease their preload, decrease their afterload, makes it easier for the heart to pump forward. And in some cases, you may need to increase contractility. So we'll briefly talk about some medications that you can use for all of these. But before we get to the medications, the most important therapy you can use is not even a medication. It's simply non-invasive ventilation, and we'll get to some of these therapies in just a second, all right? All right, so sometimes people divide heart failure into low output and high output. Low output, again, it's very intuitive. The cardiac function is dropped. Those are your cardiomyopathy patients, people with previous MIs that have a poor cardiac output, valvular heart disease, hypertensive heart disease. What about high output heart failure? This is where the cardiac output may be normal, but the body's metabolic demands have gone through the roof. So thyroid toxicosis, Severe anemia, patients with AV fistula. It's Paget's disease. And then let's see if you can get this one. What's the last one? Beriberi. Oh, come on, folks. We're talking about all right, there you go. Halle Berry. All right, so Beriberi. Don't forget about these. All right? If my dumb jokes keep you awake, it's worthwhile. All right? All right, and then we've got left versus right heart failure. Sometimes people like to talk about left versus right. Left heart failure, again, that's pretty intuitive. The left side of the heart produces your cardiac output and blood pressure, and it's weak. What about right heart failure? Well, if you have right heart failure, you can also develop congestive heart failure, because if you've got right heart failure, your body's not getting blood to the left side. And so you're going to have a poor cardiac output. There's a lot of patients that we now recognize have right heart failure. All right, and a lot of those patients have pulmonary hypertension. We're starting to talk more and learn a lot more about pulmonary hypertension. All right, I think Stuart will talk a little bit. Stuart, you talking about pulmonary hypertension a little bit? No? Okay, well, don't worry about it then. All right. And then systolic versus diastolic heart failure. Again, systolic is very intuitive. Your systolic function's poor. What about diastolic heart failure? Why would you develop heart failure? Well, during diastole, the heart fills. And so if your filling is poor, you're not going to get blood to the left side to produce a cardiac output. And we've now recognized also that diastolic heart failure is very, very common. In fact, I remember a cardiologist once saying that if you have an ultrasound probe or echo looking right at the heart, right at the moment the patient develops ischemia and infarction, the first thing that happens is not systolic failure, but the first thing that happens is diastolic dysfunction. The heart stiffens, it doesn't fill, and then that drops your cardiac output. So we now recognize that diastolic dysfunction is much more common in ischemic patients than we thought 20 years ago. Left-sided heart failure, what are the symptoms? Shortness of breath, orthopnea, PND, peripheral edema, JVD. All right, the X-ray will show redistribution of fluid to the upper lung fields. You can also get what that box is showing, maybe some curly B lines, which is that plate-like atelectasis way out in the periphery. It kind of looks like atelectasis, if I can steady my hands right up there. All right. So you guys know how to read X-rays. That shouldn't be a problem. With full-blown pulmonary edema, it can look like bilateral infiltrates. And I'll admit that I've made the mistake of diagnosing somebody with bilateral pneumonia who actually had pulmonary edema. And the tip-off should have been that they had no cough or fever, and their white count, for whatever that's worth, was pretty much normal. And so this can mimic bilateral pneumonia as well. Patients with right heart failure tend to present, as you would guess, with JVD, peripheral edema, and clear lungs. They have peripheral edema, hepatojugular reflux, and so on. Most common cause, there's a most common, so pay attention. Most common cause of right heart failure is left-sided heart failure, right? And pulmonary hypertension also. How do you treat patients? All right, so let's move on to treatment. I mentioned that there's medications that can be used for preload and meds that can be used for afterload, meds that can be used for contractility, but the most important therapy of all is not even a medication. It's non-invasive ventilation. If they were to give you, if you had a patient that was looking really sick in full-blown pulmonary edema and you only had one therapy to use, go with non-invasive ventilation. CPAP or BiPAP, take your pick. All right, pretty much equivalent. But this is the only therapy of everything that we do in the emergency department for heart failure, the only therapy that has any mortality improvement data. All right, so we'll start with that. Now, what are the medications that decrease preload? Nitrates, by far, are your drug of choice. They're rapid, reliable, they're short-acting, so if you run into problems, you can turn it off and it goes away pretty quick. Diuretics will drop your total body volume, and that will decrease preload. Diuretics take a little while, though, because if you're really afterload increase, which all these patients are, you're not actually perfusing your kidney that well. So you give these whopping doses of diuretics, and they don't diurese, right? We've all seen that. You give 60 or 80 of Lasix, and then you have to double it later on, and it doesn't work that well. If I gave everybody in this room 10 of IV Lasix, you guys would be running for the bathroom in 10 minutes because you're perfusing your kidneys. But a person with pulmonary edema has afterload through the roof. They're very clamped down. They're not perfusing their kidneys. It's not until you decrease afterload that the diuretics really start working well. Morphine, just throw it out. Morphine has been debunked as a preload reducer. It's a fantastic medication for a CHF if you're looking for practice with intubation, but that's about it, all right? Nasiratide, we've had a couple LSA articles on nasiratide, and I would say that probably all you need to know about nasiratide is that it's primarily a preload reducer, but there have been enough problems that have come up over the years that I can't imagine they would want you to use nasiratide. The only question about nasiratide I would guess you'd get is just knowing it's a preload reducer. Afterload reduction can be accomplished with high-dose nitro, so this is a great single medication that can reduce preload and afterload, ACE inhibitors and nitroprusside. All right. Of course, if they're too hypotensive to tolerate these medications, then you have to stay away from it. All right. Let's see, 3 minutes. Let's quickly go through infective endocarditis. What are the risk factors for endocarditis? Well, there's a lot of risk factors that you can read up here. Key point I would make, the biggest risk factor is a history of prior endocarditis. All right. Back when many of us were in training, we thought about all these risk factors. They're very minimal risk factors, but history of prior endocarditis is what you need to know. What's the most common valve? Most common, there it is again. Mitral valve is the most common overall. Now, if we're talking about injection drug use, it's the tricuspid valve. But all comers, it's the mitral valve. What's the most common bug? It used to be strep. Now, because of injection drug use and prosthetic valves, what's the most common bug? The most common bug now is staph. Staph has taken over strep, especially with injection drug use and prosthetic valves. What are the symptoms? Acutely, fever and murmur. Subacutely, you look for a lot of those signs of peripheral embolization. All right? The most common bug acutely is staph. Most common bug subacute is strep. If you look at all comers, it's still staph though. All right? Staph has taken over. Right? Most common cause of death is heart failure. Once your valves go bad, you develop heart failure. That's the most common cause of death. And acutely, the big complications to worry about are emboli. If it's a right side valve, you get emboli to the lung, and you can develop a multilobar pneumonia. If it's left-sided endocarditis, you get emboli to the brain and to the systemic circulation. All right? You can get a cerebral abscess. You can get a perinephric abscess. You can get emboli down to the extremities, and so on. Now, this is a great question. If you have a prosthetic valve, what's the most common bug? Well, it actually changes depending on when the valve was placed. If you're in the first 2 months post-op with the prosthetic valve, it's staph epidermidis, and staph aureus. If it's beyond 2 months, then strep starts becoming number one. All right, and I think that would make for a great question. Classic findings: fevers, chill, flu type of symptoms. All right, this is one of the classic misdiagnoses of flu. Somebody's got endocarditis, they're febrile, they're achy all over, no specific focus infection, so it's just the flu, go home. And then the patient starts embolizing, right? The embolic complications to be on the lookout for: there's your septic emboli. These would make for great visual questions. Your Janeway lesions, which are painless. Your ossular nodes, which are painful. Splinter hemorrhages, Roth spots. All right, we get views like this of the fundus only on the board exam, right? Right, and then your workup, you want to get 3 good lab cultures, 3 sets of blood cultures, and your best test of choice is going to be transesophageal echo. And how do you treat these patients? Good gram-positive coverage, which in 2019 probably means VANC. Good gram-negative coverage, which traditionally has been GENT, but if you want to use cefepime instead, that's fine. So VANC plus GENT or cefepime. And then key point here I've highlighted: for prosthetic valves, add rifampin. Rifampin gives you extra gram-positive coverage and helps supposedly penetrate the biofilm. All right. And in terms of prophylaxis for endocarditis has become very, very simple. It used to be that we prophylaxed everybody who's getting anoscopy and a Foley catheter and all these other things. It's now, based on literature, become very simple. The only patients that need prophylaxis for endocarditis are these patients: prosthetic cardiac valve, history of prior endocarditis, congenital heart disease, or transplant patients with cardiac valvular disease. So these are the patients if they're getting a major dental procedure. That's it. That's the only procedure that requires prophylaxis now. Major dental procedure, where a lot of gum bleeding, not dental cleaning, but what they refer to as maceration of gum tissue or infected tissue, getting a nasty tooth pulled out. So these patients who are getting a major dental procedure, that's it. And how do you prophylax them? Very simple. A couple grams of amoxicillin 1 or 2 hours before the procedure. In this day and age of MRSA, if they give you Clinda as a choice, I'd go with that. If they give you VANC as a choice, I'd go with that. So just a couple of hours before the procedure, it's very simple. All right? And that's about it. All right? So we'll take a break there. I'm going to hand things over to Stuart, and we'll be back in a little more than an hour to finish up cardiology. Thanks a lot.
All right. Thank you. So gracious. Thank you. Hello, everyone. Don't leave. We're going straight into this, are we not? Yeah? Okay. If you want to stand up and take a stretch, that's probably a good idea. If you want to stand up and just, no? Do it. It's good for you. Get your blood flowing. I won't lead calisthenics, don't worry. And then you get ready for the next section is pulmonary. We'll start in 30 seconds. All right. Should I start? Yeah, okay. Yeah, oh good, okay. All right, pulmonary medicine. This is a biggie, almost as big as almost heart. He has a very big heart. It accounts for a very big percentage of the questions on the test. So it's going to be in two parts now, and then after the break is the second part. All set? Okay. Pulmonary medicine. The first three slides are the slides we're going to take a few moments on, and you got to figure they can ask a few questions about basic physiology, the heart and the lungs, oxygen, carbon dioxide, the basic stuff, and it's probably going to come from this section. And so using these first three slides, I'm attempting to give you the answers to every conceivable question about pulmonary physiology that comes up on these tests. So the first one is the AA gradient. This is something, like many things, I felt wasn't really taught to us the way that we should have had it taught to us. AA gradient is the report card of the lungs. What's the report card of the kidneys? The creatinine, right? The AA gradient is the report card of the lungs. And so when people have low oxygen, when people are hypoxemic, the basic question in front of us is this a lung problem, or is this something else that has nothing to do with the lungs? What do we turn to? The AA gradient, the report card of the lungs. Make sure you know the formula, because it's an easy question to ask about. Make sure you know how to calculate that. And see that this breakdown of normal AA gradient means their hypoxia is not from the lungs, and the increased AA gradient means that there is hypoxia because of the lungs. That's the main purpose of the AA gradient. So for example, if I take an opioid overdose and I stop breathing and I get hypoxic, that's not my lungs' fault, that's my fault. That's my brain's fault, right? Nothing to do with my lungs. If I happen to work in Denver and I'm a little short of breath, that's not my lungs' fault, that's Denver's fault for being over 5,000 feet high, right? Now, if the AA gradient is elevated, it's a lung problem. And all AA gradient means is how effectively do the lungs take the oxygen from the environment and down your trachea and put it into your bloodstream. Does it go from that A to that A? That's what it means. Now, if it is an increased AA gradient, the overwhelming majority of diagnoses that we encounter in the emergency department, the mechanism of that AA gradient rise is VQ mismatch. So all other things being equal, if someone asks you what's the cause of hypoxia in this case that you're seeing in the ER, the answer is almost certainly VQ mismatch. Whether it's pneumonia, whether it's pulmonary embolus, COPD, asthma, ARDS, interstitial lung disease, these all have a component of increased AA gradient from a mismatching of VQ mismatch. Actually, the last one that I mentioned, I'm sort of listing all this string of things. Interstitial lung disease is the one where it gets a little bit different. In interstitial lung disease, and this is fairly rare, the kind that we see it mostly in the emergency department is PCP pneumonia with HIV/AIDS. That's a different mechanism of hypoxia, and that is an impaired diffusion mechanism. So just to be clear, we get hypoxic in VQ mismatches because there's big sections of lung that are getting blood, but that blood is not getting oxygenated. So it goes into the admixture, and we've got a low SAT, right? That's how it works. And so that applies to every single mechanism there, PE, pneumonia, asthma. Sometimes you wonder, in PE, is that the case? I thought in PE it was the blood isn't flowing through a section of lung, and why would they be hypoxic? The real reason is because adjacent to the area of the infarct is large atelectatic segments that do provide that VQ mismatch. So PE is just like the rest of them. It's a VQ mismatch mechanism. In PCP pneumonia, we're going to talk about this a little later, they actually don't have a VQ mismatch problem as much as they have a problem of diffusion of oxygen. And that's the only kind of exception to the rule, that type of rapid interstitial lung disease like PCP pneumonia. So that's the first slide, and it's probably the toughest one. Here's the second slide, and it boils down to another mantra like memory aid, and that is the following. One cannot be both cyanotic and anemic at the same time. I want you to contemplate that for a second. In order for you to look blue with cyanosis and to have that central blue tongue cyanosis, you need to have 5 whole grams of hemoglobin without oxygen on it, desaturated hemoglobin. If my hemoglobin is only 4 or 3 after a big GI bleed, I don't even have enough hemoglobin to look blue. And it's a very important concept. You cannot be both anemic and cyanotic at the same time. Now, think of the flip side of that, which is that if you do happen to have lots of hemoglobin and you're polycythemic, think of the blue bloater, you can be cyanotic very easily. If you've got 20 grams of hemoglobin, you've got all this extra hemoglobin, if your SAT is 75%, you might think, oh my goodness, that patient has got a SAT of 75%, that's terrible. But don't forget, they've got lots of extra hemoglobin. And of their 20 grams of hemoglobin, 15 of 20 is saturated with oxygen. And so that blue bloater that's sitting back there with a 75% SAT is getting the same amount of oxygen that you are if you don't have that disease. Interesting. And so that's why they're just sort of chilling, because they are getting that oxygen. They just look blue because they have so much hemoglobin. That's the second slide of 3. It's almost over. I know, this is bringing back some chills. Why I didn't go into internal medicine, 101. Okay, now, this is about the pulse ox, and it comes up in all kinds of questions, the pulse ox. So I decided, let's address this with one slide, the pitfalls of the pulse ox. Number 1, we don't get obsessed anymore about making patients SAT 100%. You've heard it from Amol just recently. You've been hearing this. We don't aim for these great numbers, 100% SAT. We know that that's probably not a good idea. There's a hyperoxia damage and all kinds of problems. But if a patient has a hemoglobin of 2 with a GI bleed, you must put supplemental oxygen on them because remember, they only have 2 grams of hemoglobin. Let at least those grams have oxygen on them, right? And so don't forget that if they're anemic, that pulse ox is deceiving because it makes you think, just like we were talking about in the last, it makes you think they're getting lots of oxygen when they're really not because they don't have much hemoglobin. So that's point 1. Point number 2, consider the patient who is really having trouble breathing. Okay, and is in respiratory, like it looks to be in respiratory distress. And you've got a non-rebreather mask on them, which you know provides a very high FiO2, nothing near 100%, but maybe 60, 70%, right? And this patient's struggling and they're on a non-rebreather, and they tell you the patient's SAT is 89, or they tell you it's 92, or 93 even, 94. What do you think about that? Do you think that's a reasonable SAT? Well, maybe it's a reasonable number, but remember, they're getting such a huge amount of supplemental oxygen that represents respiratory failure, essentially. If someone is on so much oxygen supplemental and they can't even get their SAT to hypernormal, then what they're getting at in the question with that patient breathing and SATing at only 90 or 92 with all of that oxygen might be that patient is actually crossing the Rubicon as it speaks and they might need to be tubed. Okay, so that is a form of respiratory failure that they're getting at. So that's the second point. The third point is the pitfalls of that carboxyhemoglobin, right? Remember, with carbon monoxide poisoning, anything that they give you in that question, anything other than the actual direct measurement of CO, what we call co-oximetry, is going to mislead you and give you a wrong answer to that question. If they give you the SAT, of course we know the SAT is falsely 100% in CO poisoning, right? We all know that. But don't be confused if they give you the PO2 on the blood gas and say, well, but the PO2 is normal. But that PO2 has nothing to do with the CO. The CO is affecting the hemoglobin. It's not affecting the free PO2 in the bloodstream. And even the SAT that you get when they is a calculated SAT. So if you get a blood gas and they calculate the SAT and that's normal, that also will mislead you. You must not fall for their trickery. You must get the CO level itself directly measured. So that's the third point on this slide. Here's the last one, and it's a weird one, and it's an interesting one. And Billy will probably talk about this a little more. Methemoglobinemia, as you know, well, that's kind of the patient that comes in blue acutely. I'm blue, doctor, but they look okay, and there'll always be something on the history that they took a medication, a redox agent, something that actually turned their Fe2 plus into Fe3 plus. They'll give you a nitrite, or they'll give you dapsone is a popular one that causes methemoglobinemia. And the person will be blue as a Smurf. They won't look too terrible because it's not a heart or lung problem per se. It's just the blood is less able to carry oxygen. And what the SAT will read is classic, 85%, mid-80s. The reason why? I don't understand, to be quite honest. It's because the pulse ox gets confused by that band, and it generally reads mid-80s. Blue as a Smurf, not too sick. I took a drug like dapsone, and my SAT reads 85%. It's a classic constellation on a question for methemoglobinemia. We did it. We made it through those first 3 slides. I promise we're going to talk about medicine now. Okay, what we're going to do is talk a little about asthma. We're going to talk about COPD, ARDS. Then we're going to get into pneumonia. This is bread. This is butter. And what they're going to do is they're not going to ask you, how do you treat an asthmatic? Use albuterol. How do you treat, they're not going to ask you these sort of things that we do every day. They're going to find the 1 or 2 points that we don't encounter that frequently that sometimes make a difference that you might have forgotten about. And so as we go through here, we're going to focus on those things. When it comes to asthma, asthma is a public health disaster. Other diseases we seem to make progress with, asthma we seem to be stuck. And this somewhat has to do with the fact that this is a disease of urban environments, pollution, poverty, access to care, things that we're struggling with in the United States. These are things that really adversely affect the care of an asthmatic. And remember that when an asthmatic comes and they're using their puffers all the time, they're not well treated by definition. Well-treated patients are on long-term medications that control their symptoms, so they're not needing to use those puffers. So just the fact that they're using them all the time is not a good sign. It means decompensation. Asthma, as we've learned over the past half century, starting from when we began this business together to now, was really changed. Our understanding has really changed. It started off as a bronchospastic intermittent occlusive disease. That's what we used to think, intermittent bronchospasm. And now we know different. Now we know that asthma is a chronic, not acute, chronic, inflammatory, not vasoconstrictive, or not just simply bronchoconstrictive, inflammatory disorder. It's a chronic inflammatory disorder. And more than that, it's a disorder that structurally changes the airways with time. In these severe asthmatic patients that are at risk for dying of asthma, if you look at their airways, you will see not just the constriction, not just the edema, and of course we address those with beta agonists and steroids, but there's actual structural changes, hypertrophy, increases in goblet cells, structural changes to the lungs that makes them hypertrophic and heavy and diseased. And so that's really, really interesting. And this picture is just the same information in cross-section to show you that there are layers of changes that only begin with bronchoconstriction and inflammation in asthma. How many people here have had the awful experience of having an asthmatic die in their care? Hands up. I'll start with myself like I always do. And for me, it's not just one. Okay, it's common. And I'm here to tell you something. It was not your fault. There's no question it wasn't your fault. Did you give them oxygen? I'm sure you did. Did you give them albuterol? I'm sure you did. Magnesium, steroids? Of course you did. You did everything you could. And there was nothing that you could have done about this, because that's how these folks die. This inspissated mucus that actually replaces their tracheobronchial tree is impassable. You can't ventilate through that. That's how that patient most likely died, and it wasn't your fault. That's also why when we do get these patients in their sickest form, when they're intubated, we go nuts over good pulmonary toilet, and we have that RT standing there at the bedside cleaning that stuff out before it becomes like that, and you can't ventilate without ECMO. Now, we've all heard that we all know about asthma, right? We all are, we're ER docs. I mean, we are experts in asthma. All of us are, right? So they're not going to ask you, like, does allergy cause it? Of course it does. They're going to find, again, the few things that you forget. So don't forget that those timolol eye drops cause asthma. and they cause COPD exacerbations. The beta blockers are absorbed systemically, and Alma will tell you that they worsen heart failure too in patients. These are absorbed. And if they do happen to give you a polyp, if they give you a nasal polyp, remember what they're thinking about. They're thinking about that important triad, or quartet actually, or quartet, what is it? Quintad? Basically, the nasal polyps go with asthma, that goes with atopic dermatitis, which is not listed there, hypersensitivity. Those patients should not get an aspirin. Maybe that'll be that question that Alma was talking about the aspirin and the MI. Those patients shouldn't get aspirin or any NSAID because of an anaphylactoid reaction. Doesn't matter, anaphylactic, anaphylactoid, they can both kill you. Okay, so that's important, Sandra's triad. Again, we were taught all through our formative years about how asthma is a problem of getting the air out, of exhaling. And it's true, there's no lie to that. But again, we didn't know the full picture. The full picture is that the severe asthmatic that's trying to die on you is in a shock state. And you probably didn't hear it like that. You probably weren't taught it like that. But that's exactly how they die. They die in a shock state. And that's because as they're heaving, and the pressure is going up and up and up in their chest, they develop invariably an obstructive shock. Blood cannot get back to the heart. And so when that patient is teetering on the edge and you're thinking, what am I going to do? And you're calling people and you're setting up to intubate them, that's what's happening, is obstructive shock. The other type of shock that we forget that they're experiencing is hypovolemic shock. If you're dying of asthma, you're not drinking your regular orange juice in the morning. Right? If you're dying of asthma and you're breathing like this, you're losing liters of fluids. So they are dying of hypovolemic and obstructive shock, not the way that we're used to thinking about this, but the way that we need to. They might ask about the common bedside test, and there's some surprising things here, some surprising things. I use peak flow as it was my temple. I love peak flow. When I was a general practitioner, it was the way I kept my asthmatic patients safe. Doc, I got up this morning, I didn't feel great, my peak flow is down by 50, I think I'm going to start the prednisone, can I see you this afternoon? I mean, oh my God, it was great in general practice. But in the emergency department, when we've studied it, it does not stratify patients like we would like. It does not predict admission like we would like. And it's not usually the right answer to questions on the test. It's a tool I use, but in the ER, they might not have used it before, they're too sick to give a good effort. There's a lot of reasons why it's not the great tool that it is in general practice. Pulse oximetry, the answer might also surprise you. I also use pulse ox. Of course I do. I'm not crazy, so do you. We all use pulse ox. But remember that because this is a VQ mismatch situation, that when patients are getting better from asthma, invariably what happens is their SATs go down before they go up. You've seen that happen. Mrs. Smith is getting worse, doctor. Mrs. Smith is getting worse. Go reassess her. And then you go see Mrs. Smith with asthma, and what does she say? Oh, I feel better, doctor. It's kicking in. But the nurse was concerned because the SAT went down from 95 to 91%. That's because of a transient rearrangement of these inspissated mucus plugs and transient VQ mismatches that characterize getting better from asthma. So if they ask you, does the SAT predict their admission? Does the SAT tell you what to do? The answer is no. And this all comes back to the same point, which is your expertise in asthma exceeds that of any test. Your expertise, our expertise as emergency physicians. That also goes for arterial blood gases. If they propose it, don't bite. Don't bite. If they ask you if ABGs are the answer to your problems, what do I do with this patient? You know the answer, the gas doesn't. If they do give you the gas values, I will tell you how to deal with that. But if the answer is using gases for management, the answer is no. That's not what we do, and you know that's not what we do. It's still what the internists do, and there is a discrepancy between our examinations, but we don't feel that that's the right thing to do. There's a lot of focus on resource utilization, the run-of-the-mill asthmatic. The run-of-the-mill asthmatic, you see them, and you treat them, and you treat them, and you do not do an x-ray. It is not indicated. It's indicated in COPD, but not in asthma. And so that's a resource utilization thing. So you can see that we might well manage an asthmatic without a peak flow as a determinant. We won't use ABGs. The chest x-ray is not necessary. And we remember there's pitfalls of the pulse ox that it can mislead initially. We've heard about asthma that it's a disease that gets louder before it gets quieter, right? Asthmatics get us more and more worried as they get more and more in distress. Their breathing goes faster and they're heaving. But what really scares us, and what we all know, that feeling, is when they start to get quieter, right? So the wheezes get louder, but when the wheezes get quieter, it means they're not moving any air at all, right? And we know that they're getting quieter because they're getting somnolent. They might be retaining CO2. So there's lots of issues there. Sometimes they do ask you about that process when it comes to the blood gases. And so let me make sure that you know how to get that exam question right. If a patient so just imagine this patient, they're breathing faster because they're scared, they can't get the air out. They're naturally breathing faster when they're in asthma, and they're in exacerbation. That means that their pH is actually going to go up. That means that their PCO2 is actually going to go down, right? So my PCO2 was 40 normally, and now it's going down to 30, and it's going down to 20 because I'm scared. My pH is now 7.55, right? And as I get sicker and I start to slow down, what happens? I get quieter, and now my PCO2 is 40, which, as you know, is a normal value, right? But if my PCO2 is 40 and I'm trying my hardest to breathe, what is that? That's respiratory failure, okay? So a normal pH and a normal PCO2 in a patient who's struggling is the sign that you're tipping over into, I can't do this anymore, failure. So that's the answer to the question if they give it to you. Look at that rising CO2 and that falling pH as an indicator that they're decompensating, especially if it goes along with the clinical picture. Now, these things, these risks, this is sort of straightforward, right? I mean, if someone tells you, oh yeah, I was in the ICU for 2 weeks and I almost died, and you know, they tell you these things about their asthma, you're going to be more worried, you're going to admit them. I don't think there's anything that's sort of counterintuitive there, so I would just leave it at that. If they've been sick in the past, there's a good chance I'll get sick in the future. You really need to know the therapies well. There's a few things that pop out here. Remember that beta-2 agonism is what we want. In the old days, I remember my brother was asthmatic growing up, and a lot of you probably remember being on treatments that were useless for asthma. Like, we used to give syrup of epinephrine, right? That was the treatment for asthma. And that was awful, made them even more obnoxious because it was sort of like, you know, a beta agonist. And it's not beta-2 specific, so it ramps up the heart rate. No good. What we want is specific beta-2 action just in the bronchioles. That's why a beta-2 agonist inhaled is the ideal and the gold standard of treatment for asthma. In fact, if you were to propose a new therapy for asthma today and go to the FDA and say, I want to use this for asthma, they would probably say to you, yeah, how does it compare to albuterol? Because that's pretty good. And that's how the research generally works, is it compares things to the gold standard of selective beta-2 agonists. Now, those evidence things there are important to know. They're more important to know for the test, honestly, because, you know, we all have our own practices, but remember that inhaled is better to oral and parenteral routes. Remember that if you give intermittent albuterol, it's just the same as continuous. There's millions of studies on this stuff. Another thing that's sort of not that practically relevant is MDIs are just as effective as inhalers. As nebulizers, but you know, that's not really practically important. I mean, what do you do when a patient's really sick and they come into your ER and their nebulizer's not working? Do you say, oh, just use your own nebulizer? No, you say, sit down, relax, here, I'm gonna help you, put a mask on them, right? Because they're sick. Now, the other thing that might come up is leave-albuterol. Remember leave-albuterol? That was Zopanex was the brand name for that, and we thought that was really good because it only had the good enantiomer and not the bad enantiomer that albuterol had. So that was very popular for a while, and we now know that it's not the case, that it doesn't appear to be any benefit, and so we've kind of moved away from leave-albuterol. I guess that makes sense. Leave-albuterol, leave it alone, right? Okay, makes sense. I just came up with that. I'm a genius. Okay. Now, asthma, steroids for asthma, remember, is it's everything, right? I mean, before we understood this, these patients didn't get better. It was terrible. Mortality was really awful, and we have to wait a few hours for these to work. There is some immediate blanching effect, actually. If you take a steroid inhaler and you spray it at a mucous membrane, you can actually see a little bit of blanching. There is a little bit of vasoconstriction. But of course, the majority of the asthma effect is in the immunomodulation, which takes several hours. I did mention their inhaleds are good. We use a lot of that in Canada, inhaled steroids to dispo these patients, but you also have to give them something parenteral. Now, because the beta-2 agonists are so effective and because the steroids are so effective, when we want to use these other, let's just say, marginally effective treatments that are effective but not so much, not dramatically, we only use these things in severe exacerbations. It's not correct to give the run-of-the-mill asthma patient magnesium. It's just not correct. It's not necessary. But if they're getting to a situation where they might actually be admitted and it's life-threatening, and then it's worth it, because the marginal benefit might be worth it. And none of these are terribly dangerous. Per se. Anticholinergics is not a problem. We know those work in a salutary way to the beta-2 agonist. Magnesium is not generally a problem if we give 2 or 4 grams of it. Ketamine is sort of a little different in that it's great for asthmatics. I had a couple of bad experiences with it because it does increase secretions, remember? And so ketamine can be used to avoid intubation, but I've more used it as an intubating agent, because I think that it's probably very effective after the intubation as a sedative agent, analgesic agent. Plus, it opens up these airways, and then once they're tubed, it's easier to do to do that toilet and to clean out the secretions. And ketamine kind of helps that happen. Now, I guess there's at least 5 things on this. It's important. These are all wrong answers. Wrong answers. Do not bite on these. Do not bite on these, okay? Theophylline works, but it's not worth it because of its toxic side effect profile. That's what I was trying to demonstrate in that picture. If you want to know, because you're looking at that and saying, what exactly was he trying to get at there? We were in Africa, and there was a patient, we were on rounds, and one of the patients had asthma. The doctor there is on the right, and he was like, okay, I'm going to treat this patient for asthma. I'm going to start an IV. You can use theophylline IV, and here's the oxygen cannula, and they're holding the oxygen cannula in front of him. And I'm like, no, let's get him beta-2 agonist. And he looked at me and he says, do you know how expensive that is? And I said, okay, well, for this patient, I'll go to the pharmacy and I'm going to buy an inhaler and we'll give it to him. And I went with my buddy and we went and bought an inhaler. It was like $25. The theophylline is pennies. And then we went back and the doctor was like, see, he's better. It didn't need your beta-2 agonist. But the therapeutic index is not worth it. The side effect profile is not worth it. It's not anywhere near as effective as beta-2 agonist, so it's out. Heliox, you might think is the right answer. It's wrong. We studied it, so we know it doesn't work. What Heliox does is it changes the air so that it's thinner and so that it flows better. Laminar flow is better. And so what Heliox is used for is large airway obstructions. If a kid's got a peanut or a hot dog in their trachea, it's the perfect drug. You change a stridorous kid into a calm kid by using that Heliox and letting the air flow through the big airways. Asthma and COPD are not diseases of the trachea or the big airways. They're diseases of the football field surface area-like airways in the periphery. And Heliox doesn't work. The physics doesn't work for that. Mast cell stabilizers. Anything that you see advertisements or advertisements, as we used to call them, on TV for asthma is wrong. Mast cell stabilizers, these long-acting agonists, the leukotriene modifying agents like montelukast are all wrong. All of those treatments for control are all wrong for acute asthma. You know that sometimes we have no choice and we have to intubate an asthmatic. We've all been there. The judgment of when to do that is exquisitely ours. It really is. Again, I have to reiterate this, there's no better expert on a patient who's crashing and when to tube them and that timing than us, right? That really is our business. But we also know that once we tube them, we have done nothing to solve the problems of the obstructed airway, and we've done nothing, or maybe even exacerbated some of the problems with the obstructive shock. So we've actually, one step forward, 2 steps backwards, if you will, with mechanical ventilation. The thing I want you to circle is, go ahead with your pens and circle permissive hypercapnia. Okay? For the young bucks, this is old hat because they've been doing it in their ICU rotations. For the rest of us, this is something new. Okay? The thing here is that, let me just back up for a second. We know that when we overventilate people with asthma, we cause pneumothoraces, right? We cause pneumomediastinum. We cause barotrauma. But barotrauma is not just a pneumo. And sometimes we used to think, we got away with ventilating this patient with these high pressures, and they didn't get a pneumo, so all's good. And then what we found out is that we're damaging the lungs greatly, that microscopically we're inflicting great pain on these lungs, and that this persistent high-pressure ventilation that we've been doing for decades is hurting these lungs and decreasing their capacity. And so now everything is about permissive hypercapnia. This isn't just for asthma. This is for COPD. As we talk about ARDS, this is for them as well. And what it means is that these patients were sick as heck, right? They had a low O2 sat. They had a high PCO2. They had a low pH, right? They were sick as a dog, right? And then you intubated them, and what permissive hypercapnia means is that leave them intubated and let those numbers gently correct themselves over the next few days. Because if we try to get an O2 sat that's normal and a PCO2 normal and a pH of 7.4 on the first day after we intubate that patient, we will hurt them. So we are permissive about CO2, we are permissive about pH, and I think most importantly these days, we're permissive about O2. There's no need to have a patient with an O2 at 100% anymore. And so these patients will be quite fine, thank you very much, at 88, 90, 92%. And in order to achieve that, sorry, just to close the loop on that, in order to achieve that, in order to not overventilate those lungs, the primary way is to reduce the ventilatory rate. You don't have to be a rocket science, you don't have to understand all the complexities of the ventilator, you just have to ventilate them at a rate of 6, because that's all they need. It's okay that their CO2 is slightly high. Oh, wrong way. Right way. Now here's the climax. I told you, asthma in its severe form when they're crashing on you is a shock state. And that's why I would never pronounce someone deceased with an asthma attack until I had gone through this list of 4 things. I want to make sure I disconnect the ventilator because they might be stacking air. Remember, their pressures are very high in their chest. That's not good enough. They've got a chest wall that's exhausted, that's unrecoiling. You need to get in there and you need to recoil that chest. You need to push the chest wall in. I didn't show that good enough here. I just show a hand on the chest. I want you to get in there and I want you to exhale that chest. And then the pressures will lower. And at the same time that this is going on, bang, 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 bang. Not even any prep because this person's dead, right? This is a kid. You're going to make sure there's no pneumothorax contributing to this by putting in chest tubes. Not even chest tubes, putting in a finger thoracostomy on both sides. And all the while that these things are going on, your chest hugging and your chest tubes is that lots of fluid is going into this patient because they are dehydrated and their hypotension that you're dealing with and their bradycardia, that has something to do with that. So big old bolus. If they ask you, will the disposition of this sick asthmatic be to the operating room? The answer is yes, maybe. Because in the ultimate awful scenario, the two things that we can do in the operating room to save a life here are number 1, anesthetic gases like isoflurane, which we can't use in the ER, which are very potent bronchodilators, and ECMO, of course. Why let a 21-year-old person die of asthma when all we need to do is bypass their lungs for a few days and get them better? That's it. That's all I have to say about asthma. Now, you'll be happy to know that when it comes to bronchiolitis, I don't feel the same affinity. I don't feel that it deserves all the slides that I gave asthma. It deserves very little. It frustrates me. And I got a few mantras for you that didn't get the questions right, but after that, we're just going to dispense with it. You know what my mantra is for bronchiolitis? You know, bronchiolitis, it kind of looks like asthma in a little kid, but it's caused by a virus like RSV, right? What's the most important thing about bronchiolitis? The mantra is, nothing works. You like that? Bronchiolitis, nothing works. Okay? You're supposed to try albuterol on them, just to try it. If it works, to be honest, it's probably asthma. And usually it doesn't work, and then nothing works, because the steroids don't work for this one. And it's just supportive care, okay? But on the exam, there's a couple of other things that you must know. Ribavirin is a drug that is used to treat this, but it's almost always the wrong answer, no matter how sick they are. If they were a normal term infant, they don't qualify for ribavirin, even as they're coding. It's used for kids with cardiopulmonary congenital disease. If that's part of the mix, then they get the ribavirin. That's an important thing for the exam. Other important thing for the exam is to recognize that the RSV swabbage that we're all doing, okay, to check their RSV status, is not for the care of that patient. It's not like we're doing anything for our patient based on that result. It's for hospital epidemiology so we don't cohort the RSV positive patients with the cancer ward and kill all the kids with cancer. Okay, so it's for hospital epidemiologic reasons that we're isolating the RSV people, not because we're treating them, because we're just supportive care. That's it, it only got one slide, because nothing works. Bronchiolitis. Let's talk about COPD. Now this is interesting, because I'm going to tell you the same darn thing I told you about asthma. COPD is a chronic inflammatory disease. Didn't I just say the same thing about asthma? Am I going crazy up here? Well, no, it is a chronic inflammatory disease, but it's a different type of inflammation. And now, at the risk of a slight oversimplification, let me give you the bottom line. In asthma, the inflammation consists of eosinophils. You know that. They've got yellow sputum filled with Kirschner's spirals. They've got the eosinophilic inflammation. And it causes hypertrophy. It causes, right, goblet cell hypertrophy, muscular hypertrophy, right? It's getting bigger and bigger and bigger. In COPD, we have a different type of inflammation. It's not yellow. The sputum is not yellow. There are no eosinophils. There are neutrophils. There are different inflammatory mediators. And in this disease, in COPD, what happens is that the lungs aren't getting hypertrophied. They're getting destroyed. They're getting eroded. They're getting eaten from the inside alive. And that's what emphysema is an eating away of the lung tissue. So you really have two chronic inflammatory diseases with very different consequences. And in the patients with COPD that lose all this lung tissue, what eventually happens is that there's no more pulmonary vasculature left. So instead of 50 arteries that take blood back to the left side of the heart from the right-sided circulation, there's only 4 or 5 arteries. So the pressure goes up. And that's the classic pulmonary hypertension that ends up killing patients with COPD. It's not more than a few months after that pressure goes up to the point where the right ventricle says, I've had it. Because right ventricle can't deal with that. And that's how patients die with COPD. And that's very different and very unique and separate from asthma. You've heard about the clinical phenotypes, the pink puffer, the blue boater. The last time I was involved with the Rosen chapter on this, I got a lot of pushback saying, you know what, we don't like that you're still using these pink puffer and blue boater designations because in reality, they don't exist. It's really, patients have hybrids. They have combinations of these things. But from an emergency doc, from one emergency doc to another, I ain't giving this up. And I'll tell you why. We talked a little bit about this blue bloater guy, right? We talked about him. He was sitting there blue, and he was sat at 75, but he seemed perfectly happy. And I told you it was because he does actually have enough hemoglobin going around. But the problem with this blue bloater dude isn't that. The problem with him in the hospital, you all know this, is that when we put oxygen on him, he stops breathing. Because his only motivation to breathe was hypoxia, right? Because blue bloaters have lost their respiratory drive. And so these patients, these blue bloaters, these patients that are polycythemic with COPD are dangerous for ER doctors, and we know that because even if we're admitting them for cellulitis, we know that that little dose of Benadryl that we give them to go to sleep might be their last dose of anything. They stop breathing all the time. We know more importantly that when we put a big old non-rebreather mask on them, we're killing them. They'll stop breathing. And so it's very important with the blue bloaters for people that have this phenotype, this low sat, this cyanotic constant cyanosis, very important that they be titrated with their FiO2. Titrated FiO2. And you never want to have a person like that sitting there on lots of O2 with 100% on the sat because the next reading on the sat will be 0%. Let's talk a little bit about mimics. And I didn't say much about this poor fellow on the right. I didn't say anything about him. I'm not as worried about him. You know, he's like this. He's like, I'm dying. Get away from me. Pink puffers, they have this tremendous drive to breathe and this tremendous anxiety that the blue bloaters don't have. And I'm not as worried, nor are you. You're not as worried about them. Okay, so let's talk about exacerbations. Now, this is actually, to be honest, this is as important for real life as it is for the test. Because in real life, if you miss one of these mimics, it's more than just getting a question wrong. It's important. So there's exacerbations, and then there's mimics of exacerbations. And then, of course, they can happen together. I mean, a person can have exacerbation and also blow a pneumo. So they can have two reasons for getting bad. There's COPD and a complication of it. Remember those mimic lists on the right there. Remember that if it's sudden versus progressive in the question, they're giving you the answer. They're telling you that it's one of these things they're looking for. If they tell you it's sudden, they're thinking about one of those 3 things. And I'm going to show you some examples of them. Now, the sickest patients that we see, whether it's trauma, whether it's not a trauma case, what is their position? Are they standing up? They're lying down on their back, And the x-ray machine that we're using to take an x-ray of them is the same one that was used in World War II, right? You've all got that machine in your ER, right? It's not the nice one in the ER department, or in the radiology department. It's the old World War II version, right? And the patient's on the bed, and you're getting kind of a hurried picture in a crazy situation. They're never really as good as the ones from the x-ray department. And one thing that we know now is what percentage of pneumothoraces don't show up on just a plain old supine patient? Over half. So we now know that this plain old trauma bay film that we're doing misses half of pneumothoraces. Wow. One of the signs, and so we're always looking for that pleural line, right? We're all looking for that pleural line of pneumothorax. And you don't find it often. Sometimes you see nothing, and the pneumo will only show up on CT, but a lot of times you see what's called the deep sulcus sign. Don't miss this. You can see there on the left side, the patient, their lung doesn't stop, it goes all the way down. And that's because pneumothoraces in patients that are supine, just imagine I'm lying on my back, the pneumothorax collects anteriorly in front of the diaphragm. And so that's why the x-ray looks like that. But of course, when you don't see a pleural line, because just imagine if you're taking an x-ray down at this patient, the CT kind of helps you to kind of visualize this, you're not going to see the typical pleural line that you're looking for in pneumothorax. And yet, look at this patient has a big pneumothorax. So they might have a deep sulcus sign on their x-ray. So look for that. Now here's another one that's very important. This is a mistake that I've made a couple of times, and I like to talk about it to have other people not repeat my mistake. Basically, it's really, really, really important, guys. You know, asthma and COPD, they get bullous disease. They get blebs, right? They get these deformities of their lungs. And it's really frustrating because they can look like a pneumothorax, right, on the x-ray and mimic a pneumothorax. And of course, what would happen if you think it's a pneumothorax and you stick a chest tube into a bulla or a bleb? Then you cause a pneumothorax. So look at this patient on the left here. You know, they've got a pleural line. It doesn't look like a typical pneumothorax. It looks like maybe a pneumothorax in someone who had previous scarring. I don't know. But then when the chest tube is inserted, look what happens. Now we wanted a pneumothorax bad enough, we made one, right? And so that's important. So every time you have something that doesn't look quite like a normal pneumothorax, if you think it's a borderline case, check a previous x-ray, do a CT, because the stakes are high here. If you make the wrong call and it was a bleb and not a pneumothorax, you could kill them. Oh, sorry, wrong way. Sometimes blebs are really easy to see and no one would make the mistake. I mean, there's a big bleb, but I don't think any of us are going to stick a chest tube in there. We're like, that looks like a hole in the lung. It's a bleb. It's not a pneumo. CT will almost always clear this up because the CT will show that the septations are going right to the periphery of the lung. This is a very important x-ray. Take a look at this for a second. This is another pneumonia mimic, and these are the patients that might have a sudden worsening with their COPD. And what it is that a small mucus plug has plugged up the entry to the right middle lobe here, and the right middle lobe is now collapsed. And this is really important because our natural response, I'm going to go into this on another slide, but our natural response when we see some white schmutz on an x-ray is it's almost like a reflex. We give, ceftriaxone, or we give levofloxacin or something, which we shouldn't do, by the way. What happened in this case is that if you look at it, there's no air bronchograms, which you get in pneumonia. What is pneumonia? Pneumonia is pus in the airways, right? So you have your pus in the air spaces, right? So you have your airways, and then you have your air spaces, and you just fill up the air spaces with pus. That's sort of pneumonia. That's what most pneumonias are. That's why you have air bronchograms, because you have tubes flowing to these pus-filled alveoli. But in this case, what's happened is there's no air bronchograms, and look what's happened to the right diaphragm. The right hemidiaphragm has been pulled right up. Pneumonia, because it's a filling of pus, doesn't cause volume loss, doesn't cause shifting of the mediastinum, doesn't cause the diaphragm to change. If you have a whiteout like that with no air bronchograms, you can see it's pulling up the diaphragm. That's lobar collapse, that's atelectasis. That's not pneumonia. And the treatment for that is critical. That patient after their tube needs to go straight to the bronch suite, and they need to get that mucus plug sucked out. And if they do, they're going to have a lot more lung to work with, and they'll survive. So those are important x-rays to know. Don't forget those few x-rays that I show you, very important patterns. In terms of the treatment, the bread and butter treatment of an acute exacerbation, how this differs from asthma is that we consider albuterol and Atrovent, ipratropium bromide to be the first-line treatments together. They're both considered equally efficacious and indicated. Steroids are indicated, just like they are in asthma. Antibiotics are indicated if they have an increase and a change in sputum. And then non-invasive ventilation here, just like Amel's comments about its use in CHF, actually the same is true in COPD. And this is fascinating, right? Because you probably remember, and we lived through this, right? We remember they came out with BiPAP, and we were like, oh, this is a great treatment for CHF. It's going to help to decompress the fluid on the lungs, and it's going to improve their oxygenation. It makes total sense. It's going to decrease their Oh yeah, it makes sense physiologically, right? But for asthma and COPD, well, this ain't going to work, right? What's the problem with asthma? They can't exhale, and you're going to stick a mask on them and push air into them, right? And we were like, oh, that's not going to work. We didn't even try it. Initially, it was like, well, it just doesn't make any sense. And then they started using it, and lo and behold, this non-invasive ventilation is actually a bigger game changer in COPD, in my opinion, than it is in CHF. They get better. They don't need any drugs, and they get better. Our numbers needed to treat to prevent an intubation or ICU stay is phenomenal. We're talking numbers better than aspirin and MI here, like 4, 5, 6, 7, 8, under 10, it's great. And so it's like, why does this work? Who cares? Did anyone hear me? Yeah, I mean, that's a lot of things are like that, right? You know, it's funny because we were almost talking about Naseritide, right, and how it didn't pan out. But remember how they were coming to talk to us about Naseritide? They're saying, look, it makes total sense. It cuts the renin here, and this is how it does, and here's the whole renin-angiotensin system that you never understood in the first place. Look, see, this is a magic bullet. Only problem is it didn't work, right? And so this one, it didn't seem to make sense that it worked, and it worked. And I think the reason that it works is that it helps splint them, it helps take all this ATP consumption, all this energy consumption out of their exhausted chest wall. It opens alveoli by stenting, apparently, and so it's a wonderful thing. One thing about NIV is that you don't wait 2 hours until the patient's nearly dead to use it. When a patient comes in, and this is how it's been studied, when a patient comes in sick with COPD, you immediately get RT down there. You immediately start coaching them because they need to be coached with this. You guys know that, right? This is all hands on deck. You're with the patient, you're coaching them, you're reassuring them that this is helping them. That's important. In terms of things that we've done that we've proved increase the lifespan of someone with COPD, as far as I know, there's only these two things. And I'm hoping that, and maybe I'm just not aware of it, but I'm hoping that pretty sure we're going to have strong evidence that vaccination is really saving lives for these people. I'm really into this vaccination stuff. I mean, they die of strep pneumo. Everyone dies of strep pneumo. Why not vaccinate them? So I'm big on that. But what I want to make sure that people know about is that first point there about the disease-altering interventions that we know that are proven to work. Now we know smoking cessation works, so that's a given. And don't be cynical about that. Don't be cynical about your ability as an empathic caring physician in that visit to make an impact. Don't forget about that. Not that I'm preaching that they don't smoke while I'm treating patients with COPD, but your support and the support of the family doctors are very important. And we shouldn't be cynical about them. They do yield results. Now, in terms of home oxygen, this is a very important point I want to make here. Okay, and it's one that I think a lot of people find confusing, including myself. You know, have you ever tried to get home oxygen for a patient and you have to fill out all the values on the forms and they're real sticklers about the PO2 and they have to fall within certain requirements? The reason for that is that the reason we use home oxygen, of course it makes people feel better that have COPD. I'm not disputing that. But insurers don't often want to pay for it until it's used for people with very low PO2. And that's because it actually modifies the disease. So the reason we use oxygen on these patients is not really just for symptomatic relief. It's because when the PO2 drops too low in their lungs, that's what causes cor pulmonale. So think about that for a second. Even though the patient might feel okay and they're mentating okay, and they actually think they're okay, and their hemoglobin is carrying enough oxygen because they're polycythemic, they've adjusted for it. They've compensated for it. The blue bloater has compensated with his hemoglobin. But the one thing that is still a problem is that there's a low PO2 in the lungs, and that's the mechanism by which the lungs how they fibrose. That's how they get damaged and cor pulmonale starts. And so the reason we're using oxygen on these patients is to prevent cor pulmonale. When it comes to ARDS, I've got great news for you, because you've been hearing that there's new terms for ARDS. There's ALI, and there's this ALI, ARDS spectrum, and none of it matters for us as emergency doctors. And I am going to make this so dead simple for you. Do not overthink these questions, okay? Basically, it's like this. When you got a chest x-ray and you've got lots of edema on it, you got to ask yourself on the exam, is the heart big or is the heart small? It's so binary and simplistic on the exam. If the heart is big, then it's cardiogenic pulmonary edema. If the heart is small, it's non-cardiogenic pulmonary edema. Whether we call it ARDS or ALI is not important. And the questions will be very straightforward. They will basically tell you that the heart is functioning normally with this situation of pulmonary edema, or the heart is not functioning normally. And that's as much as you need to evaluate it. The causes of acute lung injury ARDS are protein, and this, folks, is just analogous to the situation I talked about yesterday when I was talking about ATN. ATN is how kidneys contribute to multi-system organ failure. ARDS is how the lungs play their role. And the things that cause it, of course, are protein. All these things cause it. It's the final common pathway. Again, the questions on this will be dead simple, because what they're going to try to do is try to get you to hook on, to latch on to treatments for CHF when it's really non-cardiogenic pulmonary edema. And none of the treatments for CHF work on ARDS. So when they try to get you to bite on the furosemide, you say no. Nitrates, no. ACE inhibitors, no. Nothing like that works for this disease. The only thing that works for patients with ARDS is, like it says there, not overventilating them. The same discussion that we had about asthma. The same principles of permissive hypercapnia. The same concept of not keeping that O2 sat at 100%. It's far too high. One of my favorite exercises is to look at an x-ray with white schmutz on it and ask myself, what am I really missing here? Is this really pneumonia or is it something else? And I've taken to making this list of all the things over the years that I have called pneumonia in my wisdom and have been terribly, terribly wrong. And it's a very important list. Some of these things are straightforward. I mean, something that looks like a pneumonia, if you read the question properly, might be, oh my goodness, it's an environmental exposure. They're getting at ARDS here, that kind of thing. But sometimes they're really tough. One thing that I want to make a special note of is right-sided endocarditis. Amal talked about this a little bit. Any patient who comes in with pneumonia infiltrates on their x-ray, who's also got IV drug use, or an indwelling catheter, any reason to have circulating bacteremia, you don't call that pneumonia. You call it septic emboli from right-sided endocarditis until ruled out. I mean, I don't take a sick patient who's a drug user with multiple pulmonary infiltrates in my emergency department and start them on pneumonia treatment and admit them. I get them an echo right away. Now, the other thing I want you to know about there that makes for a great test question is, could you please circle diffuse alveolar hemorrhage for me? I want to tell you about that patient, because that's a patient that I've missed with bad consequences, okay? If you want to put something as a memory aid beside it, it's the only disease that I can think about calling a rheumatologist for at 3 in the morning. That's how I remember it. And what it is a patient comes in, these are patients with immunocompromise, bone marrow transplant, lupus, granulomatosis, these types of diseases, these chronic diseases. They come in with pulmonary infiltrates, really sick, maybe a little hypoxic, and if you're lucky, they give you the major clue, which is there's hemoptysis going on. They're bleeding from all over their lungs. And they'll often be anemic as a tip-off. And the reason why it's such an important diagnosis is that if you get these patients and identify them early, and you put them on massive, massive doses of steroids, cyclophosphamide, other immunomodulatory agents, you can fix it. You can get them through this episode. If you don't, it's an inevitable death within 24, 48 hours type thing. Really important. And so I would, if I think I'm dealing with this, I would call the rheumatologist, because the kind of doses of steroids that you're giving are just like, oh my God, I didn't know you could give that much steroids. And so that's a really important entity. Diffuse alveolar hemorrhage. Now, for that matter, that x-ray on the left could be diffuse alveolar hemorrhage. I told you earlier today to not get overly focused on the images and to err on the side of rereading the question. I think that's important. Some of these images could be consistent with so many different things. When you see multiple cannonballs, Could that be tuberculosis? Yeah. Could it be septic emboli? Yeah. Could it be cancer with Mets? Yeah. Okay? It's not necessarily going to tell you the right answer just by having the image. It's consistent with many things. The Hampton's hump on the right is something that, just looking at that, is fairly specific. If they're hinting at pulmonary embolus in the question and they've got a round pleural-based lesion like that, it's probably a Hampton's hump, not a pneumonia. Now, at ABEM General in Chicago, they're different than you and I. When you diagnose pneumonia, you write down pneumonia because you're normal, okay? Now, on the test and at ABEM General, they're very smart. They're smarter than all of us, and they write down pneumonia, Klebsiella. And they know what it is, apparently. Now, it's a little bit tongue-in-cheek, but there are these constellations, these classic patterns that are in the textbooks that test makers have a hard time letting go of. Now, we all know that the difference between atypical and typical pneumonias, for example, is not always there. We know that kids can have mycoplasma but have lobar infiltrates. We know that folks with strep pneumonia sometimes look like what we were taught mycoplasma looks like. We know that there's a tremendous variation. But for the test, please embrace these money slides for me, and they will get you a bunch of questions right. If they give you an alcoholic with a bulging right upper fissure, okay, minor fissure, give them Klebsiella. That's what they want. Just give it to them. If they give you the guy who wakes up with the single rigor, and then in the morning, of course, the rusty-colored sputum comes up, give them strep pneumo, because that's what they want, okay? And just stick to this, because that gives you a couple extra points. Now, when it comes to the images, again, you're going to have a broad mind here. There's a typical lobar pneumonia there. That could be pneumococcus. The commonest cause of everything is strep pneumo, right? Pneumonia, meningitis, bacteremia, you name it. Strep pneumo is really the winner. Right upper lobe pneumonia with the bulging fissure, that's the classic Klebsiella. What kind of sputum is that gentleman going to have? Of course, red currant jelly sputum. Right? That's how you diagnose that. When it comes to effusions, it's a bit confusing because the commonest cause of an effusion is strep pneumo, but that's just because that's the commonest cause of everything. I just said that, right? So many pneumonias are strep pneumo that, okay, a few of them have effusions. But if you are like me, you look at an effusion, the first thing you don't think of is strep pneumo. You think of worse things. You think of staph and TB and anaerobic things, right? And so have your mind go there first when you see those effusions. But probably the most important thing about this slide is what's in that yellow box. And this, again, it's on the test, but it's also in real life. If someone comes in and they have a right-sided effusion, that can be consistent with just CHF, right? But if it's just a left-sided effusion that they're showing you, please think about these completely unrelated emergencies. Left-sided effusion alone always makes me think of Boerhaav's, and always makes me think of a type B dissection, which can rip into the thorax on the left side and cause a hemothorax. Don't forget those. That's an important one to circle, those left-sided isolated effusions. When it comes to cavitation, you got to think about anaerobes, got to think about abscesses. This one here is probably just that, probably an anaerobic. It could be staph. It's less likely to be TB because it's full of fluid here in its location. So I would probably be thinking that that's one of the first three. Now, this concept of pneumonia plus is important, okay? So many of the questions that relate to pulmonary infections and pneumonias will be about identifying the constellation of pneumonia plus. So we've talked about that money slide where it has all the characteristic things about the different common pathogens. Now we're also going to show some less common pathogens and some very testable pathogens. So when it comes to the atypical pneumonias, I want to remind you all that the reason why we call them atypical is simply because they don't show up on a routine gram stain. But the fact of the matter is that for the purposes of the test, they're very different types of agents. Mycoplasma and chlamydia will tend to appear on the test as the more walking pneumonia, the more scattered infiltrates, non-life-threatening. And when they give it to you, if it's the mycoplasma, it's almost always going to have one of these extrapulmonary findings. So if they give you pneumonia plus Guillain-Barré, they give you pneumonia plus people's fingers turning white in the cold agglutinin disease, people with bubbles on their tympanic membrane, all these things that go along, or erythema multiforme, they're getting at mycoplasma. Even though in real life it could be other agents, they're getting at mycoplasma. Chlamydia, if they give you, it's the non-toxic kid with the staccato cough, and maybe he's got a pussed out eye from a birth canal infection, or maybe it's a college kid that presents just like mycoplasma. Even though Legionella appears on this same table because it is in fact atypical, it doesn't show up on the common gram stain on the test, it's going to behave exactly the opposite of these first two. Legionella pneumonia is the atypical that's going to present with a typical pattern. They're going to have lobar consolidations and they're going to have a life-threatening lobar pneumonia with it. You'll never get a Legionella question wrong because if you look at that special features things, they're going to give you the hints. They're going to tell you prominent GI symptoms. They're going to tell you the patient has abnormal LFTs. They're going to tell you something about the fact that it was a convention and 2 people got sick and there was an air conditioner. They're going to give you something to get it right. And they're sick as dogs. They're very sick with Legionella. Remember that a multitude of things explain a multitude of x-rays. And so if this, this x-ray here, it could be about mycoplasma, chlamydia, it could be about viral pneumonia. But don't forget, if it's about a patient with an environmental exposure, it could also be early ARDS, right? And so again, the question will trump the x-ray. This is a typical mycoplasma x-ray. This is what I told you, in a Legionella, and although it's an atypical agent, it presents with very scary looking, very scary looking multilobar pneumonias, and these patients often die. Now, these agents here are agents that are very testable because you just don't see that often. You might not live in the areas where they're common, and I want you to commit this chart to memory. I put everything on here that I think can get these questions right for you, okay? And again, I want you to follow this theme of giving them what they want. So when they give you the person that's from the San Joaquin Valley that comes in with 3 weeks of grumbling pneumonia, and they've got erythema nodosum, they'll show you a picture of it, you give them the fungus that they're looking for, the blasto, the histo, the coccidioido. When they give you the pneumonia, but they also give you a sheep or a goat, you give them Q fever. Thank you for that punctuation. If they give you a bird, you give them psittacosis, okay? You got to give these folks what they want. I think we're going to, are we breaking or are we, we're breaking? Okay, so let me do one more before a couple more before the break. So fungal pneumonia, just to finish on that train of thought, is very classic on the exam. I wish it was so easy in real life. They come from one of the endemic areas, Ohio River Valley, San Joaquin Valley, where we are in California. They come in with 3 weeks of symptoms, subacute. They come in with bilateral adenopathy on their chest, you can see diffuse infiltrates, and don't forget, erythema nodosum. This is a gram stain slide, and it actually shows up better here than it does in your books because of the color coding. Remember that the gram positives are purple-blue there, and I've highlighted anthrax because it's one of the few things that can come up on the test as a gram-positive rod. I'll show you a picture of that. And I've put plague on there too because that's also something that can come up a gram-negative rod. You'll notice that the last 3 entries there are white. There's no color code because they're atypicals and they don't show up on the typical gram stain. This is easily testable, and although you don't have microscopes where we work, they do at ABEM General, and this is the commonest cause of bacterial death, isn't it? And it's a strep pneumo. It's the commonest cause of otitis, pneumonia, bacteremia. It's a really big one, so it might come on. And this one is kind of exceptional in the way that it looks. It looks so classic. There aren't many gram-positive bacilli that you need to worry about. This is probably the only one. And it's got that classic boxcar appearance, very symmetrical squares. That's likely to come up on some of these test questions as well. So that's where I think, the next one is the antibiotic treatment. That's where I'm going to leave it, and we're going to break and come back. Can you yell out to me a time so I know? 15 minutes, we'll see you back here.
The things that increase filling and therefore decrease the murmur, well, Trendelenburg, hand grip exercises like isometrics, and then beta agonists, or rather alpha agonists, and then volume expansion. All right. So again, things that decrease preload or increase the murmur: standing Valsalva, amyl nitrate, beta agonists. Things that increase the afterload, which decreases the murmur, are squatting, Trendelenburg, hand grip, and alpha agonists. All right. If you only want to remember 2 for each one, what are the things that increase the murmur? Remember standing and Valsalva. What are the things that decrease the murmur? Remember squatting and Trendelenburg. And that makes sense. You put somebody's feet up in the air in Trendelenburg, that's going to increase filling, and that'll decrease the intensity of the murmur. So please remember the maneuvers that change the murmur. All right. Chest X-ray is not helpful. It's got a normal size heart because the hypertrophy is on the inside. And the EKG, I think the EKG is something that you probably ought to know. The EKG typically will show high voltage. So if you take a look up here, you'll see really giant QRS complexes. And then the other thing that's classic, the other thing to look for is these very deep, narrow Q waves. We call them dagger-like Q waves. Often in the lateral leads, you take a look at lead 1, you see very narrow, very deep out there in AVL. There's just nothing else in cardiology that produces deep, narrow, huge, deep, narrow dagger-like Q waves like this. All right. Now, don't make the mistake of looking at this and saying, "Oh, this is an old lateral infarct." These are not infarction Q waves. They're too narrow. Remember, infarction Q waves have to be at least 1 box wide. These are too narrow. So when you see Q waves that are dagger, like very deep, very narrow, in conjunction with high voltage, especially in somebody who had syncope or exertional syncope, your diagnosis is hypertrophic cardiomyopathy. Right? And how do you diagnose this? The definitive diagnosis: send them for Doppler echo, and you just saved a kid's life. Right? Because there are now surgical therapies and chemical therapies that can help treat hypertrophic cardiomyopathy. What if you can't get the Doppler echo right away and you need to discharge them for an outpatient Doppler echo? What do you put them on? How do you treat them? Well, number 1, no exertion. You tell them to be a couch potato until they get the diagnostic test. And number 2, put them on a beta blocker. Remember, this is a diastolic problem. It's a filling problem. How do you improve diastolic function? Very simple. You slow down the heart. Slow down the heart, give the heart more time for filling. It'll improve diastolic function. So outpatient treatment until they get the Doppler echo, no exertion, and you put them on a beta blocker. If they can't tolerate beta blockers for some reason, you put them on a calcium channel blocker. All right? But you never use DIG. They don't need a positive inotrope. You don't need DIG. They've already got good systolic function. You don't need afterload reducers. They've already got good systolic function. All right, and then if the Doppler echo confirms the diagnosis, then you're going to get them in to see cardiology. Okay, pericarditis and myocarditis we'll talk about. Pericarditis is definitely one of the conditions that we think about every day. Maybe we don't diagnose it, but you think about it every time you see ST elevation. You're thinking, could this be pericarditis? There's a handful of causes. Viruses are most common, but there are other types of causes. Bacterial, TB. You can get uremic pericarditis in these patients who miss dialysis. And so your treatment's aimed at what the underlying cause is. If there's no simple diagnosis, if it's uremic, you're going to send them for dialysis. If it's TB or bacterial, you're going to treat them with the appropriate antibiotics or anti-TB medications. But the majority of cases end up being viral or idiopathic. And in those cases, you're just going to use aspirin and NSAIDs, we'll get to in a second. We talked about Dressler syndrome, neoplasm, urine. There's a lot of different causes, but remember, viruses are the most common cause. Classic presentation: pleuritic, sharp chest pain that radiates to the trapezius ridge. Now, I used to think that this is the trapezius ridge, and it's actually not. The trapezius ridge is the bottom of the traps in the mid-back area. All right? So a lot of patients will complain of pain going through to the mid-back, and I've always thought, oh my God, it's a dissection. You know what? In reality, a lot of those are probably subclinical cases of pericarditis. But that's classic. Sharp chest pain radiating to the trapezius ridge, which is lower down in the back than I thought. It tends to be pleuritic, and one of the key features is that it's positional. It's better sitting up and leaning forward. It's worse laying back. The rub also changes. The rub is more prominent when they sit up and lean forward. The rub is less prominent when they lean back. So if they give you any positional change to the chest pain, it's got to be pericarditis. In real life, the other thing that changes with position might be reflux, but reflux doesn't exist at ABEM General Hospital. So it makes it very easy. If they give you positional change, think about pericarditis. And the rub increases when they lean forward. They may give you a fever if they're being nice. A lot of patients don't have a fever. You don't always have that recent viral syndrome, which is classic. We talked about the rub already. I can't imagine they're going to expect you to pick up or know about pulsus paradoxus, but that is part of the description that you may get, all right? And then the EKG, you're going to have to pick this up. There's 4 classic stages. Almost always what we diagnose in the ED is stage number 1. Stage 1 pericarditis is the classic ST elevation that's concave upwards. Take a look at the ST elevation. Remember, it's concave upwards. If it were horizontal or convex, it's got to be a STEMI. But concave upwards can be pericarditis, can be anything, but pericarditis has to be concave upwards. You'll also notice in those leads that there's some PR segment downsloping or PR depression. And I think on the board exam, they'll probably want you to pick up this diagnosis if they give you an EKG that's got concave upwards ST elevation in multiple leads and also PR downsloping or PR depression. That's what you're going to look for. That's stage 1. All right. Stage 2, everything normalizes. Stage 3, the T waves flip. Stage 4, things normalize again. Now, I don't know if they're going to ask you about these 4 stages, but if they did, what I would imagine is they'll take these 4 stages and they'll mix them up in different combinations and they'll say, what's the proper order? All right. So just remember, stage 1 is classic. Stage 2 is normal. Stage 3, T waves flip. Stage 4, things normalize once again. All right. To go from stage 1 all the way through stage 4 probably takes a couple of weeks or maybe a month or longer, and I don't think any of us have waiting rooms times even that long. So stage 1 is what you're going to be on the lookout for. Chest X-ray is usually normal unless they've got a big effusion. If they have a big pericardial effusion, which is the big complication we worry about, then you might see cardiomegaly. These patients, other complications, they can develop atrial arrhythmias. Typically, they're atrial arrhythmias, and they can develop pericardial tamponade. Right? How do you treat pericarditis? Well, high-dose NSAIDs or high-dose aspirin. Take your pick. In Europe, it's more popular to use high-dose aspirin. In the US, we use high-dose NSAIDs. It doesn't matter, either one. But then also add colchicine. Multiple studies have found that colchicine works through different anti-inflammatory pathways, and the addition of colchicine, not colchicine by itself, but the addition of colchicine to the aspirin or NSAIDs hastens pain resolution, it decreases the pain, and it also decreases the likelihood of recurrence. So put them on colchicine if they give that an option to you. And then what about steroids? I would say in the year 2019, steroids are out. All right, they kind of come and go, but right now, I'd say the past 10 years or so, steroids have largely been out. So if you want to turf that to the people upstairs, the rheumatologists upstairs, if they do a workup and discover it's autoimmune, they want to start steroids, fine, go right ahead. But routinely using steroids in the ED has been found to increase the likelihood of recurrence. So I would just say that on that board exam, don't give steroids to any pericarditis patients. It can be done upstairs if indicated. All right, pericardial tamponade is the big concern that we have with pericarditis. Think about this with Beck's triad. Remember, hypotension, JVD, and muffled heart sounds. The EKG classically shows you electrical alternans. What does classically means? It means it's in the textbooks on the boards, but in real life, actually, only about 1/3 of patients have electrical alternans, even with large pericardial effusions. And then on echo, your catchwords, your key words to look for are right-sided diastolic collapse. If somebody has a lot of fluid around their heart, pushing inwards on the heart, the weaker side of the heart tends to bow inwards during diastole, during relaxation. So the weaker side is the right side. So during diastole, the right side of the heart, right atrium, right ventricle, bow inward or collapse. So if they give you a description of an echo and they say that during the echo, the right atrium or right ventricle collapses or bows inward during diastole, bells should go off. That means the patient has tamponade. All right? And don't confuse tamponade with effusion. Patients can have large pericardial effusions and be perfectly stable. A tamponade means they have a large effusion and they're unstable, or they have a large effusion and have a positive echo, described up there. All right? So hypotension with the effusion or positive echo with right heart diastolic collapse. with the effusion, that means the patient also has tamponade. And this would be a very, very classic EKG indicating that a patient has large pericardial effusion. There's a classic triad to be on the lookout for. All three are in this EKG. You've got low voltage. Take a look at how small those QRS complexes are. So low voltage, tachycardia, and electrical alternance. You see a nice example of alternance right up there in V1. See how the QRS gets bigger, smaller, beat-to-beat variation in the size of the QRS. In real life, alternance is less than a third, but on that board exam, I think probably it'll approach 100% if there's a big effusion. All right, so tachycardia, low voltage, and pericardial and electrical alternance, that means there's a big effusion. If I also told you that this patient's hypotensive, then it's tamponade. Or if I also told you that this patient has right-sided diastolic collapse, then that means there's also tamponade, all right? For those people that are not comfortable with echo, this is not a difficult diagnosis. And they'll show you images of this. They probably won't give you letters and arrows, but it won't be that tough, right? If you're not comfortable with ultrasound, just Google search a handful of images of pericardial effusion. They're not going to give you a sliver-sized effusion. They'll give you a fairly sizable effusion, and you should be able to diagnose what an effusion looks like on bedside echo. Now, most everything I said about pericarditis also applies to myocarditis. Certainly the underlying causes, viruses are very common, especially parvo B19 and Coxsackie. Those tend to be the most common. This is often another one of those misdiagnoses of flu. Summer flu in particular. If you ever diagnose flu in the middle of summertime, take a step back and think, could this be myocarditis? This is an often missed diagnosis. Classically, the patients present with fever tachycardia out of proportion of fever. What does that mean? Well, normally as your temperature goes up, for every 1 degree your temperature goes up, your heart rate usually goes up by about 10. So it's pretty common to see a person with a fever of 101 and a heart rate of about 110. Fever of 102, heart rate's about 120 or 125. Tachycardia out of proportion to fever means they have a fever of, say, 100.5, and the heart rate's 140. It's way out of proportion, all right? So that's one of the things to think about, especially in kids. And then the other tip-off that you're dealing with myocarditis is you've got a young, otherwise healthy patient, no medical problems, who comes in with heart failure, dyspnea on exertion, orthopnea. Why in the world would this young, healthy person who runs regularly, exercises, non-smoker, et cetera, comes in and now he's got heart failure? Think myocarditis. Or in fact, even if all you have is cardiomegaly, if they give you an x-ray that shows cardiomegaly for no good reason in a healthy person, think about myocarditis. These patients are at risk for all types of arrhythmias, anything under the sun. They can have ST elevation, ST depression, fascicular blocks, bundle branch blocks. VTAC, of course, is the most worrisome type of arrhythmia. And all we can do for these patients is to just support them. There's no magical treatment. Aspirin, colchicine, no, that's pericarditis. This is different. This is myocardial injury, so just hemodynamic support, all right? And keep your fingers crossed that they end up getting better. Myocarditis looks a lot like a STEMI, all right? Remember the rules we said about pericarditis EKG? It's always got to be concave upwards. You're not supposed to have reciprocal change. You're supposed to have PR depression. That's pericarditis. All bets are off with myocarditis because now you've got myocardial injury. So you can have convex ST elevation. You can have reciprocal change. You don't always have PR depression. Myocarditis can look exactly like a true STEMI, and in fact, because of myocardial injury, you can have marked elevation of troponins as well, and as a result, oftentimes the only way to diagnose this is in the cath lab after they squirt the dye and see clean coronaries. In fact, a lot of diagnoses of myocarditis are made retrospectively after the cath comes back negative. All right? So you should never have to apologize for sending somebody to the cath lab who ends up having myocarditis. Best test is going to be echo. All right? Definitive diagnosis or more definitive diagnosis is probably cardiac MRI. We can't really get that from the ED. So if you're in the ED, get an echo. You're going to look for myocardial dysfunction, wall motion abnormality. You're looking for effusions. But if you really suspect a diagnosis, cardiac MRI tends to be the best test. And again, treatment is really just supportive, right? All right, another little mental break here. I love this sign. Caution, this sign has sharp edges. Do not touch the edges of this sign. And then in really small print, also the bridge is out ahead. All right. And this was sent to me by somebody in Boston about 5 years ago when they had that god-awful winter with about 14 feet of snow. So, and this is from a colleague, former colleague. So, all right, let's keep marching forward here. Talk about hypertension. Again, something that we deal with all the time. We'll talk about hypertensive emergency and hypertensive urgency. All right, hypertensive emergency is when the patient's blood pressure is really high and the patient is in acute distress. Hypertensive urgency is when the patient's blood pressure is really high and the staff is in acute distress, all right? But the patient's just chilling, right? They're perfectly fine. They're asymptomatic. A lot of people say hypertensive urgency is a non-diagnosis, and it really is, but we still talk about it because so many people still throw the term around. Bottom line here is that if somebody doesn't have evidence of acute end organ damage, it's not an emergency. If it's simply elevated blood pressure, all of our national guidelines say if there's severe hypertension, but there's no evidence of acute end organ damage, you can send them home. You don't need to try to lower the blood pressure in the ED to any special number. Just send them home. But the key thing to do is try to ensure close follow-up. That's it. That's what we should do. Ensure close follow-up for these patients so that they can get started on a blood pressure medicine. All right? But case after case after case we see of physicians or whatever saying, oh my God, I can't send this person home with the blood pressure this high, so we've got to acutely lower it before we send them home, and they acutely lower it and the patient has a stroke or an MI. All right? So just send them out. Don't be baited into treating these patients. If there's evidence of acute end organ damage, then you do have to treat. And the recommendations in general are lower the MAP by about 25 to 30%, not more than that, and do it over the course of an hour or so. There's no immediate rush. It doesn't have to be in the next 10 minutes. Just gradually lower it over an hour, and ideally you want to use a titratable medication because they're sick patients. They have acute end organ damage. What are the acute end organs you worry about? Well, you worry about the brain, and that would include the eyes as well. You worry about the heart, and that could include ACS. You worry about the lungs. I put lungs in there. That's really a heart problem, but pulmonary edema I would consider a hypertensive emergency if their blood pressure is through the roof. The aorta, which we'll talk more about in detail in a few minutes. Acute renal failure, so you worry about the kidneys as well. And then in the OB section, you'll hear more about eclampsia. Some people would say eclampsia is a hypertensive emergency. Catecholamine overdose, catecholamine crisis, you'll hear more about in the talk section. Some people consider that a hypertensive emergency also. But the main organs you worry about are the brain, including the eyes, the heart, lungs, aorta, and the kidneys. Those are the organs that you're looking for signs of acute end organ damage. All right? In terms of the brain, you worry about encephalopathy. So if they are altered mental status, then that would qualify as a hypertensive emergency in the setting of severe hypertension. And then either ischemic or a hemorrhagic stroke. And I've listed up there some of the typical medications that often are used. Nitroprusside is kind of the hallmark medication. People have largely switched from that to labetalol and also nicardipine, clofidipine. We'll get to those in a bit. Ischemic stroke, again, you want to try to bring the blood pressure down, especially if they qualify for TPA. And in the neuro lecture, you're going to hear about the specific parameters that you need to get stroke patients down to in order to qualify for TPA. But in general, we're still talking about a 25 to 30% reduction. All right? We'll talk more about the drugs in just a minute or so. If somebody's having ACS in the presence of markedly elevated blood pressure, nitroglycerin is probably your drug of choice. Use a high-dose nitro drip. If that alone is not cutting it, you've got your nitro drip up to 400 or 500 mics a minute and it's still markedly elevated, then you might want to add nitroprusside there. But your first line is going to be nitroglycerin, high-dose nitro. Aortic dissection. You want to bring the heart rate down and the blood pressure down. Heart rate, use a titratable agent like esmolol. Blood pressure, you can use nitroprusside. There's some other newer ones. You can use nicardipine. You can use clofidipine and so on. We'll talk more about dissection in just a little bit. And then for the catecholamine crises, you'll hear more about this in the talk section, but cocaine overdose or pheochromocytoma, the concern here is that if you give these patients, say, labetalol or a primary beta blocker, you get unopposed alpha activity, and that can actually make your blood pressure worse. So generally, if you have a catecholamine crisis, go with high-dose benzos, put the brain to sleep. That often will decrease the catecholamine surges. And if that alone doesn't cut it, you might also consider phentolamine. This is a one time to think about phentolamine, which is a direct alpha blocker. Phentolamine can be nice to keep in your back pocket for those cocaine overdoses when high-dose benzos aren't cutting it, or for pheochromocytoma, on the board exam in particular. All right? Labetalol, people love labetalol, but as we'll talk about in just a second, labetalol, although it is a combined alpha and beta, labetalol is 7 times more beta than alpha. So labetalol is really a beta blocker with just a touch of alpha, so it usually doesn't get your blood pressure exactly where you want it. All right, so let's talk briefly about some of the key drugs. We'll start with nitroprusside. Nitroprusside could be considered the hallmark drug against which everything else is compared. Nitroprusside is great because it's so titratable. It's really quick on, and it's really quick off. And the quick off is important because if you run into problems, you can hit the off button and it's gone in a minute or two. Right? There's no other drug which is as quick on and off as nitroprusside, and that's why it's always been considered kind of the hallmark or drug of choice upon which everything else is compared. Now, over the years, we've come to discover that there are some drawbacks to nitroprusside. Number one, it can give you reflex tachycardia, which is not good for cardiac patients. So typically in a cardiac patient, you need to add a beta blocker also. Well, that's okay, we can manage that. Secondly, in patients with renal failure, you can develop a buildup of the byproduct and have cyanide toxicity, or you can develop fetal thiocyanate toxicity in pregnancy. Now, that doesn't happen within an hour. It takes several hours of continuous infusion. So if you ever want to start them on nitroprusside and then switch them over to something different later on, that's okay. All right, but this is the reason why nitroprusside has always been so favored, and also why we're starting to move away from nitroprusside because of these side effects. So what are some other options? Well, labetalol was very popular maybe 10, 15 years ago. It's starting to lose favor for hypertensive crises because we now know it's really a beta blocker with just a little alpha, so it doesn't really do that much to the blood pressure. If you want to start with labetalol, that's perfectly fine, but oftentimes you'll need to add something else also. All right, and obviously stay away from this in CHF or AV blocks or bronchospasm. Nitroglycerin is fantastic. It's very quick on, and it's pretty darn quick off if you run into problems. It goes away in just a few minutes. Problems with nitroglycerin? Well, actually, more benefits of nitroglycerin. It increases coronary vasodilation, so it helps perfuse the heart, which is very good. Drawbacks, if you have somebody on a nitroglycerin drip for more than, say, 4, 5, 6 hours or so, you can develop tachyphylaxis, and it stops working that well. You need to keep running the drip up higher and higher, and then it just stops working. But for acute coronary syndrome and for pulmonary edema, I would consider this the first-line drug in the setting of severe hypertension. And then there's a few more recent additions to our arsenal. Nicardipine. How many people here use nicardipine for your stroke? Yeah, this has become very, very popular amongst the brain patients. Strokes and intracranial hemorrhages. It's pretty darn quick on. It's not too bad in terms of going away. If you run into problems, it can last 4 to 6 hours, but problems and side effects are pretty darn rare in using nicardipine. And so it's a pretty titratable drug, and as a result, a lot of people have really bought into using nicardipine, and we also do. Phenoldiprem is a dopamine agonist, and the one thing to know about phenoldiprem is that it increases renal blood flow. So this is a great medication if you have a chronic kidney disease or a renal failure patient. Right? And that's probably the only time I would consider using it. It's pretty quick on. Look how fast it goes away, 30 to 60 minutes. That's pretty darn fast. We'll probably use phenoldiprem in our emergency department maybe about once a year, and invariably it's always for a renal patient. So that's the one group of patients that you might consider using that in somebody who's in acute renal failure from a hypertensive crisis. And then the one other drug to keep in mind, clovidipine. Clovidipine is becoming more and more popular. It's actually been around since around 2008. Like nicardipine, it is a calcium channel blocker, but the reason it didn't become popular early on is because it was a lot more expensive. And what I've heard is that the company that was making clovidipine bought the company that makes nicardipine and then raised the price on nicardipine. So now they're equal price and people are switching over to clovidipine. That's what I've heard. So anyway, it is actually a very good drug. It's really quick on, and it's about the quickest offset of any other drug outside of nitroprusside. It goes away in 5 to 15 minutes, so it's very titratable. And so a lot of people are now switching from nicardipine over to clovidipine because it's so quick on and so quick off. The one caveat here is that it's made during the making process is made with egg or soy, and so you can't use this in people that have an egg or soy allergy. I don't know if they would ask you that level of specificity on the boards, but it's probably worth keeping in mind for your clinical practice. All right, hydralazine is a big problem. Hydralazine, a lot of people consider the new Procardia because it's not titratable. It can cause precipitous drops in blood pressure. It's also not titratable. It gives you reflex tachycardia. If somebody's chronically on hydralazine, then you can probably use it, but I would recommend just stay away from hydralazine if somebody's not already chronically on it. And, God, if you use hydralazine, start really low. There's case reports out there of people who got hydralazine and they dropped their blood pressure and you can't take it away. And the cases show that it can last 4 hours, even a day or so, right? So that patient remains hypotensive and also reflex tachycardia. So please be careful about that. Okay, let's talk about the aorta now. Again, something that I'm sure that we at least think about every day, so there's probably not much to say that you don't already know. There's a bimodal age distribution, young with predisposing factors and the elderly. What are the predisposing factors in young patients? Well, collagen vascular disorders, Marfan syndrome, pregnancy. Pregnancy is a hyperdynamic state, so late pregnancy can put patients at higher risk for dissection. Cocaine overdose or cocaine ingestion puts patients at higher risk for this as well. So those are the younger patients. And then the older patients, just with all of the Framingham risk factors, those are the patients that you worry about. Classic presentation, abrupt onset of ripping, tearing pain, classically radiating to the back or radiating to other parts of the torso. It tends to be maximum intensity at onset. So cardiac pain tends to have gradual increase over, say, 5-10 minutes or so. Dissection just starts, bam, 10 out of 10 at the moment it begins. Physical exam, everybody thinks about hypertension. That's what we're all taught. But in reality, there's this rule of thirds. About a third of patients are hypertensive, about a third are normotensive, and about a third are hypotensive. Why in the world would you be hypotensive with the dissection? Well, when you have a dissection, you can dissect backwards into the pericardium and develop pericardial effusion and tamponade. And those patients are going to be hypotensive at arrival. In fact, the studies show that the hypotensive dissection patients have the worst prognosis of all, right? So don't assume that everybody is hypertensive. You can have pulse deficits. Sometimes people talk about blood pressure, significant blood pressure differences. I would focus more on pulse deficits. And you can have, if you dissect backwards towards the heart, you can develop tamponade. You can also develop acute aortic regurg, because when you dissect backwards, you can knock out the aortic valve and develop acute aortic regurg. So if they present abrupt onset of chest pain and a new diastolic murmur, boom, there's your diagnosis. It's acute dissection. All right? In fact, there's 3 bad things that can happen when you dissect backwards towards the heart. If you dissect backwards to the heart, you can develop tamponade. If you dissect backwards to the heart, you can develop acute AR. And if you dissect backwards to the heart, you can knock out the RCA and produce an inferior STEMI. So those are the 3 bad things that can happen when you dissect backwards towards the heart. We'll talk about that STEMI in just a moment, right? There's 2 classification systems. There's the DeBakey and there's the Stanford. I think we've largely gotten rid of DeBakey. The Stanford classification is the one that you need to know. There's Stanford A and Stanford B. Stanford A is any dissection that involves any portion of the ascending aorta, and then Stanford B is a dissection that is limited to the descending aorta, or you can think of B as which stands for below the left subclavian. All right, A for ascending, B for below the left subclavian. And why do we need this classification system? Personally, I think the classification system is a waste of time. But the reason they want you to know the classification system is because classically, Stanford A's all go to surgery and Stanford B's require medical management. The reality is all dissections, A and B's, require aggressive medical management, and all dissections, A and B, require emergent surgical consultation. All right? Yes, it's true that A's will go to the OR, but about a third of B's will need to go to the OR also. We'll talk about why that is in just a second. All right? So The red print up here, up to 5% of type A's will have ST elevation. I talked about this already. Some dissections go back and knock out the RCA, and they can develop ST elevation. Where is the ST elevation? It's in the inferior leads, because it's a right coronary artery occlusion. So you'll have an inferior STEMI. All right? I think it would be enormously rare for somebody to have an anterior STEMI with a dissection. So if you're going to have a dissection with a STEMI, it'll be an inferior STEMI. Chest x-ray can show you a very wide mediastinum. Gosh, if they give you an x-ray that looks like this, just consider it a gift. All right? You probably wouldn't. But key thing to know about x-ray is that it can be totally normal also. So don't rely on that x-ray. Diagnostic test of choice, the CAT scan, CT angiogram is now considered your first line test. All right, because it's rapidly available, pretty much everyone has it. It gives you information about the branch vessel occlusions, and the cardiac surgeons are content with the reconstructions. They can use a CTA and decide how to plan their surgery. Now with the advanced level of CT with reconstructions. All right, MRI on the boards, don't bother with MRI. Send people to MRI, that's where they go to die. All right. I think on the board exam, the only person I would really consider getting an MRI on emergently off the top of my head would be if you're worried about a spinal cord problem. All right. But skip the MRI, go right to CTA. Now, if they give you an option of getting a transesophageal echo, take it. Definitely take it. TE is great because it can be done at the bedside no matter how sick the patient is. It gives you information about the branch vessels. It gives you all the information the CT surgeons are going to need. The problem is we usually can't get a TEE. It's very operator dependent. But if they give you an option for a TEE, I would take it. In fact, I don't care what the question is on the boards. If TEE is an option, take it. If they say Mr. Jones sprained his ankle, what imaging test do you want? And TE is listed there, take the TE. Because no doubt what happened is he had a dissection, collapsed, and as he fell, he twisted his ankle. And so you're going to want the TE, all right? So if I see TE as an answer, I'm running with it, all right? Most of the time, unfortunately, you can't get it. Aortography is gone. We can never really get it before. CT angiography gives you all the information that aortography gives you. And how do you treat these patients? Start with heart rate control, use titratable esmolol, and then once you've got the heart rate down into the 60s, take another look at the blood pressure, and if it's still elevated, then add something for blood pressure. All right? You can go with nitroprusside if you want. You can go with nicardipine if you want, but just use an afterload reducer. Key point, though, start with heart rate. Because if you start with the afterload reducer and get your blood pressure down, you're going to get reflex tachycardia, and now you're going to be chasing after that heart rate. So start with the heart rate first. All right? Now, I mentioned earlier, get emergency surgery consultation for everybody. Well, about a third of, while it's true that almost all A's will need surgery, about a third of B's will require surgery also. Think about it. If you have a descending dissection that knocks out the supramesenteric artery, you're going to have dead gut. You need to open that up. You need to go to surgery right away. If you knock out one of the renal arteries, you're going to have a dead kidney. That person needs to go for surgery right away. If it dissects down and knocks out an iliac artery, you're going to have a dead leg. That person needs to go for surgery right away. So a third of Bs require surgery also, and that's the reason I say classification system is useless from my standpoint, because all dissections need aggressive medical management right at the start, and all dissections need immediate surgery consultation right at the start also. All right? So don't assume that A's, you only need surgery and forget about the medical management, and B's, you only need medical management and forget about the surgery. All right? Just get them both going right away. Moving down the aorta to the abdomen, right? Again, AAA is probably something that you think about all the time. The majority of AAAs are infrarenal. What are your risk factors? Think about Framingham, all your cardiac risk factors. Usually you have left flank pain. If the aorta is touching the ureter, you can get shooting pain down to the groin along the path of the ureter, and you can actually drop some red cells into the urine. So think about this, abrupt onset of left flank pain radiating to the groin with microscopic hematuria. This sounds exactly like renal colic, right? And that actually is the most common misdiagnosis. So if you have a patient on the board exam who sounds like renal colic, especially who's not really young, think about ruptured AAA. Right, please think about renal colic. From my standpoint, renal colic in somebody over the age of 40 doesn't exist on the board exam. All right, you've always got to think about a AAA. These patients can present with syncope. They can present with the classic triad of hypotension, pulsatile mass, and abdominal or back pain. What does the word classic mean? It means about less than a third. It means about 15%. And that's actually true, right? Now you might say, well, in fact, a lot of these patients come in with a normal blood pressure. How in the world can you have a ruptured AAA with a normal blood pressure? Well, remember that the abdominal aorta is a retroperitoneal structure. So when it ruptures, or maybe the better term is leaks, when it leaks into the retroperitoneum, it can actually tamponade in that confined space and allow the patient to restabilize their blood pressure. And there's many, many cases of patients that are walking around for hours or days with the ruptured AAA before the full-blown rupture, and then bam, they die, right? And they often get misdiagnosed as muscle strain or something else like that. All right, so don't assume that these patients are all hypotensive. There are some very special presentations to think about. We talked about aorta enteric fistula. So anybody with the previous AAA repair who comes in with GI bleeding, you've got to think about this. It can erode into the IVC and produce a lot of bleeding. And also distal embolization. What does that mean? Well, inside the aneurysm, there's oftentimes a lot of blood and also some calcification inside the borders of the aneurysm. If parts of the calcification break off and embolize distally, you can develop mottled looking skin and poor pulses distally. So whenever you see the patient coming in with abrupt onset of loss of pulses, say on one leg, think about the possibility of AAA. You know, if they give you a picture of somebody whose legs are pale and mottled in color, and they say this person has no pulse on the right, in the right DP, and oh, by the way, they've also been having abdominal pain, think about AAA. You don't want to anticoagulate that patient, obviously, all right? Physical exam, again, you see the classic findings. Pulsatile mass is not all that common. Decreased femoral pulses. Plain film, in terms of imaging, plain films approach 100% sensitivity and specificity for AAA when there are dots on the plain film, all right, or errors. Otherwise, it's totally useless. Well, not totally, but for the most part, useless. Ultrasound is probably your diagnostic test of choice on that board exam. Get to know what the ultrasound looks like. It's not subtle, all right? Any area of the aorta that's greater than 3 centimeters is considered an aneurysm, and when it gets up to 5 centimeters, they're particularly at high risk for rupture. This is what your aneurysm is going to look like in ultrasound. So again, for those people that are not comfortable with ultrasound, just do some Google image searching, take a look at some AAAs. It's really easy, all right? Not difficult at all there. Ultrasound's great for AAA. It won't tell you if it's leaking, but it'll tell you if there's a AAA, and oftentimes that's all you need to know. If the patient comes in with syncope and they're hypotensive, you don't need to know if it's leaking. You just need to know, is there a AAA? And if there is a AAA, surgery will take them, right? Now, if the patient's fairly stable, then in that case, you may want to know, or if the patient has a known prior AAA and now they're coming in that case, you may want to know, is it leaking or not? And your test of choice there is going to be CT with contrast. That's your diagnostic test of choice there, all right? How do you manage these patients? Well, if they're hypotensive, massive transfusion protocol for sure. Type and cross them before the OR, type and cross them for 10, 12 units, no exaggeration. They're going to need a lot of blood, and get them upstairs to the OR as quickly as you possibly can, all right? And again, on the board exam, any older patient, and you can define what that word means, older, but any older patient with any abdominal or back pain, you got to think about the killers. And AAA and mesenteric ischemia are the 2 absolute killers you've got to think about first and foremost on the exam. All right? All right, another little mental break here as you think about choices for lunch. This one was sent to me recently. I love this. Let's see. There we go. All right. Okay. Let's see, we got about 30 minutes left. Acute limb ischemia, well, there's emboli and there's thrombi. Couple things to distinguish these. Emboli are usually cardiac, all right? Well, actually, let me just summarize some things right now with this slide, and then we'll recap this. You might have to distinguish the difference between an embolic loss of pulses and a thrombotic loss of pulses, all right? Thrombotic, that's just your classic peripheral vascular patient who's got claudication symptoms, and one day they come in and they've lost pulses on one leg, but you check the other leg and the other leg's got rotten pulses also, and chronic signs of peripheral vascular disease, and maybe chronic claudication. So the thrombotic patient has rotten pulses bilaterally. The embolic patient, that person comes in with abrupt onset of loss of pulses, and then you check the other side, and it's totally normal. The other side has totally normal pulses. All right? So that's the main way that you're going to distinguish between emboli and thrombi. So the causes of emboli, think about AFib, think about low EF, think about dissection. Remember, if you dissect down, you can knock out an iliac and lose a pulse. Think about AAA. We just talked about that. Distal embolization of those little calcifications. All right? And then in terms of the thrombotic patient, they'll have a history of atherosclerotic disease. They'll have your Framingham risk factors and all the rest. So picture at the top is supposed to show an embolus, and I don't know how well you see it, but the upper foot is very pale and has no pulse. I'll have to tell you that on the exam. And then the lower foot looks like it's pretty well perfused. It's nice and pink, and they would tell you it's good capillary refill. So one foot has no pulse, the other foot's totally normal. That's an embolus. Whereas, well, the bottom one, I'm sure the patient's going to say this happened overnight. But the bottom one, the patient comes in, and there's no pulse on one side, but actually both sides have chronic signs of arterial insufficiency. Remember your 6 Ps, your 6 signs of loss of pulse: pain, pallor, pulselessness, paresthesias, paralysis or paresis, and poikilothermia, in other words, cold. The first, probably the earliest sign is paresthesias, all right? You don't want to wait till they've lost their pulse. And what do you do if you're worried about limb ischemia? You get surgery involved right away, and as long as you're not worried about a dissection or AAA, go ahead and start the heparin, all right? Take your pick between unfractionated and low molecular weight, all right? But go ahead and start the heparin if they've lost a pulse and they're symptomatic, right? DVT, there's not much to say about DVT that you don't already know about and take care of every day. No Virchow's triad. Know the risk factors: immobilization, pregnancy, estrogen use, all of these risk factors. Patients typically present with pain, maybe some erythema, maybe some swelling, maybe a low-grade fever, but pain and swelling are the key things. And there is a pulse to distinguish it from some other things, all right? Homan sign, if they give that to you, they're trying to point you in this direction, all right? Test of choice, no surprise, duplex ultrasound. And if you want to use a D-dimer, that's perfectly acceptable as long as you clinically think they have low clinical suspicion plus a negative D-dimer. You're done. You don't need to work them up. And that's clearly within standard of care. It can be low clinical suspicion by Gestalt or low clinical suspicion based on Wells, take your pick, plus the negative D-dimer, you're done. If you do get the ultrasound, just remember that the ultrasound, although it's really great, is only sensitive at picking up DVTs between the inguinal area and the popliteal fossa. The ultrasound is not that good at picking up calf DVTs, all right, which we'll get to in a second. If you diagnose this, you're going to start them on heparin, oral anticoagulants. If somebody's already anticoagulated and they develop a recurrence, then that's an indication for an IVC filter. All right. Now, there's 2 major complications of massive iliofemoral DVT that you've got to be on the lookout for on the board. It's not that common in real life, but on the board exam. Massive iliofemoral DVT. 2 complications are phlegmasia ceruleodolens, literally translated painful blue swelling, and phlegmasia albidolens, literally translates to painful white swelling. All right. What happens here? Well, if you have a massive iliofemoral DVT, you can develop arterial spasm and lose a pulse. And that's the phlegmasia albidolens. The leg is swollen, pale, white, doughy in color or in feel. Or on the other hand, if you have this massive iliofemoral DVT, it causes such an obstruction to backflow, all of the blood becomes stagnant in the lower extremity. The leg becomes cyanotic and blue. You can get tense bulla, and you can develop increased intercompartmental pressures, and you can lose your pulses due to a compartment syndrome. So in either of these scenarios, the patient is going to lose their leg unless you get them to a surgeon as quickly as possible. All right? So be on the lookout for these things also. And here's a couple of pictures. The one on the left, you can see this patient's left leg. You can kind of appreciate it's cyanotic, it's large. Maybe there's some tense bulla up there. That's the phlegmasia ceruleodolens. And then on the right, the right leg is pale in color, it's swollen, it's doughy in feel. This is the phlegmasia albidolens. There's no pulse distally. So either one of these, get them to a surgeon as quickly as possible. All right? A few words about syncope. Syncope is defined as a sudden and brief loss of consciousness and postural tone, all right, followed by complete and spontaneous recovery. And that definition is very important. It's got to be brief, all right? The patient that says, yeah, I passed out at 2 o'clock in the morning and woke up at 7 o'clock in the morning, that's not syncope. That's Jack Daniels, all right, or methadone, okay? So it's got to be brief. They have to lose postural tone, which separates it from seizures, which you have increased postural tone, right? And then they have to have spontaneous recovery. So if you have to push D50 on someone or give them Narcan for them to wake up, that's not syncope, all right? And when they wake up, they have to be totally back to normal. If they wake up and they're posturing, that's not syncope, that's a stroke, all right? So if somebody meets this definition, your workup can be enormously simple. How do you lose consciousness? Well, you lose consciousness by one of two mechanisms. Either you knock out the reticular activating system, which is in the upper part of the midbrain, or bilateral hemispheres simultaneously. Now, let me ask you this. What type of stroke can knock out the midbrain transiently, and then you suddenly wake up and you're totally normal? It's not going to happen, right? It's neuroanatomically not possible. What type of stroke knocks out both hemispheres simultaneously and then totally resolves at the same time and you wake up and you're normal? What type of stroke? It's neuroanatomically not possible. So this is just basic neuroanatomy. If somebody has a true syncopal episode, based on this definition, all of those neuro workups are a waste of time. CAT scan, carotid Dopplers, and so on. As long as they wake up and they've got a normal neuro exam, the likelihood of a neuro cause is incredibly small, right? So again, that's why the definition is so important. In terms of the causes, the most common cause which gets diagnosed is vasovagal. Unfortunately, a lot of patients with syncope never get a definite cause, but vasovagal is probably the more common cause. It can be orthostasis. It can be psychiatric if there's some type of psychiatric conditions. Medications can cause orthostasis. Neurologic is listed up there, but again, in reality, if you do a good neuroexam, it approaches zero. Most of these end up being trauma, right? And cardiovascular arrhythmias are what we really worry about. And in terms of the workup can be really simple. You don't need to do any routine labs on syncope that meets this definition unless your history and physical tells you to do so, all right? If on history and physical, the patient says, yeah, I've been having heavy vaginal bleeding or I've been vomiting blood, yeah, go ahead and get your H&H. But in the absence of any history of blood loss, your yield from getting a routine CBC approaches zero. If somebody says they've been vomiting or diarrhea or they started some new diuretics or something that puts them at risk for electrolyte abnormalities, yeah, go ahead and get your Chem 7. But in the absence of that, the yield of getting routine chemistries approaches zero. What about Holter monitoring? The yield approaches zero if there's no evidence of arrhythmias on the EKG or cardiac monitoring in the emergency department. What about EP testing and all the rest, or routine echo? If there's no murmur, if there's a normal EKG, the yield approaches zero. So again, the workup can be incredibly small. Don't get any tests except for an EKG unless the history and physical tells you to get a test. All right? The EKG is the only test that you should routinely get even in the presence of an unremarkable history and physical. And what are you looking for on the EKG? Well, you're looking for ischemia, you're looking for arrhythmias. Don't forget about the intervals, long QT and short PR. Always check the intervals. Look for hypertrophic cardiomyopathy and then Brugada syndrome, which we'll just touch on in just a little bit. All right, another little mental break. This is from Austin, Texas also. I don't know what's going on there in Austin. If anybody happens to be from Austin, maybe come up afterwards and tell me what's up with this stuff. All right, and gosh, be careful about how you write things, I guess. All right. And okay, so last 20 minutes or so, we're going to run through EKGs and some dysrhythmic findings. Again, this is stuff you know like the back of your hand already. Hyperkalemia. Look for hyper-K on that exam, All right, and hyper-K can do anything to the 12 lead. ST elevation, ST depression, new bundle branch blocks, vesicular blocks, bradycardias, tachycardias. I always refer to hyperkalemia as the great imitator or the syphilis of electrocardiography, right? It can do anything. Everybody learns about peak T waves and wide QRS, but it really can do just about anything. But pay attention on the board exam, I think, pay attention to the T waves. Hypokalemia can give you sagging T waves and U waves. So comparing the two, hypo-K at the top, hyper-K at the bottom. And the way I think of it, if you look up here at me for just a second, hyperkalemia, you get a big T wave like this, and then as the potassium drops, it drops, becomes flat, and then hypo-K, then you get a sagging T wave going up into a big U wave. All right, so if you look there at the top right, that's a classic hypo-K. What you've got is, you've got an inverted T wave, and this big thing right there, that's the U wave, right? So the T wave, again, hyper-K starts up tall, and then it drops, becomes flat, and then drops under the baseline, and you get a big U wave. So that's how hyper-K and hypo-K relate to each other. What about calcium? Hypercalcemia, short QT, hypocalcemia, long QT. Simple enough. Actually, hypokalemia, let me go back. Hypokalemia can produce what appears to be a long QT as well, all right? So hypokalemia and hypocalcemia both prolong the QT. We'll sum up causes of prolonged QT in just a second. All right? Right up here. Your hypoelectrolytes prolong the QT, and this is important to remember. Hypo-K, hypomag, hypocalcemia all cause a prolonged QT. And why do we care about a prolonged QT? Because prolonged QT can precipitate torsade. Torsade is a type of polymorphic VTAC, torsade de Pointes, right? I don't know how to pronounce it. Torsade de Pointes. A lot of people use the terms interchangeably, polymorphic VTAC and torsade de Pointes, but they're not the same thing. So what's the difference between polymorphic VTAC and torsade de Pointes? Torsade is polymorphic VTAC in a French person. No, I'm just kidding. No. Torsade is polymorphic VTAC associated with the prolonged QT. All right? So that's the key distinction between the two. Torsade is polymorphic VTAC with a prolonged QT. A lot of people think that torsade means the QRS is getting bigger, smaller, bigger, smaller. Well, normal run-of-the-mill polymorphic VTAC does that also. So the only way to tell the difference between torsade and generic polymorphic VTAC is get a QT. Take a look at the QT before the torsade happened, or maybe after you shock them out of it, take a look at the QT. If the QT is prolonged, it's torsade. And what does that mean? How do you treat that? You can use magnesium infusion and go back and look for the underlying cause of the prolonged QT. Hypomag, hypo-K, hypocalcemia, a lot of medications. Look for the underlying cause and fix it. What if you have this rhythm, you shock them out of it, and now they're back in sinus rhythm, you check a new EKG, and the QT is normal? That means it's not torsade. That means it's generic run-of-the-mill polymorphic VTAC. How do you treat that person? Magnesium doesn't work, all right? What you need to do is, if you want, you can start them on lidocaine, procainamide, amiodarone is great for those patients to prevent them from going back into it, and then you treat them for ACS, right? The most common wide complex tachycardia that ACS causes is polymorphic VTAC. So whenever I see generic polymorphic VTAC, I think it's safe to assume that's caused by ACS. When you see prolonged QT type, that's caused by causes of prolonged QT. Look for and treat the underlying causes of the prolonged QT. All right? So that's why it's important to make this distinction between run-of-the-mill polymorphic VTAC, think ischemia, and generic the prolonged QT type torsade. All right? The other key point here is, what happens if you mistake the two and you have torsade and you put the torsade patient on lidocaine or amio or procainamide? What do those do to the QT? They make it worse. So you could put the patient into intractable torsade. Lidocaine plus minus, but definitely procainamide and amio. You never put a torsade patient on amio or procainamide because you'll make the QT worse. So that's another reason why it's important to know the distinction between generic run-of-the-mill polymorphic VTAC and the torsade type. All right? So there's your treatment for torsade. You cardiovert or shock them out of it. You give them magnesium, and then you look for the underlying cause. If the shocks and mag aren't working, you can use overdrive pacing with your pacer. Put them on a pacer and set it to 120 beats per minute and see if you can grab control of the heart and pace them out of it. Because when you increase the underlying heart rate, you shorten the QT, so that may work. Or you can use isoproterenol to chemically overdrive pace the patients. But you never use procaine or amiodarone on prolonged QTs. All right, SVT. SVT is pretty simple. It's associated with benign conditions for the most part, and you're going to treat these patients with the vagal maneuvers. Nothing special. You guys take care of these patients all the time. Nothing special about SVT. AFib and flutter are very common, and there's a list of underlying causes here. Heart disease is very rare, actually. Mitral valve problems are often associated with atrial arrhythmias, DIG toxicity, thyroid problems, PE plus minus. The literature has actually shown that at the top it says MI. The literature actually shows that the likelihood that MI causes AFib is really, really low. So a lot of people don't believe that you routinely need to rule out MI in AFib flutter. But fib and flutter I put together because they have the same underlying causes. They're essentially cousins, often living in the same heart, often living on the same EKG strip. The only difference I would say between fib and flutter, and they both need anticoagulation, by the way. The only difference between fib and flutter is if you need to electrically cardiovert them. Fib is one of the most difficult arrhythmias to electrically cardiovert, so you start at about 200 joules, whereas flutter is about the easiest arrhythmia to cardiovert. You just rub your feet on the carpet and shock them, and they pop out right out of it. I mean, it really is easy to shock them out of it. That's the only way. Otherwise, everything we say about fib and flutter is the same. If you want to shock them out of it to cardiovert them within 48 hours, fine. If you want to use chemicals to cardiovert them within 48 hours, that's acceptable also. And if it's been going on for more than 48 hours, don't forget the anticoagulation. All right? If you use chemicals, there's a handful of choices, and all of the choices that are listed there, you need to monitor the QT. That's the main thing about the chemicals. All right? There's your flutter. You've got your classic sawtooth type of pattern with flutter. And then atrial fibrillation is just no clear-cut P waves. It's irregularly irregular. Again, no surprise. You guys take care of this pretty much every day. Don't forget about MAT. MAT is also irregularly irregular and narrow, but MAT is associated with at least 3 different morphologies for P waves. If you look at this rhythm strip down there, you can see, well, let's see, there's an inverted P wave, and there's a big upright P wave, and then maybe a slightly different morphology up there. So at least 3 different P wave morphologies. How do you treat MAT? Just like sinus tach, you just look for the underlying cause. Almost always, these are pulmonary patients. Asthma, pulmonary hypertension, COPD, and so on. But you never shock MAT. If they gave you this patient and said, blood pressure is 80, how do you want to treat it? They're making you think, hey, this is an unstable tachycardia. Maybe I should shock it. No. There's 2 tachycardias that you never shock. Sinus tach and MAT. Because what happens if you shock MAT and sinus tach? Your press gainies fall. That's it. There's no benefit. All right, so just treat the underlying cause. Usually it's going to be nebs and steroids or whatever, so easy enough. All right, a few words about pacemakers. What are the indications for emergency pacing? This is just basic ACLS. Unstable bradycardias, no matter what the type of bradycardia is, if they're unstable, you can pace them. Overdrive pacing of torsade. In this case, you want to set your pacer to maybe about 120, all right? And pacing of asystole, that's gone. We no longer bother trying to pace asystole, all right? And then I put down there standby pacer. What does that mean? That's maybe my term. When somebody's got severe bradycardia or an AV block like Mobitz 2 or a 3rd degree, but let's say they're not stable. Let's say they're not unstable. There's no chest pain, heart failure. They got a good blood pressure. Well, if they've got Mobitz 2 or 3rd degree, you know what? I would put the pacer pads on and have it ready to go. I wouldn't turn it on if they're stable, but I would just have it ready to go. I call that standby pacer, so that if they do become unstable, you're ready to go. Boom, you hit the on button and you start pacing them, all right? What do you do if the pacemaker, if somebody has an implanted pacemaker and it fails, maybe that runaway pacemaker, get your magnet, put it over top of the pacer, and what that does is it temporarily converts the pacemaker from a demand to a fixed rate. And that gives you, or it turns it off, and that gives you an opportunity to look at what the underlying rhythm is and what's going on. All right? So remember, big magnet right over top of the pacer. As an aside, everybody ought to know where the magnet is in your emergency department. All right, if you don't know where it is, next time you go home, find out where that magnet is. Because invariably, if you don't, that's the day that the unstable pacer patient will show up. All right, and then look for the underlying abnormalities. Just a couple words about AICDs. You don't have to know this slide, but this slide I put up here just to show how many patients nowadays have AICDs. The indications for placement of AICDs by cardiologists have really, really skyrocketed. So we're all seeing more and more and more patients showing up with AICDs, including the complications of AICDs. There's two main complications: infections, which we'll get to, and then the shock, where a patient comes in and says, I got shocked by my AICD. So all AICDs that have pacer functions as well, but they'll say that they got a shock. If they get shocked one time, those patients don't routinely need to be admitted. Somebody comes in and says, my AICD shocked me, check their lights, get a good history. Did they have any signs or symptoms of ACS? If yes, fine, you're going to admit them. But if everything looks good, their electrolytes look good, they can go home. Right? In fact, a lot of patients who are savvy, when they get the one shock, they just call their cardiologist, they discuss it, and they never show up. But on the other hand, if there's two or more shocks, they all come in for interrogation and a full workup. So 2 shocks or more, they're coming in. 1 shock can sometimes go home. The other complication you're going to worry about is, one other point about AICDs. If you have to take care of a patient in cardiac arrest who has an AICD, there's nothing special you need to do. Just follow your normal ACLS protocols. The one caveat they say, if you're going to put pads on or shock the patient, put the pads about 8 to 10 centimeters away from the AICD, but otherwise all of your protocols are the same. The other complication these patients can develop is infection, right? They can develop early infections or late infections. If the infection occurs early, they usually have some early after placement, they usually have some redness and tenderness, and it becomes easy. But once the AICD's been in place for a few months, if they develop an infection, the site can look totally normal. They'll simply have pain. So if a patient comes in several months after placement of an AICD and says, it's hurting at my AICD site, even if it looks totally normal, you have to worry about a pocket infection. And the test of choice there is just bedside ultrasound to look for a pocket of fluid. All right? Simple enough. All right, so this is the most bizarre sign I've ever received. This is from a Japanese subway. Now, you know, on public transportation, there's usually special seats that are designated for people that have certain special conditions that allow you to sit in these seats. And this was the sign above those special seats. So what in the world are the special conditions you have to sit in these seats? So from left to right, person with injured arm, person holding a child, pregnant woman, and person with injured leg. Now, I don't know who the artist was, all right? Or maybe some of you are thinking you get to sit here if you're having like a Viagra emergency, or off to the right you're having the biggest bowel movement in history. I don't know. Very, very strange. Okay, last 6 or 7 minutes, WPW. Definitely be on the lookout for WPW, especially in those post-syncope patients. What are you looking for? You're looking for the classic triad: short PR, delta wave, that little slurring of the upstroke of the QRS, right? And notice, there's practically no PR interval, all right? It goes right up into that QRS and slight widening of the QRS. The key thing that I would say to look for is not the delta wave, because delta waves are not always present in all of your leads. On the other hand, short PR is going to be there. So get in the habit of always looking at your intervals, and when you see a short PR, now start looking for delta waves. I've seen some cases of WPW where delta waves are only obvious in one lead. So if you're looking for deltas, you're going to miss it. But get in the habit of always looking for PRs, and the PR is short, then go searching for the deltas. All right? But this is a classic can't miss post-syncope case. Now, the main problem with WPW is when they have AFib. If they have SVT, that's generally not a problem. If they have narrow complex SVT, treat them just like narrow complex SVTs. That works fine. If they have the wide complex or antidromic SVT, it's going to look just like VTAC. And if you treat them for VTAC, that works fine also. So SVT is not a big deal. The major problem we encounter is when they have AFib with WPW. And what your tip-off for AFib is, take a look at this rhythm, it's irregularly irregular. So right off the bat, you know it can't be an SVT. It's AFib. It's irregularly irregular. Notice the morphologies are changing. QRS complexes are bigger, smaller, bigger, smaller. They change in morphology. All right? And in some places, rates are approaching 250, 300 beats per minute. There's just nothing else that's going to go that fast. So irregularly irregular with changing morphologies, and in some places, rates are really fast. That's your AFib, WPW, and what do you have to know about that? Those patients should not get any AV nodal blockers. Adenosine, beta blockers, calcium channel blockers, DIG, amiodarone, all are contraindicated. The only choice you have is if they're stable, you can use procainamide, or better yet, just give them some propofol and shock them out of it. All right? And I think this makes for a great question where they try to give you this and they bait you into using an AV nodal blocker. Don't fall for it. When the morphologies are changing like this, it's not just run-of-the-mill AFib, it's WPW, and just go right to the procainamide or shock them. Right? VTAC we talked about already. Key thing is it's a regular rhythm. Morphologies are all similar. The rate's got to be at least 120. When you see this, look for underlying cardiac disease, electrolytes. Drug of choice now is procainamide, followed by amiodarone, followed by lidocaine. Probably even better is to shock them. All right? Procainamide's class 2A, amiodarone class 2B. What do you think the only therapy that is listed as a class 1 intervention is? It's shock. All right? That's the best evidence. So don't be afraid to shock patients that are in stable VTAC. Just make sure to sedate them first. All right? But the rate's got to be at least 120. And then VFib, by definition, is a non-perfusing rhythm. By definition, there should be no pulse with VFib. If you ever find a pulse, it's not VFib. I remember one case when I was an intern working in the CCU, we had a post-MI patient who was up there, I guess he was taking a nap. His alarm suddenly started going off saying, VFib, VFib. My senior medicine resident grabbed the paddles, we ran over and shocked this poor guy who was simply taking a nap. And one of his leads had come loose and was kind of shaking a little bit. And if we had simply checked for a pulse before shocking this guy, we would have said, hey, he's got a pulse. It can't be VFib. So anyway, we never got any Christmas cards from him. So there's your VFib, no pulse, all right? PVCs, we've kind of talked about already. You don't need to treat PVCs, except when they are back to back to back to back at a rate of at least 120, all right? Because that's called VTAC. But isolated PVCs or little mini bursts of VTAC, if it's less than 30 seconds, guidelines say look for the underlying cause, especially electrolyte problems. Fix their K, fix their MAG, look for ischemia. But isolated PVCs, you actually do more harm by just throwing lidocaine or amiodarone at them, all right? So don't treat PVCs. Just look for the underlying cause unless it's VTAC. And VTAC is defined as having a heart rate of at least 120 for at least 30 seconds, all right? And also the other mimic, this is about the third time I think we're talking about this, accelerated idioventricular rhythm. It looks a lot like VTAC, but it's not VTAC. How do you know it's not VTAC? It's not fast enough. If the rate's under 120 and it looks like VTAC, think about mimics, especially AIVR if it's an ACS patient. What if it's a tox or overdose patient? Well, hyper-K and tricyclic overdose can do this also, typically at rates under 120. So when the rate's under 120, don't use sodium channel blockers. Don't use lidocaine, amio, or procainamide. You'll kill them. All right? A little bit about the Brady dysrhythmias. First-degree AV block has no clinical relevance, all right, unless they're also bradycardic. If they're bradycardic, look for the underlying cause. Are they on drugs? Are they ischemic? And just follow basic ACLS. Second-degree AV block is a bigger source of confusion. There's second-degree AV block type 1, also known as Wenckebach, and what you'll notice down there is that the PR intervals are gradually getting longer and longer and longer until you've got a lonely P wave, and then it starts all over again. So when the PRs are gradually increasing, that's your Mobitz 1. Mobitz 2, everywhere there's a PR, it's constant PRs, and then a lonely P. Constant PR, and then lonely P. That's your Mobitz 2. Also, Mobitz 2 usually has a slightly wider QRS complex because it's more infranodal. Treatment is just basic ACLS. If somebody's got an unstable Mobitz 1, try atropine. If that doesn't work, pace them. If somebody has an unstable Mobitz 2, go right to the pacer. And I would say the same thing with third degree. If somebody has an unstable third degree AV block, skip the atropine, just go right to the pacer. Right to the pacer. All right? Third degree can be wide or narrow. Either way, just go right to the pacer. If it's narrow, if it's third degree with the narrow escape, that's usually vagal. Those patients tend to do pretty well. If it's third degree with the wide QRS, like you're seeing up here, those patients pretty much always will need a pacer, a permanent pacer. All right? But bottom line, if you have unstable sinus Brady or Mobus 1, try your atropine first. Unstable Mobus 2 or third degree, go right to the pacer. All right? Last couple slides, Brugada syndrome. Brugada is an electrical phenomenon. It's a genetic condition that's associated with sudden cardiac arrest. And this has been identified just over the past 10 years or so. What you'll see in your post-syncope patient is in leads V1 and V2, this incomplete right bundle type of pattern with ST elevation. It's this unusual ST elevation terminating in an inverted T wave. If this shows up as a post-syncope patient, they're going to want to know what you're going to do. There's no drugs that work. What you need to do is send this patient to an electrophysiologist for EP testing, and if they test positive, they get an AICD. All right? VTAC versus SVT, really simple. The books have big algorithms. Forget it. None of the algorithms work. On the board exam, if you see regular wide complex, every one of them is VTAC. I can't ever imagine that the board examiners are going to want you to identify SVT with the bundle. Just call it VTAC and every life gets saved. All right? And then finally, cardiac arrest. There's one LSA article on cardiac arrest. You guys know how to do cardiac arrest. So I think a lot of the literature is now focusing on post-arrest care. Key things about post-arrest care. Number one, when they're on the vent, avoid hyperoxia. Bring the FiO2 down and shoot for a pulse ox, not of 100%, shoot for a pulse ox in the low 90s, because hyperoxia is bad for the heart and bad for the brain. So avoid hyperoxia, shoot for a normal PCO2 also. Hypercarbia is not good. There's no permissive hypercarbia in post-arrest. Shoot for a normal PCO2. Keep the blood pressure elevated, or keep the blood pressure up. Start them on norepi right as soon as they arrive and keep that blood pressure MAP at least 65. Some guidelines recommend shooting for a minimum of 80. So we'll start the norepi as soon as they arrive, just have it hanging. If the blood pressure is good, we just turn it off. But as soon as the blood pressure falls, we've already got it hanging, we can just turn it right on. All right? And then therapeutic hypothermia is still in, especially for VFib arrest. If somebody's first rhythm was VFib, they definitely ought to be put on therapeutic hypothermia. And then finally, the recommendations from our specialty now are to try to push for cath. Post-arrest STEMI, they should really be going for cath. Post-arrest non-STEMI is probably worth still trying to encourage patients or your cardiologist to push for cath as well. And with that, we're done with cardiology. I'll hand things back over to Stuart, but thank you all very much.
Yay. 204 slides. Mazel tov. Yeah. Well, we're going to go right into it, but I have some good news, which is I have the fortunate position of bringing you to lunch. So we're going to dispense with the rest of pulmonary, and we're going to have fun doing it, and then we're going to go and have a liquid lunch. I mean, we're going to go and have lunch. Okay, good. Oh, by the way, just in the way of recognition and repetition, remember this? Strep pneumo, diplococci, gram-positive. Remember this? Hang on, where's this one? Gram-positive rods, boxcar-like, anthrax. Also a very good band. So, maybe they're not that good a band. Now, let's talk about pneumonia treatment. We're still on pneumonia now, and this is fun to do because if you're like me, you've been very frustrated by the antibiotic recommendations of the Sanford Guide over the years. Bless him for what he did. He made a very nice antibiotic guide that was a single laminated sheet years ago, and then it just basically metastasized into this massive manual for antibiotics that you need a computer. I can't even see the thing, so I need like a microscope to read it. It's got like 8 footnotes after every recommendation. It's impossible to use, but for the test, one fortunate thing is dead simple. Dead simple. And I've got a few slides that are like this that talk about treatment and how we stratify it according to how sick a patient is. Do it again for TB what do I do it for? Do it for some other things as well. But basically, if you're healthy and outpatient, so you're
under 60 and you're relatively healthy, you get a macrolide because you cover for strep pneumo and atypicals. Now, I know that things are changing and that there's different communities where there's resistant patterns. Just for the purposes of the exam, they tend to keep it simple, and they tend to keep it with what's been going on in general, not what's been on the antibiogram in your particular region. So this is safe to assume. And basically, if you go one step sicker, like you need to be hospitalized because you're really sick, or one step older or sicker, then in addition to the strep pneumo and atypicals, right, which we've talked about, you need to add gram-negative coverage. You've got to get all your nasty, lethal bacteria, Serratia and Enterobacter and things like that. And that's why we add the coverage for the gram-negatives. So that could be with a cephalosporin. Now, I think I should point out, I think most of us have heard this by now, but fluoroquinolones are probably not appropriate in this circumstance anymore if there's an alternative. So if you can give someone a macrolide and a cephalosporin, that is far preferable than giving them levofloxacin, because organisms love levofloxacin. It's very easy for organisms to get resistant to levofloxacin. It only takes one genetic mutation on a plasmid. And that's not the case with cephalosporins and other antibiotics. And so they're really discouraging us from using fluoroquinolones unless we have no choice. So sometimes you have no choice in a pyelo case, but usually for pneumonia you have other choices. So that's the second tier. Older or sicker, add gram-negative coverage. And then there's one more tier. They made such a mess out of this, but this is really all you need to know for the test. One more tier. If they've got healthcare associations, they've been in the ICU on a ventilator, or they've got a MRSA colonization, they're dialysis patients, you either cover Pseudomonas on top of everything else, or MRSA on top of everything else. And so it's basically those tiers. Add and add. Okay? And so hopefully that's a much simpler paradigm for you to know for the test. Now, we've talked a lot in the previous hour about the pneumonia plus syndromes. You know, they've got pulmonary symptoms. It looks like there's infiltrates on the x-ray, but there's lots of other things, lots of other clues in that question that are going to tell you that it's a specific syndrome, okay? And so when it comes to bioterror affecting the lungs, you need to know about anthrax and plague. Those are both class A bioterror agents, meaning that they're most likely to cause the most harm, okay? And those are the ones that are most likely going to be asked about on the test. You can see that I've designed this slide with two sides to make a big contrast between these two things. So the big difference, if you want to circle that, is that anthrax doesn't transmit from person to person because it's a spore disease. So if they were to aerosolize, as a bioterror attack, for example, they might aerosolize anthrax. They aerosolize spores. The spores go into your body and then transition into the infectious agent. And so because it's a spore disease, you don't person-to-person transmit it. That's really, really important. The classical things on the x-ray for anthrax, we've already talked about the classic slide, and I put that up there. The classic x-ray finding is what I've shown you there. It's a hemorrhagic mediastinitis. I tell people if they've worked in an area where there's lots of pertussis, and I have because they didn't vaccinate in a lot of places I've worked, you see x-rays that look just like that. They get this ratty mediastinum. In this case, it's from hemorrhage, and it's not a very good thing to see. It's not a good situation for them. But anyway, that hemorrhagic mediastinitis, that slide, and that history of inhaling a spore and not being infectious to others, those all go along with anthrax, inhalational anthrax, and the treatment is doxycycline, among other things. Now, plague is different. Plague is much more concerning in that if you've got plague in your lungs, you're very contagious. It can be aerosolized and other people can get it, so they have to be separated. And that's the huge difference that I want you to register. Now, with plague, it has that stage of bubonic plague and then pneumonic plague. So just to remind you of that, I'm reminded of a story where I was working and I took a call from we called it the blood gas phone, but it was the emergency results phone, and the voice on the other end was quite panicked and telling me, "Doctor, this patient's got Yersinia pestis," a patient that was seen in your ER. And it was just a very, very scary moment for me, especially coming from Canada to hear about that, Yersinia pestis. That doesn't sound very good. And there was a pause, and she says, plague, doctor, plague. And it was a defining moment, and then I just paused. I didn't know what to say. I said, "You mean like Black Death?" Well, it happens all over the U.S. It's endemic. They have it in Colorado. We have it in L.A., in the forest above us. There's endemic plague. And this gentleman that had come to the ER, he had been camping out there. He was an eccentric gentleman, and he had a bubo. You know, a bubo's just a big lymph node. He had a big bubo under his arm, and he was sick. They incised it. They sent it for culture. They admitted him to the ICU. And then the next shift, they called back to say what it was. Anyway, that's bubonic plague, and what happens is after the flea bite and then they get the buboes, they're not necessarily contagious, but then it crosses over systemically into their lungs and becomes pneumonic plague, and then they're contagious. The thing about bioterror is they're not going to bother with the bubonic, they're not going to release fleas. They're going to release the plague. So there ain't going to be no bubonic part. It's just going to go straight into this really scary, contagious pneumonic part. And the treatment there is doxy. And it reminds me of what Billy told me. What Billy did the tropical medicine course at Gorgas in Lima in Peru. And I said, did you learn anything, Billy, aside from drinking fine wines and enjoying yourself? And he said, yeah, I did. If you're not sure what's going on and things are getting bad, the patient's sick, the patient's dying, just try a course of doxy. And I said, okay. He said, no, really, really, really. I mean, if you think about it, a lot of these exotic things. So if you think about these bioterror things, and for that matter, if there's an infectious disease that you kind of think you don't know what it is and it sounds bad, doxy is a really good guess. I would go for doxy first. And if that's not on the list, I'd go for the fluoroquinolone, honestly. So that's basically the contrast there. These two things also are pneumonic plus syndromes, are viral agents, but I want you to know about them. They come up all the time. Now, they're different than the two bioterror agents because there's no antibiotic to treat these things. They're just going to be conservative management, but they're really deadly things, right? So the hantavirus, the person comes in with the pneumonia, but with shock. And they're going to have to tell you some clue about some type of field mouse or something about Southwest United States. They're going to have to give you some sort of clue, and then you'll be, oh, that's Hanta. And that's really just supportive care. And SARS is similar in terms of supportive care. It's a viral agent. It's caused by the coronavirus. Now, that one we know is transmitted from the aerosolized feces of the civet cat, among other things. That happened in China, and then, of course, it traveled around the world. A lot of us in our specialty were heroes during the SARS outbreak. I'm reminded of the fact that we lost colleagues in our specialty. We lost colleagues doing heroic things to take SARS patients and expose themselves to risk, not to mention what we've done, a lot of our colleagues have done with Ebola. Pretty proud to be an emergency doctor. So with SARS, basically, it's person to person, and with hantavirus, it's not. It's no person to person. So please draw that contrast, just like you did on the last slide. Hantavirus, no person to person. SARS, major league person to person, a major mortality. And there's nothing more than supportive care. If they ask about MERS, MERS is the Middle Eastern one. It's similar to the SARS, but it's a little less virile apparently, and it might come from camels. We're not sure. So that's that. So that's all the pneumonia plus stuff. Now we're going to get to HIV/AIDS. And I kind of want to level the playing field here because I know that some of you know way more than I ever will about these things, and some don't see it much in where they practice. So I want to kind of level the playing field for the test here. It's not intimidating at all. It's just a few really basic facts. The first thing is what's in bold there. Just remember that people who die from AIDS die the same way we all do. Of strep pneumo, okay? They die of the same old bacteria that take the rest of us, okay? And that's the number one most important thing I want you to remember. Regardless of the stage of disease, their threat is from common organisms. Now, of course, they have all these other exotica, and we're going to go through a few of those things, but don't forget the main point. It's funny, though, the end of that slide, it talks about malignancies. Right? Sometimes a Kaposi sarcoma can be anywhere, can be in the lungs and can mimic a pneumonia. But it's kind of ironic because all of those cancers are really viral anyway, right? They're from viral agents, like human herpes virus 8, for example, responsible for Kaposi sarcoma, is a co-infection of HIV. So cancer and infection, as we know, are coming together these days. This is another money slide. This is the one that I was mentioning before that I forgot about. So this is another one of those slides where we have a treatment for the index case, so to speak, and as he or she gets sicker, we add on additional considerations, okay, just like we did with that pneumonia chart. So in the case of AIDS, HIV, the first thing you need to know is that from the moment that they seroconvert, from the moment that they contract the illness, they are automatically regardless of their CD4 count, automatically at more risk for TB and TB reactivation. TB and HIV go hand in hand. They love each other. And they don't care if your immune markers aren't showing depression. If your CD4 count is above 500, you can still get TB with greater frequency once you convert to HIV. So that's very important. The difference, the thing that makes TB different at different stages of HIV/AIDS is how it presents. So a patient with a healthy CD4 count who's had latent TB for years may well reactivate once they contract HIV. But they'll present with TB just like anyone else. You'll know it. They'll have lots of symptoms. They'll have an x-ray that shows stuff, right? They'll have a skin test potentially that will be positive. Other things will be positive. And as you get more immunocompromised from TB, as that CD4 count drops below 200 and below 50, they still get the TB just the same, but the body's so weak, you don't get that much response, and the response that you get is erratic, and you might not see anything at all on the chest x-ray at low CD4 counts. You have to assume that you're concerned about TB as they get lower if they've had exposure. You've got to be concerned about it because it can be very tough to pick up. So the other big thing that happens once you get below 200, and that's a very critical number, and it probably is a little more like 150 or 100, but 200 is most commonly used in the books, that's PCP pneumonia. I told you at the very beginning of this talk that that's a special disease for pathophysiologic reasons. I'm going to go into that in a slide or two. But that's where PCP kicks in. They're not going to give you a question of a patient with PCP pneumonia and a CD4 count above 200. Not going to happen. And they're also not going to give you a question of a PCP pneumonia with a normal LDH. Ain't going to happen. Okay, and I'll tell you the rest of that story in a minute. Once you get below 50, now you're starting to talk about pre-morbid end-stage stuff. That chronic diarrhea from Mycobacteria avium complex, CMV, the fungi start to take over, and the cancers related to infections really start to take over. So why is PCP so special? We mentioned that it's the one type of pneumonia that we know of, it's the one type of illness that we know of that comes to the ER where they get hypoxia through a different mechanism, not through VQ mismatch, but by an inability to diffuse oxygen across their alveolar membranes. Now just think about this for a second. A patient with PCP pneumonia, and by the way, you're probably thinking to yourself, didn't they change the name of this disease? They changed the name of this disease, they changed the name of this organism from Pneumocystis pneumoniae to Pneumocystis urevecii. I think I pronounced it right. But guess what? They realized that we can't, that was devastating to us. So they said, but you can still call it PCP pneumonia. So don't worry about it. They're not going to trick you on the organism. PCP pneumonia is the same. They just changed the organism name to urevecii. So that's no big deal. But let's talk about what just makes this disease so special. The presentation of these patients is subacute. They might not even say they have a pulmonary complaint. They might just say, I'm tired, right? But what makes them so characteristic is you hook up that pulse ox to them, and they take a couple of steps, and whoosh, from 90 to 50 in less than 2 seconds, these people desaturate just so quickly and so dramatically. And I think it has to do with the fact that there's this global problem of diffusion of oxygen that kicks in. Most pneumonias from VQ mismatches, most of the hypoxia from VQ mismatch, and these patients that actually can't get across the membrane. And the reason that oxygen can't diffuse across the alveolar membrane is because it is rife with inflammation caused by this organism. There are stacks of organisms and lots of inflammation that are actually preventing the diffusion of oxygen across the membrane. And that's why, one, you have such a massive desaturation and dramatic desaturations, even when they move around in the bed sometimes, because of that global diffusion problem. It's also the reason why they get the symptoms of fatigue, the profound unwellness that they get. And lastly, this is special. It's why it's the only type of pneumonia that really must have steroids. It must have steroids to decrease that inflammation. Otherwise, just with antibiotics, they won't get better. And that's why the steroids are so key in any patient with PCP that even shows the hint of desaturation. Now, that's not it. There's more. PCP doesn't show up on a regular stain. It needs a bronchoalveolar lavage with a silver stain to make the diagnosis. So you'll not do that in the ER. You'll have to make this diagnosis empirically. Please know that a lot of patients with HIV/AIDS cannot take Bactrim, they cannot take trimethoprim sulfamethoxazole, they're intolerant to it. And so we often find ourselves going down to the second agent, pentamidine. Circle pentamidine because it's a classic for exam makers because it causes hypotension and hypoglycemia. Pentamidine causes hypotension and hypoglycemia. If that bit about the inhaled stuff is confusing to you, years ago, what they used to do is they used to inhale pentamidine into patients when their CD4s were dropping. That would prophylax against PCP pneumonia. But we don't need that anymore. I mean, we've got better things and we've got highly active therapy. That's what that inhaled business is about. And the thing to know for the test on that was always that pneumothorax was a complication of pentamidine prophylactic therapy. Sometimes we end up going down to the third line treatment, dapsone. And you know that one because when you think dapsone, you think methemoglobinemia. And you think of a SAT monitor that says 85%. Blue as a Smurf. Got it. All right. Foreign body aspiration. Remember, this isn't just Johnny, the kid, who we don't see and is choking on something. This could be older people that are edentulous. This can be people with neuromuscular disorders. We want to know if there's a bulbar problem, a pseudobulbar problem. These are patients that are prone to aspiration. Now, let's talk about an exam question, a little bit scenario here, okay? You're just having a good time and you're watching your son Johnny, who's 7 months old, and he looks fine. 1 minute, you turn your head, and the next minute, well, there might be some pieces of the Tonka toy and Lego missing, you're not sure, but he's sputtering, and he wasn't before. Well, what's going on? I mean, it's a foreign body aspiration. I mean, it's pretty much, that's what's happened. He was fine, and now he's got this. And now he's in the ER at 3 in the morning. What are you going to do? This is a dilemma, because the answer to the question is just like it was for torsion that we talked about, okay, just like it was for necrotizing soft tissue infections that we talked about, it's specialist now. If a kid comes in and he's choking, and he had that history of choking, and it's a really clear-cut history like that, they might not want to come in at 3 in the morning when is he sitting okay? He's looking there, okay, I'll come in the morning. And it's pretty hard to argue against that if the kid's looking okay in front of you. But you must remember that they need to have bronchoscopy. They need to have rigid bronchoscopy. It can be done by a general surgeon, it can be done by ENT. I mean, there's a lot of specialists that have that skill set, but they got to look. They got to. Because when we don't look, what happens is that they can come back in months later with perforations through their chest wall and fistulae. And the irritating thing about this is that kids with choking and people with aspiration syndromes in general, they get better with the treatments for asthma. With albuterol, oh, he got a little bit better. Okay, send him home. Oh, he's got this again. It's like, why did he just started having asthma a month ago and now he's been in 4 times for it? It's because we missed a foreign body that's still in there, and it can cause increasing problems as time goes on. So be aggressive about making sure that they get scoped. Okay? Now, if it's 3 in the morning and I want the guy to come in earlier to help me out, I can take some x-rays. And this is the set of x-rays that you must know for the test. There's a PA and a lateral. They look normal. Maybe there's a little bit of a flattening of the diaphragm there, but I don't see a foreign body. When I'm looking for foreign bodies in kids, I x-ray above, I x-ray below, right? Who knows where the thing went? So maybe something's in the stomach at this point. I don't know. Something's in the neck. So we do those. They look okay. How you do an expiratory film on a 7-month-old, well, I don't understand that. I was going to do my demonstration, but I'm afraid that I might get into a choking fit because I do a demonstration on how I had to take expiratory x-rays in little kids when I was in Canada. They made me do that because they didn't have x-ray techs. And you'd have to sit the kid in a little pigastat, in a little thing, and basically the kid would go, this is the part where I get into the choking fit, you go, and then you go, I think I got it, right? And then you go back and develop it, and you say, is that an expiratory film? I don't know. What was he doing when you took it? I mean, you don't know, right? So you just stick the kid on his side. That's the answer to this problem. Never think about expiratory films. It doesn't make any sense. You can't time it. You put the kid on their side, and it gives you the answer, because the dependent lung should collapse when it's down with gravity. And yet this right side doesn't collapse at all. In fact, you could say it's even more inflated than the left side. That proves an obstruction of the right outflow. That proves that you've got a foreign body there. And now I've taken those little x-rays with Johnny, and I'm going to get the consultant to come in at 3 in the morning now because I've already proven that there's a foreign body right in the major tracheobronchial branches. When patients have aspiration, I don't know if you've ever been in this situation. You're intubating someone, and as you're intubating, you see lunch You see the patient's lunch, right? Moving from that hole into that hole, right? And you kind of look up at the nurse and you're like, could you please put up 900 of Clinda? You know, like you're kind of thinking, I got a little burrito down in the lungs here, it's not good. And that's wrong. And it's wrong because we know that when you aspirate, you get a chemical pneumonitis. And if you start to treat those patients with antibiotics right after they've aspirated, you increase their mortality. Because what happens is you aspirate 5,000 organisms, right? And then the clindamycin or whatever you give kills 4,500 of them, or even more. And the rest of the organisms are like, actually, clindamycin tastes pretty good. I don't mind it. And so you find 3 guys that kind of like Clinda in there, and they go hog wild and kill the patient. You select the resistant organisms, and then you kill them. So you wait for patients to become symptomatic and febrile after aspiration before you initiate treatment, and you get better results. This is a story about tuberculosis. It comes from the Centers for Disease Control and Prevention. And it's a touching story of a woman who's giving tuberculosis to her daughter. Now, I honestly think that there's too many arrows here, but it's CDC. Who am I to argue? But I think there should be only 2 arrows here. And I want to tell you what you need to know about TB for the test. Give me 1.5 minutes and I'll do that. The biggest problem when it comes to TB is our failure to recognize primary TB, primary infection. So let me tell you what I'm talking about. I was working with one of our senior residents a few years ago, and he was boasting to me about how he was at work despite severe illness. Something that we do because we can work no matter what, right? And he said, in fact, my pneumonia, in fact, it's right here. And he takes out his cell phone. He says, take a look at my x-ray. Shows me this. Shows me an x-ray basically that looks like a big lower lobe pneumonia. And I had to explain, I said, we don't call that pneumonia in residence at County USC. We call that tuberculosis, okay? And this is really, really important. If you're HIV positive, or you have AIDS, or you're immunocompromised, or if you're just unlucky, and you're one of that small percentage that once they contract TB, it just keeps on going. And when it keeps on going, it doesn't present that cavitary lesion in the apex that you're all looking at from medical school. Oh yeah, TB causes that apical. Au contraire, that causes a regular pneumonia. And so it's really important. You look at a patient who's got regular pneumonia with a consolidation, but they come from Southeast Asia and they were just in prison and they have relatives with TB, it's not pneumonia. That's the important point. And so we're always looking for this, but this is what I want to remind everyone is 100% consistent with TB, okay? So we've all seen that x-ray. This is miliary TB. I don't even think they can show you miliary TB on the test because I don't know if those monitors in the test stations can actually reproduce the small diameter of the millet seeds. But suffice it to say that miliary TB, if you see it, if you encounter it, I have many times, is systemic TBemia, if you will, and they're contagious, and they're pulmonary contagious as well. They might have other extra pulmonary manifestations as well. I didn't specifically mention it, but I will now, that TB and HIV, one other thing I want you to know about it that's different than non-HIV positive patients is that when you've got TB with HIV, you can tend to get it extrapulmonary. They very often have it extrapulmonary. The average patient with TB in the world has pulmonary TB or extrapulmonary TB. They've got it in their bones or their uterus, right? They don't usually have them together at the same time. But with HIV/AIDS, as you get sicker, the incidence of both pulmonary and extrapulmonary at the same time go up. So you can have scrofula and GU TB at the same time as CNS TB in the lungs as well. Very important point about the acid-fast bacillus smear is that it is insufficiently sensitive to make your to rule out TB anyway. Okay, and so if a patient again comes with sweats and chills from prison with risk factors and endemic areas, that type of thing, and you get an AFB negative, it means nothing to you. It's going to have to be repeated again and again before you have confidence that that person is okay. And so you're going to have to get hospital epidemiology involved. And these patients should be basically assumed to have TB until they're fully worked up with a full set of AFBs, not sensitive enough. Another thing that I think is very, very surprising is that if they tell you to send a patient, if the answer to on the test is send the patient home and they've got TB, you might be thinking, oh, that doesn't make sense. It makes excellent sense. And so to be honest, I want to discharge every patient that I can with TB home where they're not a risk to to the whole hospital inpatient team. And so very rarely does TB result in a sepsis syndrome where they're in shock and they need to go to the unit. Some people say that that does occur. I'm not sure if that's really true because they get co-infections with other things, and there's some controversy in my mind about that. But generally speaking, if their vitals are normal and they've got TB, dispo should be home in general if they're stable. In terms of skin testing, remember that it's a Bayesian phenomena. We don't consider skin tests to be positive or negative. It's all relative. So if I took the average person off the street here in Vegas, I'd need 15 millimeters of reaction to convince me that they were positive for TB. But if it's a patient with HIV/AIDS, any reaction makes me think that they have it. If it's a person like the resident that I just told you about who works with me in our emergency, 10 millimeters will do it because they work with lots of TB patients. And so it's all relative. You should know the side effects of these drugs because they love to ask about side effects. It's iatrogenic injury, so we cause it, so we should know about it. I would for sure know at least the first 4 on there. They come up all the time. Let's talk about sarcoidosis. You know, sarcoidosis causes a lot of morbidity, and it doesn't really get enough attention. It causes a lot of morbidity. And I want you to think about this in the context of bilateral hilar adenopathy. This affects African Americans predominantly. You might get the lab abnormalities on the question. They might tell you calcium's up. They might tell you the hemoglobin's down. They might tell you ALP is up. Bilateral hilar adenopathy is really suggestive of it if they put that. And you know what's really interesting about this disease? Those non-caseating granulomas, that if they're on the skin, like on that woman on the bottom, you can biopsy that and get the diagnosis right there and then done. It's interesting that you can actually biopsy skin lesions. The treatment is usually with steroids. It can affect multiple parts in the body, including the heart as well as the lungs. This is an interesting X-ray. We don't see as many lateral X-rays as we used to. I lament that. I really thought they helped me an enormous amount. I want everyone to sort of see what the issue here is. When you look at that X-ray, you see the top arrow is pointing to a mass that's in front of the heart and behind the sternum. That area should be black, okay? The heart should only have contact with a part of the sternum, right? Maybe a half or 2/3 of the sternum. What if the heart has no contact at all with the sternum? That's COPD, right? That's hyperinflation. What if the heart has complete contact with the sternum? Well, it's one of two things. Either the heart is massive or there's a mass in the anterior mediastinum. And that's what they're getting at here. And that's what they look like. They look like that. And when you got that, you know the differential is the terrible T's. By far the most common thing is cancer. If they're a younger man who's never smoked, lymphoma is pretty high on the differential. Anyone else, the most common thing would be bronchogenic CA. These other exotic things cause it, but they'd give you some clue if it was one of those. You know, teeth teratoma would have some other different clues. Thyroid is going to have perhaps endocrine symptoms. So you'll get something else to go on. So that's an important thing to remember and an important location. Now, when it comes to this picture, can you all please circle for me superior vena cava syndrome? Can you all please circle headache, 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 headache? That is the way that this disease presents. If you ever see words like suffusion or engorgement, or if you happen to see this internet picture that's been circulating around of this gentleman, then you'll have better clues. They'll be driving it home that the blood can't get back down to the heart. It's stuck up in their face and they're suffused and swollen. This is an emergency. This is an emergency. They die of this. They'll die that same admission if they don't get interventional radiology and a stenting of the SVC. If that's not an option that's available, the alternative answer is immediate palliative radiation, and you can irradiate that tumor to shrink it to open it up. First choice IR, if it's not available, radiation. They're not going to ask you about a simple pneumothorax and how to treat it and how to put it in the chest tubes. It's not going to do that bread and butter stuff. They might get to some of the things that are less common. Cervical pneumothorax. That's a pneumothorax and a hemothorax usually that comes every month with menses. And that's because endometrial tissue has been spotted in every location in the human body, even in the brain, even in the pineal gland. And the thing about that tissue is that it can respond to hormones just the same as the tissue in the gynae tract can. And so with the period comes the tissue inflammation, the pneumothorax, the hemothorax, and so that's catamenial hemopneumothorax. And that can be treated. How would you treat that? A pleurodesis, right? You'd want to basically seal the pleura layers, the visceral and the parietal pleura, together so that they couldn't ever get another accumulation of air or blood. This is what an x-ray looks like if you're a family doctor. It's beautiful, well labeled, there's no fingers or jewelry on it. There's no hands of the emergency doctor trying to bag the patient, things that we see on our films. But this is the classic pneumothorax, right? The classic line that you see, and those are all the classic features. Remember, we don't necessarily see those things on our films in the ER, where supine films can miss up to half of pneumothoraces. Now, how many of you, like me, have had that experience where a patient comes back from a CT scan or you get an x-ray read saying tension pneumothorax? Okay, put your hand, again, I'll start with me. And I know what that means. It means what I've been told in ATLS is that I'm a bad doctor. But they go further than that. You know that I'm a bad person. I'm a bad person, and I can't forgive myself. That's what we're supposed to think. Now, I would submit that most of us here have received a CT read at some point in the trauma that says tension pneumothorax. But here's the good news, is you never did anything wrong, and I never did anything wrong on this score either, okay? They didn't have tension pneumothorax. Tension pneumothorax is a clinical diagnosis. Now, with the rare exception of an x-ray like this, which I think it's hard to argue there's not a pressure effect here. You can see the diaphragms being pushed into the abdomen and stuff like that. But in general, tension pneumothorax is a clinical diagnosis, not an x-ray diagnosis. And in order to make that diagnosis, we need two things. We need hypoxia and we need hypotension. And if that patient that you sent to CT in good faith didn't have those two things, you did nothing wrong. Okay? And I want to make sure that we don't feel guilty about this anymore. Tension pneumothorax, hypotension, and hypoxia must be there. So that's the main thing. The only other way you can make the diagnosis radiologically is when you show progressive shift of the mediastinum. This is a clinical diagnosis. Clinical. Hemoptysis has gotten short treatment over the years. In fact, they didn't even have a section in the Rosen textbook until the last edition on it. And it comes up all the time on the test. Number one thing that you need to know for every test I've ever done in my life is asked this, is what's the most common cause? And the most common cause is Bupkas, is basically this to bronchitis, so whatever. There's two categories of blood in the sputum, and you guys know them. There's the blood in the sputum that's a little bit of streaking of blood in a person that's got pneumonia that's been coughing their butt off, right? And then there's the person that comes in and says, yeah, I just coughed this up, and they show you a cup full of red blood. I don't care about that one. I'm really scared about this one, okay? And so frank blood in any amount is life-threatening because remember the mantra, when you bleed into your lungs, you die of asphyxiation, not exsanguination. If you want to take that one step further, that hyperbole, you'll be in the morgue long before your first blood transfusion is necessary if you're bleeding into your tracheobronchial tree. And that's how we focus the treatment. We're not happy to transfuse that patient. We must stop the bleeding under all circumstances because we can't transfuse our way out of this mess. The ABCs of hemoptysis treatment are as follows. From the moment they get there, you want the bleeding side down. Sir, what side was your, I have right-sided lung cancer. Here's my incision right here. Perfect. That side goes down. That's both before and after the intubation, what you're going to do. Because you don't want that blood, it makes sense, right? You don't want that blood to cross over the carina, and then you've got two lungs full of blood, and then you're dead. And so that bleeding side goes down as a critical initial maneuver. And then we're setting up to RSI them. We're going to tube them with an 8.0 or bigger if we can, because we're going to need to look down there, and we're going to need to operate down there. We're going to need to suction down there to prevent the blood from clotting and causing basically that same thing I showed you with an asthma cast, you get a blood. We can't let it happen. We have to aggressively reduce their bleeding, correct their coagulopathy under any cost. Once we are able to tube them, we want to isolate the bleeding by putting that tube right down the left main stem if it's a right-sided bleed, or down the right main stem if it's a left-sided bleed. You might be thinking to yourself, I know how to do a right main stem intubation, right? I'm pretty good at that. What about the left-sided? You can do that too. Rich Levitan, one of our luminaries, showed on a nice autopsy, on a cadaver study, that just by turning the head to the other side while you're doing the intubation, you can effectively get into the left side most of the time. You can use a bougie. That's my trick. Using a bougie, you can go into the left side. But you've got to isolate the bleeding. You've got to ventilate the good lung and isolate the bad lung that's bleeding. Now, the last point there is, how are you going to save this life? I mean, you're doing this temporizing here, right? You're MacGyvering it. How is this life going to be saved? Bronchial artery embolization. They need to go to the angio suite, and they need to have their bronchial arteries blocked off, and that lasts about 72 hours. Then we can do some surgical planning, get the surgeons involved. Oh, this is the lobe that needs to come out, that keeps trying to kill this guy, and they take it out under controlled circumstances. So starting with bronchial artery embolization, and then for definitive therapy after that. Pneumomediastinum is usually benign, but you're not doing the ABEM examinations to be asked about benign things. As Almo so eloquently stated, it's VTAC, right? It's not SVT. Same thing goes for this. You know, in both blunt trauma and in non-trauma, you get lots of these benign conditions. Let me give you some examples. It's very common for us to see a little bit of air in the mediastinum after an accident, after a car accident, blunt trauma. And you've probably seen that. And it just happens sometimes. A little bit of air dissects through the cap, on a tissue level. There's a little bit of dissection of air with the force, and it just goes away. It's not a big deal. If you get air in the mediastinum after penetrating trauma, well, that's a major problem, right? That's usually going to be that missile has made a hole in the trachea or one of the big bronchi, and a little bit of a hole in one of those is a major problem. So that's what you're concerned about. You're concerned about pneumomediastinum in penetrating trauma. That's the problem. What do you do in a case like that? Well, I don't have the x-ray right here, but just imagine that you have this pneumomediastinum, you had a bullet that went in. You're going to have a massive pneumothorax probably too, right? Because it had to go through the lung to get to the mediastinum. And what's happening here is you've got that pneumomediastinum. What are you going to do? You're going to do your resuscitation. You're going to stick in a chest tube, right? But the chest tube won't work because the chest tube has got a little hole here, right? And there's a hole in the trachea that's 3 times the size that's competing with. So you put the tube on suction, and that tries to compete with the air that's coming out of this big hole, the carina, say. Not good enough. What do? Second chest tube. That's when you put the second chest tube, and put that on suction. And then if that doesn't work, you put in a third chest. I mean, hopefully you're getting a thoracic surgeon to bail you out here, but at that time, a third chest tube can go in on suction because you're competing with the rent in the trachea. Okay, so that's pneumomediastinum in a trauma case, penetrating trauma. What about non-trauma? Okay, it's exactly the same thing. I see patients with pneumomediastinum all the time from smoking crack, from smoking bongs, from making forceful Muller maneuvers, which are basically reverse Valsalva maneuvers. And those people get pneumomediastinum. They're not going to ask you about that. They're going to ask you about the guy who shows up, who's indigent, who has a history of alcoholism, who's febrile and sick, who's got air in his mediastinum, and he's got Boerhaav's. And so remember now, you have 2 critical signs of Boerhaav's from this course. There was the pneumomediastinum, and we talked about the left-sided pleural effusion, because when the esophagus ruptures, that's where it goes. So those are 2 critical signs. Now, this is getting to the really weird part. You know Hammond's crunch, by the way, which is that sound that air makes in the mediastinum. So if they have an audio stimulus of someone who might have this, that's the Hammond's crunch. But what's really wacky about this is the treatment for it, and the treatment of tension mediastinum. I've never seen this. Mediastinum is treated like we just discussed. If it's Boerhaav's, they go to the operating room. If it's a hole in the trachea, they get chest tubes and a surgeon. But sometimes pneumomediastinum hang on just a second, is a little bit more complicated than that because it can cause a tension. I've never seen it. If it happens, what you're supposed to do, take your finger, take a knife, stick it in here, the air comes out. Can you believe this? If it happens on the exam, that's what you're going to do. So they're going to give you a situation that looks just like a tamponade, but it's not fluid or blood in there, it's air. And you're going to have to release that air by putting your finger in here and letting the air out. Isn't that weird? Now, sometimes it's hard to see this because sometimes you see a border around the heart, you're not sure if it's air or not. I always do a lateral neck because the air rises. And then you see it easily. You see that stripe of air in front of the spine there? That's very helpful. Now, I show this slide and I get nauseated. And I think, oh, God, I'm really happy I didn't go into internal medicine. I mean, look at this thing. It's really a slide that's way more complicated looking than it needs to be. Here's the story on transidate and exudate. Transidate is thin, and you need to treat whatever caused it. It's thin fluid that was caused by CHF, by pneumonia. Just treat the underlying cause. Exudate is thick fluid that needs to come out. So that's basically empyema, thick pus that's not going to go away. That's cancer that needs to come out. Okay? And sometimes when they ask you about these numbers, the exudate has lots of stuff in it, like lots of protein, a high LDH ratio. Okay? But it's just because it's thick and there's lots of stuff in it. So basically, bottom line, transidate, you leave it, you treat the underlying condition, it's thin stuff. Exudate's thick, and if it doesn't come out, they're going to die because you need to find out what it is. Now let's talk about PE. We're getting down the home stretch here. Don't panic about PE in terms of all the new literature that's out there and all the active investigation and the latest thing that Dr. Klein has come up with. Don't worry about that. Just worry about the basics for the test. And I'm going to give you what I think the level is, the level that we're expected to be at. I'm going to bring us to the same page. Now, basically, Virchow's triad, and they're not going to ask something simple like that. They're going to kind of go to the less common things. So I want you to circle lupus there. The lupus anticoagulant was, I guess, one of the worst named things in medicine because what does it do? It coagulates, right? So that's anticardiolipin antibody. The patients that have lupus and have that are clotting machines. They clot, and so that's a big risk factor. You might get a question, actually, just to put pieces of knowledge together, about a woman that is having a lot of miscarriages. Because that happens in lupus, doesn't it? They get a lot of miscarriages. When she is successful at having a baby, the baby has heart block. A classic finding of a lupus baby is heart block. And then she's short of breath. Oh, that's a PE question. The other thing I mentioned earlier when we talked about nephrotic syndrome, and we talked about how patients with nephrotic syndrome are clotting machines as well. They form venous clots, and that's because they pee out all their factors in their urine. The standard symptoms are not a mystery to you. Don't forget that syncope is a presentation of this about, 5-10% of the time or so. Don't forget about that. And don't dismiss the diagnosis of PE just because you have a fever, especially if it's day 2 or 3 of the presentation, because, what is a PE anyway? It's an infarct. And it doesn't surprise any of us that after you infarct something that you get a cellular response and you get the fever sometimes. You can get quite a significant fever on day 2 or 3 from a PE. So think about the whole context of the question and think about whether they might have been describing PE, not pneumonia, when they've got an infiltrate. So here's some more good news. We know there's all these scoring systems for pulmonary embolus, and we know that PE is made, the diagnosis is made just like we talked about those Mantoux skin tests. We base our diagnosis on our pretest probability. Right? And to get that pretest probability, we can use the Wells score, the Carolina score. There's all these scores that have been come up with. But guess what the great news is? Those scores are no better than you as an experienced emergency physician. So it's totally legit for you to write in the chart, this is a patient's history and physical, and based on my assessment, I think this patient is at low risk, medium risk, high risk, no risk for PE. That's totally legit. And just as good as doing one of these scales. And then once you do that, you apply a diagnostic test, and then you reevaluate for your post-test situation, right? And so this is a figure that comes straight out of common textbook. I think this is from Rosen, from Jeff Klein's chapter. And basically, it has the algorithmic approach. If the patient has lower, moderate pretest probability, then you can do a D-dimer. And at this point, the playing field is more or less leveled in terms of D-dimer because we're all using the right D-dimer assays. There is that minor difference. Some people's assays, the cutoff is 250, some is 500. Don't worry about that. They'll give you the situation if they give you the dimer of what the normal is. But the bottom line is that the D-dimer is good enough at this point unless they have high risk to stop. Now, if I came off a plane from New Zealand and I said, you know what, I'm short of breath, and I've got this big swelling in my leg, I'm not sure what that's from, and every time I breathe it hurts, it's sharp. Oh, and my SAT is about 75%. None of you are going to do a D-dimer on me, right? Because I have a PE, and it's obvious. And for that matter, you're not just going to send me to CT either, because I might die in the CT scanner. You're going to start heparin, you're going to get going, and then you're going to CTPA me, right? If the CTPA is negative, then what are you going to do? Are you going to believe that? I just told you that story that was from a textbook. You're not going to believe that. You're going to think maybe the test was wrong or maybe it missed it, and you're going to keep going. And that keep going usually means lower extremity Dopplers, but it might mean a VQ scan, because a VQ scan is more sensitive for PE and picks up submental PEs that CTPA misses. And so it's not necessarily crazy to, in some selected cases, obtain a VQ scan when you've got a high prob. Now, the basic tests for PE are all usually abnormal, but they're so nonspecific as to usually not be helpful. Sure, you're hypoxic. Sure, your AA gradient goes up. Whatever, it goes up in COPD and other things too. EKG, we used to teach that the most common abnormality was sinus tach. We no longer teach that because we diagnose so many of these things that a lot of them don't have sorry, did I say VTAC? I meant sinus tach. Big difference between those two. So we used to teach that sinus tachycardia was the most common thing, and now, because of the greater number that we're diagnosing, it just seems like nonspecific changes are actually the most common thing. Now, the chest X-ray classically is kind of normal, but if you really look into detail, they usually have subtle abnormalities that represent volume loss. And so an elevated hemidiaphragm on top of a good story certainly increases my suspicion of PE, because I know that volume loss and lung collapse are really, really key in PE. Although the chest X-ray usually is nowhere near diagnostic or helpful, there are some times when it actually is. And I've looked back at my chest X-rays on positive CTs and found some pretty interesting Hampton's humps and Westermarck signs. In this patient on the left, they've got a Hampton's hump like I showed you before. On the right, you can see that there's an oligemic area showing no blood flow because of a pulmonary embolus cutoff. That's Westermarck sign. And this X-ray has both of them on it. And honestly, I think that at this point, a radiologist might say, hey, that's a PE. I mean, they've got a Westermarck and a Hampton's hump. I can see it. I see the infarct and I see the oligemia. So that is something that does happen. The same thing goes for the EKG. Like we said, it's most commonly non-specific changes here. But as you start to pile up the findings of acute right heart strain on the EKG, start to get a little more confident in your suspicion. Patient had a normal EKG, and then they have some symptoms that might suggest PE, and then you get an EKG that shows all of these signs of an acute right-sided heart strain, you better be thinking about PE. So usually nonspecific, but in some cases with all these findings it can be quite helpful. And let me point out one thing. The inversion of the T waves from V1 to V4, and these ones are puny. I'm going to have to replace this one with a bigger, more Wellens-like. Think more Wellens-like, the big, deep T wave inversions that you get in V1 for V4. Not only do they suggest PE because of the acute right heart strain, but they are specifically prognostic of a worse case. And so when you have that deeply inverted V1 through V4 T waves, not only does it suggest the right-sided change, a right-sided shift, but it also suggests a worse prognosis, a bigger PE. Don't forget that the D-dimer has its false positives in all those conditions there. It's not like you're going to take a patient who's 1 day post-op with clots forming everywhere and think that D-dimer is going to help you. It's not. So remember those false positives. Those are times where you're going to have to go for other mechanisms to get your diagnosis. I did mention that CTPA is very specific in terms that it shows you the actual clot, and if it's not a PE, it shows the alternative diagnosis, which is wonderful. But in fact, the CTPA is less sensitive than a VQ scan. And so, for example, a young, healthy, otherwise healthy woman with a normal chest X-ray, the VQ is going to be a lot better at detecting small PEs than CTPA. Now, having said all of that, is it really important? And this is sort of philosophical. Is it really important to pick up every single small PE? That's what we're grappling with. It may be, and there's some suggestion of this in my take of the literature, it may be that the CTPA is exactly sensitive enough as we'd like it to be. Because it's sometimes, if it goes too sensitive, maybe it's picking up PEs that are just naturally occurring as a regular course of events. You know, as we sit here, we are all forming tiny little clots and unforming them in our calves. And as we sit here, some of us are going to transiently probably have positive VQ scans in this dynamic equilibrium that's happening. And so I want you to consider that it's not always good to go to the most sensitive test for something. It may be that the CTPA is perfect. That's interesting. There's some important points on treatment that you have to know, okay? Heparin is not given the same way in PE as it is in acute coronary syndrome. This could not be more important. In acute coronary syndrome, heparin doesn't help. It's a bridge to cath. It's a bridge to transplant. Heparin doesn't cure. If you put someone with unstable angina on heparin, their life expectancy is no longer. It's only a bridge. And what it does do in acute coronary syndrome is cause lots of in-hospital complications and bleeds and hematomas and catastrophes. That's why the American Heart Association lowered the dose of heparin from the original, which was 80 and 18, as you see here, like it is in PE, down to the new recommendation of 60 units per kilogram bolus and 12 units per hour, because they recognize that this risk-benefit ratio is skewed towards risk in acute coronary syndromes. However, in pulmonary embolus, not only is it the treatment, it's so critical to get the right dose of it. We use the full dose, and we use a weight-based dose. We had to settle an action at one of the places where I work because a large woman with a PE that was diagnosed properly got a standard 5,000 unit bolus of heparin. That should never happen. Every time I need to heparinize a patient or anticoagulate a patient, because you can use other things like low molecular weight heparins as well. Every time I make a diagnosis of PE or DVT and I have to anticoagulate, every time I consult the pharmacist, because they'll give you the goods and the proper dose. In this woman, what we probably should have given her was 8,500, and she got 5,000, and she didn't do well. And the literature is very clear that heparin is the treatment for this disease, and it prevents them from dying. Now, moving along to TPA and lytics, if heparin's good, wouldn't TPA just be better? And that's what we thought when TPA first became available on streptokinase to use in PE. But surprisingly, it didn't work out as planned. I was involved with one of the first patients that got TPA in our hospital, and he had a saddle embolus, gave TPA, and it broke up into 1 million pieces and occluded the entire tracheobronchial tree, and he died. And that can happen. And in recognition of that TPA is kind of not necessarily a magic bullet, we've developed criteria for when TPA is indicated. You give it when they're in shock. So when they give you a PE case and they're hypotensive, you can give the TPA. If it's not like that, don't give it. It's heparin in the proper dose or low molecular weight heparin in the proper dose. So that's important. The only possible exception to that is if they're going out of their way to show you an echo with a big right ventricle that's really struggling, they're trying to tell you that patient also you can give TPA to that patient as well. That's another possible indication. Other than that, normal blood pressure, you can't give it. You give heparin. Greenfield filter for IVC, you guys know when you use that. That's a patient that anticoagulation is contraindicated, so you give that. Surgical embolectomy, I would have never even mentioned this years ago, but it's sort of coming back in vogue. I just want you to know that if that's an option that seems like it might be viable, it might be the right answer. A lot of surgeons are leaning towards doing that in some cases. Just remember that if they can't get heparin because of a bleeding problem, it's still a problem because they still need to anticoagulate them from that. Okay, and just a few more airway things before we're done. We all know the P's of RSI. They're not going to ask you sort of basic procedural things about stuff you do every day, but they might ask you some situational awareness sort of questions, sort of dynamic situations in airway that you have to make a judgment in. And so let me share with you my mantra for this, okay? Every time I go to administer a paralytic to a patient, I ask myself 3 questions. Will I be able to bag this patient? Will I be able to tube this patient after I've given him the sucks? And will I be able to crike this patient if I'm in real trouble? And if the answer isn't if the answer is not yes to 2 out of 3 of those questions, Probably what they're getting at in the test question is don't give paralytics, do an awake intubation, find an alternative, do something safer because you're going to get into a situation where you might have no options. So you want to be able to bag a patient, looking at their face and the dynamics of how that's set up, and their chin obviously is an indication they might be in hard tube. If they've got a big vascular tumor in front of their crike, that might be hard to crike. The Mallampati score and all that stuff that goes with the lemon is not as applicable to us in the ER as it is in the operating room because, they're in C-spine collars, they can't cooperate, but those are, you should know it. You should know those are criteria that predict a difficult tube. And sometimes they give scenarios. If you have any scenario where you can't see the cords but you see the epiglottis, that's when you use all your adjuncts like your gum elastic bougie and your lighted stylet. That's what all those are for. But if they give you a situation of angioedema, say this is a patient that's developed facial swelling after an ACE inhibitor, those are typically African American patients, or say it's a patient with congenital C1 esterase deficiency. The thing about that is that those patients are, they're scary, right? But the thing about that is their swelling is usually anterior, and the answer to the question is go posterior. So if you do a nasal tracheal intubation and you go back here, the posterior structures are usually not swollen. That's the answer to that one. Last one, penetrating neck trauma. We're really worried about giving sucks to a patient who's got a stab wound in the neck, for example, because as they've got an expanding hematoma and we give the sucks, their airway occludes instantly. These strap muscles in your neck play a very important role in stenting open your airway, and when you've got an expanding hematoma, it's curtains. And so we give ketamine to those patients to maintain their muscular tone, and we intubate them that way, and that's something that comes up sometimes on the test. The last slide is on tracheostomies, the last two slides, I think. And the situation here is airway, airway, airway first. They come in with a respiratory complaint. The right answer is, what about the trach? What about the trach? What about the trach? Because 90% of the time, it's a trach-related issue that causes them to get into trouble. And so we're going to remove the inner cannula, clean it, the outer cannula, clean it, and only then do we move on to the rest of the examination because that's a really important part. And the most scary thing, we talked about the patient who comes in and they've got a little bit of blood, right? What if a patient comes in with that blood and they've got a trach? That's not good. That's a patient that you really want to get out of your emergency room as quickly as possible and into the operating room. Because what could end up happening is that you get a little bit of bleeding from this tracheo-innominate fistula. And this happens. It happens because it's exactly the place where they put a trach, is right over the innominate artery. And so they've had like a sentinel bleed is the common thing, just like in subarachnoid. They describe, they had the first episode and it's your warning sign. They have that. They have like a little bit of blood through their tracheostomy, and they have a little tenuous clot in between their airway and their blood vessel that's holding together. And then you call the specialist, and they go in there with the scope, and they put the scope down the tracheostomy, and the patient codes because they've just disrupted the clot and they die. You need to take those patients directly to the operating room and be prepared to open the chest. Then you put the scope, and then if it happens to have been the innominate, you go and you repair it. So they go directly to the operating room. Now, if you're as unlucky as I am, and you are in a case where that's not a possibility, what are the damage control things you can do in the ER? If someone starts bleeding in front of you in the ER from one of these things, what you can do is you can blow up the balloon bigger. So if you blow up the tracheostomy balloon bigger, it can tamponade the vessel. And if that doesn't work, what's well described is you take your finger, just like I talked about with the tension mediastinum, and you stick it right in the hole, and you actually occlude the innominate between your finger and the sternum. You sit on the gurney on the way to the operating room. All right, that happened. And it might happen to you, so hopefully it won't, and you'll know what to do when it does. I've had a great time with you guys. Thank you so much for all your attention. Have a great lunch.
So, yeah. See here. Check, check. Check, check, check. 1, 2. Check, check. 1, 2. Check, check. Check, 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 check. 1, 2. Check, 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 check. 1, 2. Check 1, 2. Check, check. 1, 2. Check, 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 check. Yep. Okay. Here we go. Here. Check, 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 check. 1, 2. Check, check, check. 1, 2. Hello, 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 hello. 1, 2, 3, 4. 1, 2, 3. Check, 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 check. 1, 2. 2, 1, 2. Check, 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 check. 1, 2. 1, 2, 3. Check, check. 1, 2. I guess I could pad that. 1, 2, 3, 4. 1, 2. Check, 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 check. So it wouldn't be so bad. You could do that. How about that, huh? Do you like that? I was just testing you out there. Scared Michael. Check, check, check. 1, 2, 2, 3. Check 1, 2. One, 2, 3. 1, 2, 1, 2, 1, 2, 1, 2. Check, 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 check. 1, 2, 3. 1, 2. Check, 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 check. 1, 2, 2. And I'll tell you why that's going to be. Hey, 1, 2, 3, 4. And yes, 2, 2, 3, 4. And how's that? See, ha, he, ha. Yep, why did that get up there? Test 1, 2, 2, 3, 2, 2, 3, 2, 2, 3. Mm-hmm. Check, check. Check, 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 check. 1, 2. Check, check, check. 1, 2. Check, check, check. 1, 2. Check 1, 2, 3. 1, 2, 3, 4, 5. 1, 2. Check, 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 check. 1, 2. Yes, and I'm going to say, hey, hey, hey. Oh, gosh. Martin Aleman. Yeah, it works okay. Come on, yeah. Yep. Check, 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 check. 1, 2, 1, 2, 3, 4, 5, 5. 1, 2, 3, 4, 5. And that did 1, 2, 3, 4, 5. That went high. 1, 2, 2, 2, 1, 2. Check, 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 check. Test. Yep. 1, 2. Still like to go down a little bit. So, could be the sensitivity of this. They're all coming in now. to get too hot. Mm-hmm. Check, 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 check. Test, test. Check. 1, 2. I don't like how that is. Check, 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 check.
All right, all right. A few people are not dwindling back in here yet. You guys got the slides? Hello, everyone. Welcome to the second half of day 2. You're almost halfway through. Congratulations. This is one of the funnest ones of the 3. We do this course 3 times a year. We used to do it once in July and twice in August, but now that you can take the exam in March, we also do now one in February and 2 in August. So it's always a little different personality in each group that comes to these, and this is always sort of the more intense, cram it in, gotta get this test done, just let me cram it in and stick little plugs in my ears and keep them in there until I sit down on that exam. So I want to thank you for being here for a lot of different reasons, but I want to thank you because your patients thank you for being here. What we need to know, every time I sit through this course or I go through all the slides, which I do every year as sort of part of co-directing this course, I am flabbergasted at what we need to know for what we do. Absolutely flabbergasted. So, good on you for being here. I think everybody learned something that you didn't remember, and hopefully it's worth your while. So. Now, I'm Diane Birnbaumer, by the way. I'm co-director of this with Rick. Rick is gone. He had a family issue and had to leave, and gives his best regards to all of you. He also thanks you for being here. But what we're going to do now is, after you've had your lovely lunch and your 2 nights in Vegas and a little bit of gambling, perhaps, a little bit of fun, is we're going to talk about sex, which is a very appropriate topic for Las Vegas. And those of you who flew into Las Vegas, when you got off the airplane, if you paid attention when you were walking through the airport, you saw this. What happens here stays here, which is the Vegas sort of motto. Do go crazy, it'll just stay here, it won't go home with you unless you happen to become a member of the STI club. There are certain sexually transmitted infections that are not curable, that you actually will take home with you and perhaps give to other people, so be careful who you sleep with. Okay, let's talk about, does this sound right? This sounds funny to me. Does it sound okay out there? Okay, got it. When we talk about sexually transmitted infections, we're going to focus on the 2018 STI guideline that came out from the CDC. A couple things about your exam, which all the other speakers have also been telling you. When you take your exam, you sit down at ABEM General, those of you taking the qualifying exam and those of you taking the concert. What they've put on that exam are things that the test questions have been vetted. The test questions have been validated and tested, meaning that they have several go-rounds they have to go through of tests coming to you that aren't really actually being scored. That means that there's a lag time between what happens in the real world in your day-to-day job, which you will do the cutting-edge thing when you go back to work, and what you're going to get tested on at ABEM General on the exam itself, because there's a year or 2 lag time on what's happening in the real world to what gets to that exam. The reason I mention that is the STI guidelines that came out in 2015 are now that's the last time they came out as a one-time guideline. Now what they're doing is this instant knowledge translation concept where they're updating the guideline every time something new changes. So things that are brand new, I will tell you about, but I will tell you when they're not going to be on the exam, and I'll focus on what's on the exam. Because part of today is to pass the exam, but also part of today is to kind of get some information to take home. So the last formal STI guideline now is 4 years old, but things have changed since then, and we'll talk about that as we go through it. So what we're going to talk about when it comes to sexually transmitted infections is I like systems. I like organizing things in a way that I can remember. We have just so much we have to remember. So I think of sexually transmitted infections as infections that cause sores and infections that cause drips. And if you think about it that way, you already have a first dividing line into 2 big categories of the kinds of infections that present that way. So let's start with the sores, or the ones that cause ulcerations. This is the list of things that can cause ulcers on your genitals. And if you were taking your, say, internal medicine board exam, which I took about 1 million years ago, some of the things on this list would be very, right game for testing to an internal medicine group. For an emergency medicine group, anybody showing up with sores on their genitals is going to have a sexually transmitted infection if they present to ABEM General. So it's going to be syphilis, herpes, chancroid, or LGV. And we're going to focus on those, but know that other things can cause it too. Things like yeast infections, fixed drug eruptions, but they won't, Behçet's, that will not be on your exam. What they're going to want you to know is what causes ulcers that are infections, in sexually transmitted infections. So let's start with syphilis. Now, if I did 2 residencies, internal medicine and emergency medicine. If I'd stayed in internal medicine, I would have gone into ID. because I think organisms are fascinating, and they're super smart, and they're a lot smarter than we are, particularly things like gonorrhea. Syphilis is incredibly stupid. It still responds to penicillin. It's not a very bright organism. However, its history is fascinating. There are a lot of very famous people out there in the world who've had this. Both of the Lincolns had it. I have no idea who brought it home, but that was, I'm sure, interesting dinner conversation as far as who brought that particular infection home. Henry VIII had it. Hitler had it. We had Benjamin Franklin, who spent most of his time across the pond over in London. He had it. And it probably arrived on the European continent because of this gentleman, who is Christopher Columbus. Syphilis wasn't known on the European continent until 1493. Now, if you remember back to grammar school, there was a little ditty that you learned. Columbus sailed the ocean blue in 1492. Well, when he landed in the Caribbean, odds are that the theory is that the syphilitic spirochete organism was picked up by the guys on his ships and taken back to Europe. And I'll tell you, when it hit Europe, it killed basically a third of people who got it. It was a big deal. We've learned a lot about syphilis since that time, and what we've learned about it is it causes a lot of things. That little spirochete, that little twirly thing, causes lots of trouble. It's Treponema pallidum is the organism. You know that. And what will happen is, let's say you're walking down the street today in Vegas, and you see those signs that say a girl to your room in 15 minutes, and you make the phone call, 1-800-GIRL-TO-MY-ROOM, or whatever you want, and you sleep with the wrong person today, and you pick up syphilis today. The incubation period is going to be at the time of your exam, you're going to have your chancre. Okay, so you pick it up today, you're going to be fine until you sit having your exam a month from now. And that's when you're going to get your chancre. And what you're going to have at the site of inoculation is a painless indurated ulcer. Doesn't hurt. Men tend to notice it more than women because their genitalia is just right there. Women, it actually can be in an area they don't see. So a woman may have a painless chancre and have no idea she has it. It will be at wherever you're inoculated. It can be on your mouth, it can be on your hand, it can be on your forearm. It's wherever you're inoculated, you'll have a painless chancre. Again, the incubation period averages 2 to 4 weeks. It can be as long as 3 months, but it's about a month. So it'll be when you're taking your exam. What's cool about it, or not so much, is that it's going to heal by itself. You're going to take your exam, you're going to be focused on the exam. What is that lesion thing? I don't know what it is. It's going to go away by itself. Basically, it resolves. So you think you're all better, but you're not. The spirochete's still in there. And the testing at the time of the primary chancre, and I think you heard a little bit from Stuart about this yesterday, the testing may not be positive during the time of the primary chancre. So your syphilis testing, the serologies may be negative when someone has a primary chancre. Okay, so it goes away, life is good. Here's a little organism on the left, that's the chancre on the right. Again, painless. That person, that gentleman may have no idea that he has a chancre there, but painless. And that it's, again, on your lips if that's where it occurs, or you can actually see it down on the genitalia in women, and she may have no idea. The woman who has that chancre may have no idea. It doesn't hurt. She may have absolutely no idea it's down there. And again, all of those go away. So 2 to 4 weeks in, you get that, they all tend to go away. But what happens is about 2 to 10 weeks after that, so you pick up syphilis today, we're now talking Thanksgiving or Halloween. On Halloween, you develop a rash. It starts kind of maculopapular on your torso, annular looking, looks for all the world like pityriasis rosea, which Peter Sokolov's going to do your derm talk and show you pictures of pityriasis. It looks exactly like this. So it's not a specific rash to syphilis. It's just a secondary syphilis rash that's all over your body. And what's happening is it's now disseminating. It's now not just at the site of inoculation. It's kind of crawling all over your body. So you get kind of aches and pains. You may get a low-grade fever. You may get some lesions down in the genitalia that are different than that primary chancre. They're called condyloma lata. They're these flat lesions, which are also highly infectious. And you get lymphadenopathy. Again, your lymph nodes are trying to fight this infection. Now this, again, if you ignore it, so it's Halloween, you've got this rash, you've got to take the kids around the neighborhood, it also will go away. But what happens then is it becomes latent. So the syphilitic organism now just hunkers down in your body and does all kinds of terrible things over time. Now at the secondary stage, it looks like this. This is a person with secondary syphilis. This is the rash. And interestingly enough, we are, as a country, seeing an uptick in syphilis cases significantly. In fact, we've seen several secondary syphilis cases where I work recently. So keep an eye out for this. We're seeing an uptick in syphilis cases nationally, nationwide. That can look a lot like pityriasis, right? That looks like pityriasis rosea. It tends to be palms and soles, but I will tell you it's not always. But I'll tell you, at ABEM General, what they tend to do is say, a person presents with a rash, and you notice there's a lesion on their palm and a couple lesions on their soles. They're going to want you to pick up on that being sort of the syphilitic part of the rash. So here's some on the palms and soles. You don't want to shake this person's hand. Okay, this is infectious. Don't shake this person's hand. And if you look really, really, really closely at that tongue, if you look kind of right around there, look really closely, you can see spirochetes jumping off of there. That is the same rash on your skin in your mouth. Those are called mucus patches, highly, highly infectious. And these lesions on the left are called condyloma lata. These are kind of flat, wart-like lesions on the genitalia, lots of them. And they, unfortunately, are not perfectly distinguishable from condyloma acuminata, stuff you get with HPV. So when you see lesions like this on the genitalia, you're going to think, well, it might be secondary syphilis, but it might also be condyloma acuminata. Smooth and flat, more like syphilis, but they may be warty-like as well. Now, once it's gotten latent and it's like hanging out in your body, what happens over years is that it basically sits at, it loves your aorta, it loves your brain, it loves your spinal column, and so basically it makes you crazy. It gives you neurosyphilis, gives you tabes dorsalis. It can cause basically aneurysms of your aorta. It's pretty gnarly business. It gums up all of your lymph system, so you get gummas all over the place. So you get things like this. If I don't feel my joints very well because I have tabes dorsalis and I'm walking funny and I've got some neurologic dysfunction, I get basically Charcot's joints of my knees. Or I get these gummas of my skin where all my lymph tissue is trying to fight this organism that's just gone rampant through my body. I can have them anywhere. And these are fascinating. That top left picture is a post-mortem brain in somebody who had syphilis of the brain, who was basically nuts from the... And you know, in dementia workups, what we're supposed to do is do, at some point in time, not us, but our colleagues, do a CSF VDRL, because neurosyphilis still occurs and it makes people demented. So that's what a brain looks like. In the middle is apparently Ben Affleck. He looks a lot like Ben Affleck, who has all the gummas all over his face. And that woman on the right, this person right here, that thing right there, if you were to put your hand on it, is pulsatile, because that is her aorta. It is dilated because she has aortic syphilitis, or syphilitic aortitis, and basically it's eroded through her sternum, and that thing actually, her cause of death 2 days later is that thing ruptured externally. Nasty business. The death certificate on the bottom left there is tertiary syphilis. It was a huge, huge, huge problem in the 19-teens and 1920s. Enormous problem. Now, diagnosing this, the way to diagnose syphilis, we used to be able to do dark field microscopy. And that's sort of antique and interesting. And we still have a dark field microscope where I work, but it's basically up and sort of in storage and dusty. We don't use dark field much anymore, which is a little bit of a shame, but anyway, because it's a quick diagnostic test. What we do now is serology. So we do serologic tests, and I know that Stuart mentioned this a little bit yesterday, but we have two kinds of serologic tests. One is either the VDRL or the RPR, and that's a test that's not to the organism itself. That's a test that basically measures your body's reaction to being infected with the organism. So it has some false positives. Other things can cause that to be positive. Things like lupus can cause it to be positive. The confirmatory test that is specific to the treponeme is the FTA. The reason we have two, and that we need to know about two, is the FTA is positive for life. And even if you get cured of this episode of syphilis and you get it again down the line, the FTA really doesn't change in any predictable manner. But what does change is if I cure you of the syphilis that you picked up while you were studying for your board exam at the board review course in Vegas this year, and I treat you, what will happen is that VDRL will go down to 0. But now you come 10 years from now and haven't gotten any better judgment in that 10 years, and you get infected again, your VDRL will go up. So the reason that we need to know about the two tests is the VDRL is what we follow for test of cure, the FTA is positive for life. So that's how the testing works on this thing. When it comes also to testing, they recommend testing for HIV. That's an institution thing, but no, the CDC recommends this, and the treatment for syphilis is penicillin. Penicillin, penicillin, penicillin. It dies when you whiffed its direction. And the reason that it's important to understand how sensitive this is to penicillin is, let's say I have that rash, and you are spot on hot. You came back from the board review course, you noticed that I had a couple lesions on my palms, you looked at my tongue and saw that thing on my tongue, you saw the rash, and you diagnosed secondary syphilis. You decide you're gonna give me the penicillin you know works. Okay, I am penicillin, boom, it works. The problem is my body is full of all those spirochetes, and they all die pretty fast and all at once. And when they do that, they release an endotoxin, and they give me a thing called the Jeris-Herxheimer reaction. So what I get is that all of those organisms are dying. I get febrile, I get myalgic, I get really achy. Happens usually within the first 24 hours of getting your shot. So that if you don't warn a person that's going to happen and say you might get a fever, if you do, just relax, take some Tylenol or something to take your fever down. Then they may come back and say, dude, what did you do? I had a rash, and now I have a temperature of 104. What's up with that? So know the Jairus-Herxheimer reaction occurs. And I'm going to tell you a story from my career that will help you remember the Jairus-Herxheimer reaction. When I was an internal medicine resident a million years ago, in my second year, we had a 1-month medical consultation rotation we had to do, which meant we got called by all of the surgical services all the time. And I got a call in the middle of the night from a panicked orthopedic service that called me to the recovery room because a guy had spiked a fever to 105 in the recovery room. And they were worried that he was basically septic and dying. They were frantic. I ran to the recovery room, and what I noticed was first all these big orthopedists standing around the bed. And in the bed was this 19-year-old big strapping guy who basically had the sheet over him, and sticking out from under the sheet was a bare foot and a foot in a long leg cast. And what he'd been admitted for was an open tib-fib fracture that he'd had basically ORIF'd, and they put him in a long leg cast. But on the naked foot, on the sole was a rash. And pulling down the sheet, on his torso was a rash. And looking at his meds, he got Penox and Gent pre-op because he had an open fracture. It was so much fun to look at that orthopedic group and say, did you touch that rash? They all ran to the ER to get their prophylactic penicillin shots, but they all basically their penicillin had treated this guy's secondary syphilis. It was awesome. It was awesome. It was so great. You'll never forget it. All right, I want you all to look to the person to your right, look to the person to your left, look in front of you, that person, look at the person behind you, and then look within. Because one of you has herpes. I'm not kidding. I'm not kidding. 20% of adults in North America test positive on serology for HSV2. 20%, 1 in 5. So in this room, there are probably 50 of you who basically test positive for HSV2. Now, that doesn't mean all of you know you have it. It turns out you can acquire HSV relatively asymptomatically. There's a primary infection where you get it and you are naive to HSV. So I've never had a cold sore. I've never had any kind of herpes of any kind. And I go down and have my bad judgment here in Vegas. And now I get a disease that I can take home with me. I get herpes. And I've never had it before. That's basically a primary lesion, a primary infection of that. Now, if I've had, say, cold sores before, fever blisters before, and I pick up a genital infection of HSV2, this is HSV1, I pick up HSV2, I'm less sick. I already have some antibodies. I'm less sick. I don't get quite as sick. And then you can have recurrences of this. So it turns out that there's a broad spectrum of how people will present when they pick up HSV or they manifest HSV. So if you are naive to the virus completely, you've never had any HSV before, when you pick up the virus, you get viremic. So you have an initial systemic illness phase where you get viremic. Then you break out in the lesions, and the lesions tend to be blisters, and then they unroof and become ulcers that are really painful and multiple. They'll last 2 to 7 days, then they take a while to heal. So your illness, if you are naive to herpes and you pick it up today out there in Vegas, you're going to be sick for 3 weeks. You're going to be 3 weeks before you're better. If you're somebody that had fever blisters and you pick it up today, you're not going to get as sick. You probably won't get systemically ill. Your lesions will come on sooner. You'll end up with less lesions, less painful, and you heal more quickly. So and then if you're a recurrence, it's a whole different ballgame. So no, the primary infection is the bad one, and people end up pretty sick with that, and they get systemically ill. These are what the lesions look like. So in the picture on the left, the gentleman with all those sort of ulcerated, those are all really painful. All those ulcerative lesions are painful. And on the right, in the female genital area, they can coalesce completely. They can end up denuding the entire sort of vulvar area. So in the primary infection, it tends to be pretty dramatic when people get this infection. When people have, what happens with the herpes virus is I've picked it up, and I don't ever eradicate it. I never eradicate it. In fact, when it hit in the early 1980s, where this was a big deal, it was the first incurable sexually transmitted infection, it was a big problem. People thought, oh my God, no, I'll never get rid of this thing. And you don't. What happens with that virus is it basically hunkers down in your sacral plexus. You've acquired it genitally. It lives now down in your sacral plexus and your nerve tree down there. And what tends to happen is it recurs. So people may ask you, will I have this again? The answer is yes, but. So if somebody came down with that first infection, they were sick for 3 weeks. They got viremic, then they got the ulcer, the vesicles that were then ulcers, and then it took a while to heal. What you need to tell that person is, yes, odds are very good that you're going to have this recur. However, You are not going to be as sick as you were that first time. Recurrences, half of them have a prodrome. People know it's coming. It feels tingly or itchy or numb down there. They know it's coming. So they can either prophylax it, take the medicine, and basically not abort the recurrence from happening, or it's shorter. They end up with just 4 or 5 lesions, not 15 or 20 or 30. They end up with less lesions. So people, yes, recurrences are common. Some people get them every menstrual cycle. Some people get them every time they're stressed. So you're sitting at your board review exam, knowing that your exam is 3 weeks from now, and because you're anxious, you get tingling down there and you get a recurrence. So a lot of things will trigger these recurrences. They are something you can actually give meds for. You can suppress them, which is nice. The other thing to know about herpes is one of the reasons that 25 or 50 of us in this room are positive antibody for this is people can shed the virus without being symptomatic. So people can actually, it's about 1 day in 100 that people will actively shed the virus, that they don't even know they're shedding it, and can give it to their sexual partners. So it's actually something that gets spread pretty rampantly. Now, the diagnosis is made clinically. We don't usually do testing for this, and in fact, the CDC really doesn't recommend doing any testing with one exception, and that's a woman of childbearing age. The reason for that is that if the baby picks this thing up, if a mom gets pregnant and she has herpes and she's not surveilled during her pregnancy, it turns out that herpes, congenital herpes, is devastating. It's one of the torch. It's the H of torch, those torch infections that you can get for kids. You'll hear about it in peds. When we talk about peds, you'll hear about it in derm. Those are the things that are really, really scary for kids. So women of childbearing age, you may actually want to test. And what's recommended now is PCR testing, not viral testing, none of that. In fact, SANK tests are off the table completely. So in general, you're going to make the diagnosis clinically. In a woman of childbearing age, you're going to consider actually sending a confirmatory test to verify. Now, as if it weren't bad enough already to get sick for 3 weeks when you pick up herpes, it turns out about 10% of people with that primary acquisition of infection, the viremia, whole shenanigans that happens, about 10% will get a true, honest-to-God viral meningitis. And it tends to be as they're starting to feel better. So they're starting to kind of heal, things are starting to feel better. Then they get the headache, the photophobia, the whole 9 yards. If you tap them, they have white cells in their CSF that's almost all lymphocytes. It can be as high as 1,000. So this is something that you can see in people that, and again, 1 in 10 will get this. Some people get urinary retention. As the virus is sitting down in their sacral plexus, it causes an autonomic dysfunction as it's kind of setting up shop. And people may end up with urinary retention. That happens women more than men, but that can absolutely happen. Some of the other things are rarer that can occur, but those are the things that are big enough and common enough that it's something you kind of need to know, not just for your real life, but for the ABEM general exam as well, where they may have somebody present with, had recent lesions and now comes in with a headache, a fever, and photophobia. You need to know that that could be basically a meningitis from herpes, not encephalitis, a meningitis. Again, I mentioned the torch, which is something just to kind of keep in mind. You can get herpes anywhere. It tends to be around the genitalia, but it can also be perianally as well. And that can just happen from just the secretions that occur with sex. It gets in those secretions and actually kind of smears itself around, and you can get it perianally as well. Now, if you have a case where they give you a case on the exam, or a case comes into your ER where it's somebody with multiple painful genital ulcers, so what's going to go off in your head is herpes. Sure sounds like herpes. Multiple painful genital ulcers. They may even look like this. Except they also give you that the patient has a large fluctuant lymph node. That is chancroid. So the synapse to make in your brain for both real life and the ABEM exam, I cannot imagine they're going to put this on the exam. But in real life, these outbreaks occur, and they tend to occur sort of in little pockets around. We had an outbreak of this not that long ago, actually, in Long Beach, right near where I live. So this is the synapse to make looks like herpes lesions, but what's with the big lymph node? Then go look it up. That's chancroid. And the reason it's important is chancroid is an organism. It's basically a gram-negative bacillus that we can't grow. It's hard to grow this thing. And you treat it with ceftriaxone. This is something you can basically treat with. It's not something you treat with antivirals. You treat it with ceftriaxone. So that chancroid occurs as well. And just add in your brain the bubo, and you won't miss chancroid. The thing else that can happen with chancroid is sometimes the lesions aren't multiple painful lesions that are sort of that shallowish looking thing. Sometimes they're what are called kissing lesions, where if it's on one part of the genitalia that touches an area of skin, it can auto-inoculate there. That's called a kissing lesion. Now, the fourth of the four, the first one we talked about was syphilis. That's spirochete. The second one is herpes. Okay, that's viral. The third one is chancroid. That's bacterial. This is the fourth one. This is LGV. Very uncommon in the United States. However, again, it occurs in outbreaks. Anybody who lives in New York City, you guys had an outbreak of this about 3 years ago in New York City. We also had an outbreak in Long Beach in Southern California, and there was an outbreak in Washington State of LGV. This is a chlamydial disease. So now we're up to our fourth kind of organism. It's chlamydia that's actually intracellular. This is the same chlamydia. It's chlamydia trachomatis, like we're going to talk about in a minute, but it's specific serotypes of it. And when somebody picks this up, this tends to be men who have sex with men. It's the vast majority of these cases are MSM kind of acquired cases. And what they get is an evanescent ulcer that they may never even notice. It's painless, it tends to be small, they may never ever notice. But then they get adenopathy, usually bilateral, usually not fluctuant, and kind of matted. And the classic presentation, the sign they would give you if it's the exam, is the groove sign, meaning it's adenopathy above and below the inguinal ligament. I'll show you a picture where basically there's a line that kind of goes through the adenopathy. And again, it's not super fluctuant. It may be a little tender. Eventually, it's going to erode through the skin and cause chronic draining sinuses. That's why you want to pick this thing up. They may have chills, they may have fever, but mainly they come in for this adenopathy, and that groove sign, which is this, is what you're looking for. Now, the diagnosis is made like any other chlamydia. You're going to send NAATs, works great. Treatment for this is 3 weeks of doxycycline, so it's a long-term treatment deal. It's not just a one-shot-and-go kind of deal. And they recommend doxycycline over azithro, so that's the recommended treatment for this, but these are the pictures that you'll see. Okay, this is a little bit tender, might be a smidge fluctuant, but it's not a big, gigantic lymph node like you see with chancroid. This is what happens if you miss it. So if you happen to work overseas, you may actually see this. It turns out that LGV is something we see more often overseas. Chancroid we definitely see more often overseas. And this is the elephantiasis, chronic draining sinuses thing that can happen if you miss this, if you don't treat it appropriately. All right, it's like, oh my God, Diane, just quit talking about all this stuff. Give me one place to go look it all up. This is what you want to highlight. So if you just can't remember this stuff, it's like, I just can't remember all this garbage. This is the page to go through the day before your exam. Okay, it has everything you need to know right there on this page. Now let's go to the drips. Let's go to the things that cause the drippy things down there. Let's go to this group. And it turns out there's a large number of things that cause drips down there. The things we think about as the classic STIs are chlamydia and gonorrhea. But you can also have non-gonococcal urethritis that does this. And then we get into the vulvovaginities that also cause drips down there, some of which are considered sexually transmitted. So let's pick them apart. Let's go in there and kind of pick all these apart. Let's start with chlamydia. And if somebody were to ask, what is the most common sexually transmitted infection in the United States, it is chlamydia by manifold. It is way more common. And the thing about chlamydia is kind of a silent little nasty thing. It doesn't cause gigantic symptoms. It doesn't make people super sick, but it causes a lot of low-grade harm over time. So it's a major cause of infertility and PID. It's probably the biggest reason that we have so much infertility in the United States. And the thing about it being kind of this low-grade thing is it can infect several parts of your body. Your urethra if you're a guy, your urethra if you're a woman, your cervix. It can actually go up into the upper female genital tract, but it doesn't tend to disseminate and cause lots of systemic problems. It just does this local thing. And because it's not super inflammatory causing in your body, people don't end up with getting, I have tons of discharge and I have, just terrible problems when I pee. They don't. And women may have no symptoms whatsoever. Asymptomatic infection is quite common. Quite common when it comes to chlamydia. So it's one of the reasons that it's so prevalent. The incidence is so high, we pass it around like crazy because people have no idea that they have it. So symptoms can be mild with this. So discharge may be there or not. And if men have I know that it was referred to a little bit yesterday by Stuart, but men's discharge with this is just like a little clear drop of fluid. It's not purulent by any stretch. And if they might have some burning when they pee, but it's not horrible. So this is not a dramatic thing by any stretch. It is a cause of epididymitis, probably the most common cause, but it ends up being not that common because we pick this up. We pick this up a lot. This is something, if you were to pick it up today, you would have your infection while you're taking your exam 3 weeks from now, but you may not even know, right? Because the symptoms are so mild. You may not even know that you have this. So asymptomatic is common. The thing that can happen in women, and this is something that happens in real life more than ABM will put it on their exam, but it's going to make you a better practitioner. If you take care of a woman who comes into your ER, and she says, what's weird? I went to see my primary care doctor 6 days ago because I was having burning when I urinate. And they put me on oral antibiotics for 3 days, but it still was bugging me. So I went back again 3 days ago, and because it was still burning when I urinate. And they checked my urine, and there were white cells in it again. They said it was infected again, but they gave me more antibiotics. It's still bugging me. What this is could be chlamydia. So the same chlamydial urethritis that men get, women can get too. It's called dysuria sterile pyuria syndrome. And what's going to tell you it's urethritis, because you're a smart person, is they're not going to have urgency frequency. It's not cystitis, right? It's actually just the urethra. It just burns when I pee. I don't feel like I have to go more or go more often. It just burns when I pee. They'll have white cells in the urine because it's a urethritis, but they'll have nitrate negative. They won't grow organisms if it ever gets cultured. And you're going to know to switch them to chlamydial treatment because that's what they have. And you can do a urine test for chlamydia and you're going to look like a rock star. So that's called sterile pyuria dysuria syndrome. The diagnosis of this is NAATs. The nucleic acid amplification testing has changed everything. And it can be urine. So urine in men, urine in women. It's a fabulous test. Works great. And the treatment is azithro. For the simple chlamydial stuff, the lower chlamydial stuff, it's azithro, single dose or doxy for a week. Gonorrhea is different. Gonorrhea is super smart. And in fact, there's a strain of gonorrhea out there that is resistant to everything we have. Everything we have. It's actually in the United States now. It was not stateside for a while. It's now in the United States. And if, God forbid, this ever gets out into the real public, because this is going to be impossible to treat. The thing about gonorrhea is if you were to sleep with somebody today and pick it up today, by the time this course closes on Tuesday, you're going to be miserable. And you have a 50-50 chance. If you sleep with somebody who has gonorrhea, a 50-50, it's basically playing Russian roulette with a gun that has only 2 chambers in it and 1 bullet. You will pick it up 50% of the time on a single sexual encounter, and the incubation period is basically as long as 14 days, but usually 2. So within 2 days, you are symptomatic. And you're going to be women will get a discharge. Men get purulent urethral discharge, and it burns like glass, like peeing glass when they pee. It's pretty dramatic. And the urethral discharge can be profound. It's definitely purulent. It's not subtle. Okay? It is not subtle. It can cause epididymitis in men. In women, it can go all the way up into the upper genital tract. And it can disseminate, which causes all kinds of trouble down the line. So it is a really aggressive, nasty bugger. So you're going to pick this up and pick it up quickly. So it's just very aggressive. So if you ever do a pelvic exam on a woman, it says, my discharge changed. I know always have this little bit of a white discharge, but man, it's a little bit green and it's a lot more than it used to be, or even a little more than it used to be. Or she says, it's weird. We had sex last night and I'm spotting today. What's up with that? I'm not having my period. I just have these little tiny spotting. What's happening? What's happening is that cervix right here is basically covered with gonorrhea. That, coming from the endocervix, is gonococcal schmutz, and that's a really upset cervix. And if you traumatize that with sex, or you basically put a speculum in there and take a swab and swab that, it'll bleed a little bit. So women may present with a little bit of spotting as their symptom when they get gonorrhea. If you were to gram stain that, I know gram stains are kind of quaint and old-fashioned, but if you were to gram stain something, if someone has gonorrhea, for instance, Jan told you about gonococcal conjunctivitis. If you were to gram stain all that schmutz in somebody's eyeball, what you'll see under the microscope is this. It's those gram-negative intracellular diplococci that we know are gonorrhea. And look at the number of white cells. That explains to you why gonorrhea is so irritating. The body doesn't like it, so it sends out all the troops. And you have all kinds of white cells that are at whatever site of infection to try to fight this particular infection. Now, we don't send gram stains usually. I do want to emphasize, consider it in that terrible conjunctivitis case, because you may get the positive gram stain that tells you this is not just your run-of-the-mill bacteria, it's true gonorrhea. That's the time it's most helpful. But in general now, what we do is NAATs. We have men pee in a cup. Women a urine test in women is actually quite sensitive. An endocervical swab is better, but not by a ton. So urine tests of NAATs are absolutely fabulous. What they don't give you is sensitivities. So you'll notice in guidelines and public health things, please consider culture. They want to know what the sensitivity is because we know there are strains out there that are resistant to everything we have. But the reality is for what we do, we basically make the diagnosis using NAATs. If we have a presumptive diagnosis in the ER, we treat. Know that now, because gonorrhea is so smart, the treatment for gonorrhea is 2 drugs, period. 2 drugs. If you're treating for cure, it's ceftriaxone, 250 milligrams, and azithromycin a gram. The azithromycin used to be given to catch the co-infection with chlamydia if they had it. Now it is a necessary second drug for treatment for cure for gonorrhea. So it's a 2-drug therapy, and that's been out long enough that it is infinitely testable on this exam. And in the real world, it's a 2-drug therapy, absolutely 2-drug therapy. Now, you can get gonorrhea other places. It's much more aggressive than is chlamydia, so it can affect you lots of places. You can get rectal, you can get conjunctivitis, which you heard about from Jan. It can cause pharyngitis, it can cause PID, which we'll talk about in a minute, and it can disseminate. So you heard about this from Jan when she talked about the room stuff. The person that comes in with the septic knee joint, who's a young, sexually active 24-year-old person. That person with a hot, single septic knee is gonorrhea till proven otherwise. That when it disseminates, when it goes through your body, what gonorrhea loves is your synovium. So it will go to your joints. It will go to your hand. It's one of the causes of atraumatic flexor tenosynovitis, is disseminated gonorrhea. And it likes your skin. It causes little emboli in your skin. So pictures like this, where let me back it up a second. I'll show you but it basically causes these little necrotic pustules on the erythematous base when it disseminates. They're little septic emboli. It can cause worse things, but fortunately it's rare. So meningitis, endocarditis, very rare. But skin stuff, absolutely. Joint stuff, absolutely. When it disseminates, so you pick up gonorrhea today, and when I'll tell you, most people don't. Most people, it stays where it starts. The group that tends to disseminate are women during their menstrual period. So about 3% of dissemination cases, 3% of women with cervical gonorrhea will disseminate during their menstrual cycle. The other place it disseminates from more frequently is the pharynx. And basically anything that causes the bloodstream to have access to gonorrhea. So it disseminates with that. And you get these skin lesions, I'll show you pictures of. Your joint fluid gets involved, your joints get involved. What you're going to do to diagnose this is you have to basically culture, or do NA testing, but culture every place it could come from: cervix, urethra, throat, rectum, how it got to where it went, the blood, and then where it ended up, the skin, the joint. You have to basically, all of those are necessary to make the diagnosis of disseminated gonorrhea. So it's a lot of testing. If you got a kid with a hot knee, you're going to basically swab that person's urethra or their cervix, their throat, and their rectum, and you're going to do blood cultures, and you're going to tap that knee. All of them get sent for testing. This is what the lesions look like. Now, I will tell you, if you look at this picture and you just think about your life at home, your job at home, if you look at this picture, okay, well, if I were to walk into a room and see that, the first thing on my mind would be MRSA, right? We all see tons and tons of MRSA. Little necrotic pustules kind of all over the body, scattered. If you see these, though, particularly on distal extremities, and they look like this, and you take a swab, and the middle of it kind of comes out because it's goopy and gummy in the middle, that's probably disseminated gonorrhea. So just, if you see what you think is MRSA, multiple MRSA, little abscesses all over the place, please think about this and ask about a sexual history. This, again, you take a swab to that thing, you swab that middle of that, it's necrotic. It basically is just gummy. It just comes out of there. This is gonococcemia over a joint. So if you see this, it's like, I've got a little, like a blood blister there, but no reason to have it. Or that kind of blister is on a finger that clearly has tenosynovitis, particularly flexor tenosynovitis. Think disseminated gonorrhea. That's the only way it can get there without some sort of break in the skin. This you saw a picture of before, this same illness. This is basically GC conjunctivitis, and this is, you have to diagnose this. You miss this, they get corneal ulcerations, or I've seen 3 cases in my career, people lose an eye from endophthalmitis, from untreated, missed gonorrhea, gonococcal conjunctivitis. So it just looks like a gnarly case of conjunctivitis. All right, let's kind of climb up the female genital tract a little bit, and let's go higher, and let's see what happens when upper female genital tract infections occur. So PID is defined as an infection of the endometrium, the tubes, or the peritoneum, alone or in combination. It can be just the endometrium. It can be just one side of the tube. It can be just peritonitis. It can be just Fitzhugh-Curtis, which is a version of peritonitis. That's pelvic inflammatory disease. And the thing about PID is it is a multiple organism problem. What they're finding more and more, so chlamydia has been the big problem for here. Back in the day, when gonorrhea was really rampant, PID made people really sick. Gonorrhea got up there and caused trouble. But what's caused trouble over the last 30 years has been chlamydia. Because chlamydia has gone up, they're not caused a lot of symptoms, but a lot of damage done. And we also know that a lot of the organisms that live in the female genital tract will kind of climb up there with them. They're kind of hangers-on. They go up there with them. So ureaplasma, mycoplasma organisms get up there. BV turns out to be a portal for all of this to occur. People who get BV are more likely to get PID. So it ends up that this is a polymicrobial infection. The reason that's important is, at least until now, and we still don't have a single drug therapy to treat PID. Whether you're treating it as an inpatient, outpatient, any drug regimen is going to involve more than one drug to treat PID. So this is a polymicrobial infection. One of its offshoots is to cause TOAs, tubal ovarian abscesses, and that tends to be much more unilateral symptomatology, but the reality is it can just basically cause rampant troubles up in the tubes. The presentation ranges from anything from totally asymptomatic to just some dyspareunia, to a little bit of pelvic pain, to flat out toxic. They can be anything in that range of things. And what's interesting is anything in that range of symptoms, including minimally symptomatic to no symptoms, can cause tube damage. So it's the reason that basically in this room, everyone in this room either is or knows someone with an infertility problem. And it's because of this. It's because of this particular problem. And the reason that what happened as a result of that, because we now know that ectopic pregnancies are 1 in 50 pregnancies in the United States. 1 in 50 pregnancies is an ectopic now. That's unbelievably high number. That's remarkable, absolutely remarkable. The CDC sort of noticed this problem about 20 years ago, and they changed the diagnostic criteria for PID. So if you learned your diagnostic criteria for PID 2 or 3 concerts ago, I want you to erase it, because now the diagnostic criteria is strictly clinical. So if a woman comes in and she has cervical motion tenderness or adnexal tenderness or uterine tenderness, it doesn't have to be all of them, that alone is going to have you say, yep, I'm going to treat you for it. Again, this is women, sexually active women or women of childbearing age, that you're going to treat that person. Okay, even though she may not have PID. The reason they've lowered the bar so low is to try to minimize this risk of ectopic pregnancy and minimize infertility. And I will tell you that there seems to be some effect of this, just as an aside. There's some data out that's relatively recent that says there's definitely been inroads made in this. Infertility rates have basically plateaued. They're not continuing to rise. So this is having some effect on, you're having this low bar. So it's a clinical diagnosis. All other testing is just icing on the cake. If it's the SED rate's not high, or if the calcitonin, whatever you use as an inflammatory marker, isn't high, it still is PID on your clinical diagnosis. You're still going to send tests like gonorrhea, chlamydia tests, but the reality is you're going to treat anyway. If you were to look in there, this is what you would see. You'd see all this stranding, you'd see some pus, and this is the scarring that's happening from PID, where the tubes just can't pass that fertilized ovum anymore, and they end up getting an ectopic pregnancy. What you also need to know is that some people need to be admitted for PID, but most don't. So PID admission, you will absolutely admit anybody who's sick. And that's just a no-brainer. That's what you do in your job. That's what you're going to absolutely do. If somebody can't take their meds, or you're worried about compliance, or some places will take adolescents who have PID and admit them for a day or two for IV antibiotics. There's a little bit of data to support that, but probably not. So just absolutely the sick ones are the ones you're worried about getting through a course of therapy. In general, though, they're going to go home. And what the CDC has done is they've divided their treatment recommendations into what do you give them if they go home, and what do you give them if they stay in the hospital. What I don't want you to do is memorize any of this slide. I cannot imagine, because this has changed, this evolves, okay? This evolves as it's supposed to, as we know different things about resistance. This is the sort of current updated version since the 2015 guideline. They will not put this on an exam because it just changes too fast for them to put it on an exam and have it be something that's a valid kind of question. So I cannot imagine they'd put that on the exam. But if they do, they may be evil and put in something like a person who's really sick, give you all these choices of antibiotics that are going to freak you out, but only one of the choices on the answers will include admission. Well, you don't need to know the antibiotics. You just need to know that person's sick enough to need admission. So honestly, I don't think they'll go there. Just know in the real world, what you're going to do is all of these diseases we've been talking about, these infections, you're going to go look it up. You're just going to go look it up. There's no reason to commit all this to memory. There's an app. The CDC has their STD treatment guideline app. There's an app for this you can put on your phone. It's all there, just right there for you. Now, on this first line of this slide, this remove IUD if in place, put a line through that. That is no longer the case. They no longer recommend taking out IUDs in women who have PID, so put a line through that. That was officially sanctioned since this slide was made. So know that it is no longer something that they said, leave it, and then treat the partner, and then know that there's complications that occur. Now, Fitzhugh-Curtis syndrome is ripe for questions. Remember that PID can be peritonitis alone. But if those organisms decide to crawl up your right gutter, particularly chlamydia, and then kind of hang out on top of your liver, all those little strandy sort of inflammatory things that happen to your liver capsule. And what women will present with who have PID that's now gone sort of peritoneal and is living up by their liver is they'll present with right upper quadrant pain. So think about what you think about in somebody who comes in with right upper quadrant pain. You think gallstones, hepatitis, gallstones. That's what we think about. And the woman will be tender there, absolutely be tender there. But it's not a true hepatitis and it's not gallstones. It's actually a perihepatitis from the chlamydia, basically, building townhouses on top of the liver capsule. So it causes all these inflammatory changes. What is important is the LFTs are normal. So it is something that it's absolutely something that can present in your practice, absolutely. Where somebody comes in with right upper quadrant pain, there's no gallstones, their LFTs are normal, but they're tender. What is that all about? Maybe it's PID. So no, this is definitely into something that can occur. And as far as an exam question, be a really fun one to write if I were an ABEM item writer. So just know this is something ripe for exam questions. All right, if we stay with the drips, let's go to the things that cause vulvovaginitis, which is way more common than all of the sexually transmitted infections. And this is an inflammation of the vulva or vaginal tissues. And the women tend to present with discharge, itching, and basically irritation locally from this. Usually it's infection, but no, that can also be things like contact dermatitis. So I took care of a woman not that long ago she knew she was latex allergic, had a new sexual partner who was using latex condoms. Poor baby had just raging vulvovaginitis from contact vaginitis. So you can end atrophic vaginitis can happen too, but most cases are from infection, flat out from infection. Trichomoniasis is a sexually transmitted version of a vulvovaginitis. This is it's another type of organism. We talked about all kinds of organisms. This is another one. This is a protozoa. This is a flagellated protozoa. If you remember back to med school, it's a little thing that looks like a kite that would go dashing across your field of your microscope as you're watching. It's this thing just goes flying across your field. What it causes symptomatically is a discharge that tends to be relatively foul-smelling, tends to be kind of frothy and greenish, that women may present with. And if you see that cervix, if you get lucky and you see that cervix on an exam, I want you to instantly get on an airplane and fly back to Vegas and bet the farm. Because you saw something that only happens 2% of the time. It's in every textbook. It's everything you ever hear about trichomoniasis, that strawberry cervix, which is basically goop all over a cervix that house all those meibomian glands all inflamed and unhappy. That is not common, not at all common. So, and if they give it to you on an exam, great. If you see it in real life, great. But know that it is not common by any stretch for people with trich to get this. It is sexually transmitted, so partners can pass this back and forth. And it is very treatable. Okay? You can basically treat it with metronidazole, super treatable. Tinidazole, I mean, they work just fine. They may have a disulfiram-like reaction. I'm going to mention it here. Billy's going to mention it in talks as well, where if somebody's taking metronidazole and they drink a lovely Chardonnay, they may end up with the flushing and the diarrhea and the whole shenanigans that goes with it. So warn people no alcohol if they take metronidazole, and partner treatment happens with this. One of the reasons it's important if a woman is pregnant who gets this is you must treat this. This is crucial to treat because it has a high incidence of premature rupture of membranes with this preterm delivery. So the cervix doesn't like having trichomoniasis around. Now, BV is very common. It is the most common cause of vaginal discharge, absolutely the most common cause. And what this basically is all these our bodies are literally trillions of bacteria that are doing all these fabulous things all the time that need to be there. And women's genitalia has this wonderful balance of this soup of bacteria that are causing all these wonderful balanced things there. And we muck it up by giving somebody antibiotics, or something happens with their physiology, and they end up overgrowing one of those particular organisms. They basically grow Gardnerella. They grow tons and tons of it, and they get BV. The CDC has criteria for diagnosing BV, and I want to mention this here, even though in real life we can't use this, because this is how they decide what's BV and what isn't. Copious thin discharge, okay, that's fine. I can see that a woman can complain of that, I get it. Clue cells on a wet mount, got it. That's a test I can send, that's something they can see upstairs. A pH greater than 4.5. The women's genitalia is basically acid, acidic. So basically the pH becomes alkaline. Well, I don't ever measure vaginal pH in anybody ever. And then that fishy odor is one of the 4 criteria. They're called Ansell's criteria, and you're supposed to have 3 of the 4. Well, if you happen to examine someone and it has a fishy odor, that's, well, okay, fine, I've got that. Or if the patient complains of it, I've got that. But usually it's with KOH, when they basically put KOH on the slide upstairs. And the problem is that they don't give us we have a stat critical value up here in the lab. We have a fishy odor here in the lab. They don't do that, right? So we don't know. So unless the patient complains of that, we're making this diagnosis based on clue cells. I'm going to tell you that is fraught with trouble. We'll come back to that in a minute. These are those clue cells. So basically, it's the vaginal mucosal cells covered with all those Gardnerella organisms, just coated with those Gardnerella organisms. Now, I can treat BV. You can treat BV very easily. Metronidazole, beautiful. There's topicals as well, but metronidazole, beautiful. Single dose, 1 week course, all kinds of versions of this. The reason it's a problem, though, is that women can have overgrowth of Gardnerella and no symptoms whatsoever. Not at all. So if you have a woman who's not symptomatic at all, and there's clue cells in her urinalysis, and she has no symptoms and she's not pregnant, you're not going to treat that. Okay, it's really common, so you're not going to treat that. However, any symptomatic woman with clue cells gets treated, and any pregnant woman with clue cells gets treated. That's very important. Turns out BV increases the risk of preterm delivery. It increases the risk of miscarriage, especially in women who've had a miscarriage before. So it is really all pregnant women with clue cells / BV get treated. All symptomatic women get treated. Asymptomatic, not pregnant, no treatment. Okay, that's the be-all, end-all when it comes to BV. Now, Candida is a third of the big three that cause the vulvovaginitis. This is also really, really common. And that you tell me the diagnosis on this woman. So you have a woman who comes in to see you, and she says, you know the weirdest thing? I had a yeast infection 6 months ago, took the medicine and went away. And then I had it again 4 months ago, took the medicine, went away. And I had it again 2 months ago, took the medicine, went away. And what's up with this? I have it again. What's her underlying diagnosis? Diabetes, flat out. This is a yeast. And any of you who are bakers know yeast and sugar, it loves it. It loves it, right? It needs it to grow. So people who have diabetes are this wonderful medium for yeast to grow. Very common in people that have diabetes, extraordinarily common. So, and when women get this, it's super itchy. It's just major itchy. And often when you look there, they have very swollen erythematous genitalia because it's so itchy. They've been kind of rubbing and scratching, and because it's driving them absolutely berserk, driving them absolutely crazy because it's so itchy. Now, it is not odorous. This is not an odorous discharge, but they may have that sort of thick, cheesy discharge that we learned about, like this. Not everybody does, so you know. But this is what we look for. This is sort of the classic case of Candida vaginitis. It's diagnosed with a wet mount, and what they see up there is yeast. They're going to say yeast forms or hyphae. They're going to tell you that's what they're seeing up there in the lab when they've cleared it out from the fishy odor from before. They're going to actually tell you they have yeast. This is super easy to treat. Okay, very easy to treat. We basically fluconazole works, beautiful. Single dose, done. And there are a gajillion over-the-counter preps. If you walk to the CVS, right out here in front of Bally's, there's an entire row. I was there earlier to buy toothpaste. I thought, let me check it out. There's a whole row of this stuff out there. So there's lots of treatments that people can have for this. They can buy over the counter. These are the hyphae they're seeing upstairs. Again, this is the yeast infection that happens often in diabetics. Oh, the other group? What's the other big group that gets this? We do it. We give people antibiotics, right? So we give people a yeast infection because we give them antibiotics. So know that we cause this sometimes as well. Here again, if you are just, Diane, quit talking, you want one slide, this is it. Here it's all summarized for you in the vulvovaginitis. A few more things down in the lower genital tract, and then we're going to kind of climb up into sort of the GYN stuff up above. So Bartholin glands are really important glands in the female introitus area. They're super important. They're lubricating glands that are vitally important. But they tend, because of where they are and sort of what we do with our clothing, et cetera, they tend to get glommed up a little bit. So people can get Bartholin cysts, which is just the opening has been blocked a little bit, that very quickly turn into an abscess. Lots of organisms around can cause it. It tends to be coliforms that grow in there, and you get an abscess, and it can be enormous. Because think about the tissue. The tissue in the sort of the female external genitalia is very interstitial. It can there's a lot of space that can happen in there. So they can end up with a gigantic abscess. So if they end up with a Bartholin glands abscess, the key, it's an abscess. As long as there's no systemic sign of infection, they're not febrile, they're not toxic looking, their blood pressure's fine, it's just there, you're going to drain it like any other abscess. The thing about this abscess, though, is because the cavity can get so big because of all that interstitial tissue, for that cavity to kind of heal down and close up, you're going to need to have a drainage point for it to last for as long as 6 weeks. So what you're going to do is open that little cut, usually be prepared. I usually put like a trash can underneath with the chucks because it can just be a lot. Have it all just collected. I'll get rid of it all. And then you're going to put that ward catheter in there. The reason you're doing that is it's going to keep that little opening that you make open. Because remember, that it's cutting somebody's little cut down in that female genital area is like biting your cheek. It heals really quickly. It's that kind of tissue. It heals really fast. So you want to keep it open. That's why that ward catheter goes in there. You're going to leave it in there for 6 weeks, though. So if you're a nice person, and all of you need to go home and be nice people when it comes to this, you're going to make the cut, the little opening, and you just use an 11 blade, just poke it. Well, you're going to make that, though, sort of near the introitus itself, near the vaginal opening, not way down on the abscess, way outside. You're going to put it near the vaginal opening, because once that's drained, you're going to put the ward catheter in, and part of that hangs out for 6 weeks. The woman can tuck it up inside her vagina, so there's nothing hanging down that's giving her any sort of discomfort. So you make your little cut sort of near the opening to the vagina, as long as it's the purulent area, you're good to go, flexion area, and then put that catheter in. And if she's not systemically ill, you're done. If she is, then you're going to give antibiotics, and mainly covering for coliforms. They also recommend covering for GC as well, but in general, you will not be using antibiotics in this. Absolutely not using antibiotics. Now, condyloma acuminata is the last little thing we're going to talk about down below. Now, we talked about condyloma lata when we talked about syphilis. Those tend to be flattish warts, can be bumpy though. This is the true, honest-to-God wart. This is HPV. This is human papillomavirus. It's a DNA virus. This is venereal warts basically, they're spread by contact. You touch someone, you can get it. They can be jillions of them. They can be solitary. They incubate over a longer time, 1 to 3 months. They can self-propagate as you kind of contaminate your own self. They can be anywhere. They tend to be soft. They're not painful. They're only painful if they rub on something that makes them painful. In general, they're not painful at all. But they're a problem. Okay, they're a problem. It increases the risk of cervical cancer. It turns out that cervical cancer is an infectious disease most of the time. It's HPV related. It's why it's recommended that adolescents get the HPV vaccine. We don't want them getting the warts, and we certainly don't want them getting cancer. Sure that some of the penile cancers are related to HPV, and some throat cancers are related to HPV. So this is something that we absolutely know occurs. And for us, we don't treat this. We diagnose this in the ER, and we send them on their way for their prolonged treatment to basically burn these things off, or whatever treatment's used to get rid of them. But they're not, the virus is still there. They aren't cured of the virus. That's why the vaccine is so important. You have to think about other STIs. If they picked up this, they could pick up something else. But in general, all you do with this is diagnose it and send them on their way, knowing that this is HPV related and it never goes away. Again, it can be a solitary lesion, or it can be a lot, like we saw on that other slide. Okay, enough with the infections already. Let's climb up into sort of the upper genital tract of a woman and see what can happen. So ovarian cysts are extremely common, extraordinarily common. And if you think about what happens to an ovary during its month of its cycle, is the whole first half is basically growing a follicle, maturing a follicle to pop out an egg. That at mid-cycle, middle schmerz, that egg pops out. And then the second half of the cycle, the egg is off doing its thing, either getting fertilized or not. But what's left where that egg popped out is the corpus luteum. And what it's doing is it's getting ready to produce a hormone to support that pregnancy if it happens and it implants. So middle schmerz is that I had a friend who was one of these super body aware people. We'd be out to lunch and she'd go, "Oh, I just ovulated on the left." It's like, good for you. She was very body aware. Good for her. So this is what happens. Here's your cycle. I'm making the follicle in the beginning of the cycle, so that's great. And middle schmerz, I'm popping out that egg, and the second half of the cycle is the corpus. Now, why do I even care? What difference does it make? Well, it turns out that corpus luteum, because it needs to start to make a hormone to support the pregnancy for the first part of the pregnancy till the placenta takes over, what it does is it gets very vascular. So a corpus luteum is a vascular cyst. A follicular cyst is a simple cyst. So what happens here is here's a follicular cyst. That thing, if it ruptures, it causes some pain. It can cause a little bit of fluid down in the pelvis because it's leaked out of the follicle. Not usually a huge big deal. This is a much bigger deal. This is a corpus luteum, and these things can get very vascular. And I had a classmate in my med school class who ruptured a corpus luteum cyst and basically bled down to a crit of 3 before they got her into the operating room. You can bleed like a ruptured ectopic pregnancy. Your pregnancy test isn't positive. It's coming from this thing. It's from a corpus luteum. So this tends to be a very vascular, potentially life-threatening cyst if it ruptures. Now, that's the cyst that's growing and rupturing and doing its thing. The other thing cysts can do, though, is they can turn. They can torse. Ovarian torsion turns out to be, so a couple things about this. It's twisting on its pedicle, and it tends to be an abnormal ovary that does this. Most torsion is not in a normal ovary. Most torsion is in something, in fact, dermoid cysts are a big actor in this one. Dermoid cysts are the ones with teeth and hair, and they can get really big, and they tend to twist. The problem with this, though, is that a testicle, which you heard about yesterday, kind of hangs down in space, and it can twist at least 360, and actually not infrequently 720. It does a double whammy dealy, sort of a triple sow cow, double whammy down there in the scrotum. In the pelvis, the female pelvis, it doesn't do that. This tends to torse 180, maybe 360, but often will flip back on itself. So this ends up being a hard diagnosis for us to make sometimes, and it is the rule to miss. So if someone comes in and they had just excruciating right sort of adnexal pain, right lower quadrant pain, that's better now, it very well could have been a torsion. Maybe it was a ruptured cyst, but it very well could have been a torsion. The diagnostic test of choice is ultrasound, and the ultrasound's looking for both the abnormal ovary and is also looking for flow to that ovary. It is not 100% diagnostic by any stretch, but it is the best thing we have. So it's not uncommon to miss it. It can torse and detorse. It tends to be abnormal ovaries, and ultrasound is the test of choice. So that's the sort of the adnexal torsion deal. This is what, if you look in there with a scope, you're doing a laparoscopy, this is what you might see. That ovary is twisted on itself. Now, one thing that's interesting is abnormal ovaries that don't tend to torse are ovarian cancer ovaries. Ovarian cancer ovaries tend to stick and not turn. Because it's cancer, it tends to stick to its local structure. So a big ovary from cancer tends not to torse. Now, one of the entities that you can get is endometriosis. And you guys heard about this from Stuart this morning, where these poor people that get endometrial tissue in their pulmonary area can get pneumothoraces when they have their menstrual cycle. I actually saw one of these cases. I thought it was all baloney. I actually saw a case. It's a real thing. Endometriosis for us in the ER is a diagnosis of exclusion. What these women will present with is episodic pain here or there, usually down in the pelvis area, usually during their menstrual cycle. It can be intermenstrual, but usually during their menstrual cycle. Every once in a while, endometrial tissue will implant somewhere that's kind of cool. So we had a case of this in a woman who'd had a cesarean section, had her baby, it was lovely, and about a year later presented because every single time she had her period, she ended up with a swollen area at the site of her surgical scar, where she'd had her C-section. And the endometrial tissue had implanted along her surgical scar, and she ended up with a little bit of bleeding in the area and swelling in the area every menstrual cycle. Awesome. It was awesome. It was just a great case. So it can implant anywhere, absolutely anywhere. Again, for us, this tends to be a diagnosis of exclusion. You rule out everything else, refer them, but it's something we can see coming in the ER. What we see way more often are fibroids. Fibroids are rampant. They're much more common in African American women, but they're across the board. And fibroids can present anything from bleeding to pain. And these things can be inside the uterus, they can be hanging off the uterus, they can be, we've seen them, they can have basically 9-month size uteruses that are basically all fibroids. These tend to be benign. There are leiomyosarcomas, they're rare, these tend to be benign, and the most common reason we see people in the ER is pain and anemia, because they've had lots of vaginal bleeding. These things, especially if they're submucosal, they cause a lot of bleeding. Our job is to diagnose everything appropriately. This is fibroidal bleeding only. It's not a necrosing fibroid. You're good to go. We got your pain treated. We'll transfuse you if we need to, and then you're on your way to follow up with somebody. Ultrasound's the way we diagnose this, by the way, if you need to diagnose it. Now, the cancers that occur, uterine cancer, if you see a woman, it tends to be women in their 50s and 60s, can be older, but the peak is women in their 50s and 60s. If you see a postmenopausal woman, and menopause is defined as no menstrual bleeding for over a year. It's not that weird little spotty thing that happens for some women in the last couple of years of their menstruation lifetime. This is something where they haven't had a period for a year, nothing, and now they're having vaginal bleeding. That is someone you have to worry about uterine cancer. It turns out only 10% of those women have cancer, but that's 1 in 10. That's a lot. So it's basically vaginal bleeding in a postmenopausal woman is endometrial cancer till proven otherwise. Lots of risk factors. Our job really is to identify that, to know that it's, first of all, make sure it's not coming from some other part of the body. It's not peeing blood, it's not pooping blood, it's actually truly from the vagina. And then if it's a postmenopausal woman, you have to worry that it's actually cancer. Again, it's all this sort of endometrium that's doing its bad thing. It's a very curable cancer if it's caught early. So this is our job to say, ooh, really important, let's have you go get seen. Ovarian cancer also tends to happen at about the same sort of, the peak is the same range, although it has softer shoulders. Ovarian cancer actually can occur even in younger women. There's some risk factors for this that aren't that important. Your job, so we have a case of this we had actually within our institution, basically a woman who came in with new onset ascites, young, like 20s woman with new onset ascites with no reason to have ascites. She wasn't a drinker, she never had a disease, no reason to have ascites. If you have a woman who has new onset ascites and no reason to have it, it's ovarian cancer till proven otherwise. And you just get your ultrasound. You can do a bedside to look and see if there's ascites or not. And if there's ascites, please look at those ovaries, because it turns out that's not an uncommon presentation by any stretch. So new onset ascites, gynecologic neoplasm till proven otherwise. One of the sad things about this is that it is usually advanced at the time of diagnosis. So if they have ascites, it's an advanced problem, and the early symptoms are really vague, like bloating. That's the most common complaint early. So this is a tough one to pick up early. By the time we see them with ascites, it's advanced disease. Now, the third of the cancers that can happen is cervical. And I'm going to sort of loop back a minute to those warts that people get, that HPV. Well, this cancer, cervical cancer, is something that we should hopefully eradicate off the planet if we can get people vaccinated. We already were catching it early before it caused all kinds of terrible trouble by doing things like pap smears and looking in there and doing routine sort of female genital exams. But now that we have the HPV vaccine, what we're hoping is that we can completely eradicate most of the cases of cervical cancer. It's a squamous cancer, which HPV causes squamous cancers of your pharynx, of your penis, and of your cervix. It causes squamous cancers. And when these women present, they may present with some bleeding or nothing. And you just start doing your exam for whatever reason. They've had lower abdominal pain. And you look in there and it's like, oh, that cervix doesn't look good. That's not a normal cervix. Please send that person. This is a completely curable disease. This is something people do not have to die of anymore. But if it's advanced, it's horrible. They block their ureters. It's just terrible. It's a terrible thing. So HPV related, if you see it, get them followed up on this thing. And again, this is hopefully something we can eradicate. All right, vaginal bleeding, 2 categories, right? Pregnant vaginal bleeding, non-pregnant vaginal bleeding. In the non-pregnant person, it can first of all, make sure it's uterine. And if it's vaginal bleeding in somebody who's in her menstrual sort of lifetime, there's lots of reasons it can be caused. There's anovulatory bleeding, dysfunctional uterine bleeding. I will tell you the terminology is changing. When I make these slides again, probably next year, right now there's a whole push to changing the terminology away from all of this. So this will go away. But for now, ovulatory and anovulatory bleeding can happen. Basically, the setting of the system doesn't work right. Our job in these cases is usually make sure they're not bleeding to death, which is extraordinarily rare. If it's hormonal, extraordinarily rare. Get them stabilized. If they need a little transfusion because they just can't walk across the room because they're so anemic that they're short of breath, give them something to make them feel better. Non-steroidals if they're having discomfort, and non-steroidals will actually decrease the bleeding too, so it has a two-pronged deal, and then send them on their way for follow-up. Let me skip this. Let's go to OB. So obstetric problems. For most of us that work in North America, United States, if somebody's 20 weeks pregnant or greater, we often never see them in the ER. They get schlepped up to L&D and they get their problems taken care of in L&D. But you will see these patients when they have their ankle sprain or they have their asthma exacerbation or they come in unstable because they're bleeding like crazy. You will see this. So a couple things about pregnancy. Normal pregnancy, for anyone who has been in love with someone who's pregnant, known someone who's pregnant, or been someone who's pregnant, you basically have a lovely parasite growing in you who you are going to love more than life itself. It's going to cost you $300,000 to get out of the house, that particular thing. And during the time it is gestating in you, it's doing all kinds of crazy stuff. That uterus that is this big gets this big and then goes back to that big. That is crazy. Your body needs all this extra blood to be able to support you, the placenta, and that baby. So you increase your blood volume. You increase your red cell volume, but your plasma more. So you get basically anemic because you have more plasma than red cells. Your breasts get tender. Your coagulation cascade changes. All kinds of stuff is just wacky crazy to grow this thing that you're going to love more than life itself. Two important pieces of data, well, 3 actually. 1, urine pregnancy tests are so good that if they are positive, they are positive. That person is pregnant and it catches it early. So it is positive almost at the time the egg and the sperm shake hands, right? It is positive super early. Very low threshold for that to be positive. Low counts for beta. Number 2, a 20-week pregnant woman, which is approaching viability, has her umbilicus where her uterus is. Her fundus is up to her umbilicus. So if you ever see somebody who's pregnant and she doesn't know her dates or but she's unconscious and can't tell you, get your hand on that belly. And if you feel her fundus up at the umbilicus, that is a potentially viable child. Okay, now you got a whole different ballgame. Got to get other people involved in that. And a beta HCG early in pregnancy should double about every 2 days. It's a little more accurate than that, but basically every 2 days a beta, so if I'm pregnant and my beta, it's Monday, and my beta is 500, by Wednesday my beta should be 1,000, by Friday my beta should be 2,000. Okay, that's the normal sort of what happens in a normal pregnancy. So those 3 pieces of information are really important. Urine's positive early, 20 weeks is here, doubling time for betas early in pregnancy is every 2 days. Now, we deal with abortions a lot, miscarriages a lot, and there's a whole range of these that can occur. And I'll tell you, this is another set of terminology that's changing. But right now, the terms to know, threatened is where they've had bleeding or something, cramping or bleeding, but the os is closed, ultrasound or exam, or ultrasound, shows that that baby's still inside. That is a threatened miscarriage. Okay, that's a threatened abortion. And that woman gets vaginal rest, meaning nothing goes in there, but she lives her life. Okay, she goes and lives her life the way she wants to. Inevitable is bleeding and or cramping. That cervix is open. Okay, that it's not holding anything inside anymore. That is inevitable. That will pass. Okay, that is a pregnancy that's going to pass. And then incomplete is something that includes anything from intrauterine fetal demise to blighted ovum to they've passed some of the products of conception and not all of them. That's an incomplete abortion. That's usually true with the D&C, cleaning things out in there. So those are the 3 big categories of abortions, and they're now getting reclassified, just so you know. But right now, for your exam purposes, that's how they're defined. The one that we worry the most about, with very good reason, is an ectopic pregnancy. We worry very much because remember, statistics are 1 in 50 pregnancies, naturally occurring pregnancies, is not where it belongs. It's growing somewhere other than in the uterus. There are definitely risk factors for that. So it turns out that if you get pregnant after you've had a tubal ligation, it isn't where it belongs. So that is a big risk factor for somebody getting an ectopic pregnancy. Previous PID, definitely a risk factor. But know that about 45-ish% of women who have an ectopic pregnancy have no identifiable risk factor. Probably because they had a chlamydial infection they didn't know they had. And they scarred their tubes up, but they just didn't know that they had that. So ectopic pregnancy, they may not have risk factors that they're aware of by any stretch. And when people present, they present about 5 to 8 weeks since their last normal menstrual period, so they're actually a month or so into the pregnancy, and they come in with anything from pain only, bleeding only, or bleeding and pain. Anything. Okay, all of it. They can just have a little bit of pain. It may be a possible ectopic pregnancy. And how sick they are really depends where that thing implants and how big it gets before it causes symptoms. Our job is to determine where is that pregnancy. So I have a woman who her pregnancy test is positive. She knows that. She tested herself at the CVS down here in the corner. She knows she's pregnant. She comes in, she's got a little bit of spotting, a little bit of pain, not terrible. She's hemodynamically stable. My job is to figure out where is that pregnancy. And you have to in anyone who comes in who's pregnant, who's having bleeding or spotting or pain. One of the things you're going to do is an ultrasound. Now, those of you in this room who've already taken your qualifying exam and you're going to take your concert or concert exam, you will not get this ultrasound on your exam. The ultrasound you can get on your exam is one looking for a fast exam and one looking at the heart. They put those as fair game. So you got to know those. Those of you in this room taking your qualifying exam, your first exam, you may get this picture on your exam. This is a normal intrauterine pregnancy. This is the sort of bright white, sort of kidney bean looking thing. That's the endometrium. That dark thing in the middle is the gestational sac. That round thing in the middle of that is the yolk sac. And those 2 little bright white lines at about 4 o'clock are the fetal pole. So it's just before you're going to see a heartbeat. You may actually see a heartbeat on this if you looked for it. So this is basically, it's where it belongs. It's in the uterus, and it is a growing baby. Okay? It is a growing fetus in there. That's what's in there. Transvaginal gives you a week ahead of transabdominal. So what is recommended in all these cases is a transvaginal ultrasound because you get a week of lead time on this. You see things a week earlier. It's basically literally inches from looking at the patient's baby. What you need to know is not just the ultrasound finding, and what it's going to tell you is intrauterine pregnancy. Don't see anything in there, just an endometrial stripe, nothing. Maybe a gestational sac, we don't know. And it's going to tell you whether there's free fluid or not, or if the adnexia are normal. 5 big things in an ultrasound. You're going to pair that up with a quantitative beta-HCG. Really important, quantitative number. The reason for that is that, 2 things. One is, if a woman has a quantitative beta-HCG of 1,500 or higher, I think the number's going to change too, but for your purposes, 1,500 or higher, and her ultrasound shows nothing in the uterus. just an endometrial stripe, not a little blip, not a little anything. That means that that baby is growing somewhere it doesn't belong. Okay, that person, you may not see it, but it's growing where it doesn't belong. That's an ectopic pregnancy. If a woman, though, has a beta of, say, 200, it's really low. You may see nothing anywhere because the beta is not high enough, but you're still going to go ahead and get the ultrasound because you may see free fluid. You may actually see something growing out in the adnexa. You always need to get a quant plus the ultrasound. Okay, even if the quant is low, you get the quant plus the ultrasound. What they may see, if you're doing, sort of, if you're going to do a laparoscope, you may see what's on the left, but this thing on the right, I just want to mention briefly. This right here is a normal baby growing where it belongs. This out here at the same time is a baby growing where it doesn't belong. That's called a heterotopic pregnancy, one in, one out. The only reason I mention it, it's not that common. It's about 1 in 4,000 naturally occurring pregnancies, but it's 1 in 100 to 1 in 400 fertility-assisted pregnancies. So if you're dealing with a patient who knows she's fertility assisted and she comes in with what looks like a normal baby growing in her uterus, know that she may have one on the outside. She had an ultrasound that showed one, but she's having right adnexal pain. She may actually have a heterotopic pregnancy. So that's 1 in, 1 out. Main concern is in somebody who's fertility assisted. So to diagnose pregnancy early on, ectopic or intrauterine, it is an IUP. If you basically see the baby in the uterus, it's an IUP, and they're not fertility assisted. It's like, good on you. You have a pregnancy. Everything looks like it's okay right now. You had a little bleeding. It's a threatened miscarriage. You're good to go. Vaginal arrest. Good on you. Good luck. Congratulations. You can flat out say it's absolutely an ectopic pregnancy if you see that growing outside the uterus. You go to the adnexa, and they say on the adnexa shows gestational sac and a yolk sac out there. That's growing where it shouldn't belong. That's diagnostic of ectopic. The other thing, diagnostic of ectopic, is a discriminatory zone of 1,500 or higher and a totally empty uterus. It's growing somewhere it doesn't belong. We just can't see it yet. Diagnostic. Everything else, my beta is too low to see anything. My beta is higher and there's a little bit of something in the uterus. I can't tell what it is yet. Those are called pregnancy of unknown location patients. It's a new term. And those people get followed. As long as they're stable, not having a ton of pain, where they're imminently rupturing something you can't see yet, you're going to basically say, you're going to go home, you're going to either follow up with us in our clinic here or with your gynecologist, obstetrician, and they're going to recheck a beta in 2 days. Make sure it doubles appropriately. Then when it gets to the discriminatory zone, they're going to re-ultrasound and see what's happening, get a chance to see that. So our job, know when it's an IUP, on ultrasound, know when it's an ectopic on ultrasound or ultrasound plus labs. Everything else, as long as they're stable, they get followed up with follow the beta HCG, or if they're unstable, they stay with you anyway. Okay, and again, that's just logic. That's what you would do. So that's what you're going to do with ectopic pregnancy. Here's basically somebody who has an ectopic out on the outside. Treating ectopic. So say you diagnose it, good on you, yay for you. They used to basically just go in and take out a tube and an ovary. They used to just go in and just rip out a tube and an ovary. And what they've discovered since is that's probably not a great idea. You lose fertility. You don't need to, okay, so most women don't need that. So they've gone to salpingotomy. They actually open it up and they take out the ectopic and then they sew it back up again. They just basically birth it out of there. Or if you hit the right criteria, it's small enough, your beta's a certain number, blah, 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 you can get medical therapy. It turns out about a third, even 40% of ectopics are treated medically with methotrexate. So it stops mitosis, so the sort of cells that are dividing in there stop dividing, and that basically that ectopic pregnancy stops growing, and that basically takes care of the ectopic medically. So 2 ways to treat it, surgically and medically. RhoGAM is something that's a little bit controversial. I know Billy may have talked about it yesterday in his trauma and pregnancy thing, he mentioned it a little bit. But if a woman the 3 tests you order in all women who are pregnant is an ultrasound if you're worried about ectopic, you're going to order a beta HCG quantitative and a type and screen. The screen is to base blood type if you need to transfuse, of course, but the screen is what we're looking for usually. Is she Rh negative or Rh positive? Your job is if someone is Rh negative and they're early in their pregnancy, first trimester, and they've had anything where baby's blood could have gotten into mom's. It's a threatened miscarriage, it's an ectopic pregnancy, whatever. Baby's blood could have gotten into mom. You're going to give RhoGAM, you're going to give low dose, 50. If she's over 12 weeks pregnant and she has a little bit of trauma, she bumps her belly against the counter because it's out to here, you're going to also give her RhoGAM, but a higher dose. So RhoGAM, the answer for ABEM general is to absolutely give it in Rh negative women. There's a little bit of controversy if you listen to podcasts right now, but for ABEM general, please give it. In your real life, please give it unless you have a talk with the gynecologist. All right, one place where pregnancy can go completely crazy is molar pregnancy. Now, molar pregnancies tend to be first time pregnant. They tend to show early. Their size greater than dates. They tend to have hyperemesis. They barf like crazy. And they end up basically having bigger bellies. So what they tend to do is what the woman will come in with is she'll say, gosh, my pregnancy test just turned positive. I could only be pregnant like 5 weeks, but look, I'm showing already. Excuse me, because she has hyperemesis. What's happening is there's no baby in there. What's in there is all this trophoblastic tissue. It is kind of amazing when you see this stuff. It shows like this on ultrasound. It looks like a snowstorm. It's pretty amazing. And when they go in there and take it out, it looks like this. All these little bubbles of stuff. This stuff, if they clean it all out of there, this woman can go on and have a normal pregnancy later. But it's molar pregnancy. It's all this trophoblastic tissue. And again, your clinical clues are, and the beta is sky high. The beta is way higher. So at 5 weeks, it'll be at 100,000. And she's barfing her brains out, and she's showing early on. That is your clue that this is a molar pregnancy. Now, at the other end of pregnancy, let's get us down to where, okay, I'm due to deliver. The bad things that can happen there are abruption and placenta previa. Abruptio placentae, we think of it in trauma. So we tend to think of it in the person in the car crash or the person who falls down the stairs, who's pregnant out to here. And that placenta basically pulls away from the inner wall of the uterus. It can happen spontaneously, and the two groups it happens spontaneously to are basically drug users, particularly cocaine, and maternal hypertension. So a woman who has hypertension. Basically, that the placenta separates from the uterine wall. We were taught in school that they get dark red vaginal bleeding with this. The actual answer to that is yes, sometimes, but not always. If that placenta pulls away from inside the uterus, but it's concealed, meaning that all the way around it's still attached, but it's just kind of in the middle of this pulled away part, they're not going to have any bleeding at all. They're just going to have abruption. And the uterus doesn't like blood in there. It likes the placenta just nicely rested against it and contiguously so. It doesn't like it pulled away. So the uterus gets irritated and it gets cramping and they get basically really tight. It's like having basically contractions all the time. They come in with a tender, really, really firm uterus, really, really painful. What's frustrating about this diagnosis is that ultrasound doesn't pick it up. In fact, a lot of the time, ultrasound doesn't pick it up. So your job is to suspect it in cocaine, hypertension, trauma, third trimester. Okay, if they're tender, you're going to even if they're not bleeding, go ahead and get the ultrasound if you want to, but it shouldn't change your mind if it's negative, and they go up to L&D. They get monitored. That's what happens with abruption. Again, it's the uterus here pulling away from the wall, the placenta pulling away from the uterine wall, and it can be concealed. Now, it's different from previa. Previa is that placenta now is over the exit. The placenta has basically grown across the exit door. So there's no way for that baby to get out. And if you've ever seen the placenta, if you ever saw your own or somebody you love's placenta, it is this gigantic, vascular, crazy thing that has a blood supply as thick as your thumb. This thing is amazing. So if it's now over the opening and it starts to bleed, it is painless and it is bright red and it can be life-threatening. So previa is basically that. It's sitting there just basically, and the baby can't come out. The baby, the exit door is blocked. So it's painless, third trimester, bright red bleeding. If you ever see somebody like that, nothing goes in there. Nothing, not your finger, not a speculum, nothing. Because if you disrupt that thing even more, you really can end up with trouble for both the mom and the baby. No pelvic exam, nothing goes in there. Again, normal placentas are usually high writing, usually fine. If it's previa, that has to go to the operating room. They have to have a cesarean to get that baby out of there. Again, the other thing, ultrasound is fabulous for previa. And it's not transvaginal, right? Nothing goes in the vagina, but you can actually do a lower sort of abdominal ultrasound down here, suprapubic, and you'll see the cervix, it's right there, and you'll see the placenta just draped right across it. So ultrasound for abruption, bad. For previa, good. For abruption, you can go ahead and do a pelvic if you need to. It's not going to change anything. For previa, put nothing in there at all. Abruption, if they bleed, dark red. Previa, if they bleed, bright red. Okay, that's the difference between the two. Now, last couple of things in pregnancy, and then we're going to bring Billy up. Pregnancy-induced hypertension. Or I guess Billy, anyway, yeah. Pregnancy-induced hypertension. So this is something, you don't have to know a number. Please do not memorize numbers. The only number you need to know is the same number you would know for anybody else that you would think about hypertension. It was 140/90. If you see a pregnant woman, especially her second or third trimester, whose blood pressure is higher than 140/90, that's higher than it should be. Okay, most of the time, blood pressures are low when you end up, especially in your second trimester of pregnancy. So that's just a warning sign to you to just be a little concerned. And if you see somebody like that in the ER, you don't necessarily have to treat, but you better get on the phone and talk to the obstetrician and say, did you know that Mrs. Smith is in here with a blood pressure of 140/90, and she's now in her 29th week of pregnancy? Did you know that? Because they may not be aware. What we do care about is when it gets beyond just pregnancy-induced hypertension to something truly pathologic. So preeclampsia. The definition of this has changed a little over the last couple of years. So the definition, what this is hypertension is causing end organ vasospastic problems. So it's causing a perfusion problem to your brain. It's causing problems with your liver. It's causing all kinds of end organ, is your kidneys, etc. So you basically, the definition is a new onset blood pressure of 140/90 or greater, plus proteinuria, and that's 1 plus dip. Okay, it doesn't have to be tons. It's a 1 plus dip is plenty. Or some sort of end organ dysfunction. So say you take care of a pregnant woman who comes in because she sprained her ankle, but her blood pressure is 142/92, and you basically notice that when you've gotten labs sent for something, she has a creatinine of 1.3. That's preeclampsia. By definition, that's preeclampsia. What is no longer preeclampsia are cankles. So calf, ankle, sort of all continuous from your knee to your foot is all the same size, the cankles. So it turns out because so many women just get that as part of being pregnant, it turns out that just was not a very good differentiator from preeclampsia, so that's off the table. So cankles are no longer part of preeclampsia. There are certain women at risk for this, primates primarily, but people have multiple pregnancies, twins, triplets, they're at increased risk of this. And the symptoms they'll present with, it'll be somebody who comes with a headache. Yes, I always get headaches, but this one's weird. And oh, isn't this cute? Yes, I'm due in January. You'll notice the pregnancy and they have a headache. And then you're going to check the blood pressure. It's like, oh, boom, I'm worried that you have preeclampsia here. Because if you miss it, the other area, by the way, that they get pain is right upper quadrant. It's probably from, I'm not exactly sure why, but they get pain in the right upper quadrant, so it's another thing. Come in with right upper quadrant pain, blood pressure 142/92, second or third trimester pregnant, you got to worry that that's preeclampsia. Because if you miss it, they can go on to eclampsia. They've crossed the threshold when they actually seize. So the thing about eclampsia is you fix preeclampsia either by treating them with something like MAG or antihypertensives, or delivering the baby if it's something you can't get under control. The end organs are having trouble, you deliver that baby. It's considered curative. Eclampsia happens now that they've had those end organ issues, and now they've gone across the threshold and actually seized. This can actually happen even post-delivery. So if I were an evil item writer, and I were going to write an exam question for you, I would write the following. You're called to the bedside of a 28-year-old female actively seizing. Her husband, who is cradling an infant, expresses concern about why she's seizing. What you're going to want to notice is that infant seizing woman, it can occur as long as 8 weeks postpartum. So this is something where it can still happen even as long as 8 weeks postpartum. So know that eclampsia can happen after delivery. Delivery is still the treatment. If MAG doesn't work and if benzos don't work for the seizures and the hypertension, et cetera, hydralazine, those are the sort of treatments that you're going to use. That's something that will get delivered, but they can also have eclampsia after delivery. One weird offshoot of sort of the preeclampsia spectrum is HELP syndrome. And this is basically tells you what it is. It's hemolysis, elevated liver enzymes, and low platelets. The name tells you what it is. So it's right there for you. What you're going to get on labs is you're going to have sent labs, and you're going to be glancing at the labs. And as you look at the micro on the CBC, it's going to say schistocytes. There is nothing good that causes schistocytes. Nothing. TTP causes schistocytes. Your valve that has endocarditis on it causes schistocytes, and HELP syndrome causes schistocytes. You're going to have thrombocytopenia with this. Your LFTs are going to be up. This, again, is very important to treat. This is something you just need to pick up on. So HELP syndrome is a version of preeclampsia. Now, you heard from Amal yesterday that appendicitis is the most common surgical emergency in pregnancy, and it absolutely is. And our job is to just remember that there's still an appendix in there. It may be moved around a little bit. The most common misdiagnosis for missed appendicitis in pregnancy is pyelo, okay, white cells in the urine and sort of flankish kind of pain because the appendix has been pushed out of the way. But just know this is the most common surgical emergency in pregnancy. UTIs are extraordinarily common in pregnancy. Now, a couple things about them. They all get treated. UTIs increase the risk of preterm labor and increase the risk of losing of a first trimester miscarriage, so they all get treated. Pylos in particular need to be treated because they definitely increase the risk of preterm labor. So you treat people basically across the board, even if they're asymptomatic. If the urine looks like it's infected, they get treated. You culture these women because they want to make sure that it's the right bug juice you're using for this, but all of them get treated. Usually cephalosporins are fine, so amoxicillin, nitrofurantoin is fine as well. Drugs in pregnancy, there's a list. I don't want you to memorize this list. What I want you to know about drugs in pregnancy are a couple of things. Again, list for you if you're interested. Virtually all antibiotics are okay except for the fluoroquinolones. If it's an asthma person who's pregnant, all the asthma drugs are fine. Use them, okay, with impunity. Use all the asthma drugs. They're all fine. And when it comes to anticoagulation, which is an area they like to ask questions about, the drug of choice to treat a woman who's pregnant, who needs anticoagulation, is low molecular weight heparin. You don't use Coumadin, it's teratogenic. Has problems with fetal, sort of fetal genesis kind of issues. And all of the new anticoagulants haven't been tested yet in pregnancy. We don't know. So it is low molecular weight heparin in pregnancy. Last little bit, preterm labor is defined as labor before 37 weeks. If you think you have somebody who's in preterm labor, they say, what's so weird, I'm 32 weeks pregnant and I've been having a little bit of cramping and then I had this gush. I thought I peed myself, but I didn't have to pee. Worry, they're in preterm labor or may have premature rupture of membranes. That person needs to go up to L&D. Don't put anything inside. So premature rupture of membranes, again, that gush happens. What's up with that? And it may happen before labor. In fact, those of you in this room who had your membranes rupture first, it's like, whoop, there's the gush. I guess I'm having a baby. Haven't had any cramps yet. So it can happen actually before you end up going into labor. So the key here is not to let somebody's prematurely ruptured get infected. So if you suspect it, the easiest way for you to diagnose it is not to put anything inside. Okay, you don't want to get anything infected in there. So if you do need to look inside, use something sterile. But the reality is get nitrazine paper. You can get it from your L&D suite. You can even sort of use a urine dipstick. If what's coming out from below is alkaline, so its pH is higher than 7, that's probably amniotic fluid. Okay, so that's your clue that this is actually somebody who's had premature rupture of membranes. If you ever get somebody who comes in and they're in labor, and you kind of look in there while they're in labor, and what you see looks like a purple thumb, that is probably a umbilical cord prolapse, and that is a true, honest-to-God emergency for that baby. You put the woman in knee-chest position, her butt goes up in the air, her chest goes down to the gurney, she is knee-chest, you put your hand in there, you take that baby's head and you push it up, and you're feeling for a pulse in that cord. You want to feel, because the baby is strangling him or herself as their head pushes on that cord. You basically push the baby up, and if you can, get that cord inside. If not, just keep the baby up and get them up to L&D. C-section is a crash C-section to get that baby out of there. The killer of women, and we've all been in hospitals where you've heard this code blue L&D. There is nothing worse. Code blue L&D. One of the things that can happen, usually in precipitous deliveries, so it's somebody who just, their delivery ends up precipitous for whatever reason, but it can happen in normal labor, it can happen in a C-section, is amniotic fluid embolism. What's happening is you have two problems. You have a true honest-to-God embolism, so all this amniotic fluid is now in the bloodstream, so it's truly an embolism. So you get all the things that happen with that. It can block stuff and hypotension and all the stuff that an embolism would cause. But it also is full of all the stuff the baby's been floating in for 9 months. There's skin cells, there's meconium, there's all this stuff in that fluid that is now in the mother's bloodstream. So they get raging DIC. They get tissue thromboplastin exposure like crazy, and they get raging DIC. This is lethal about half the time. It is a devastating, devastating problem. Amniotic fluid embolism. Second and third trimesters, abrupt onset, look like an embolism because they are an embolism, but they get raging DIC. ARDS, terrible, terrible stuff. Last couple slides. If somebody delivers in your ER, so you have somebody, we had twins delivered in our ER not that long ago, somebody delivers twins in your ER, and then they start bleeding, and they really bleed a lot. One of the things that can happen is, especially in multiple pregnancies, that uterus has been stretched a long time, and it's like, dude, I'm tired. I pushed these two babies out. I am tired. And it doesn't clamp down like it's supposed to. What you basically need to do, so prolonged labor, multiple births, precipitous deliveries, what you're going to do is you're going to take the ball of your hand and you're going to rub on that uterus like crazy and then get somebody to start a drip, like a Pitocin drip. So oxytocin drip. You're going to basically rub that thing to get that thing to clamp down. And uterine rupture, thank God, is rare. Okay, more traumatic than atraumatic, so that's rare. Retained products of conception can make people have bleeding, so bleeding or infection, so that can occur. And uterine inversion, which to me is almost a misnomer, is where somebody gets placenta accreta. So say you deliver somebody, a baby in your ER. Cool, yay for you. And that placenta is supposed to be gone in 30 minutes, so the placenta should expel itself. And it just doesn't. It just doesn't. The last one of these we had was when a paramedic actually tried to help. and pulled the umbilical cord after the baby was delivered. And basically, as he pulled, the entire uterus just everted out through the woman's vagina, and she came in with basically her everted uterus, basically inverted uterus, out. You don't want to pull on that. If a placenta doesn't come out on its own, you're not going to do anything except call somebody to take care of it. Trauma in pregnancy, you heard about from Billy, so I'm not going to spend a ton of time. Perimortem C-section, there are indications for this, but don't do it unless you feel a baby that is well above the umbilicus. You don't want to be doing a perimortem C-section in a baby that is non-viable. So the sort of rule of thumb is gestational age greater than 24 weeks. And then the last bit, endometritis is an infection inside the endometrium area. They tend to present with sort of foul-smelling discharge. They tend to be very sick. This is IV antibiotics and admission. And breast abscesses and mastitis are extremely common. This is a staph infection. This is something that they continue breastfeeding or pumping. You treat with a cephalosporin. They can use warm compresses. Extraordinarily common. So this is something, and they don't have them stop. A woman who stops breastfeeding even for just a short amount of time may have trouble getting back up to speed as far as the amount of milk they produce. So they continue to basically pump or breastfeed through that. All right, that's what it looks like. We're done with this part. Billy's going to come up and start with trauma, and I'll see you guys with environmental in a little while. Thanks.
Tox. Take a stretch if you need to, understood. It's actually tox we're doing.
Oh, tox.
Stand up, get the blood flowing, all of that. While you're doing that, I'll give a few introductory comments about tox. The first thing I'll say is I'm not a toxicologist, and that's good. You don't want a toxicologist up here teaching you this because they teach it in too much detail. The second thing I'll say about tox, if any of you have taken the peer exams, and I can't remember whether it's 7 or 8, one of them has like 24 really hard tox questions. And you might think, Jesus, I'm going to flunk this thing. They will not be that hard. Right? There's a whole board that creates toxicology exam questions for toxicologists. For you mortal emergency physicians who are regular docs in the ER, the tox questions will be much more straightforward than that. They'll be pretty to the point and squared up because they should save the hard questions for the toxicologists, and they will. The third thing I'll say is because of that, all of those things, a brief review of tox, we've got a couple hours here, really should do it if you're preparing for a test. There's a couple pages that we're going to look at in the slides here that are worth sort of going over again and maybe packing them into short-term memory kind of stuff. But really, just a quick review ought to really do it because they can't make the test all about this because there's a boarded subspecialty on it. All right, with that as intro, we're going to talk about tox. And let me say one other thing about tox. And there's got to be a couple toxicologists in here somewhere. There you go. There you go. Don't take this the wrong way. You could be, and I took poison call for the LA County Poison Center, mostly bites and stings for a decade, but don't take it the wrong way. Tox is one, it has no literature really, right? There's the Poison Center reports. You can't do studies because even the animal studies are different. There's different metabolism. So there's no real literature. It's a whole specialty based on case reports. So there's no science. There's all kinds of great biochemistry. It's fascinating shit. The second thing is, if you were the best toxicologist in the world, you wouldn't save many people. Let's just talk about tox and people who are poisoned who come to the emergency room. Of people who come to the emergency room intoxicated with something, and that includes all the stuff, alcohol, Tylenol, all that stuff, 99% of them live with basic supportive care. All stuff you know how to do. They're not breathing, well, maybe you should breathe for them. Pressure's low, give some fluids and a pressor. So good supportive care is the hallmark of most toxicology. And where there are antidotes and specific shit to be done that the genius Houdini of the toxicologist would bring to the table, for the 1% that are gonna die, who arrived alive in an emergency room, the best toxicologist could only save maybe half because the drugs had a head start. You can't stop the process that's already started. So toxicologists can't save that many lives. It's great science, great biochemistry rather. It's fascinating stuff, but it's of limited importance overall if you know how to do supportive care. So let's dive in. Principles, this lecture, let me just give a quick overview. We're going to do some intro stuff, then we're going to do the toxidromes. There are a few toxidromes. Those are really important because if you're going to ask a non-toxicologist a question, you'd like to be clinically obvious. So give some clinically obvious shit. Those are called toxidromes. And then the last part of the lecture, we're going to go from A to Z and talk about various drugs you might encounter, trying to emphasize the ones that are most important. All right. What are the principles you'd like to reduce exposure? What's the problems with reducing exposures? A lot of people who are seen by toxicologists are like suicidal and stuff. They intentionally are going around your attempts to reduce exposure by exposing themselves. You'd like to reduce absorption when you can, and we'll talk about charcoal and all that. Increase elimination, get it metabolized, get it peed out, do all that kind of stuff. You want to know when to intervene, give supportive care, and then when possible, give a specific antidote when there is one. So that gives you the new ABCDEs of toxicology, which are airway, breathing, circulation. And now, instead of disability, it's decontamination. And instead of exposure, it's elimination. And the F is find an antidote. This is why people like to tell jokes about emergency physicians. They say things like they don't seem to know the alphabet very far. Here, we get all the way up to F. Same in trauma. We get to the FAST exam. Beware of hypoglycemia, and you know this. Anyone who's got altered mental status, you should check a sugar. Because, I think it's pretty apparent why salicylates give you hypoglycemia, right? You're uncoupled, your metabolism's running like a car that's out of gear. So yeah, you might get hypoglycemic. But it's not intuitively obvious why acetaminophen will, except for the fact that the liver is sort of the gateway to all carbohydrate metabolism and it kills your liver. All right, insulin, I get that. Alcohol. Alcohol can make you hypoglycemic if you're drinking hard alcohol, right? Vodka, because 2 carbon fragments are not a diet. There's lots of calories there in alcohol, but you can't make sugar out of it. 2 plus 2 plus 2 equals 6. That sort of reaction exists, but only in plants. It's called photosynthesis. So unless your patients have leaves, they can't take alcohol and turn it into glucose. 3 plus 3 equals 6. That biochemistry you can do, that's called gluconeogenesis. Your liver knows how to do that. But 2 plus 2 plus 2, you can't do. So if you're living on vodka, you'll become hypoglycemic because you can't make sugar. So check a glucose. Oral hypoglycemics makes sense. Decontamination. So since the drugs had a head start, you oftentimes can't get them out. If I was to drink a bottle of vodka and 5 minutes later you were to try and come and make me empty my stomach to get it out, where would it be? In my bloodstream almost all already. It's super fast. You all know this. This is why after work a drink, makes you feel better like almost immediately. And then, it also won't benefit if it's non-toxic, and some of you, there are gray hairs in here. I know and I'm up there with you, coming up on my, whatever it is, 4th time on this. But we remember the days when we used to do charcoal, lavage, charcoal. Oh, that was just insane. We'd take a perfectly white room in the emergency room and turn it into a Dalmatian. And there was this sense, there was this belief that it was street justice. They'll never do that again. We'd put the E-wall down. Street justice. Turns out when they asked patients, that study was done, they asked patients, more than half of them didn't even remember that whole process and that struggle. So there's not even street justice in it. Who might theoretically benefit from decontamination? Early ingestions, a delayed release product, they can give you some sort of stories that might make it think. But by and large, we don't do a lot of this, and there's really nothing in the way of prospective studies that say this works. Syrup of ipecac, kind of dead now. Anything that says syrup of ipecac, that ain't the answer anymore. We just realized that when you give syrup of ipecac, it makes them barf things that might help, like charcoal. And so we just don't do it anymore. There are a variety of contraindications. If someone's, way out in the middle of, Buffalo Park in the Northwestern Territories of Canada, maybe you would. But otherwise, remember, there was a time when every household had syrup of ipecac, in the cabinet so that your mom could give it to you when, you got into something you shouldn't have. But we don't do that much anymore, and it's not recommended. Lavage, uncommonly used. Again, you might do it in a couple of situations. You might use a large bore, the E-walled tube, if there was things like plant material or stuff you need to get out of there. But remember that when you lavage, your big fears are going to screw up the airway. They're going to, vomit, aspirate, things like that. And so there are lots of problems with that. And that takes us to charcoal, which still works. There's a couple different types of charcoal. What's the difference between charcoal and superactivated charcoal? The superactivated charcoal is super. It's got about 10 times the absorptive surface area. So it actually is better, but you don't really need it. Dose, 1 to 2 grams per kilo, max 100. If you're using charcoal that comes with a cathartic, a lot of us have the premix, it's got sodium sulfate or one of those other things in it that makes them shit. Don't use the stuff that makes them shit repeatedly because they can get into problems with overactive gut motility and problems like that. So yes, you can use them for 1 dose, but after that you want to use plain old charcoal. And the worst thing that you can do with this is aspirate it. Charcoal works and will enhance elimination by binding some stuff, but it will really do it if they have enterohepatic circulation, where they pass the thing around their GI tract, and they're basically getting this concept of gut dialysis. And that happens with things like theophylline. That's why theophylline, we really invented theophylline not to make asthma better back in the day. We invented theophylline to justify toxicology fellowships. It was a great drug. It had enterohepatic circulation. It would be bound by charcoal. It had cardiotoxicity, neurotoxicity, unpredictability, bad level correlation. It was just like the poster child for a tox fellowship. Fortunately, now that it's gone away, I don't know if anyone's doing tox anymore, but there you go. What's poorly bound by charcoal? Lithium iron, so the heavy metals, caustics, cyanide, hydrocarbons, alcohols. Alcohols are just gone. They're in your system. Alkali and acid. Contraindications, ileus and obstruction, particularly if you're giving it with the cathartic, and avoid multiple doses of the cathartic, the sorbitol, the mag citrate, the sodium sulfate that they put in there. When would you use multi-dose charcoal? Anytime you were worried that this was a sustained release pattern, or it's got that enterohepatic circulation like theophylline, or it's got a lot of fecal elimination, like carbamazepine is like 30-40% fecal elimination, something like that. So while most drugs are, conjugated in the liver, peed out in the kidneys and things like that, there are a few drugs that have some fecal elimination, and that would be really helpful to make them go and have charcoal in their poop. And carbamazepine's the poster child for that. Charcoal hemoperfusion, you can do this for really tough intoxications that are protein bound or that you can't get rid of. It's not done that often because it's a bit of a pain in the ass to get set up and hard to do, but there are a couple places. Having noted that, whole bowel irrigation has a rising star. We're using it more often for a variety of things. It's more often being recommended for sustained release preps, for gastric bezors, for iron, lithium drug packers, lead, and the contraindications are pretty straightforward, ileus and obstruction. The favorite thing about ordering whole bowel irrigation, where they're going to have to put go lightly in until it comes out the same color it goes in, clear out, is that'll get your nurses to find them a bed. Because that whole process of making them shit until it's clear does not sound appealing. There's nothing that will get you a bed faster than whole bowel irrigation orders on the chart. Misnomer of the month, you will do anything but go lightly if they put that in you. I mean, there's the other misnomer in medicine that I really like is skilled nursing. Those are the two big misnomers. I mean, at least when you work in an emergency room, as I told you, I work in the center of excellence of ground level fall and doesn't look good. They're all coming from skilled nursing facilities with like sodiums of 175. I mean, those people couldn't keep a succulent alive. That was fighting for its life, mind you. Somehow that succulent would fall off the window shelf. I don't know how it would happen. It'd be like ground level fall. That succulent could fall out of a wheelchair. I love the wheelchair slither, They go like some ribbon of pasta. They go down. You get ground level fall. You're like, out of the wheelchair? Yes, doctor. All right. Again, some of you are old enough to remember the days when we used to do things like for PCP, we used to give them vitamin C and we would acidify the urine in an attempt to do. There is no drug that we treat with acidification anymore. So if anything comes up on acidify the urine, just think, no, we don't do that. If anything comes up that talks about forced alkaline diuresis, again, something we did once upon a time. Nowadays, if you see that on a question, that's wrong. We don't do that anymore. We do some ion trapping with salicylates, but that is not forced alkaline diuresis. Those are different things, and there is no drug for which forced alkaline diuresis is recommended anymore. It's out of the picture, it's wrong. When you get to things like alkalinizing the urine and you're giving people bicarb and you're trying to get their urine pH up to 8, and it won't, a lot of times it's just like, you're like, how much bicarb do I have to give this person? Their pH won't go up. What's the problem? The problem is you can't pee electricity. So for every HCO3 minus you want to go into the urine to alkalinize it, there's got to be something plus to go with it so that you're not peeing electricity. And so if the person's a little bit hypokalemic or hypomagnesemic, the pluses that might go there, they won't do it because your body really thinks hypokalemia is life-threatening, and it thinks hypomagnesemia is even more life-threatening. So if you'd like to get the HCO3 minuses to go into the urine, you need to give more potassium or magnesium or both to get it to alkalinize. Hemodialysis, all kinds of things. One of the problems with hemodialysis is that your nephrology colleagues are really, really good at, kidney-related emergencies and nephritic syndrome, all this stuff, but they don't know jack shit about tox. And so when you tell them that they need to do dialysis for toxicology, they often just don't get it. And that it's really emergency, like they can't show up at their usual pace. Oh, we'll be down sometime later this afternoon. Yeah, no, come down. This is like an emergency. This person's getting clinically worse. Dialysis may save their life. Get here. And you have to sometimes ask the renal fellow, like, when was the last time you had a chance to save someone's life? I'm not, mostly what you do is make sure that the estate is completely empty so that there's no money left in it by dialyzing them forever. Today, you have a chance to save a life. Come on down. It'll be fun. But you have to get them there, and then you have to help them out with it because they often don't follow your recommendations. So for things like salicylates, lithium, and they always want to pretend like they know the level indications, which really is bad. Because remember that on the acute, on chronic, and the chronic overdoses, the levels don't matter. So they often misinterpret the need for dialysis based on the levels. So the lowly, poor first-floor emergency physician keeps talking about how shitty the patient looks, and they keep on yawning and saying, but the level's not that bad. No, stop talking levels, come down and do it. The levels don't matter when they look really bad and it's a dialyzable drug. Come down, hook them up. We'll talk later about why the levels don't matter. All right, low protein binding, low molecular weight, small volume of distribution. These are all things that, they're in basically the water compartment of your body. Those are all really dialyzable. All right, so that's the intro of some basic things about tox. Now we're to the F of the primary survey, A, B, C, D, E, F. Find an antidote. These two slides, this one, these blue and yellow slides, they're kind of gray and grayer in your notebook, are the antidotes. And I'm not going to go through them all. We're going to go through the drugs here in a moment. But this is the kind of thing, that you look at before you go sit down in an exam, just to refresh yourself, short-term memory. I don't memorize this shit because what do I do when I got a bad overdose? It's the same thing you do. I call for help. I call the poison center. So why would I jam my head full of this bullshit? It's their job to know this. And so, but before an exam, for some of the basic ones, the 10 or 15 overdoses that are common enough for you to know the antidotes to, this is worth looking at to review. So there's the second page of them, and we're going to talk about them. All right, now, really basic stuff. You get a tox thing. By the way, overdose, let's talk about overdoses. I already mentioned a bunch of them are suicides. Some of them are inadvertent. There's all kinds of stories behind them. The tox stories are always fascinating to hear. You should always want to cross-reference the tox story with someone else, with the pill bottle, with the pharmacy, because there's a lot of untruths there. And so when you ask about how reliable the story is, that actually has been looked at. So about half of overdose patients tell the truth. That means half lie. And of the ones that lie, they lie in both goddamn directions, which is really irritating. They both overstate how much they took and understate with about equal frequencies. And they often omit the parts that's really important, like, the 10 grams of Tylenol. They admit that. Well, I took this and this and this. And there are a lot of times they're fairly random, the overdoses. I remember I was a resident when I saw this kid who overdosed on theophylline and Tegretol. It was perfect. He had a pretty bad theophylline overdose, but he was therapeutic on the Tegretol, so he didn't seize. So he was like he undid himself. He partially treated right at the same time. It was great. Now, in a tox question, they give you someone who took some shit, took unknown substance, whatever it is, and they give you the electrolytes. They're telling you, please calculate if there's an anion gap or not. That's why they gave you the electrolytes. Electrolytes mean find out if there's an anion gap. And if they have an anion gap acidosis, you know it, it's mud piles. And let me just say it while we're on the tox section. Look at the I in mud piles. It's iron and INH and not isopropyl. You don't get an anion gap with isopropyl. All right. Yes, ethylene glycol, yes. Isopropyl, no. No. So there they are, and they're pretty straightforward. So there's like going to be a mud piles question on pretty much every exam you'll see. There'll be one, maybe two. So that's pretty straightforward stuff, I think. Then there's the less straightforward thing, which is looking for the osmolar gap or the osmolal gap, where it's measured minus calculated. Here's how you calculate the serum osms: twice sodium, BUN over 2.8, glucose over 18, alcohol, and there people fight over what the alcohol number is, anywhere from 4 to 5. And if there's more osms in there than that, when you measure the osms, then you should be looking for what those are. And they might be another toxic alcohol, like isopropanol, methanol, ethylene glycol, or one of these other things. All right? So less of that. But the anion gap stuff, pretty straightforward. You can expect questions on that. Let's talk a little bit about tox screens. So there's the urine screen you get that just, has a, depending on where you work and which product you have. There's, second and third generation of these, even fourth now, I think. And, they give you a list of, the stuff that's out there on the street, to try and help you confirm. You should understand that those urine drug screens have lots of false negatives and lots of false positives. And by and large, you should identify the toxidrome that's before you and use such a one of these urine drug screens for drugs of abuse, street drugs, just to confirm. And if they disagree, right, the stuff that it's saying is there doesn't go with the toxidrome that's in front of you, stay with the toxidrome that's in front of you. That's the hard fact. The urine tests, these are largely useless. If you told me you were going to steal them from my emergency department, I couldn't have them anymore, I would be just fine with that. Here's some of the lists: false positives, false negatives. There's all kinds of stuff in there. Some of them we'll talk about more in detail. Fentanyl, right? And all the fentanyl drugs, they're tox screen negative. So for opiates, you'll see tox screen negative opiate deaths. That's to be expected with fentanyl and carfentanil. There's all kinds of other positives that are there and things like that. So just understand that they're very limited in their value. Have those urine screens got a little better over time as they've gone through a couple? Yeah, they have. They're still not great, though. Then we go to the place where you think you know what they took and a level might inform you. You're looking for a Tylenol level or acetaminophen level, whatever, rather than nail the drug manufacturer specifically for Tylenol. You want a acetaminophen level, or you want, a lithium level, or one of these things. Having taken poison center call, and I had a real toxicologist backing me up, when we got into levels, I almost always talk to the real toxicologist because people get the levels wrong. The levels misinform people about what they should do as often as they inform people about the correct thing. And the most common reason for this is they don't understand that the patient's got an acute on chronic ingestion, which means you can't use the level the same way. Right? Almost all the nomograms and stuff like that are about an acute one time, I pounded all the pills in the cabinet, and now let's see what I got. But they can really mislead you if it's not that pattern. So lithium's a real common one. They're on lithium chronically, but they took a bunch of it at one time. So they got a chronic level, and they got this acute superimposed, and so the levels are going to mislead you. Salicylates are another one where the levels are really misleading. And there's, so they used to say the level for dialysis was 120, then they said it was 100, then they said it was 80. And now we're back to a little more common sense based thing. The indications for dialysis and salicylate overdoses, they look like shit. If they look bad, dialyze them. All right, now we're done with the intro. Now we do the 5 toxidromes, and these are really straightforward. You all know them. So I'm going to blitz, right? So anticholinergic, hot as hell, blind as a bat, dry as a bone, red as a beet, mad as a hatter, can't see, can't pee. You know it. They're pretty obvious, right? The anticholinergic one, the kid gets into the stuff, right? The autumnal high with the flower or the plant, right? They got eyeballs as big as saucers, 12 millimeter dilated pupils. They're giant. You can't miss it. And they're talking all kinds of shit. They're entertaining. Causes, antihistamines, atropine, tricyclics, anti-Parkinsonian drugs. There's Jimson weed. That's the autumnal high. Treatment, they can get seizures and agitation. You might try some benzos on that. If they're really whacked out of their mind, you can give them some physostigmine, which is, if they're acting delirious, you could give them a drug. What drug could be better named? Give them a milligram of antilirium. They're delirious, give them antilirium. And it really works. People are hesitant to give physostigmine when they got a bad anticholinergic, and you really shouldn't be. It's really quite, there was some fear that it might cause some dysrhythmias. That's really not been proven to be such a big concern. If they get ventricular dysrhythmias because they're anticholinergic, you might try Lido or Amio. If they get torsade de poing, if suddenly they take a trip to France and get a dysrhythmia, you can give them mag sulfate. And then anything they do you don't like in terms of wide complex tachycardias and things like that, just give them sodium bicarb. So that's kind of a useful slide for anticholinergics. And then they're going to show you here the difference between the anticholinergics and the sympathomimetic, right? They're both agitated, their pupils are dilated, their temperature's hot, and the skin is dry in anticholinergics and wet in sympathomimetics. It's sort of true. I find this a little bit of over-reliance on skin vital signs and stuff, but there you go. But you all know what the sympathometics are, and they're sort of different qualities, right? There's PCP. That means they threw a part of their bathroom at the cops. Only PCP does porcelainophobia, makes you rip a toilet out or the soap dish from your shower and throw it at the police. There's only one thing that does that, it's PCP. If they're super paranoid, freaky, and all that, you know it's methamphetamine. They got no teeth, they got meth mouth, right? They're doing that kind of stuff. It's methamphetamine. And the cocaine is the chest pain because of the vasal. I mean, you know them well. These are not strangers to your emergency room, and they should be straightforward. Causes, amphetamines, cocaine, PCP, ecstasy. PCP is one of the things they might ask you about, rotatory nystagmus. I don't know if you've ever seen that. It's really good. When you see someone with really good rotatory nystagmus, you'll want to shave their head and look for 6s because it really doesn't look normal when you see it. I remember a PCPer I was on the jail service on a post-welfare check, full moon gang sweep Friday. That's bad, just for the record. If you happen to be in the jail on any night, a post-welfare check, full moon gang sweep Friday is not the day to be there. So we were getting hammered, and I had 2 useless interns with me, and I was the R3, and I was behind, and I was doing stuff. One of those useless interns became chair. Talk about fucking disasters. But anyway, so I'm hearing these like Tasmanian devil noises from the hallway, literally. And I'm thinking, oh God, we got a duster out there. I'm suturing some heads, doing stuff. And the duster manages to get the gurney vertically behind him. He was 4-pointed and then some. So gurney now upright behind him. And he comes hopping into the emergency room from the hallway, promptly rips the sink off the wall, porcelainophobia, points the sink and the pipes at me, water spraying all over the place. And I'm like, turn to the interns. That's PCP. Anyway, but that's all kind of PCP stuff. Rotary nystagmus, there you go. Treatment, benzos, and maybe more benzos after that with some fluids. Rule out rhabdo, look for the, with all these sympathomimetics, they can get hyperthermia, rhabdo, and all the other things that you should be concerned about. All right, so we're 2 down of the toxidromes. Here's the third one, opiates. This is a real tough one. Pinpoint pupils, not breathing. Just in case you haven't noticed that, we're in the middle of this opiate epidemic that's out there. and I drive around Long Island, you see people out there going like this. In LA, if someone gives you, a hand sign, it's their gang affiliation. In Long Island, when they're going like this, they're giving you the Mallinckrodt symbol for the pill, the M's. Need some 30 milligram M's. This means they're selling them on the corner. You could pull up. Yeah, I'd like to overdose. I love the names for some of the more, we had a lady who, her husband, I don't know if it was husband, her significant other died of an opiate overdose the day before. And she was there, and then the next day she comes in with an opiate overdose. And he had taken tons and tons of Narcan to reverse, so we were thinking it might be carfentanil, which is the super potent veterinarian version of fentanyl. And so we asked her, we're like beginning to get on to her and treating her. She comes in, we're like, ma'am, are you using carfentanil? Did you have access to carfentanil? And she says, well, I had to look all over the house for it. It wasn't in there. I'm like, and? Well, it was in the glove compartment. I was like, of the car? She said, yes. I said, that doesn't make it carfentanil. Thank you, though, for that information. Anyway, so opiates, you're all familiar with it. You know what happens if you over-narcotize someone, they get the pinpoint pupils. You should be aware of the fact that some opiates, right, all opiates are not created equal. Some opiates do weird things. They'll give you dilated pupils and agitation. So in general, it's the small pupils and they're not ventilating. But some, like a Dilaudid overdose, a Demerol overdose, a diphenoxylate overdose, even dextromethorphan overdose, I call them the Ds. Those are 4D opiates that all give dilated pupils, agitation, and seizures. So if you only recognize opiate overdoses that are pinpoint pupil, somnolence, and hypoventilation, you'll miss some. Causes, there you have them all. And remember that the Narcan has a shorter half-life than some of the drugs you're talking about. Propoxyphene, there's another one that causes agitation and seizures. And it's still on the D list because it's Darvon. Still on the D list. So that would be the 5th D of the dilated pupils and agitation on the opiate list. Okay, clonidine can mimic a heroin OD or an opiate OD. Right, with the pinpoint pupils and the hypoventilation and the sedation. Treatment, Narcan, start low dose because they're not very nice. You don't ever really want to hard reverse them because they're not nice when they wake up. And there are other really more important reasons aside from their personality disorders that you don't want to hard reverse them if they have cocaine and heroin together and you reverse the heroin, then you have unopposed cocaine with Narcan. That's bad. Right? The Narcan has a little bit of adrenergic release, so now I got cocaine with a catechol. That's bad. You're asking for VTAC, VFib, problems. So that's another reason not to hard reverse them. You don't want to hard reverse them if it's something like, the diphenoxylate, the Lomotil overdose, because then you're going to end up with the opiate reversed, and you're going to have Narcan, which is again a little bit of a goose to their adrenergic system, plus atropine. Now you're going to have a heart rate of 200 because the unopposed atropine. So there are some combinations which you should respect that are commonly out there that are reasons not to hard reverse an opiate. If you've reversed them and they go back down, they might need to be redosed, and there's all kinds of stuff. Is it safe to let one of these people go who's refusing further treatment after reversal? Different states have different laws regarding your ability to confine them, and New York basically says if they have any wisp of competence, you can let them go after that. What are some of the ways that letting an opiate overdose goes wrong? One, they resedate because they had a longer lasting one. That's usually not that big a problem. They'll be brought back. Most times they'll be found and brought back. It doesn't happen that often. But the biggest reason is you didn't take enough time to figure out that, yeah, they were an opiate overdose, but what they took was Percocet. So the problem is that if you want to take enough Percocet to have pinpoint pupils and stop breathing, that's a lethal Tylenol overdose. So now you let someone go with a lethal and treatable overdose. So you want to look for that. All right, cholinergic, sludge, salivation, lacrimation, urination, diarrhea, gastrointestinal upset, and emesis, plus the killer bees, bradycardia, bronchospasm, bronchorrhea. They always ask questions about how much atropine should you give them. They ask you, should you give it up until they stop urinating? Give them atropine until the urination stops. No, who cares if they're peeing? Give them enough atropine until the diarrhea stops. Yeah, the nurses want you to do that. But that's not when you stop. You stop when the killer bees are stopped. when the bronchuria, bradycardia, and respiratory distress associated with those is over. So you give atropine titrated to the killer bees. You don't care about the sludge. No one dies of sludge. People die of the killer bees. The nicotinic effects and the muscarinic effects. The nicotinic effects are the muscle weakness and the fasciculations and respiratory failure. What are the causes? Organophosphates, and there's been some, there was a rebirth of those questions because these were possible terrorist agents and chemical warfare agents, so they wanted us to know about them. And there's all this stuff about getting serum plasma red cell levels and intracellular red cell levels of this. Again, that's a mess. They won't ask that. Treatment, atropine plus 2-PAM. Treat until the secretions are dry. All right, so we're almost done with the toxidromes. We're to withdrawal syndromes, alcohol, barbs, benzos. Remember, no one dies of opiate withdrawal, even though they wish they would, and many people die of opiate overdose. No one dies of a benzo overdose, unless they choke to death on the pills, unless they get an airway problem. No one dies of a benzo overdose, but the withdrawal pattern is potentially lethal. So sedative hypnotic withdrawal is lethal. Opiate withdrawal is uncomfortable. So keep those straight. And you'll see people nowadays, there's a lot of Xanax and stuff out there. There's a lot of alternate benzos. Xanax is particularly ragged in withdrawal. It's a suburban abuse drug that's really ragged and nasty in withdrawal. So withdrawal syndromes are things we see and deal with, and you should respect sedative hypnotic overdoses because they are potentially lethal. And alcohol withdrawal gets worse and worse and worse until it gets to the DTs. There you have the label of the beer, the DTs beers. And to have DTs, delirium tremens, you need to have more than D and T. This is a diagnosis that is misused a lot. There are multiple definitions out there of the DTs, but to have the DTs, you got to have delirium tremor and dysautonomia, manifested by hypertension, tachycardia, and a fever. That's one of the definitions out there. And I could take 100 charts that say the patient has DTs, and just by looking at the vital signs, the patient has no fever, they don't meet the criterion. So we overuse DTs. You could say severe withdrawal, impending DTs, that would be correct. But to call them DTs, if you say DTs, admit medical ward, that's wrong. The whole definition of DTs was to identify a population of withdrawal patients that needed to be in the ICU because they might have vasomotor collapse. So DTs means no ward. DT means admit ICU because they're at risk for dying. We do the same thing, by the way, with thyrotoxicosis and thyroid storm. Thyroid storm was defined in a way to identify those patients, and they have to have a fever for storm, was identified people who needed to be in the ICU because they might die. So thyroid storm and DTs are disease entities that were specifically defined to identify an ICU population at risk for death from their problem. Both of them require you to have a fever, and in both disease entities, it's a sloppy definition because they might have other reasons for a fever. How many alcohol withdrawal patients have you seen who might have pneumonia or aspiration or a cellulitis where you can't tell where the fever is coming from? It's a sloppy definition, I got it. But it is what it is. All right, now we get to acetaminophen. We are at the part of this talk where we start at A, and it already sounds horrible, and get to Z, going through all the drugs. Obviously, we're not going to do the whole PDR. We're going to do sort of the common ones. And the most common one of all is acetaminophen. And we could stop acetaminophen overdoses in this country anytime we wanted. They did it in all other countries. They decreased the number of people on their liver transplant list by half in the UK, Italy, Benelux countries. And how did they do that? They just said you can't sell acetaminophen in more than 7 grams at a time, and it has to be in a blister pack. Now, in the United States, that's too much of an impingement on your personal freedoms. You need to be able to back a pickup truck up to Costco, use a forklift to get a 150-gallon drum of fucking Tylenol at less than a half penny a tablet, bring it home, and store it in your house where someone can overdose on this. And that's why we keep half of our liver transplant list loaded down with acetaminophen overdoses, where the cure is demonstrated and proven in like a dozen other countries. But we can't figure it out enough here in the United States. We're such fucking geniuses to do the same thing. Now, I'm going to do this. Last time I did this, someone thought it was really misogynistic. So if I don't mean it to be that way at all. But women do overdose more than men, particularly in suicide. I will do my example of an overdose, and I mean no misogyny in it whatsoever. So there's a fight at home. She stands, well, you're such an asshole. She goes to the bathroom. She opens up the cabinet and takes what's in there. It's not really well planned. Like I say, the kid that I talked about, he took the Tegretol and the Theophylline, and they canceled each other out. They take whatever's in there. Now, if there's a huge jar of Tylenol in there, if there's the blister pack in there, like, I hate you, motherfucker. They throw that away. They don't take them anymore because they can't get to them because they're pissed. This is not a rational thing, and this is how these overdoses happen. And the blister pack is super effective at preventing it. Now, if you also said to me, Dr. Mallon, you loser, half toxicologist, poison control, take and call loser, you could only have one level, I'd be all right. I want the Tylenol level. I want the acetaminophen level. Because it's super common, it's out there, and it has sneakiness to it. We'll go through that in a minute. If you hang out with your toxicologist, they'll tell you in the livers there's the 3 metabolic pathways that go down, and the middle metabolic pathway goes to the toxic intermediate, and you should be able to say, if you want to hang out with your toxicology friends, you got to say, yeah, let's go get some NAPKI. You get the NAPKI is the toxic free radical. You see it down there at the bottom, and that's what causes the hepatocellular toxicity. And here's the important thing. Here's what it looks like. Early on, you overdose, and usually they're drunk at the time, right? This is how it is. And they might have some GI symptoms, but then they get better. They're still potentially a treatable lethal overdose, but they look pretty good. So an overdose that's super common has a silent period while it's still treatable by the antidote. That's the level I want. If you were going to tell me I could only have one level, that's the level I want. So remember, they may ask you on the exam the sort of 4-hour rule. If you were going to get a level, you'd like to know when time 0 is, and then you check the level at 4 hours, and if it was greater than 140, they get 140. That used to be the mnemonic for it. If the level's greater than 140, they get 140 mg per kg of NAC, and then you go from there. Now we mostly do it IV, right, which is a shorter protocol. That's the main reason we've chosen IV. Because giving it orally is great, right? It goes right to the target organ. If you give the antidote orally, it goes straight to the portal system and into the liver. There could be this is an overdose for which oral administration is perfect. But it takes that protocol, the oral NAC protocol, takes 72 hours. And no one wants one of these patients in their emergency room that long. So we'd like to do the shorter one. So we do these IV a lot. Safe in pregnancy, you should still give it in late presentations because nothing else is going to save them, and they're going to go on to liver transplantation if it's bad. And here's the nomogram. Remember, it's only for acute overdoses, and there are lots of acute on chronic ones that may be worse at lower levels. So again, don't be fooled by the serum levels when someone has both acute and chronic going on. And there's the NAC. And NAC is used for other things besides Tylenol. I remember I had a patient recently who was taking the dysuria, over-the-counter dysuria meds, the Azole, is that what it's called? One of those, that for urinary symptoms. And I saw her, and she had pyelo, and everything was boiling out to pyelo, but she kept vomiting, and I was like, what's with that? So I got her liver functions, and they were symmetrically bumped, 1,000 each. And I was like, So I started asking more about the Azole, and she had taken a lot of it, because the dysuria was just torturing her. And so I called the poison center, and no, they said, absolutely, this is something that you would treat with N-acetylcysteine, and so she should be admitted and put on that. And I was like, really? But the thing I remember the most was the way he told me that. So I called them back. I'm like, these are liver functions. Here's where we're at. Here's how much she took. I said, and so there's this pause, and the guy at the poison center in New York said, "Knack her up." I'm like, what? You said, give her NAC. I'm like, oh, okay. I'm on it. We're on it. We'll follow the orders. And off we did. So there are other things besides Tylenol that get treated where you need to restore reductive potential of your liver so it can continue doing safe metabolism. All right, now we're to the next most common overdose in the emergency room. Well, probably not the next most. The Tylenol and acetaminophen are common and treatable. Alcohol is really, really common. And we see both withdrawal and intoxication. We see a lot of trauma. It's always interesting to see on the exams what's the biggest cause of death related to alcohol ingestion. And they have things like liver failure and varices. It's anyone who's worked even, 10 minutes on a Saturday night in an emergency room knows it's trauma, 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 and trauma. And then it's 2 more traumas before any of those other medical causes of death even begin to wane. About every single way you can die, if you were to do that book or that movie, 1,000 Ways to Die, alcohol would be in with every one. You look at farm deaths, you might think, oh, that pastoral living, it's so clean, the fresh air, eating the natural vegetables. They're fucking hammered all the time. When they flip the tractor, they're drunk. So about half of all farm deaths are alcohol related. I know, I grew up on a farm in Western Mass. There is nothing good about being on a farm in the middle of January. You'll be hammered too. You can look at like boating stuff, half of those fatalities. You can look at violent crime, almost every way you can die, alcohol's in there. Alcohol's in there. So it's trauma is the way they die. And occasionally they die of alcohol withdrawal and other things. We got the DTs there and giving them the thiamine and the B vitamin. Wernicke's and Korsakoff. So Wernicke's is still out there and people don't recognize it. So remember, it's oculomotor paralysis or dysfunction, cranial nerve 6 palsy, nystagmus, ataxia, and global confusion. You'll see patients that have this, and remember that when you give them a banana bag, if you do that with 100 milligrams of thiamine in it, that's only to prevent them from getting Wernicke's. If they have Wernicke's, that is not enough to treat them. If they are confused and can't follow commands and can't get up and walk because they're ataxic and can't move their eyes, they need gram amounts of pyridoxine. And when you order, and I've had lots of people, I remember a guy who, I was stopped by the residents to look at him because his stomach was in his chest on the chest x-ray, and like, what do you think of that? And I was like, all right, it looks like his stomach went through his chest. He probably had a diaphragmatic hernia. Does he have any scars? The residents looked at me like, why would he? Scars? I'm like, that would have been associated with that. They're like, oh yeah, we'll go look. And then I was like, well, what's going on with him anyway? Why don't you just ask him? Well, he's altered. And so I go there. The guy has every peripheral manifestation of chronic alcohol as you can imagine. He had a rhinophyma bigger than Karl Malden's. He had cherries. He had everything. All of those are there. And I was like, well, they're like, well, his electrolytes are normal, CAT scans normal, all this stuff is normal. So I said, did you try giving him some B vitamins? And they're like, So anyway, after we got to around 600 milligrams, because it's usually 5 to 1,000, 500 to 1,000, the guy sat bolt upright. We said, what happened here? He goes, a kraut got me in the big one. WW2, that's from a bayonet. That's how awake he became. This is a guy who hadn't said a word in 4 hours in the emergency room. Adequate doses of B vitamins, he woke right up. So don't forget, Wernicke's is out there. But it's gram amounts of B1. When you order pyridoxine in high volumes, so it's B6 or thiamine in high amounts, it's shocking what happens in almost every hospital I've ever worked in. The pharmacist has like seizures, like you've asked for plutonium or polonium. They ask, you want the water-soluble B vitamins? And those, that's a toxic amount, doctor. I'm like, what are you talking about? There's no B vitamin toxicity. They'll PB vitamins. But anyway, it's always amazing when you ask for a gram of B1, they'll act like you're like a big B vitamin theft suspect. All right, now we get into the toxic alcohols. These are kind of important. They're fair game. There have been a bunch of methanol overdoses all around the world with bad hooch, so you got to pay attention to it. They get wicked bad. There's a little bit of my Massachusetts. They get wicked bad acidosis. You've all seen a million DKAers over your career, and they all have bicarbs of 5, 7. That's what a bad DKAer with a pH is, even 7, 6, 9 has. When you see bicarb 0, doesn't happen often. That's methanol. There's not many things that give you bicarb 0. Severe acidosis. The acidosis from the formaldehyde being formed. They might have visual changes and blindness. They might get pancreatitis, and they might seize. So it's kind of CNS and eye stuff. The bottoms on these toxic alcohols, the bottom of the slide gives you the clinical stuff that you need. Treatment for methylpyrazole and ethanol and dialysis. Remember, if it's a bad toxic alcohol, the 4-MP, right? They're going to ask you about the 4-MP. I'm fine with the 4-MP, but you need to understand that might just be a temporizing move while you get to dialysis. They may yet need dialysis. Don't think of the 4-MP as the final die cast on this. I got some more. Ethylene glycol, the antifreeze, the solvents, the coloring in it is added so that you know it's there. They get an anion gap acidosis, right? It's on the mud piles. They get an increased osmolar gap. So if you did the calculation versus the measured, right, it would be off. They get oxalic acid crystals in the urine, the envelopes, and it causes acidosis and hematuria, renal stuff. It's all renal stuff. Crystals, hematuria, it's all renal stuff. As opposed to the methanol, which is I can't see, neuro stuff, seizures, severe acidosis. And now, treatment here, 4-methylpyramidol, again, the 4-MP, bicarbonate if they need it for acidosis, and again, dialysis. All of the toxic alcohols, if they're bad, even if you see a frat boy, so you see some frat boy come in who's got, and I remember I saw one once with an alcohol level of we called it the Vegas level. His level was 777. He was intubated. You know, we were having trouble. His pressures were dropping. We were doing all the supportive care stuff. We dialyzed him. So even a regular old alcohol overdose that's bad enough, alcohol, you know, it's beyond intoxication at that point. What the chart should say is alcohol poisoning. But when they have alcohol poisoning, it's the same thing. You dialyze. Any of these look bad, they get dialysis. Any of these alcohols look bad. So dialysis of severe acidosis are bad clinical findings. And then finally you get the rubby, right? There's rubbies and rummies. Rummies are people who are on the, on the street drinking a lot of rum. And the rubbies are desperate who are drinking rubbing alcohol. And they had to take all those hand washers, right? The foam ones that you have in your hospital out of the jails, right? Why? Because there's alcohol in those. So people are withdrawn from alcohol, drink that shit like crazy. What's Pruno? Pruno is the alcohol they make for themselves in jail because they're withdrawn. You take the prunes, you take some tap water, you take some of that white bread that's on the cafeteria line, that's your yeast. You put those together in a plastic bag, you put it somewhere warm for a few days, let it ferment, then you strain it through your drim shocks and drink. I've tasted it. It is horrible. Horrible, horrible, beyond belief. But if you were withdrawing bad, you'd do it. But anyway, so when people are withdrawing, they'll do anything to treat their withdrawal. If there's no alcohol around, they'll drink rubbing alcohol, they'll do mouthwash, they'll do NyQuil, they'll do ginseng, right? Those little ginseng things you see at that little Chinese thing. Oh, get the healthy ginseng. They're a quarter alcohol. That's like a small shot of alcohol. The kids all know that because they mix it with their Vicks Formula 44 when they're doing their skittling. They know they can get that alcohol without an ID. All right. So rubbies, ketosis but not acidosis. The yellow box is the key. Normal anion gap, as I said, in the anion gap acidosis, isopropyl is not there. And then you have your toxicities in increasing order at the bottom. All right. No, we havenent left A yet. All right, amphetamines. We all know what that looks like. Sympathometic, hypertension, tachycardia. Amphetamines, how do these people die? Well, some of them die of strokes and hypertensive-related things. A lot of them die of trauma. So if you were to take cocaine and amphetamine and compare them, in amphetamine, 2/3 die of trauma, 1/3 die of the drug. So a lot more trauma, because you know how paranoid they are and how the cops are involved and all that stuff. 2/3 die of trauma, 1/3 die of drug. As opposed to cocaine, 2/3 die of drug, 1/3 die of trauma, and that's because with cocaine there's so much vasospasm, so you can get cardiac and CNS problems related to it. Remember that beta blockers are contraindicated. If you've ever seen that YouTube of the guy who is on the table and they give a beta blocker to who's a cocaine chest pain and watch his vessels go like this. There's a beautiful YouTube of a guy on the table who gets a beta blocker in the cath lab for cocaine chest pain, and all you have to do is watch like 5 seconds of that YouTube. You're like, don't give them beta blockers. Diane mentioned this. It's a good one. Cocaine associated with abruptio placenta and prematurity. We've all seen rhabdo, strokes, MI, status, all things related with cocaine. Here's the MI associated with. What's the incidence of cocaine causing MIs? You'll see numbers all over the dartboard from around 1% to some. There was a Philly study that said up to 25, 30%. Most people who see a lot of cocaine in an urban inner city ER where there's a lot of crack cocaine and things like that, think the incidence is really pretty low, in the 1-2% range. That this idea that it's 25, 30% is a little bit cray-cray. So yes, can it happen? Yes, it's vasospastic. Sure. If they inadvertently took their own beta blocker that they're on for, their hypertension afterwards, sure. Antabuse reaction, pretty rare, an uncommon thing. They love it on exams though. So alcohol plus flagyl will give it to you, as well as the, disulfiram, and it can be pretty bad. You'll see hypotensive people flushed, puking, headache, seizures. It can be pretty bad. I've had to admit people for this. The question will always invariably say, a young woman who saw her gynecologist recently, they're trying to get to the flagyl. So that's code for on flagyl. Arsenic and some heavy metals. I don't think they'll ask a lot of heavy metals, but here's a picture of, the arsenic findings with the nail changes, and the treatment is chelation. They get neuro and gastroenteritis kind of things. Barbs. The old days, probably again, some of you in here remember the days of seeing barb blisters. I certainly do. When you see these people who are out so hard that they were barb blisters, but they still had some ventilation, so they didn't die. So they were brought in with these barb blisters. And there's short-acting and long-acting ones, and they can get these cutaneous bulla, and the treatment is Lavarge charcoal, alkalinization for the long-acting ones only, for phenobarb in particular, and hemodialysis. Don't see a lot of barbs anymore. Benzos, see lots of them. Remember, flumazenil, relatively contraindicated because the person with a benzo overdose is probably a chronic benzo abuser. And as I said, the benzo withdrawal syndrome is potentially lethal. So the last thing you want to do is give flumazenil and take a non-lethal overdose and turn it into a lethal withdrawal pattern. So no flumazenil for these. All right, what causes most of the overdose deaths? If you go to the Poison Control Center data, and you want to talk about non-drugs of abuse, right? So we got, we're away from the heroin and all of that, which we've been in the middle of this epidemic of. But if you go away from those drugs of abuse, the vast majority of deaths are beta blockers and calcium channel blockers, with the calcium channel blockers leading the way. A lot of times it's PEDS, where they get into 1 or 2 tablets. These are really at the top of the list. 1 or 2 tablets could kill you. There was that landmark paper, I bet all of you remember it and have heard some lecture about it, where they go through the list of 1 or 2 tablets will kill you if you're a child, overdose list. And these are on there. The antidotes, glucagon 5 to 10, it often doesn't work. Insulin and dextrose, and then nowadays we're going with intralipid. Again, you'd have to call your pharmacy. I don't think they'd ask for a lot of detail on how this is given. And that you just need to know that intralipid is one of the options. I think that's the detail we're talking about. You could try atropine, it doesn't work. You could try vasopressors, they often don't work. You could try a pacemaker, which frustratingly often doesn't work. And the other thing that you might try with these is ECMO, or as I like to call it, resuscitative ECMO, because if this is a young, healthy person with a couple of tablets of a beta blocker in them who's going to die, all I need to do is give them extracorporeal membrane oxygenation for a couple of days and let their liver catch up, and then they'll be better. And so RECMO is resuscitative extracorporeal membrane oxygenation. People talk a lot about it in cardiac arrest and things. Overdoses are a totally valid reason to play the ECMO game. Totally valid reason. And then don't forget the timolol eye drops. I see this missed all the time. Someone comes in bradycardic, and everyone says, well, they got sick sinus syndrome, blah, 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 get the card, blah, 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 put in a cordis so they can float the pacemaker, blah, blah, blah. And I go, they're on any beta blockers? And they say, no. And I go up to them, I look at this old person, when was the last time you saw your eye doctor? They say, well, about a month ago. What, did they put you on some new drops? Yep, where are they? Timolol. So timolol eye drops, well-known cause of significant bradycardia, well-known cause of worsening CHF. Remember that, as you become specialized, you know what emergency physicians say about specialists, right? A specialist is someone who knows more and more about less and less until they know everything about nothing. So from the ophthalmologist specialty standpoint, all they really know is that the heart pumps the blood to the eyes. And so it doesn't occur to them that the timolol, which could affect the heart, isn't going to do so well with it. So timolol eye drops are higher potency than you think. It's common treatment for chronic open-angle glaucoma. So don't forget, when someone has a beta blocker or bradycardia kind of thing, because it'd be a shame if they got a pacemaker when really they should just be taken off the timolol drops. And So that's out there. Now we go to the calcium channel blockers, very similar stuff, bradycardia, hypertension, conduction delays. No, does this look familiar? So we start with the calcium gluconate to get by the calcium, the calcium channel blockage. We're going to try and do that. Then we do all the same things that we did for the beta blockers. Glucagon, insulin, glucose, intralipid. You could again do ECMO. And these overdoses are really, I mean, when you're faced with a kid or a young adult with a calcium channel overdose or a beta blocker overdose, they're really frustrating. Because a lot of the things you might try, the fluids, the pacer, the vasopressors, the supportive care, you think you have all the stuff you need to support them. It doesn't work. They need to get this stuff out of their system. Now, I said earlier that all those patients who arrive alive to the emergency department with an overdose of some kind, less than 1% die. And that's true. That doesn't mean you can't die by overdosing. There are lots of successful suicide overdoses. They're not coming to the emergency room because they're found dead. And among those, top of the list is carbon monoxide. So it's a real common cause of intentional suicide, but it happens accidentally as well. Carbon monoxide, they always ask these questions. It shifts the oxyhemoglobin dissociation curve to the left. That's bad. Right? Your hemoglobin's super smart. Oh, I'm over. I'm going to break there. Your hemoglobin will end with the idea of how smart your hemoglobin is. Remember, you got a lot of it in you. That makes you really smart. All right, well, is it break now? Is that what's up? Break. Break it is. Thank you. Full 15 minutes on the break. Full 15.
Okay. Feel free to wander around while we do this. You guys have the Billy and Diane show this afternoon. I apologize for that. I don't swear as much. I just can't bring myself to do it. I try, and it just doesn't happen. So that's just not me. Okay, we're going to do environmental emergencies. A couple things about this. It's 2 one-hour sessions. It's a huge mishmash of stuff. The environmental section of what's going to be on your exam is 3% of the exam. So for the people taking the qualifying exam, that'll be, 5, maybe 6 questions. People taking the concert exam, that'll be 3 or 4 questions. So it's 2 hours of all kinds of stuff that they're going to pick and choose a few questions out of, which makes it a little hard to teach and a little hard to study to try to figure out what's going to be on the exam. There are certain things, though, that are kind of high yield that I'll focus on as we go through it that they tend to like to go for. I retook my concert exam 2 years ago, and I was actually surprised at what they pulled out of this, which was kind of annoying. But anyway. So just know that don't spend a boatload of time on this. Spend your time on cardiology, spend your time on trauma. That's where the vast majority of the questions come from. And the things in the other sections that you're not terribly sure about, use this as the icing on the cake. You don't spend a lot of time on this. That being said, however, this is the fun stuff. Right? The stuff that falls under this environmental category is the reason a lot of us even go into emergency medicine in the first place. Not necessarily to take care of people with this stuff, but to go out and do things that make us at risk for this stuff. Right? And so that I love this. The topics in here are super fun. The other thing about this, though, as we go through this, the point of this talk is to make everybody in this room, whether you work at sea level or at altitude, whether you're a scuba diver or an extreme climber or whatever, make everyone in this room able to answer whatever questions come up on the exam from this section. I absolutely guarantee that there are people in this room who are experts at some of the things we're going to talk about in this next, sort of 2 one-hour sessions together. So it is not meant to make you a hyperbaric chamber person. It's not meant to make you someone who can climb Mount Everest and know exactly what to expect, or someone it isn't. It's meant to basically get everybody on the same page. So we'll have a core amount of information that you all will get that hopefully will help you pass whatever 2 or 3 or 5 or 6 questions pop up on your exam. So that's all the disclaimers. Let's get into this. Let's start with drowning. So we're going to start in the water. When it comes to all these environmental emergencies, we're going to start in the water. So a couple things about drowning. First of all, there's all kinds of videos out there of people taking phone videos of people flailing around in the water. That's not a great idea. What they've done with drowning is they've renamed it. So those of you who are taking your concert, if you have the term near drowning in your head, that needs to go away. And there's actually very good reason for that. The term near drowning implies something, oh my God, they almost died kind of drowning. And it led to a lot of admissions that turned out not to be important, turned out not to be necessary. So the terms have been redone. So the terms now are water rescue. So that's somebody who's flailing around in the water, but hasn't started the process of drowning yet. They can even be underwater a little bit, but plugged out and they're fine. They may cough a little, but they're fine. There's non-fatal drowning. I went under, I started to inhale the water, but I got brought out before I was dead. And then there's fatal drowning, where I'm under the water and I die. That terminology change is really, really important because this water rescue group, which is a large proportion of people that end up in the water and under the water, that group tends to be fine and don't need admission. So this reclassification is very, very important. The people that drown or have all these sort of water rescue kind of issues tend to be kids and people with testosterone and alcohol in their system. So a lot of the stuff we're going to talk about in the environmental section, testosterone kind of works its way in there, and alcohol for sure. So kids, we know that drowning is one of the leading accidental causes. In fact, I think the leading accidental cause of death in children is drowning. And in fact, my niece had a graduation party. They have a pool in their backyard. A bunch of people were supposed to be watching all the kids. Somebody wasn't watching all the kids, and one of the 2-year-olds was in the bottom of the hot tub. Basically plucked her out of the bottom of the hot tub, and she sputtered and coughed and kind of was kind of freaked out a little bit, and then was fine and toddled around the whole rest of the party saying, I almost drowned, I almost drowned, I almost drowned, which she did. So that's a problem. Kids end up under the water. They just definitely do. A lot of risk factors for this. The other is dumb things with booze and jumping off of boards and all kinds of crazy stuff. What happens when you're underwater is you have this incredibly cool thing called the mammalian diving reflex. It's actually so cool. Your glottis closes, you shunt blood to the important things like your brain, you slow things down, you basically stop breathing, the urge to breathe goes away, your heart rate slows down. It's very profound in children. It's one of the reasons that kids can be underwater for a while and plucked out and survive. It's a remarkable, remarkable thing. It's magical. It's not perfect. At some point you will drown, but it's kind of cool that kids have this. And the other thing about drowning is shock is rare. So if I'm at ABEM General, or I'm taking my concert or my qualifying exam, and they give me a question of an 18-year-old is found at the bottom of a pool and is brought into the emergency department altered with a blood pressure of 70 and a heart rate of 70. That's not from drowning. That's from trauma. And a 70-70, Billy told you yesterday, 70-70 is basically neurogenic. Right? That's somebody who has a cord injury. That's the stupid testosterone-driven kid who dove into the pool, broke his neck, and is at the bottom of the pool because he can't move, not because he has drowning. He can't move. That's how he ended up on the bottom. So just know that hypotension, shock, is not associated with drowning unless there's trauma involved to some degree, either neurogenic or true trauma. How you survive from drowning really depends how long. Lots of things, all logical, right? They all make sense. How long you're down there, is the water cold, how old are you, what kind of comorbidities do you have? When they got you out of the water, did they do anything for you? Did they do CPR? All of those things make a difference. It turns out that people can still survive drowning even as long as 60 minutes underwater, depending what their factors are. Is it a younger person? Is it colder water, etc.? So if you have basically somebody who's been underwater and I saw them half an hour ago, and now I go out to the pool, and they're on the bottom of the pool, you're still going to do full resuscitation in that person until you can kind of figure out the big story. If somebody's not that would be a near-drowning person, right? That's a person, a non-fatal, not near-drowning, a non-fatal drowning. That's somebody who's not dead yet. That's a non-fatal drowning. If they die, that's fatal. If they don't die, it's non-fatal if I can get them back. If it's anything short of that, though, if it's like this cute 2-year-old who walked around saying, I almost drowned. If they're just sputtery, or they come to see you because they were plucked out of the pool, if their lungs are clear, okay, their lungs are fine, they're oxygenating fine, you observe them for a little while, they go home. So again, this new terminology, no more near drowning, is to basically get us comfortable with the idea that a lot of these people can go home. Now, if you want to be under the water and stay there a while, you scuba dive. Now, scuba diving, it is an area that's like moths to the flame. ABEM item writers love questions about scuba diving. They love this. So let's talk a little bit about it. Now, you need to know some basically physics to understand this. How many of you are divers in here, in this room? You are all insane. Just saying. If you think about what you are doing to your body underwater, it is insanity. It is absolutely, a fish doesn't put on a liquid tank and come out of the water and walk around. We put on an oxygen tank and go down under the water. It's nutty. It's fabulous. It's fabulous. But what you're doing to your body is nutty. So physics-wise, what happens? There are a couple of principles. You don't have to know which one is which, but a couple of principles that are really important. So if I have an enclosed gas space of some sort, so I will use my lungs as an example. That's an enclosed gas space. I close my glottis, that's enclosed. And I now put more pressure on the system. So I'm at sea level-ish here. So I have whatever's pressure here. And now I go underwater, and I put a bunch of pressure on the system. What happens to that volume? This is Boyle's law, the one at the bottom. What happens to that volume of gas is it gets smaller. And you know this, and you can demonstrate this to yourself when you fly home. So when you fly home, what I want you to do is when you're up at altitude, I want you to get a bottle of water, get one of those plastic bottles of water, and drink it empty, and then tighten it tight, empty, and stick it in the seat back in front of you. What you're going to find when you land is that enclosed space gas is all scrunched up, right? More pressure at sea level than it was up in the air. Or flip it around. If you've ever gone skiing someplace like Aspen, and you go to the grocery store in Aspen, and you decide you want to buy a pre-packaged salad in one of those plastic packages. It's already pre-done, it's already been pre-cut up, it's just in a plastic thing. What it's going to look like at Aspen is a beach ball. Because it was packaged down at sea level, where the pressure is high, more pressure on it. Now I'm up in altitude, there's less pressure on it, it expands that gas, and it's like a beach ball. So gases expand and contract. The volume of it is smaller and larger depending how much pressure is on it. And that makes total sense. And it makes sense what can happen to you, your lungs, your ears, whatever, depending where you are in water and how quickly you're moving up and down. Okay, so that makes sense. The other two things to know, and that'll give you the overpressurization syndrome and the air embolism. That's the injuries that occur with that gas thing. The other thing that happens, though, is certain gases, when there's more pressure on them, have a higher what's called partial pressure. It's akin to concentration, not quite right, but it's akin to this, like there's more particles there. And with more pressure, it's going to go from the gas form into the liquid form. So it's going to get shoved over into the liquid form. That means that nitrogen, that's normally we're breathing right now, there's kind of more particles of it as I get more compression, and more of it gets shoved into my liquid, which is my bloodstream and my tissues. That means that the illnesses that come with that are nitrogen narcosis at depth and the bends, decompression sickness, as I come out. So let's get into details on how these things work. Those are the laws of physics, and you can absolutely logically figure those out. That is not, it's not any major degree in physics here. Certain people should not scuba dive. If you have panic attacks, it's not good to be 60 feet under the water and have a panic attack. If you have asthma, or God forbid you have big blebs in your lungs, you don't want to be down underwater and having your pressures change in your lungs. You don't want to. Everybody here knows, who scuba dives, knows that if you have a cold, if you have a significant cold, you should not be scuba diving. We all do it anyway. A little Afrin spray, a bunch of decongestants, whatever, but you shouldn't, because of all the passages that are air-filled or blocked and you can't equalize pressures, pretty bad things can happen to you. So certain people just shouldn't go under, and even healthy people who are usually able to dive, there's certain times where you shouldn't. If we start to go down, so I'm at the surface, we have on all of our gear, we've got our BC on, and we're doing our thing, and we've got your weight belt on. Disorders of descent. So as I start to go down, all that pressure again is on my body more. So I'm starting to go down. The things that can happen on my way down mainly are pressure problems. So if I don't equalize my pressure, so if we go back and we look at that scuba diver, what you'll notice is that scuba diver is basically pinching their nose. And what they're doing is equalizing the pressures in their ears as they go down. You take the elevator here up to the 24th floor, you're going to feel your ears pop. You got on a plane, you have this happen. The baby that's screaming in the back of the airplane is the baby that has the cold and can't equalize the pressures in their ears. That's what's happening to you when you dive. You have to equalize the pressures in your ears. So these are called squeeze syndromes. My gas-filled spaces are getting smaller. For my lungs, that's not a big deal. I'm breathing, I can equalize that just fine. It tends to happen more in things like my face mask or my ears, and I need to equalize those pressures as I go down. As things get smaller, I need to add more air to things. It can happen inside your face mask. If you've ever even just done free diving, you have your face mask on tightly, you dive down, that amount of gas gets smashed, gets smaller, so your face really sticks, your face mask sticks hard to your face. You blow a little air from your nose into your mask and it equalizes it out. So those are called squeeze syndromes, and there's lots of them. Any gas-filled space gets smaller and can cause a squeeze problem as you go down. The reason it's a potential danger if you go down with a cold in particular, where you can't equalize your nose, using your nose pressures, you can rupture things that affect giving you vertigo. So you can basically end up with TM rupture, and you can end, especially if you're in cold water, get severe vertigo. And having vertigo and vomiting, 40 feet under the water, is kind of a nasty thing to have. You can have barotrauma anywhere there's a gas-filled space, so know that there's lots of versions of this. And again, this is all gases getting smaller because I'm going under more pressure under the water. Now, let's say I'm down there at 60 feet and I see a shark and I freak out, or I have my panic disorder and I freak out, or I drop my weight belt and I go shooting to the surface. If I close my glottis on the way up, my lungs become that same thing as that pre-packaged salad that was at sea level that's now like a beach ball. They expand. And one of two things can happen when my lungs get huge quickly. I can either drop a lung, I can basically get overpressurization syndrome. I can drop a lung, I can get pneumomediastinum, pneumothorax, or if it's worse, I can end up with air gas embolism. I not only pop my lung, I shove a big bolus of gas into my bloodstream. This is sudden and dramatic and not infrequently lethal. What these people will come, they'll basically come to the surface. They often are comatose or seizures, and it's abrupt. This isn't something that takes a while to happen. This is, I've popped something, and by the time I get to the surface, I've had an embolic phenomenon, and they're often seizing or comatose or dead. Okay, so this is basically an expanding my lungs too quickly deal. Down at depth, you can have something happen called nitrogen narcosis. Now remember, I have pressure on my system, so the sort of partial pressure of that gas, nitrogen, is more, and it likes to be in liquid form because it's kind of shoved over into liquid form when I'm at depth. And if I stay down there too long, I end up with too much nitrogen in my system, and it makes me crazy. It's called nitrogen narcosis. It makes me make mistakes. It makes me confused, and eventually it makes me sleepy. And it is not infrequently a cause of death at depth, where somebody basically is down, and that's why you have your dive tables. You know, if you're down X number of feet for X amount of time, you need to basically get out of there, get out of Dodge. You have too much nitrogen in your system. And any of you who've taken a dive medicine certification, you've actually been put in a chamber and often given nitrogen narcosis. They basically put you under pressure, and they'll have you bring in card games. Or you can YouTube this, YouTube nitrogen narcosis chamber, and what you'll see people playing cards and making mistakes, or doing crossword puzzles and making silly stuff, unable to walk, completely gibberish coming out of their mouth, and eventually coma. They basically just go out. That's called nitrogen narcosis. And it's very important not to get that at depth, because then you start doing stupid stuff, like taking off your belt and going to the surface and having another problem. Decompression sickness is, now I've been down there a while, I have had some of that nitrogen get into my system because it happens no matter what. Okay, I've been down there long enough that there's some nitrogen in my system. I need to let that percolate out of my system slowly. So your dive tables will show you. You come up to a certain depth and you hang out for a while because I have less pressure on me, so it gets out of my blood into my lungs, and from my lungs I can breathe it out. If I come too quickly to the surface, it's like, shit, I got a plane to catch, I gotta go, I gotta run, darn, I knew I shouldn't have done this last dive, but I did it, and I gotta go. And you skip a couple stops. What you end up doing is trapping nitrogen in your body. It doesn't get it. It's like putting bubbles in a champagne bottle. You trap the bubbles in the liquid form. You get them trapped in there. So they're trapped in my body. This is, again, a disorder of ascent. Now, what happens with this is it's gradual in onset. It's not an embolism. It's just trapped little tiny nitrogen bubbles all over the place. So, and a lot of this is factored on how deep you are, how long you were there, and did you come out correctly. It's two types of decompression sickness. One is the type 1 decompression sickness. This is the bends. This is what you've heard about with the bends. And this is called Caisson's disease. There's a great book by David McCullough, who writes these big, gigantic books, usually biographies. But he wrote a book called The Great Bridge. It's about the building of the Brooklyn Bridge. It's awesome. It's a fantastic book. But he talks about the caissons that they had to build under the river to be able to sink down the sort of the bottom of the building of the bridge. And so what these guys would do is they'd go into these caissons and work all day, but under the pressure of the water above them. They were in a box, but the water pressure was still on the box than on them. And they would come out and they would go home. And once they got home, they would get these terrible aches and pains in their shoulders and pains in their hips, and they would just feel really, really awful. That is Caisson's disease. That is type 1 musculoskeletal and lymphatic decompression sickness. You can end up with a marbling of your skin called cutis marmorata. That's a buttock cheek, by the way. If you're not sure what anatomy that is, that's somebody's butt. But basically, it gets this modeling of the skin. And again, it's nitrogen trapped in those parts of your body. That's decompression sickness type 1. It doesn't kill you, it makes you miserable. What can kill you is decompression sickness type 2. This is where it's not just trapped in my body, it's trapped in my central nervous system, or it's trapped in my peripheral nervous system. And if you think about it, it makes sense how people will present. First of all, these bubbles are not one big huge one. They're a bunch of gajillion little ones everywhere. And so your neurologic symptoms are going to be variable. It comes on slowly, right? Does not immediate. This is where it happens to sort of settle itself out. And I may end up with my right foot numb, my right cheek numb, a little bit of trouble speaking, and my left arm is weak. That is type 2 decompression sickness. And that can come on as late as 2 weeks after somebody's been down under for a while. So this has nitrogen in their system. Either type of decompression sickness is treated, there's a couple of versions, with, I'm going to skip this, with hyperbaric. We'll talk about that in a second. This summary slide right here, if they give you a question that says a person is at the surface of, a diver comes to the surface and is found comatose and seizing. That's a disorder of ascent. That's probably somebody with arterial gas embolism. You can actually look at this and kind of put together ascent, descent, and at sort of depth. Hyperbaric chamber is going. If they write a question, on this. And in the list of answers is hyperbaric, your recompression therapy or hyperbaric. Just check it. It's really the thing that they're going to want you to bite the bullet and say. It is the definitive treatment for any decompression sickness. And this can be as long as 2 weeks after you've come out and had your decompression sickness. As long as 2 weeks later, you can have this. It is the treatment of choice for somebody who has arterial gas embolism with, of course, resuscitation. So this is something that it's going to be the answer to any of the critical sort of scuba-related injuries or illnesses they may present to you on an exam, and it actually is also in real life. There's a compression chamber near where I live, out in Catalina, and we always, every summer, we have people die of scuba things right off the coast where I live, every single summer. We see the helicopter go by, we always know what's happening. There's always somebody out there that has this happen. Now, the other thing to know is those of you who dive know that you're not supposed to dive that last day before you go home. The reason for that is that you can still do everything right, but if you've been diving a couple of days and there's some nitrogen still in your system that just takes a while to bubble its way out. Slow, it's just a little tiny bit, but there's some. What happens when you fly is now, I get out, I did 2 dives that last day. I know I shouldn't, but it'll be okay. And now I get on an airplane. An airplane basically goes to an altitude of about Denver. So even though it's at 37,000 feet, it's compressed, it has pressurization that's about 5,000 to 7,000 feet of elevation of pressure. Now I've taken my sea level body that's been scuba diving, and I've taken it to Denver in 3 minutes, 5 minutes from takeoff. Okay, I've gotten myself up to that. So what I've done now is given myself another reason to get decompression sickness. So you can precipitate decompression sickness, even in somebody who wouldn't get it if you stayed at sea level, by flying. So there's reasons that they don't want you to fly. And again, that's the reason. It's the nitrogen issue. One last thing about this. These pressure things that we talked about, this Boyle's law of sort of pressure expanding and contracting depending on, gas expanding or contracting depending on pressure. Blast injuries are basically a super fast version of that. So a blast injury basically takes a huge pressure wave against you fast. So all of the gas-filled structures in your body get compressed and then kind of back to normal. So it makes or expanded and back to normal. It makes total sense what gets injured if you're near a blast. It's all those gas-filled structures. So eardrums go almost every time. Your guts can go, air in there, and your lungs can go. So the same Boyle's law, the same expansion-contraction of gas-filled spaces, it's the same idea of pressure, it's just the pressure wave is super fast. So blast injuries are a similar version of that. Okay, let's go to altitude. If we're going to fly to 5,000 feet, let's just bag it and let's go to altitude. Let's go climb. So there are a bunch of Harbor grads here, so thank you. Hi guys, it's good to see you. They know that I've had a long distance relationship with my husband. I did for the first 10 years of our relationship, and he lived in Colorado. We live together now, thank God. But he lived in Colorado, and I lived in California. And he lived up in Summit County, Colorado, at 9,000 to 10,000 feet, and I lived at sea level. And we would fly back and forth to see each other. He gave me this hat because every time I would go there, I was in really great shape when we met. And every time I would go there, I could not breathe. I would get short of breath just walking 10 feet. There's no oxygen at altitude. It is true, there is a problem at altitude. And if you're used to being at sea level and you go to altitude, there's an issue. What happens is that there isn't the same amount of oxygen that you breathe up there. There just isn't. So part of the problem with that is your body freaks out, especially if you go there quickly, and it gets very hypersympathetic. So you get tachycardic because it's trying to circulate this blood that doesn't have as much oxygen as what you're used to in there. And you get basically some leaking of fluids that can happen with that. You get sympathetic activity can happen with that, and it can cause some serious trouble, serious trouble. The range of things it can do range from the sort of the minor syndrome of acute mountain sickness, and anybody who's gone to altitude, I'm willing to bet virtually everybody in this room who's ever been at altitude has had a version of acute mountain sickness to one degree or another. You felt your heart pound. I went to Peru. I was up in Peru doing the Machu Picchu thing. I remember sleeping, feeling my heart just pounding. That was the tachycardia that goes with basically being hypoxic at altitude. You feel queasy, nauseated. That's acute mountain sickness. But there are lethal things that can happen to you at altitude. Last summer, the number of people that died on Everest was unbelievable. Absolutely. They were literally, it looked like the Black Friday sale at Target. You know, the line of people going up that mountain, it was insane. They were crawling over bodies to get up that mountain. They will kill you at altitude if you're not careful. Pulmonary edema will do it, cerebral edema will do it. The kind of more entertaining things that can happen at altitude, like high altitude flatulence expulsion. Choose your tent mate carefully and be careful what they eat before you go to altitude, because remember, gas-filled spaces get bigger, so flatulence expulsion could definitely happen. Whether you get sick or not at altitude depends on several things. It depends on how quickly you go there. So if you're flying from sea level to going to 10,000 feet in 2.5 hours, that's not any time to acclimatize. But those of you who do high climbing know that where you sleep and how high you go makes a big difference. So people who climb will climb and then come back sort of 1,000 feet and then climb back 500 feet. They'll sleep at a lower level to give your body some time to basically acclimatize. A couple things about this too. If you've ever had an altitude illness of some sort, odds are you're going to get it again. So it's something that basically is something that you are prone to. So if you had it before, you'll get it again. Certain people should never go to altitude. If you have any sort of right to left shunting of your heart, you have a septal defect of some sort, you're a little bit of Eisenmenger's, you're basically in trouble, that person should never go to altitude, ever. And it turns out being a jock doesn't protect you. You can be the biggest marathon runner ever at sea level, and it won't protect you from getting acute mountain sickness. You can still get sick up at altitude. It turns out that women over 50 have a lower incidence, so maybe that's why I didn't have too much trouble. Okay, acute mountain sickness. This is that you go up to ski. It's like, yeah, dude, we're doing our ski vacation. So cool. Get off the airplane. We go to Aspen. We're sitting there having our drinks, and I'm just not feeling so great. I got a headache. I'm some nausea. A lot of us know this happens. So you can prevent that with basically using acetazolamide. It turns out acetazolamide, we're not exactly sure how it works. It causes a respiratory alkalosis, so it causes you to basically blow off CO2. It causes a respiratory alkalosis. We're not exactly sure why it minimizes or even prevents completely acute mountain sickness. Now, a couple things about it. You shouldn't use it in people who have sulfur allergies because it has a sulfur moiety. Whether it really causes allergies, not clear, but it's not worth it. Worth taking the risk. And if you do take it, any of you who've taken this know, it makes your fingertips tingle. It makes around your lips tingle because you have a respiratory alkalosis. It's like what you did when you were a kid on the playground and hyperventilated. It's basically doing that. And it makes carbonated beverages taste disgusting. Just gotta let you know. Like, go for the hot toddy rather than the beer because it makes stuff taste gross. So the best treatment to prevent is acetazolamide. If you get this particular problem, first of all, don't drink and hydrate. Drinking makes it worse. And then things like oxygen can sometimes help. Steroids maybe, but oxygen can't. What's worse, though, is say you're with your buddy and you're skiing, and that first night your buddy has pretty bad acute mountain sickness, has tachycardia, nausea, just feels gross. And then the next morning, as you're walking across the parking lot, hauling all your gear, your buddy is really short of breath. Granted, you're at altitude, there's less oxygen, whatever, but wow, your buddy is short of breath. And you listen, and he sounds really rattly, and you go to the hospital, and there's rales everywhere. It turns out high-altitude pulmonary edema is the biggest killer at altitude. You drown, basically. You leak into your lungs. It's a non-cardiogenic pulmonary edema. Your heart size is normal. It's that X-ray. You have a normal heart size, but you look for all the world to be in raging pulmonary edema. These people usually have had acute mountain sickness beforehand, but may not, usually do. And this is somebody basically, if you can't, here's a picture, by the way, all the things that can cause non-cardiogenic pulmonary edema. Here's a list for you, just for interest's sake. But if you're at altitude and you've got somebody who has this, what you need to do is give them oxygen right away. And if they don't reverse quickly, you get them off the mountain. They're supposed to basically be, and what's interesting is you don't have to take them all the way down. You just have to get them down altitude-wise, a ways, 1,000 feet, 1,500 feet, and then it may just go away on its own. It doesn't respond to anything else, though, like oxygen's the key. Diuretics aren't something, it doesn't work. It's not a fluid overload problem. It's basically a leak issue. You've got to get them off the mountain. So if it's an ABEM question on somebody who has RALs and that chest X-ray at altitude, the answer is going to be, if you can't oxygenate, get them down off the mountain. Get them down. The other thing that kills you up there is now, instead of your buddy having shortness of breath, your buddy can't walk straight. Your buddy is really ataxic. You're walking around, has a terrible headache, some nausea, vomiting, may even have a seizure. That's high altitude cerebral edema, and it's the real deal. It is honest to God cerebral edema. So they have a swollen brain, they have all the things that go with that, and the definitive treatment for this is descent. Get them down. Now, there are tweeners that can happen. So what I need to do is get more pressure on that person, right? I need them to get more oxygen and more pressure. So if I could actually compress them a little bit, I may be able to make them better. So this thing in this picture is called a gammo bag. It looks like a big Oscar Mayer wiener, basically. It looks like, and what you do is you put the person in it, and it has a pump, an external pump. Some are electric and some are just done with your foot, that pumps this enclosed thing to a higher pressure, as if they were down at a lower altitude. And that basically is one way to try to fix it if you have a temporizing measure, but for the real deal thing is you get them down. You got to take them off the mountain. All right, if you're up there skiing and you get lost, you may end up with accidental hypothermia. Now, we know that your body's temperature is basically, you control it by four major mechanisms, and they're basically radiation, conduction, convection, and evaporation. A little bit with your lungs, but those are the big four. So if you're out in the cold and you're bundled up, you can be okay. But if you're out in the cold and you're not, or if you're out in the cold and you're wet, those things will contribute to whether you actually get hypothermic. So you can be out in the cold and bundled up just fine, and you won't have any trouble at all. It just depends on how much of you is in contact and whether it's cold, wet and not, that sort of thing. Now, the definitions of this, there's mild, moderate, and severe. There's actually even one that's worse than severe. But basically, it depends on how cold you get. And as you go down in your temperature, at first, you're going to know I'm cold, and you maybe just get out of the cold. But you'll eventually start to shiver, and the shivering is a way to generate heat. If you get too cold, though, you stop shivering, and you become altered, and eventually you just die. So these stages of hypothermia, we can intervene at virtually any of them for the most part, but these stages of hypothermia are important to understand, and you lose that sort of shivering thing that's so important. We know who the risk factors here again are: testosterone and alcohol, extremes of age. Okay, but old people and young people, babies and older people, they're the risk for this. There are a couple principles that are kind of interesting to know before you figure out how to treat somebody. So one is this idea of paradoxical core afterdrop. And this concept is, if I warm you, you have 5 liters of cold blood in your system, of 28-degree blood in your system. And if I warm, say, your extremities, it's going to take a while to get all that blood warmer, and I'm going to shove the blood to the center that's cold. This turns out to probably be clinically irrelevant. It's a lovely thing to talk about. It's probably clinically irrelevant. But what isn't clinically irrelevant is cold-induced diuresis. And any of you who go out and camp in the cold, so you love the snow camping, you're out and you camp in the cold, you know that you pee more. You're getting up in the middle of the night once or twice to pee because your body, your nephrons, basically, I'm not exactly sure the mechanism of this, of logically, and teleologically it makes no sense why it would be something your body does. But especially if your hands are cold, and any hunter in this room knows you need to keep your hands warm if you're out in the cold, because you end up with this diuresis thing. So if you're taking care of someone who is brought in cold from the outside, you're taking care of somebody with basically accidental hypothermia, assume, especially if they've been out there for a while, that they're going to be dehydrated, that they're going to be hypovolemic because of this diuresis that tends to happen in everybody. What you're going to do is, and there's certain things that also change when you're cold. So you don't metabolize things well when you're cold. So, and I know that your volume is low. So I'm going to give you some volume resuscitation, but I'm not going to, on purpose, choose normal saline. Because using all these fancy balanced, lactated ringers, whatever, you can't metabolize it very well because I'm cold. So that, I'm going to go ahead and stick with normal saline. I know you're coagulopathic. That's why we keep trauma patients warm. I know you're coagulopathic. I'm going to be aware of that. I know that you can't use glucose very well, so I'm going to watch your glucose level. I'm going to kind of keep it up, but I know you don't use it well. I know you won't shiver. I know that you don't use oxygen well. Just a lot of bad things happen when your body is cold. So here's the list of sort of what can happen, but as they get sicker, the altered mental status is a problem. Volume loss is key. And your EKG changes in a way that item writers adore. So I'm going to give you a question. I'm an ABEM item writer. I'm going to say, the nurse comes to you, you're taking care of a patient with altered mental status. The nurse hands you the following EKG. Which of the following are you going to do? The nurse hands you this EKG. Which of the following are you going to do? Are you going to give procainamide? Are you going to give adenosine? Are you going to give atropine? Are you going to check a core temperature? What are you going to do? And the answer to that is you're going to check a core temperature, because that's the Osborne J wave. This is something that you see with hypothermia, and I've seen cases of this, and those of you who work in the cold, you can see this. It is something that the ABEM item writers absolutely adore. So of the few things that you need to study to cram in from this chapter, please just make sure you know what the Osborne J wave looks like so you don't get surprised if they hand you that on the test. Now, they will not ask you on this test, I absolutely guarantee. They will not ask you what to do about how to resuscitate somebody who's in cardiac arrest who's cold, because there is not an agreement out there on what's the best way to do it. American College of Cardiology has their idea, the people that are in the wilderness medicine group kind of thing have their idea. Just a couple things that are principles. If someone is cold, you're not going to consider them pulseless unless you take the pulse for 1 solid minute. Any pulse you feel counts. So if you have somebody and they have just 2 beats a minute, that is a pulse. That is done. Okay, that you consider that not a full cardiac arrest. Okay, that is somebody that, and you're going to resuscitate anybody who has any sign of life, period. Your main thing you're going to do is warm. What you do about CPR is very controversial. What you do about giving drugs is very controversial because the drugs don't work very well. Even our resuscitation drugs that we're used to using don't work very well. And the heart doesn't like being cold. It's irritable. So they may have those 2 beats a minute and you start CPR and it shuts the heart down. The heart doesn't like it, so it shuts the heart down. So treating dysrhythmias is controversial. The key really is you're going to warm that person up. And again, all the questions, in real life, it's controversial enough. So they will not ask this on an exam. I absolutely guarantee it. But they may ask you how to rewarm somebody. There are various ways of doing this, and how sick they are will depend on how aggressive they are. If it's truly somebody who is a pulse of 2 or truly cardiac arrest who is hypothermic, that person is the kind of person they're going to want you to do something like ECMO. They're going to want you actually to do something like put them on a machine that will warm their blood if they're in cardiac arrest. Anything short of that, though, somebody who's shivering, somebody who's cold but otherwise alert. You can do anything from a bear hugger, which are so fun. I like bear huggers on night shifts when I'm cold, because I'm always cold at 5 in the morning. So I go just wrap myself in a bear hugger. But make sure their wet clothes are off, make sure that their skin is dry, and then put them in a bear hugger. You can use hot water bottles. You can have them breathe warm humidified oxygen. That works fine. This core after drop probably isn't important. And if you need to, you may need to put them on something like ECMO. So dialysis, ECMO, etc. So the other thing is, we all know that when you die, you get cold, right? You're dead. And eventually your core temperature drops because you're dead. And we were always all told as well that you're not really dead until you're warm and dead, except sometimes you're cold and dead. So how do we figure out who's cold and dead? If you have a circumstance, there are 2 times. If you have a circumstance where somebody particularly is like an avalanche victim, and when they're pulled out of the pile of snow, if their airway is packed with snow, that person is dead. They're cold, but they're dead. Because they probably died of the asphyxiation first, not a hypothermic kind of death. The other person who's cold and dead is somebody whose initial potassium is 12 or greater. If the initial potassium is 12, it suggests that they were dead and then cold, rather than cold and then dead. So those are the 2 times where you absolutely don't even have to resuscitate. It's considered they're truly cold and dead. That's all there is to it. They're gone. Now, out of the cold, that's the extreme things, but you can get frostbite. And if you, so I live in Southern California. Have I ever seen frostbite? No. But if you understand thermal burns, you understand frostbite. It's the exact same idea from cold instead of heat. Instead of being thermal, it's from cold. And it goes in the same kind of degrees of damage from cold than it is from heat. Same thing. So frostbite is truly, I've frozen tissue. Frost nip is I've basically frozen it a little bit, but it's reversible still. It's not damaged permanently. First degree is superficial, like a superficial burn. So the superficial surface of the skin has been frozen. And as it gets deeper, it just has increasing first, second, third degree. 4th degree is basically the frozen chicken leg in your freezer that you forgot about. It's all the way down to bone. The reason that's important is depending how far down it goes, different structures of the skin get damaged. So if I get a blister from frostbite, and it's clear, the fluid inside is clear, I've only damaged down above the blood vessels. I haven't gotten down to freezing my skin down to the blood vessel level. If it's bloody in that blister, though, I've frozen it down to the skin appendages that include the blood vessels. So now that's a deeper burn. That's a deeper, basically frostbite. It's a deeper damage done. Clear blebs are a more superficial frostbite. Bloody blebs are deeper. The things that are in red on this slide, they will not ask, because this changes all the time as far as what we should be doing with blisters, either in thermal burns or in these. Clear blisters theoretically should be debrided. Bloody blisters are meant to be kept intact. I think, honestly, the goal is not to touch Anybody whose skin is frozen, just don't touch it. Warm it, definitely warm it, and get it warm as quickly as you can. 40-degree water baths, get that thing warm as quickly as you can. What you're not going to do is cut off anything, because the body will do its own thing. It will basically cause a line of demarcation. And if you read the book Into Thin Air by John Krakauer, amazing, amazing, amazing story, phenomenal story of the climb in Everest. There are pictures in very tragic, horrible. But there are pictures in there of other people that survived and what they looked like with their initial frostbite and then what they actually lost. Guy lost the tip of his nose, both of his ears, tips of fingers, but it wasn't anywhere near as much as what it looked like the damage was done on the initial end. So frostbite in January, amputate in July, just let it sort of demarcate itself, and it will. Now, you can have cold injuries that aren't even frostbite. They're non-freezing injuries. This is trench foot, immersion foot. And if you read the book All Quiet on the Western Front, it's a wonderful novel, very classic novel, but they describe what it's like to have trench foot, to be standing in these slushy pits of, where were doing all of their fighting. They were down in all the, what are those dug things out? I can't remember the word for now, but anyway, they're standing in slushy water. And their feet don't ever get frozen, but it's literally standing in slushy water all day long. And what it does is it damages or kills your skin appendages, which are sweat glands and nerve endings. So what you end up with, and these people would end up with, is once they get back, first of all, it's incredibly painful. And you know that, right? You've been out in the cold sometimes, and just standing in the shower hurts, and you didn't get frost nip at all, or trench foot at all. So that it's very, very painful, and it damages those skin appendages. So these people end up with hyperhidrosis of their feet. They end up with chronic burning, pain in their feet. It's a problem. This is trench foot. Chilblains are basically skin glandular issues or inflammatory skin lesions that are super itchy that happen, especially in people that are out in sort of non-freezing but really cold temperatures over and over again, often when they're wet. So it tends to be things like legs you see this most commonly on. These are chilblains. It can be ears, it can be feet, and they're just itchy, and the treatment for this is to rewarm, and sometimes you need things like steroids and nifedipine. Let's flip to what's happening outside. So if you took a little stroll today, it's 107 degrees outside today. Heat illness, and if you believe in global warming, whether you do or not, the reality is that we had the hottest year on record in North America last year, the hottest year on record. So heat illness is something that we are definitely seeing. Heat illness, there's a whole bunch of risk factors for heat illness, and there have been tragic stories. I don't know what is with all the news agencies having this need to put the most tragic story from wherever in the country as one of their lead stories on their news feed. Twins die in an enclosed car in Florida was one of the ones recently. 1-year-old twins die in a car. Do I need to know this tragic story? I don't think so. But we know that that's the risk group that happens. So kids in cars. It's why you don't want to leave your dog in a car. It is totally legal to break someone in California. It is totally legal to break the window of somebody's car if they have a pet inside and it's hot outside. You are totally allowed to do that to save the animal. Same thing with a person in there. So we know certain people are at risk for this. The elderly that are in their unventilated apartment in Chicago when it's a bajillion degrees outside. So older people, babies get this. People with certain drugs on board. You heard about anticholinergics, right? You don't sweat. Billy just told you that. So those people are at risk for getting heat illness. People who exert themselves are at risk for getting heat illness. People on diuretics. There's a whole group of people at risk for getting heat illness. And it ranges from, just like altitude illness has a big range, so does heat illness. One end of this spectrum is if you were to go out and take a walk right now out there and take a sort of a brisk, lovely walk, you would feel really hot and uncomfortable in about 30 feet. That's heat stress. Your body's saying, dude, get out of here. Get back in the cold. Are you nuts? Get back into air conditioning. It gets worse from that when you get into things like heat exhaustion, which is now your body is not coping very well. You're not super sick yet, but you are on your way, unless something gets fixed, to true heat stroke, which is you have crossed the threshold and you cannot manage the amount of heat you're either generating yourself or exposed to out there in the environment. This table puts them into sort of ranges of category. So the minor heat illnesses are things like heat stress, I'm hot, I need to go inside. Heat cramps that happen usually after you've been working out in the heat. It's usually your thigh muscles or whatever big muscles you've been using. You get cramps afterwards. It's probably just a fluid and electrolyte issue. Heat edema, where you go take your honeymoon and you're in Hawaii, it's lovely, but it's a little warm outside and your ankles are swollen and your ring is super tight because you have heat edema. That goes away by itself, by the way. No, nothing. That just goes away by itself. Heat syncope is the graduation stuff, right? Everybody's out at graduation, watching junior graduate from high school or college or whatever, and goes down. That's probably a pooling problem from heat. And prickly heat is the same idea as chilblains, but from hot. So it's blocked sweat glands, it's itchy, it's called prickly heat. Moderate heat illness is that heat exhaustion, and that's basically the summer flu. So heat exhaustion is somebody who's there working out in their yard and it's hot outside and they haven't had quite enough liquid and they start to feel kind of queasy and they have a cold sweat and they might even have kind of diarrhea. They just feel kind of gross. That's a water depletion and or salt depletion issue, and that's something you can fix by bringing somebody inside, cooling them down, giving them some liquids. But if they persist in their gardening and ignore those symptoms, they can tip over where they now are absorbing or producing too much heat. Their temperature goes way over 40 degrees or higher, and now they're altered. Becoming altered is a big deal when people have heat illness. That's a huge problem. So heat stroke can happen two ways. I mentioned you're either producing too much heat or you're exposed to too much heat or both. So heat stroke, when I learned about heat stroke a bajillion years ago, I was taught that heat stroke was the elderly person in their stuffy apartment in Chicago when it's 110 degrees outside. So this is classic heat stroke, the person who doesn't get enough water, who basically comes in dry, altered, and hot. Okay, that's the classic. However, I could make every single one of you in this room develop heat stroke today in this room by having you overexert yourself. You could basically end up producing much more heat than your body can sweat away or radiate away, conduct away, and you will get heat stroke that's exertional heat stroke. Exertional heat stroke tends to happen in two categories of people. One is people in the military, and the other is athletes, particularly athletes who are training in the summer. So any of you who are coaches for your high school football team know that that is a risk. In fact, they don't let, in Southern California, in an area of Southern California, they won't let them do football training for the kids in the heat of the day, in the middle of the day. They just won't let them. It's too hot in the area where they do this because exertional heat stroke is an absolutely real deal. If you compare the two, the classic sort of little old lady in her apartment comes in dry, altered, and hot. That person tends to die more often, mainly because they have other illnesses going on. They have underlying things. So those people are dry. They rarely have their kidneys go. They don't get rhabdo. They just have all of their end organs kind of crap out because they're hot and they're older and they have underlying problems. The exertional person, what happens when you're hot is there's certain organs in your body that don't really like being hot. In particular, your endothelium doesn't like it. Your liver doesn't like it. So an exertional heat stroke person has a super hot blood pumping through their body, and they damage their endothelium, and they go into DIC. So the athlete, the football player, or the military guy who's got this 60-pound pack on down in 29 Palms who's hiking around outside, what they end up with is DIC, and they end up with rhabdo. They also tend to go into ATN. So that group gets some specific end organ problems that happen because of their exertional, and they're often sweaty. So if you use dry skin as what's going to make you call it heat stroke or not, you're going to make a mistake if they have to be dry. You can have sweaty skin and absolutely have heat stroke. The features of heat stroke is what you've done is you've overwhelmed your thermoregulatory system. You just aren't able to lose the heat that you have. Altered mental status is the sine qua non. It's basically the thing that calls it heat stroke. And the end organs, again, that don't like it are your endothelium and your liver. And it turns out that LFT bumps at presentation. So if somebody comes in with heat stroke and you basically get LFTs on them as part of their initial labs, if their LFTs are bumped, it's a prognosticator. It basically says, ooh, they've been hot long enough that they've cooked their liver. Okay, that turns out to be a prognosticator. And again, DIC happens. They are tachycardic, all the things that you would expect. They're hyperventilating, they have all the sort of end organ things that you'd expect from somebody who's cooking inside. So your job is to say, okay, I've got somebody really sick here and really altered, but while I resuscitate, I am going to make them cold as quickly as I possibly can. The fastest way to do that in an ER is evaporative cooling. So what you're going to want to do is strip them naked, either take a sheet or some towels and get them damp, drape them on the person, and then get a fan and blow the fan across the person. Evaporative cooling. It actually bring them down to 0.2 degrees centigrade per minute. It can be very, very effective. The only problem with that, I challenge you to go back to your hospital and find a fan. I am not kidding. Turns out the Lovely Joint Commission, one of Billy's favorite things in the world, the Lovely Joint Commission has decided that fans blow cooties around, so we can't have fans in our hospitals. So we had a heat stroke patient years ago at Harvard it was the middle of summer. It was obvious raging heat stroke. And we sent the medical student across to CVS to go buy a fan. It's like, just go here's some money. Just go buy a fan. Well, it was the middle of summer. It was very hot. And the only fan left that the poor guy came toddling back with was one of those little bubby fans that you like do this kind of thing. So obviously that wasn't going to work. But guess where we found a fan? You all have them in your hospital. Go to, actually maintenance isn't, it's actually housekeeping. So you know when you come into your night shift and you hear that at the end of the hall, it sounds like a 747 at the end of the hall when they're waxing the floors and they want to dry the floors? They have these gigantic metal fans. So get that. And we did. We got it. We put it over on the table over there. We're blowing across the page. We're so proud of ourselves, except if you do that, anchor everything down. All the 4x4s and everything, it looked like a snowstorm. It looked like a snow globe in there. Everything was kind of flowing around in there, but it worked. So evaporative cooling is the way to go if you possibly can. You can try ice various places. You can try things like lavages. You can try putting them on something like a bypass machine. But the reality is evaporation, if you do it right, is the way to go. Absolutely the way to go. So fans and spraying, try the ice packs, etc. If they shiver, you don't want them to shiver, so you can use something like chlorpromazine to stop that. You don't want them to shiver. But the reality is you've got to get them cool. That's your absolutely first and foremost thing to do. So I'm going to tell you a story that's going to help you understand what happens with heat stroke. Because the other thing with heat stroke is if you bring somebody's temperature down fast, that altered mental status improves. It actually helps you determine, is this hot altered person heat stroke, or is it a toxic thing? Is it like serotonin syndrome, or is it neuroleptic malignant syndrome, or is it meningitis, or is it something, there's a lot of things that can cause somebody to be hot and altered. Is it thyroid storm? If I get them colder and their mental status is better, that almost clinches the diagnosis of heat stroke. So years ago, I took care of a guy in San Francisco who was basically this Taekwondo black belt, 6'4" muscle mass of person, who had decided that he was dating a little tiny marathon runner person. She was adorable. And so he decided 3 weeks before the marathon that he was going to run the marathon with her. Didn't train at all. But he was Taekwondo, mind over everything. And God bless him, he finished. 26.2 miles, crossed the finish line, and went crazy. He basically was violent and whacked and altered and just agitated, crazy. And we get a call that there's like 6 people holding this guy down in the back of the ambulance. They're on their way. It's like, whoa, okay. Rolled in, crazy. He's so strong. And he was drenched in sweat, and he was so hot to touch. It was unbelievable. We drew his blood, and it steamed up the tubes. It was crazy hot, so hot. So we cooled him, aggressively cooled him, and finally and literally as his temp came down, he was about 39 degrees when we finally got him to, he was normal. His mental status got better. He's a super nice guy. His girlfriend came in. They were chatting at the bedside. They really wanted to see each other. And in the ER, he proposed. So there's all the ohs, and all the men in the room said, he's still altered. I'm going to break here and have Billy come up and do his second part of talks, and then I'll come back and do the rest. Thanks.
All right, we're in the home stretch on talks. I know it doesn't seem like it because we're in the early part of the alphabet, but it'll go. Feel free to get up and get another cookie or some more coffee, and we'll forge ahead. Those cookies are actually pretty good, the chocolate. There's not that many left, but the chocolate chips are good. All right, we were starting with carbon monoxide, and my first point was it's a common way to successfully commit suicide. But you'll see accidental exposures come in. It's the old story, it looks like the flu, and it's easily to miss, and indeed that's the case. The most recent one of these I saw at Stony Brook was a girl who came in with a headache, no history of migraines, and the resident went in and talked to her, and we were having the should we scan her kind of conversation, and those kinds of things, and I went in to see her and talk to her. And oftentimes this is the case, when you just get to a little more free-flowing conversation, less directed. I'd asked if anything happened at the house, anything unusual, and that was when she chose to mention that the smoke alarm had gone off that morning. I was like, oh, that could be important. Thank you with the alarm sound effects. I appreciate that. And indeed, she had a carbon monoxide level that was elevated, and she hadn't been aware of there being a problem. It was a rental property, and they had to find out that the furnace was bad and things like that. You may get these stories of someone using a hibachi in the house because it rained or things like that. And then the old classic tox question is, is your dog sick? Because if they have a pet and the pet is sick, we get different viral illnesses. So it's not like if you have the flu, they have the flu. If you're both sick, you and your dog, it's carbon monoxide. There are a couple of those weird tox questions that you ask about their pets. Did your bird die? That's like the Teflon pan left on the, that apparently kills birds in a second. But anyway, so with carbon monoxide, altered mental status, you want to do an EKG and look for EKG changes because they may not complain of chest pain, but the high oxygen consumption organs are going to be involved, so that's brain and heart, and so you want to look for that. And remember, there are multiple levels of toxicity. It's not just the carbon monoxide binding up the hemoglobin, there's also the carbon monoxide effects intracellularly, and there's direct myopathic effects, so they get cardiogenic shock because they have a combination of hypoxia with direct myopathic effects of carbon monoxide as well. Remember the difference quickly, we'll talk about cyanide more, but between carbon monoxide and cyanide. Carbon monoxide's gradual onset of symptoms, headache and such, whereas immediate collapse on the scene of a fire where they suddenly go down, that's cyanide. That's not carbon monoxide. And so that's a different thing. Here we have these half-lives listed on this slide. It is a fair game question. I've seen it asked, and it shows why you put them on, it's 5-hour half-life on room air, 1.5 on 100% O2. So remember, they go on 100% O2 immediately. And if you put them in 2 level of increased atmospheric pressure at 2 ATM, then you can drop the half-life all the way to 20 minutes. There is this reported delayed neuropsychiatric syndrome with significant carbon monoxide poisonings, and those who believe in hyperbaric oxygen treatment swear that that's the real reason you do this, is to decrease that. The literature is a mess on the topic, but I think if you're faced with a significant carbon monoxide intoxication on an exam, the answer is still hyperbaric oxygen treatment, although there's lots of ongoing debate about this. Remember, in pregnancy, fetal hemoglobin binds too, and so you would use lower levels of intoxication and lesser symptoms in a pregnant woman as an indication to put her in a chamber. And there's a monoplace chamber that you could do 2 ATMs at and decrease the half-life and hopefully improve it. Remember that in a carbon monoxide overdose, the pulse ox will be normal. So you have to ask for the calculated carboxyhemoglobins, and you got to look for, because the oximeter will measure carboxyhemoglobin as normal. The PaO2 on an ABG is often normal in these cases as well, and so you got to ask the lab to measure the carboxyhemoglobin levels specifically. All right, that's carbon monoxide, really common cause of successful suicide, sometimes a diagnostic challenge when it's accidental and it's furnaces, and things like that, hibachis, other things that are the cause. Caustic, and it's colorless and odorless, right? So you're not going to smell anything off in case. Now we go to caustics, and alkali are worse than acids because alkali have liquefaction necrosis that continues to proceed, as opposed to acids that cause coagulation necrosis and often arrests at a cutaneous level. When you talk about someone who, tried to chug down some lye or Drano or something like that, remember that the presence of oropharyngeal burns or absence doesn't really tell you what's going on further down. Some people really throw the Drano back, and so there's not much in their mouth, but they still have significant esophageal burns, and so they still need to be scoped. So your intention to get these people scoped emergently should be high if the question asks, do they need endoscopy, their mouth looks clear, the answer is yes, they do. Don't give charcoal because it's going to mess up all the burns and it doesn't work. If it's hydrofluoric acid ingestion, which is really uncommon, right? Most hydrofluoric acid exposures are from rust remover and etching in their fingers and skin. But if it's ingested, you can give milk and mag citrate by an NG. Solid alkali, usually it's lye, dilute with water or milk, and other caustic ingestions, dilution causes an exothermic reaction and it can cause vomiting, so don't do that. Upper upright chest x-ray, looking for perfs and free air, and urgent endoscopy, looking for burns in the esophagus, which will over time become this, which is a high esophageal stricture from a full thickness burn. Chlorine gas, green smelling, pungent odor, makes your eyes water, gives you pneumonitis, can cause pulmonary edema, supportive care, humidified oxygen. This usually happens at a hazmat scene or an industrial scene where the gas is leaking. If you talk to the real experts in hazmat, they'll tell you that the key piece of equipment for them is 10 by 50 binoculars, because that's close enough. And if you could have any other piece of information, you'd like to know the prevailing wind direction so you could stay out of the cloud as it moved. Clonidine overdoses, we see these a lot, particularly in jail populations, and the reason they do it is because they're withdrawing from opiates. So they know that the clonidine might help them. So someone in their jail block says they have hypertension that requires clonidine, and they end up on a clonidine patch or have clonidine tablets, and people will eat the clonidine patch, which obviously is, supposed to be delivered gradually, and now they have a clonidine overdose that looks like an opiate overdose with coma, meiosis, and respiratory depression. Treatments, fluids, atropine, and pressors as needed. Most of these can be ridden out with supportive care, and so you should recognize that. Cyanide, now we're talking about the immediate collapse on the scene of the fire. It may smell like bitter almonds. The fire source will be burning plastics, electronic equipment, synthetic, tiles in the ceiling. This place would be, and as it was back in 1980 when it burned, right? You guys know this is the haunted hotel, 1980, something like 80 people died up on the upper floors. Fire started near where we are right now in one of these kitchens on the other side of this wall, and the upper floors of the hotel filled up with bad smoke filled with cyanide and other toxic fumes, and most of the people who died of smoke inhalation and cyanide. Now, they won't be cyanotic with this. They'll have a normal PaO2 and O2 sat. And if someone immediately collapses, you want to go after this. They too will have a severe acidosis with an anion gap. And the treatment of this is to create a controlled state of methemoglobinemia, which can give you cyanomethemoglobin, which you can get rid of. So the nitrites will create that, so you can start with the amyl nitrate poppers that are inhaled, then go to the sodium nitrite, then to the thiosulfate, which ultimately will give you sodium thiosulfate, and the thiocyanate, which is renally excreted. Hydroxycobalamin, the vitamin B12, is a pretty expensive form of treatment of this, but a lot of fire chiefs want it, again, because this is for treatment of the fireman who collapses on the scene, and that forms a compound which is renally excreted. So the hydroxycobalamin, which is sort of new, but not so new that it's not testable. So you ought to be aware of that. That's a testable component of cyanide toxicity. DIG overdoses, we stopped seeing them mostly because people realize that DIG really doesn't work. Right? It's in the late 90s and stuff. There were these DIG withdrawal trials of people with stage 4, New York State heart class 4 heart failure that supposedly were DIG dependent. They removed their DIG and they were all the same. DIG is a lousy negative chronotrope for AFib, and it's a lousy positive inotrope for heart failure. It does neither, and very well, and it has a narrow therapeutic index. And at one time, DIG was one of the most common reasons, because of that narrow therapeutic index, DIG toxicity was a really common reason to be admitted to the hospital. But and nowadays, we're all concerned about, right, the CHF epidemic, and you have an OBS unit where you do some CHF care and try and avoid rehospitalizing them, because if your hospital rehospitalizes these CHF patients, it counts negative against your performance, so you put them in OBS and try and do that. And we're very concerned about this epidemic, and the reason the epidemic is out there is because we stopped killing them. It used to be we put them on DIG and Lasix, which is an excellent way to cull the herd, because when they're on Lasix, they get a little hypokalemia, which increases their cardiac irritability. Then they get a little worsening of their heart failure, and they stop metabolizing their DIG, so their DIG level goes up. So when they meet, the DIG level and the K meet at 2.5, they die of VFib. So we, for years, were culling the DIG herd, the CHF herd with, DIG toxicity and cardiac arrest. You don't see that anymore because they're not on DIG anymore. The antidote, remember it poisons the pump, so they get hyperkalemic in an acute dig overdose. And a K greater than 5.5 is one of the indicators for Digibine. That's a commonly asked question. Digibine, each vial binds about 0.5 milligram of dig. 20 vials will cover anything. And there are multiple, for the toxicologists in the room, there are like 3 or 4 different ways to calculate the exact, using the dig level, their height and weight, and all of that kind of stuff, to figure out exactly how to neutralize. That would be just an unreasonable question for a non-toxicologist. But if they ask you how many vials, 20 vials will cover everything. If you're not sure, you can start with 10. Somewhere between 5 and 10 vials would be the choice I would choose with that. Start at 5 or 6 vials. And the stuff's pretty pricey, like all of the antibody-related synthetic products. It's a class 1A antiarrhythmics that are contraindicated in dig toxicity, so you don't want to use those. Low potassium, as I said, makes the heart irritable and worsens it. Low mag makes it worse. And high calcium increases toxicity. There's a big debate about whether they can get calcium chloride as part of their treatment, but generally speaking, the answer is no. Let's talk about the EKG with dig, because it depends very specifically on how the question is asked. What is the most common EKG change with dig use? And that's the Salvador Dali mustache STT wave changes. What is the most common dysrhythmia associated with dig usage? And that's just frequent PVCs. What is the pathognomonic dysrhythmia for dig toxicity? That's PAT with block. Dig increases automaticity, which gives you PAT, paroxysmal atrial tachycardia, PAT, and dig decreases conduction velocity, which gives you the block. So PAT with block, I might have said PAC. If I did, I misspoke. It's PAT with block, that's pathognomonic. There is another pathognomonic dysrhythmia, but it's almost never asked about, which is bidirectional VTAC. The one they ask is PAT with block. Calcium indication, as we indicated, is not indicated in terms of, there are people who would argue this, but for standard answers, not indicated. GHB, gamma hydroxybutyric acid, became a drug of abuse among weightlifters, primarily on the West Coast, and Gold's Gym was associated with this in Venice Beach. And these guys are all, trying to make themselves bigger and become, they're all interested in the weight gainer 5,000 muscle milk and all those kinds of things, because they want to bulk up and then turn that into muscle, and they don't want to get busted by the testers at the contest that are looking for steroids and other anabolic compounds. And it turned out that GHB was not being tested for, and so when they realized they could use it as a weight gainer, and where this comes from is, these are not geniuses. It's Gold's Gym. Go there. They're not geniuses. What they found out was they were looking for things like, what animal gains the most weight quickly? And it's a grizzly bear, pregnant, preparing to hibernate. They have to put on a ton of weight so they can have, the cubs while they're hibernating, and then they start feeding, and then they come out raving hungry after but they have to gain all this weight to do that. And in grizzly bears, they have a lot of what's called brown fat, and one of the anabolic things in brown fat is GHB. And that was enough information for the weightlifters. There needed to be no human trials, nothing beyond that. Me want to be big like grizzly, gain weight gainer. And they started using it and found you could get a little high with it, and you could even get to, if you overdose on it, you could even knock someone out, and it became a date rape drug. And these guys all worked as bouncers at the clubs in Southern California when they weren't in the gym, and they started dispensing it at the doors. And that's how it came out. And it became a date rape drug as well. And it will knock you down. But it usually wears off. One of the things about them is they might need intubated. Occasionally, they just go apneic on you. And unlike other causes of apnea where the respiratory rate seems to slow gradually, and you're like, hey, I'm going to have to do something about this, they just stop breathing. You're like going about your business, okay, they're a little altered, they got this thing on, and then you turn around and someone's like, they're not breathing, doctor. Like, what? And then they extubate themselves 4 to 6 hours later, and that's GHB story. It's hard to test for. You have to send specific testing if you want to find it. It's not routinely detected on drug screens. And if they're co-ingested with alcohol, really common because it's sort of a club drug scene, you'll see it last a little longer because it's potentiated by the sedative hypnotic effect. GHB withdrawal, if people are using GHB regularly, and they often will describe it as being used by the capfuls. But someone who's taking 2, 3, 4 capfuls every 6, 7 hours, and they stop, they get a GHB abstinence syndrome that looks just like alcohol withdrawal, exactly, and it's managed exactly the same when that happens. GHB mostly kind of came and went. Anyone seeing frequent GHB around? So it's kind of gone away. There's one place where I'm still encountering it every once in a while, which is specifically as a date rape drug in the gay community on the West Coast. So it's still being used in that sort of thing, and you might encounter it there, so keep an eye out for it in that specific population. All right, now we're to hallucinogens. The more serotonergic they are, the more hallucinogenic they are. LSD is a pure serotonergic hallucinogen. If you looked at ecstasy, MDMA, it's sort of some serotonergic, some sympathomimetic. It's kind of in the middle. And they get psychosis, anxiety, sympathomimetic, a little bit to a degree. Treatment's benzos, and if they're really having a lot of problems with the hallucinogen element, you might give some Haldol or some droperidol if you had it around, and keep them in a quiet room and let them ride it out. Hydrocarbons. So this is still coming up, and it's around. Halogenated hydrocarbons and other toxic additives are worse, so you want to look for those. Aspiration, pneumonitis, coughing, tachycardia. If you're talking about huffers, they often will have silver or gold paint in their eyebrows or in their hair. They're filling a bag with it and spraying that in there. And the reason it's silver or gold paint, because those are heavier pigments, so there's more propellant in the can. So if you see a lot of graffiti around your house or in the underpasses near your home that have gold and silver in them, they're usually kids down there huffing. And if you're a member of the Audubon Society and you're out bird watching, there you can see the bright red cardinal. And then over here underneath the underpass, you can see the silver-headed huffer. And then when they run from the police, if the police come to make them stop graffitiing, as they ramp up and they get adrenergic, they have this cardiac sensitization, and they'll often collapse with a dysrhythmia because of the sensitization of their myocardium, along with the catecholamines induced by the cops showing up. If it's an oral ingestion, you can lavage them if they're halogenated or aromatics are involved. And the chest x-ray, you ought to consider doing a delayed one and watching them for at least 4 to 6 hours to see if they're going to get any of those findings, which can be in a delayed fashion. Here's the mnemonic out there, CHAMP, for the toxicity things that you'd really want to get the poison center involved and an expert involved. Camphor, halogens, aromatics, metals, pesticides, those are all things that would worsen this substantially. Hydrogen fluoride, if the question mentions etching or rust remover, it's hydrogen fluoride that they're after, and they'll get this skin burning, and the fluoride ions will keep penetrating until they're quote-unquote quenched. And the thing that will quench them is the calcium in your bones. So they'll get a full thickness burn all the way down to bone if you don't provide some alternative way of quenching it, which is why you would, for a typical rust remover exposure with their hands all burning and on fire, they'll come in. You're going to mix up the calcium gluconate with some gel and apply it with a glove and see if that makes them better. If it doesn't make them better, you may need to escalate the treatment and give some injections, or you might need to do a beer block or intraarterial calcium gluconate. You keep going up until the pain goes away. So you don't want to do it if it's only a couple fingers. I've seen people do things like put a digital block up. No, you don't want to do a digital block for symptom relief. You need to know if they're still hurting, because if they're still hurting, you would escalate the treatment. So don't digital block these. This picture's a little bit wrong because it shows the liquid calcium gluconate to mix with the KY jelly and then put the glove on. It works a lot better if you have the powdered stuff to mix with the KY jelly. The liquid stuff makes a mess. You could use it, but the powdered form before it's been, the hydrophilized calcium is a way better way to mix it into the jelly than you smear it on the hands and put a glove on and watch them to see if their pain resolves. And if it doesn't, then you escalate the treatment. Hydrogen sulfide, this happens in oil refineries. If you were to look in the Saudi toxicity journals, it can come out of wells. But more commonly, we think of it as sewer gas. I mentioned I worked on farms where they have, as a kid, and they'd have these like conveyors and things. You'd be shoveling cow shit all the time. And at the end, there'd be this big manure basin. And if you fall into that manure basin, you're going to be in hydrogen sulfide gas, and you're going to lose consciousness because it's a knockdown agent. And then if someone goes in to help you, they're going to lose consciousness. And then there's going to be two in the thing. And then the third, now it's like an IQ test. If a third person goes in, they're not very smart. If they wait for someone with scuba equipment to come in, they're a little smarter. If you sit in that for any length of time, you're going to be dead. Many of these don't arrive alive. They're dead on the scene. They'll tell you, they'll ask in the questions as you're emptying their pockets, you found a discolored coin, or there was a rotten egg over. All of those things are to confirm hydrogen sulfide. Most of the care that hydrogen sulfide needs is supportive care, but there have been some recent suggestions that you might try an amyl nitrate popper, and then the sodium nitrite after that to make sulf-methemoglobinuria. Sulf-methemoglobinemia, which is less toxic. You'd get the sulfur out that way. But there's no really good trials to say that will work. And as I say, many of the people who have this happen in an industrial scene or on a farm or in a sewer workers because it's sewer gas. They're found dead. And so obviously not a lot of treatment works at that point. Higher affinity for methemoglobin than cytochrome oxidase. So treatment, removed from the source, always put them on 100% O2. They say you could use methylene blue here, but the cyanide antidote kit with the amyl nitrate poppers and the sodium nitrite is the way to go, if you're going to try it. And did that say the coin thing at the bottom? Yeah, the coins in the pocket will be discolored. All right, isoniazid, there's some keys to isoniazid. I don't know why they pick on the Vietnamese, but if the words Vietnamese occur in the question, it means that there's someone in the home who might have TB. I mean, obviously they could pick India, they could pick any other country where there's TB, but for some reason they pick on the Vietnamese with this. So here what you have is a situation where a kid gets into 2 of grandma's INH pills and then has status epilepticus. So it's a toxic INH, and the finding is coma, metabolic acid with seizures, and the treatment is to give them, there we go, one light went up, is to give them pyridoxine, vitamin B6. If you don't know how much they overdosed on, start with 5 grams of B6. If you do know how much, because you have the pill bottle and you could do the counting and the math, it's gram for gram. You give a gram of pyridoxine for each gram of INH. Iron, another pretty common overdose, right? You got kids around, mom with pregnancy with prenatal vitamins around, and so these are an important one, and they're sneaky. They're sneaky. Iron is sneaky in a bunch of ways. So first off, it has a secondary phase which is relatively asymptomatic. That makes it sneaky. And the first phase isn't that distinctive. It's a little GI upset. You can imagine that in the middle of winter, you got a bunch of kids with viral syndromes, barfing and puking. Now you got another one barfing and puking, and you can see how, without some really good questioning, you might miss it. Ultimately, it goes on, if the levels are high, to cause vasomotor collapse and hepatorenal failure. There you see 0 to 48 hours, the quiescent syndrome, and you can see, unless you're careful, how easy it would be to send that 0 to 6 hour kid home if you didn't get the history of an iron ingestion. That would be really easy to do. Now, if you do the testing when they come back and they started getting acidotic, they have a high white count and a high sugar. This is the next place where it's sneaky. So you got this 2-year-old who, the real problem is they got into mom's iron, but they can now have a sugar of 300, a white count of 15, they're a little acidotic. And I've seen this happen because we use this as an oral case at LA County. I've seen lots of senior residents go down the must be DKA pathway. No, it's iron. In fact, before we could get iron levels, we used to use the height of the white count and the sugar to tell you where you're at. So iron is sneaky, and it has an antidote. So you want a 4-hour serum iron level. Remember that you can get the TIBCs and the other ancillary tests, but they're artificially wrong in acute overdose, so they're not that useful. Remember that. No charcoal. Remember that. There's the labs, increased GAP, increased glucose, increased white count. That looks like DKA. You can see how you can fall in that trap. In many questions, it's just about getting the KUB and seeing the radio-opaque pills. That will tell you what's going on. And now you're after it. Now you know they got iron in them. Now you can check, try and treat them with defuroxime, IM usually. If they're really sick, you give the defuroxamine IV. The problem with defuroxamine IV is it causes hypotension. The indication for giving it IV is a sick patient with hypotension. So now you're talking about a kid with hypotension on hypotension. I'd really like a poison center on the line. I'd like a pediatric intensivist to help me. You know, anytime you're going to be given defuroxime IV, it's a dicey proposition. And if you're correct in your choice of def, they'll make the pink urine, the Vin Rose urine, which shows there was chelatable drug that's now being removed renally. So def indications, severe GI symptoms, acidosis and shock, level really high. But if you have to go for defuroxime IV, remember, this is not an easy game to play. There's the Vin Rose urine being made as the increase in chelation by the defuroxime goes on. For many heavy metals, there used to be a variety of challenge tests, and we used to talk about doing the defuroxime challenge. You didn't know if it was iron. Let's do a def challenge and look for the Vin Rose. Almost all of the heavy metal challenges are out in modern toxicology. They're perceived to be unreliable, delayed, sort of not very useful ways to go about this. You really should be pursuing levels as a way of doing this rather than doing, for example, the defuroxime challenge. Lead, another common cause of overdose, usually from paint. There have been all kinds of problems with this and nowadays, if you're doing a home flip or something and there's any paint in there, you got to get rid of that. It's just, finding lead in a house you've purchased is almost as bad as finding, asbestos in a house you purchased, because it's now you got to get all the appropriate authorities in to get it out. And the toxicity of lead is primarily CNS. And remember, they can get a wrist drop. Peripheral neuropathy is a classic question, a foot drop or a wrist drop. In a kid with pica, that's lead. That story all holds together. Serum levels are greater than 50 is severe. They also sometimes ask this odd question about lead, which is what might be seen on the smear. And it's basophilic stippling of your cells that they'll see, which indicates there's lead. And you might see lead lines, like see the distal radius and distal ulna. See the very dense, that's a lead line in kid with chronic exposure. That kid's 5, 6 years old, right? They say count up the wrist bones, it'll roughly tell you the age. So I see like 4 or 5 of them. That's a perfect age for pica. And here's the kid's KUB that shows there's 3 windowsills in the GI tract. And so when you see that positive lead in the GI tract, that's got to go because that's ongoing toxicity, so it's whole bowel irrigation. Lithium, still around, not used as much by psychiatry as it used to be, and it too can be sneaky. It still shows up on exams too. They might have hyponatremia, and if they do have hyponatremia, it worsens the toxicity. Serum levels don't predict the CNS levels, and the serum levels are really only useful in the acute overdose in someone who does not take lithium regularly. Many times the levels are misleading. You'll see a level, at 2.1 or 2.2, which you might think, that's not too bad, but it's a chronic thing and they can be really bad. Clinical is tremor and seizures and altered mental status. They may have diarrhea. Oddly, there's some things about the diarrhea that you don't always see it, but I've seen it twice in my career. If they have a pinkish hint to the diarrhea, like it looks a little like undigested Pepto. Remember, Pepto comes out black. But the diarrhea looks like that Pepto pink, that's lithium, if you see that. If they have seizures, use benzos or phenobarb. And the reason they say not to use dilantin is because dilantin decreases the excretion, so it worsens and prolongs the toxicity. These are tough patients, and they can get by you, too. They're sneaky, so you want to think of lithium. They'll ask the EKG questions, bradycardia, QT prolonged, and T-wave flattening. Or inversion. Look at this, diffuse non-vascular T-wave inversions with a prolonged QT, that's a lithium EKG. There's only a few EKGs you need to know. PAT with block, that's DIG. This one here, the bradycardia with the diffuse non-vascular T-wave inversion, QT prolongation, that's lithium. And then the other one you need to know is a tricyclic overdose, which we'll get to in a moment, which is widened QRS and an R-wave in AVR. Clinical status more important than the level. I've said it a bunch of times. Don't be misled by the levels. Hydrate them with normal saline, because the normal saline, the sodium will compete with the lithium. This is a perfect water-soluble, small volume of distribution drug, so if they're sick, they get dialysis. Particularly if they're in a coma or having seizures, you need dialysis for this. Get rid of it quickly, and they'll clear their lithium very, very quickly with dialysis in a couple-hour run. Worst risk in renal failure. Worst risk, they might give you someone who's a psych patient recently started on a thiazide diuretic. They like that. The recent initiation of a diuretic, which then ends up in a rising lithium level with decreasing lithium excretion, is a common sort of format for that question. You might not need to know the little detail about the hydrochlorothiazide, but if you see that in there, it's a real hint they're going after lithium. Monoamine oxidase inhibitors with the severe hyperthermia and agitation that can occur if they're given these other drugs, the hypertensive crisis in the setting of amphetamines, cheese, wine, fava beans, tyramine-related compounds that can cause that are the things you're looking for. MAO inhibitors are really not often used anymore, but they might mention someone who's using a lot of St. John's wort. St. John's wort has got MAO inhibitor type compounds in it. Fava beans, you don't see those very often anymore. It always comes up in the G6PD questions. Oh, they can't have fava beans. And I always wondered, why do they have it? But when you go to the Mediterranean, they use fava beans in all kinds of stuff. I had this Coptic Lebanese guy when I was visiting Egypt, and I was in Cairo, and he spoke pretty good English, so I kept him as my cab driver for a while. And after a couple days, I said, show me Coptic Cairo. And he's like, well, Coptic Cairo is pretty poor, and they have a horrible life, and they're being persecuted. I'm like, sure, just take me to one of the places where you guys have. So I went to this place, and they served me, and this was my first hint, a dish called fool. It was fabulous. It was fava beans with mint and raw tomatoes and this sort of vinaigrette. Oh yeah, the GI problems I had after that. Remember in Cairo, they fertilize their fields and water their fields with something euphemistically called night soil. That's when they drain their sewage out over the fields. So everything in those fields is basically, no matter what it is, cucumber, tomato, anything that comes out of the field is basically a container of E. coli. So the uncooked veggies in the fool in Cairo. There's these words in medicine you learn about. Like tenesmus is one of those words. And you read about it, you're like, oh, tenesmus, yeah, that's that. But, until you have it, you have no idea. Like, tenesmus is a completely inadequate name for what it really is, which I think it should be recalled histaminic anal crisis, because that's what it is, right? You need to know where a bathroom is at all motherfucking times, and it can't be more than like 10 feet away. That's what happened to me after the fool. I suddenly understood tenesmus. All right, methemoglobinemia results from the oxygenation of normal iron and to the 2+ to the 3+. It's unable to bind oxygen. What are the causes? If they have a home, somebody who smokes their own bacon or sausage, that's the nitrites and the nitrates. Benzocaine, you ever seen someone getting sprayed, the benzocaine in their throat turn blue? You were trying to do some procedure in their mouth. They're like spitting the stuff. You're like, a little more, and then they turn blue. That's methemoglobinemia. If you've never seen that, it happens. Back off on the benzocaine. And pyridium can do it as well. They present with vague symptoms, and they can get cyanosis. And they'll get better when you put them on oxygen, usually, but not always, as this slide indicates. Cyanosis unresponsive when it's more significant. They might have chocolate brown blood. They'll talk about that in lab. They might tell you draw their blood and it looks brown. That's methemoglobinemia. And if you give them methylene blue, it will treat it and reverse it. Now, they always say this thing on the bottom, and I've always wondered, because I had the fava beans, which are contraindicated in the G6PD deficiency, and it was in the Mediterranean where there's a lot of people with that G6PD deficiency. So obviously those people learn you can't have the fava beans. But now, they always say this, methylene blue contraindicated in G6PD deficiency, but they never say what you do if they have that. Like, I don't know what the answer is to that. If anyone knows the answer, I'm interested in hearing it. All right, now we get to the mushrooms. Mushrooms are kind of fun stuff to talk about, right? The saying, there are old mushroom gatherers and there are bold mushroom gatherers, but there are no old, bold mushroom gatherers. And the reason for this is that if you boldly go about picking mushrooms and you know what you're doing, some of those mushrooms can look really pretty normal and edible, and they aren't. Some mushrooms really loudly announce that you shouldn't eat them, but there are a whole bunch of them that look normal, like the false morel. Morels are delicious. I can remember picking morels as a kid. You could sell them for $30, half bushel back then. Now they're probably 5 times that. But anyway, so you could get it wrong. Now, the thing with mushrooms is after you eat them, the sooner the symptoms, the better off you are. So you saute them up, you're thinking things are good, you eat the mushrooms, and 90 minutes later you're like, I got tenesmus, I got to go. That's good for you. If you eat them and think that was great and you're sipping your after dinner drink and then you go to bed and in the morning you wake up with diarrhea 12 hours later, that's bad. So delayed onset to symptoms means the mushroom you had is more serious. See that thing? It's called a death cap. I think you can buy that in Vaughn's right now. It looks just like the thing you buy in Vaughn's, so you kind of need to know what you're doing with mushrooms. Like that one, I could see how if you were out there on, what is that show, Naked and Alone? Yeah, I'd eat that thing. Because it looks totally edible, and you can see that would be a mistake. That's Amanita phalloides. Nausea, vomiting 12 hours later, then the toxin kills your hepatocytes, then you need a liver transplant. That's not good. Now, you're out there naked and alone. You're on the TV show. You see those. I don't think you have to be very smart not to eat that. Everything about that, you just look at it, you feel like you're in Alice in Wonderland's thing. Like you already feel like you're hallucinating. I think that mushroom says loud and clear, don't eat this. Like you don't need to know anything about a rattlesnake, right? You come up on a rattlesnake, all coiled up, the head back, the tail going, come fuck with this. You don't need to know anything about a rat. You could be from another planet, you should step back. You don't need, and I feel the same way about this mushroom. There's nothing about that mushroom that says, go ahead, saute me up. So that's muscaria, which gives you mental status change, hallucination, delirium, seizures, but not hepatic toxicity. So one amanita, the death cap, kills your liver, and this one gives you delirium and hallucinations. Now let's go down to psilocybin. Those also look delicious. I'd be all for, get the butter melting. I'm going for it. But those will cause hallucinations, euphoria, nausea, GI stuff, but early after you eat them. All right, we're moving through the alphabet. Neuroleptics and phenothiazines. Dystonia reactions, right? The bent neck, the torticollis, rigidity, oculogyric crisis. Now there's a name that sounds like what it is. I'm sure if you had that, you'd be like, oh yeah, that's oculogyric crisis. That's a good name. Then there's akaesthesia, which is where you've all seen that, right? Somebody got some compazine or something, and they whip out their IV, and you go into the room, like, what's going on? I got to go. They always say the same thing. I got to go. And they're like getting up. Imagine if you could find out what causes that exactly. How rich you would be with the patent on that drug. And I would call the drug, I got to go. Imagine how often it'd be used in your emergency room. You'd be like, really? He wants to say, no, give him 5 milligrams, I gotta go. Actually, nurse, make it 10. You'd be so rich. But anyway, that's akaesthesia. So akaesthesia and dystonia are different things. And then they can get the anticholinergic symptoms and things like that as well. So the rest of the thing there. And it's not good to be on these neuroleptics if you're in a hot environment. Diane was talking about heat exposure and some of those things, and these can make it worse as well. Neuroleptic malignant syndrome, Diane talked about this. When you cool these off, they don't really wake up. It's slow onset over days. They get lead pipe rigidity, they're planking. They may have elevated CKs and renal failure and hypertension and all of that. And the treatment is fever control, benzos, and then look at that bottom. That probably should be in a yellow box down there. There aren't many places on an exam where you're calling out dantrolene and bromocriptine. So those are in the sort of antidote for neuroleptic malignant syndrome. Narcan, we've already talked about, half-life 30 to 60 minutes. You can precipitate withdrawal with it. We talked about some of the other reasons not to go high-dose Narcan. You can use almost any route with it, although in Pulp Fiction, when they did the intracardiac route, I felt like, I was in LA when I saw that movie the first time, and people were like writing notes. I wanted to stand up, public announcement, no. Don't go for the intracardiac. Go under the tongue. If you got to stick someone in, do something like that. Oral hypoglycemics. Remember that the non-sulfonylureas, metformin and that stuff, they don't cause hypoglycemia. And if they're on an oral agent, a sulfonylurea like glyburide or glipizide, one of those, and they have hypoglycemia, the standard answer on the exam is they need to be admitted and followed. And if they have recurrent hypoglycemia in the emergency room, you need to put them on D5 or D10. And if it happens again after that, then they get an octreotide drip. And that octreotide drip is a new thing, right, relatively new in the last 5 years or so. And so that's kind of an examinable thing, and it comes up that you might do that to prevent them from getting their recurrent hypoglycemia. Risk factors, extremes of age, alcohol, hepatorenal insufficiency, that all makes pretty good sense. Renal stuff in particular, if they have renal insufficiency, it makes the oral hypoglycemics that much stronger because they stay around that much longer. So metformin and fenformin, which we don't see anymore, remember the fenformin diets, but people still get it over the border. You can still get fenformin over the border in Mexico, or pick the place where you want to cross and get it. Causes lactic acidosis, and it can cause severe acidosis with contrast. So that's kind of worth knowing about. Symptomatic patients with sulfonylurea or metformin should, like I say, be admitted. I think in the real world there's some latitude on this. You might OB some of them. You might, make sure they're not having a lot of recurrent hypoglycemia and do it. But be clear, at ABEM General, they want you to admit these. Treatment, glucose bolus and drip, glucagon, octreotide. The bottom there, as I indicated, is where we're at with this, with the octreotide for refractory sulfonylurea overdose with recurrent hypoglycemia despite the other stuff, gets octreotide. Some poisonous plants, the stone fruit, they have cyanide in their cores. The anticholinergic plants, deadly nightshade, hembane, and ginsenweed. And the dig plants are folly, foxglove, oleander, and lily of the valley. So those questions sometimes come up. Almost everyone has seen somebody who inadvertently got into one of these dig toxic plants. The common story is the Eagle Scouts are all out, they're looking to grill some hot dogs. They can't find anything but oleander, so they strip the bark off, put the hot dogs on it lengthwise, put it into the fire. And so it turns out the hot dog is an excellent transport and solute media for the toxic glycosides that are in there. And so then they eat them and they get bradycardic and they get their dig stuff going on, their PAT with block. And that's a classic sort of plant story. So there's your stone fruit. That's where Laetrile was made from, as pits of apricots and things like that. Gets you your cyanide. There's Datura species with the trumpet flower, or the dragonweed it's called. It's all over LA. It's all over here too. In fall, it gets those pods, and when those pods break open, they have this white sort of milkweed-like fur with these black seeds. So if you see someone with like white fur and what looks like poppy seeds in their mouth with pupils the size of, small, coffee dishes, that's anticholinergic due to the ginsenweed, and that's called the autumnal high. And the kids learn, where do they go to get the information? Who's telling these kids how to do this shit? You go to the web. You go to, and the Vaults of Arrowwood is a really cool site run by a couple of pharmacists and a couple other docs, but they've been trying to close the Vaults of Arrowwoods forever. It's got all kinds of really useful information, how to find out if your ecstasy is bad, and what about the high potency marijuanas, and all of that stuff is all there. If you want to look for it. They'll give you recipes. So the autumnal high only happens with the seed pods. But I've seen them in spring doing the flowers. You make a tea out of the flowers, and they tell you how to sort of titrate it up. Last time I had 4 teenagers with the tea from the dragonweed, this Datura species. And 3 of them were not that bad, but one of them was full-on delirious, and we gave the physostigmine to and all the stuff. It was great fun. And there's foxglove and the oleander. Oleander comes in a the pink, the white. I think there's a yellowish one too. It's the break between the highways on Route 5 for much of California. If you're wondering what that plant is between the northbound and southbound lanes, it's oleander. It's one of those. It's almost a pest plant. If you plant it, you can't get rid of the shit. You have to try everything. Like I say, you can have Mack trucks driving by spewing toxic fumes all day long. It'll still grow just great. Tobacco, I remember the first time I tried chewing tobacco, that was a mistake. I was like 16 and I got all the salivation and confusion and stuff. I didn't seize, fortunately. It was miserable. But you'll see that pediatric ingestion of cigarettes can happen. Remember, the cigarettes can be tainted with other stuff too, so you got to be alert to other things that are in cigarettes. And you can do lavage and charcoal and benzos if they're having seizures or are real whacked out with it. It'll usually make them better. Rat poison, superwarfarin, as I said, the 2-year-old who's beginning to cruise, doing their thing. They're looking for this in the corners. They're going to eat it with a cat turd and a ball of hair. It's delicious. It's fabulous. And the half-life of this stuff is super long. So the PT will increase over 8 to 24 hours, and it can last as long as 5 days. I was always surprised at the Poison Center. A lot of these are managed as an outpatient. You just got to tell them no trauma, no gym, no sports, those kinds of things, but they let them go and follow them. It blocks synthesis of 2, 7, 9, and 10, the standard vitamin K dependent stuff. Treatment is lavage, activated charcoal. You can give them vitamin K. If they're bleeding, give them FFP or PCCC. All the usual things that you would do for that. But a lot are managed with just some vitamin K and sent out. All right, salicylates, another important overdose, really common. It's out there. It comes not just in the tablet form, but oil of wintergreen is salicylate. And it's sneaky. It can confuse you and look like sepsis. I'll never forget one day I'd seen a couple of these over the years, and they talk about their altered mental status. They're sort of sedated, but agitated and irritable. They have that little mix. And so you can kind of recognize it. And I remember a resident coming to me and said they had this lady who was in her 70s. She was altered. She had a low-grade fever, and the UA was negative, and the chest x-ray was negative. And it was the usual question to the attending staff, do I really need to tap this lady? She doesn't have any meningismus or things. She's a little bit wacky, but I don't know what her baseline is. And I looked at her nursing note, and it indicated she had chronic arthritis. And so I went and I held her by her shoulders and kind of got eye contact with her. I said, ma'am, what are you hearing? And this is a direct quote, "Fucking Megan!" And that was the hint that maybe we should check a salicylate level because she was describing her tinnitus. And so you want to look for that. And remember, they get an anion gap metabolic acidosis from the uncoupling of their metabolics. And then they overbreathe. They get a respiratory alkalosis. So they have both things together. And with these people die of these with levels, when they're chronic aspirin overdoses, they die with remarkably low levels, 40s and 50s. Many of them are not recognized. They're admitted to the hospital as an old lady with sepsis, right? Somebody finds a couple white cells and a few bacteria and they call it urosepsis, but it's not. It's a salicylate overdose. They're hypotensive, or they call it pneumonia because they start having some cardiac, because of the cardiotoxicity, they can get some pulmonary infiltrate, some pulmonary edema. So they call it pneumonia. And so these are missed and not appreciated. In children, you'll see hyperventilation and diaphoresis. Anything that's a nursing home, anytime you smell oil of wintergreen, like someone's got a diaper full of poop and someone thought they should make that better by putting some oil of wintergreen nearby, that can have high cutaneous absorption and super high potency. So look for those. As I mentioned here, you can see the hypoglycemia. We talked about that right up front because their metabolism's just chugging along and giving them the fever. They can get the non-cardiogenic pulmonary edema, which you might call pneumonia and sepsis. And remember, in the chronic overdoses, the nomogram does not apply, as I have said several times, like a broken record. The treatment here is to alkalinize the urine, which is a form of ion trapping, not forced alkaline diuresis, which I encourage you to recognize as a wrong choice. You got to get the pH of the urine up to 7.5 or 8, even better, and you're going to give amps of bicarb in the fluid plus potassium and magnesium, so there's some positives to go with it. All right, serotonin syndrome. A lot of times the tox literature and sort of the books on this will kind of tell you that neuroleptic malignant syndrome and serotonin syndrome, you could really easily tell them apart. It's just not true. There's a lot of overlap between them. Yes, the neuroleptic malignant syndrome is slower onset, and it has, the lead pipe rigidity, but the serotonin syndrome often gives you lower extremity stiffness. Here's a list of some of the SSRIs. When they change their dose or increase their levels, they can get all of these changes of serotonin syndrome. It's rapid onset, altered mental status, dysautonomia, myoclonus, lower extremities greater than upper. It's not true lead pipe, the whole body as you see in NMS. It's more the lower extremities get stiff. And it's not cogwheeling stiffness. It's just stiff. Distinguished from NMS, and there you have in the red, the bottom. And on an exam, they'll probably make it pretty straightforward which they want you to choose by the onset and some of the other findings that are listed here in red. But in real life, it's not so straightforward. In real life, these can be confusing. Now we go to the TCAs, and again, many in the room are old enough to remember the days when you could have, a shift completely ruined by 1 or 2 TCAs that would keep you pinned at the bedside for hours while they, either seized or had dysrhythmias, and you were doing everything you could to keep them alive. Remember that tricyclics have a bunch of different components to it. They have an anticholinergic effect, which will give you the flushed skin, dry mouth. They have some CNS effects, and they can get confusion, ataxia, and seizures. The cardiovascular effects are there. And what usually happened in a bad TCA overdose was you'd sort of suspect what was going on. They might have had some dilated pupils, the anticholinergic effects. You kind of were figuring it out, and then they seized. And when they seized, the seizure caused acidosis. And the acidosis caused them to unbind drug. And so when they unbound drug during the acidosis, that precipitated cardiac toxicity, and they went into VTAC. And so then you'd have to fight their way out of the VTAC and try to prevent the seizures. You could be doing this. And some of these patients can take 8, 10, 12 amps of bicarb during their management. And they can be really rough to manage. And they get widened QRS and VTAC. And here's the EKG, or it's coming, the EKG that you need to know. Treatment is lavage and charcoal, but you often have to intubate them. Anytime, the answer for the antidote part of this is anytime a TCA does anything you don't like, the QRS widens, they have a dysrhythmia, they have a seat, you give an amp of bicarb or 2. Anything you don't like, the reflex is bicarb. And remember, you're giving the bicarb not so much for the HCO3 minus, you're giving it just as much for the high doses of sodium to overcome the channel block that exists with it. If they get torsade, you can still use magnesium. And for delirium and seizures, it's benzos. But your first answer on any TCA is the bicarb. And here's the classic EKG, a little bit of tachycardia, a little bit of widened QRS. But the key thing is, look how big that R wave is in R. AVR has a monster-wide R wave. And the R in R is the classic finding of cardiotoxicity in a TCA. And once you say it that way, then you don't have to read. There was a very famous article by Neiman out of Harbor, UCLA, who described the early findings of tricyclic toxicity. And here's what he said. He said, thinking that the average air doc would understand him, he said, what you're looking for is counterclockwise rotation of the terminal 40 milliseconds of the QRS in the frontal plane. To which most of the air docs said, what him say? What? I don't understand. What that all translates into is an R wave and AVR. AVR is in the frontal plane. That R wave is the terminal 40 milliseconds, and its expression and wideness of it is all about counterclockwise rotation of the axis. There you have it. So that's like the third important EKG. If you knew those 3 EKGs, you'd be way ahead. And there's the antidote, the bicarb. Now we got some tox smells. This is just a list because they sometimes do the smells. How many of you are non-DKA smellers? There's always a bunch, yeah. I can walk into the critical area at Stony Brook and know there's how many there are. There's 3 DKAs. I think there's 2 over that way, and there's 1 down here. So I'm good at that, but other things not so good. Rotten egg smell, for example, you might smell it early on, but once it's in the department for a while, you become nose blind. You know those ads? You're nose blind. You actually down-regulate your ability to smell that rotten egg very quickly. And there's some other ones there. Wintergreen we've touched on. Pears, chloral hydrate. I can't even really picture what pears smell like, even as I stand here. Fresh cut grass, phosgene. All right. So when might you see something in the belly on an x-ray? This is a good one, and there's a couple different of these mnemonics. I always use the one that's chipes, but it gets you the same thing. This one's coins, and it tells you how to look for things. The key one on this, on a case, right, they're going to give you a white count and a kid who's not looking good with GI symptoms, and it's going to be iron. And so they get whole bowel irrigation until that iron is gone. What do I like on here? You know, charcoal not useful, that's a pretty good list. Whole bowel irrigation, pretty good list. Sustained release glove, drugs, and the iron and the lead I would add to that list, and the body packers. We're into a few little things. Non-dialyzable drugs. Cyanide, it doesn't come off. TCAs, protein bound. Iron, you can't get it out of there. Benzos, distributed into the fat. Phenothiazines, hallucinogens, they're out of the compartment you're dialyzing. So they're non-dialyzable. And we are ahead. Are we ready to go? Do we need a break? What's up, Di?
Nope, stretch, go, go, go.
Go,
There
go,
we
go, she
Power
says. Go, go,
through.
go. Here she comes. All right, that was it. And really, Tox, that review should do it. If you were to look through that stuff again, it would really take care of it. It's sort of quick, high yield. I wouldn't go crazy looking at it. And don't let peers, whatever it is, 7 or 8 that has all those bullshit, difficult Tox questions freak you out.
All right, you can stretch in place, but we're going to power through. This is one of the longer days. I apologize for that. So I wish I developed this business. This is called Hangover Heaven. It is basically a bus that drives up and down the strip that is very air conditioned, and you can get IV fluids and a little ondansetron as you get over your hangover. And once you pay cash at the door, and then they boot you off when you're better. So I wish I'd thought of that business. Okay. So let's continue in the environmental stuff. And we're going to do burns and kind of go from there. So we were talking about heat illness. Let's talk about burns. So we see lots and lots and lots and lots of burns. We see them all the time. And their rate, just like we talked about with frostbite, they go basically on how deep they go into the skin. So first degree is that sunburn, which all of those white-skinned people out by the pool today are all getting. Then I learned first, second, third degree kind of burns, 4th degree even. It turns out that they're renaming them, and I think appropriately so. So what used to be 2nd degree is now superficial partial thickness burns. And the reason that they're renaming them is it's a lot like what we talked about with frostbite. There's certain levels of burn depth that will make a difference on whether I'm going to do a graft on you, whether you need a big kind of flap graft or just a little bit of a thin skin graft. And it depends on how deep that burn is, not the degree so much as describing what it is. So superficial partial thickness does actually get down and gets blistering, but it's moist at the base. It actually hasn't gotten down to any major structures, and it usually doesn't need anything like grafting, but deep partial thickness does. These blisters they can actually be dry blisters. They get down deeper, and these don't blanch anymore, but they have some pain left. So some of the nerve findings are still left. So the pressure they'll feel, but they may not feel pain as much. And then full thickness is where it's burned all the way down, and there's no nerve sort of function left at all. That's basically leather. It's just not functioning at all. That's basically leather. So these different sort of ways that they're describing superficial and deep partial thickness and full thickness burns help guide the surgeons and the sort of people that take care of these burns as they repair them. There are certain things that are important about burns in general, just as far as how to manage them. One is how much burn surface is involved. And it is important to know that sort of the rule of 9s is one way to do it. There's the Brunn-Lauder chart for kids. It's worth knowing that. For the exam itself, I don't think they're going to ask you this specifically, but it's worth it. On the next 2 pages, there's some pictures that show some of the different sort of percentage body surface areas that are involved. The general rules are the deeper the burn, and the more of you that's burned, the worse off you are. And in particular, fluids become a problem. If I get down to, your skin is magic. Your skin is your biggest organ, and it is magical. It packages you inside and protects you from all of these things that assault you all day long. But if you break that barrier, not only are you assaulted by bacteria and things, but you don't hold your fluids inside. So you leak. You basically start to leak out of everywhere. So we know people with deeper burns with no way to keep the fluids inside ooze like crazy and can have a lot of fluid loss. It used to be a very sort of tempting thing, and not infrequently on the exam, to have things like knowing how much fluid to give somebody who's burnt. And knowing things like the Parkland formula was something I would have encouraged you strongly to do until recently. I honestly think that they will not ask anything on the exam about how much fluid to give a burn victim, because this is changing. What's on this slide is the Parkland formula. And this, I had this memorized for a bajillion years because it was around for a really long time. But one of the things that, like the new ABLS, the Advanced Burn Life Support sort of training system, and some of the things that's coming out of the trauma literature, basically say that that may be too much fluid. That we were actually giving so much fluid that we were ending up with people 2 or 3 days down the line with things like pulmonary edema and having compartment syndromes. They would end up with abdominal compartment syndromes and just bad stuff. So there's a new formula that's the ABLS formula. It's not quite as much fluid as this. So rather than spend any brain space on it at all, don't bother with how much fluid should you give. And when you go back to work, just look it up. The ABLS formula, talk to the trauma surgeons, know that you need a bunch, but it may not be as much as we used to give with the Parkland formula. So that's kind of the deal with the fluids. Here are these sort of percentage body surface areas. It would theoretically be a question they could ask where they'd want you to know, a 25-year-old guy comes in who's burned with his entire right arm and his entire front of his torso, to know that's 9 plus 18, and so 9 on the front of the chest, just to know to calculate that. I wouldn't spend time. Honestly, I wouldn't. Of all the things in the environmental section, I wouldn't spend time on that. And here's the Lund-Browder chart for infants. Another thing I don't think they'll ask, but it's something that is sort of regional and depending on where you work, is when someone gets burnt, transferred to a burn center. So, but there are certain rules of thumb that make sense. Right? And it's just logical. If it's a part of your body that's burned where really specialized care will be helpful, it makes sense that that person's cared for in a burn center or transferred to a burn center. So your palms, your perineum, your face, certain places, your creasing surfaces, your flexor surfaces where things are bent, those make sense that you might want to have somebody taken care of in a burn center. And it makes complete sense that the more burn you have, the deeper burn you have, the more likely you are to go. So there's all the things on this list are from one of the criteria that are out there, and the ABLS has its own system, but you'll find your own burn center may have its own criteria. Again, nothing for the exam, stuff that you just need to know for your own institution, what your own burn referral sort of criteria are. They may show you pictures like this, and this particular picture shows probably full thickness burns where it's white. Those pictures, the areas that are completely white, that is probably insensate completely and burned so far down that that's actually a true full thickness burn. But the places that are pink and oozy, there's still some skin structure involved, intact. So some of those are going to be deep partial thickness, and some of those are going to be superficial partial thickness. So this is basically not second and third degree anymore, but deep, superficial, and probably full thickness burns. This is somebody who probably has full thickness burns. When it's actually this white, and pretty where it's black where it's been burned so badly, this, at least on the hand, this is basically somebody who has full thickness burns. We have complications that definitely occur with these, and we do worry about inhalational lung injury. And those of you who've done your LLSA tests, I think it was 2 or 3 years ago, there was a very good article on inhalational lung injury, what to do about people that are in enclosed space burns, and what kinds of things happen to your lungs from all the chemicals that you inhale, all the particles that you can inhale when you're in a burn injury. And there can be systemic toxicity like carbon monoxide poisoning and carbon cyanide poisoning that you just heard about from Billy. So it's a range of things that includes ARDS, pulmonary edema, all the way down to toxins that are involved. When it comes to these airway burn issues, in real life and on the ABEM exam, a low threshold to intubate somebody who may have been burned. The edema it can happen too quickly, especially as we do our fluid resuscitation. So low threshold to intubate people on burns. And in real life, if you're transferring somebody, it's really better to intubate early than it is to wait too long. The infections and things aren't something that are acute. Those things happen down the line, so they're not something that happens while we're there. So there's nothing we need to do about sort of prophylaxis or anything with burns. And other things can occur down the line that just aren't pertinent to our practice. But what is pertinent to our practice is the concept of doing an escherotomy. And this is, I would asterisk this page, because this is something that they may very well ask you on an exam. And the classic example of that would be, you have a person with basically full thickness burns to their torso, and they come in with a respiratory acidosis. Their PaCO2 is high, their pH is low, and they have this circumferential full thickness burn of their torso. What's happening is it is like having a corset on because it has no more sort of elastic characteristics at all, and you end up with something that's just tight around your chest and you can't breathe. So you end up retaining CO2 and getting a respiratory acidosis. A similar concept is something circumferential and full thickness to an extremity or your neck, where basically, again, nothing can get in or out because it's been constricted. You end up with neurovascular compromise here. You end up with venous congestion of the brain if you have, or even sometimes arterial problems to the brain, if you have circumferential, full thickness burns to the neck. The key to all of those is in every single one of those cases, you will do an escherotomy. You will go in and you will take your scalp. How many of you have done an escherotomy in your career? It seems incredibly dramatic. It's like this idea that you're going to take this burned person and you're going to take a scalpel and you're going to cut them open. But what's interesting about it is that because it's a full thickness burn, all of the vascular structures have been destroyed. It doesn't bleed. And because it's so tight, it's sort of like when you have your hot dog on the barbecue and you poke it and it pops open. That's what happens. And it is miraculous what happens, once that pressure has been relieved. They can breathe better. Their distal neurovascular compromise is gone. This is something that the ABEM item writers like to write questions about so that you have the nerve to actually say, yes, I would do an escherotomy. And in real life, please feel free. It is insensate. They can't feel it. It doesn't bleed because the vessels have all been completely destroyed, and it really helps the distal structures or the structures being involved. So escherotomy is ripe for possible questions and something in real life that can be limb and life saving in somebody with a bad burn. Now, electrical injuries, electricity, I don't know about you, there's certain areas of life that freak me out, and I'm sure I hate electricity. I think I got a shock when I was a kid, like one of those that like make you vibrate and you remember the whole muscle memory part of it. That freaks me out. And my husband loves to redo things in the house, so he is always playing around with electricity and doing lighting, etc. Makes me crazy. It turns out electrical injuries can be quite lethal, and the ones in your home can definitely be lethal. This is tissue damage from electrical current passing through you. And two things happen with this. One is you have the electricity problem that happens, and the main area of your body that's problematic with that is your heart. It can also, though, cause damage because electricity, if it meets resistance, it doesn't meet resistance, it goes really quickly along all of our wires that are out there, and it's really fast, that's no problem. But if it meets resistance, it gets hot. For instance, if you've ever used the wrong kind of plug to, say, charge your cell phone, you'll feel that plug, that metal part of the plug, get hot because it's the wrong kind of. There's either too much flow or too much resistance happening. It gets hot. Same thing happens in your body. So the parts of your body that are more resistant are things like your bones, so that it hits your bone, and your muscles. So the most resistant is bones. The least resistant is nerves. Blood vessels are kind of along there. You'll generate heat. So the things that happen when you get electrocuted with something is you end up with the electrical problems, usually your heart, the heat problems from resistance, and then if it's a big enough voltage, you're going to get trauma too, because that causes a blast kind of problem. You often get thrown. So the people that get these injuries, it makes sense. It's toddlers that chew on a cord. It's testosterone and alcohol doing dumb stuff around electricity. There's one of those great sort of Darwin Award kind of pictures of a group of teenage boys that basically have one of those little blow-up pools that they want to play in, but they want to listen to music. Shows all of them standing in the pool with a ladder kind of thing in the middle, with a boom box that they're playing music from plugged into the wall. Beautiful. That's a great way to knock out like 14-year-olds in one fell swoop. So that kind of behavior does this. And it is true, the people that work on these high voltage lines that also get involved in this stuff. When the recession happened, we had a whole slew of these cases that came in on people that were basically stripping copper wiring from abandoned kind of development areas, housing developments and commercial developments. They were going in and stripping the copper wire because copper wire is very valuable. You get a lot of money for it. But some of these hadn't been decommissioned, so some of them were still live. So the people that were basically stealing the copper, we had one guy come in who basically had used a metal wire cutter and basically cut into a live wire and just electrocuted the bejesus out of himself. It was awful. Again, it's the resistance that causes the heat, so that's the problem. And then the other major sort of concept is that alternating current is worse, 3 times worse, than direct current. What alternated current, so alternating is that sort of 60 hertz thing that you kind of read about when you're getting your converters that you need to use when you travel. The reason it's a problem is if I have direct current, so I just have where it is just blasting, this huge amount of voltage is blasting direct current through. What it does is it will throw me away if I touch it. It will blast me away from that. Alternating current, if I grab it, it stimulates and relaxes, and stimulates and relaxes, and so it's a thing called let go current, where I grab it and I cannot let go. I get tetany and I cannot let go. This is the thing where they tell you if somebody is grabbed onto some sort of electric wiring, don't go touch them. They can't let go. You'll just become part of the circuit. Don't go touch them. Have somebody turn off the circuit, and then you can go try to resuscitate that person. So the injuries, again, depend on how much current, what kind of voltage it is, so alternating current, direct current, and how high the voltage is, and what kind of tissues it's going through that will tell you what's wrong. Now, household current isn't a lot of amps. It's not a huge amount, but because it's alternating current and it is so ubiquitous, it causes the most amount of deaths. So household current, so if those stupid teenagers standing in the water had that boombox fall into the pool, they would have all been electrocuted from household current and could very well have died. Without question, could very well have died. And your exam, what you see, may not tell you at all what happened in there. The higher the voltage, the more likely you are to have obvious damage done. You'll have burns and things that will go with it, and you can have the injuries they get from being thrown. But the lower voltages may cause, or the alternating current may cause nothing externally and kill somebody, flat out kill them. Low voltage injuries is the kind of thing you see at your house. This is the kind of thing that happens at your house. This is the majority, because of greater access, most things are low voltage that were around. Those are the things that cause the most deaths. Low voltage, again, with this let-go current problem, what it tends to kill you with when it kills you is it throws you into ventricular fibrillation. It basically just throws you into VF. So when you have cardiac arrest from a low voltage, usually alternating current, you have a VF arrest. Okay. Otherwise, other kinds of rhythms are uncommon, which is different from high voltage injuries. High voltage injuries, if it's a guy working on the wires behind your house where it's 7,000 volts behind your house, what happens there is it's a lot of voltage, they get thrown, they get injuries, they have burns from the injury itself, and when they have a cardiac event from that, it's asystole. Their heart just stops. It just goes flatline. It just stops. So a potential question on an ABEM exam would be, they'll give you somebody who has a VF arrest from an electrical exposure. They're going to want you to know it's probably low voltage. Or somebody who has had is asystolic after some sort of electrical exposure and, oh, by the way, has some trauma. Well, that's probably a direct voltage injury, a high voltage direct current injury. What you're going to do is, because if you think about what's happening, this electricity is traveling all through the body. All the muscles can be damaged, all the tissues that it travels across can be damaged. So you're going to get an EKG, you're going to get electrolytes, you're going to get a BUN and a creatinine, you'll get all the things that could be damaged and a CK, because your muscles are what it travels through. So you're going to check a CK, and you're going to go ahead and get an EKG in these folks. Now, not everyone who says, I touched the thing and I felt the buzz and needs to be admitted. We used to admit all these folks, which turns out is way overkill, way overkill. If you see somebody who had a household exposure, they were able to let go of what happened. They weren't stuck holding on to it. And you see them and their EKG is fine. They're not having any chest discomfort. They're just hanging out, no cardiac complaints. Those people can go home. They don't need to stay. If the EKG is abnormal, if they had a period of not being able to let go, if any of their labs are funny, if any of their labs are CK elevated, those people need to stay. And all high voltage injuries need to stay in the hospital. They almost always have burns or deeper injuries than we can see, so they'll follow the CKs. This is the kind of burn you'd see with a high voltage injury. Big, big burn spot. And underneath all of that is really, really damaged tissue, really damaged tissue. And this is the one that's kind of the unique thing that we know about. This is basically the kid that gets the oral commissure burn. This is the child that chews on the cord coming from the wall. And they chew through that outer coating that's protecting the wire itself, and they get a burn in the corner of the mouth. Well, why do I care? What difference does it make if they get a burn in the corner of the mouth? As long as they're okay, do I have to worry? Well, there's one extra added thing that's a problem with these kids, and you can actually feel it yourself on yourself. If you put your finger underneath your jaw at the base of your eye tooth, and you feel gently, you're going to feel your pulse. That's your inferior labial artery. That's an artery. Comes right through the same foramen as our inferior labial or infraorbital nerve. It comes through the same place. It feeds the corner of the mouth. If I have a kid who's bit that thing, and they have now basically, they've cauterized that corner of their mouth, it has an eschar that will involute over time as that thing matures. And when it falls off, it tends to open up an area that is a direct arterial pumper in there. So these kids, you don't have to admit them. We used to admit them, which is ridiculous. That takes days to happen. What you need to do is have really good, basically, advice for the family of what to do if this thing falls off and the child bleeds. Direct pressure is plenty, but bring them back to the hospital because you may need to do something like tie it off. Now, the ultimate sort of electricity from God is lightning. So lightning injury, and I'll tell you, so I was raised in Southern California. I did not see one thunderstorm my entire childhood, all the way well into my adulthood. And for the last 5 years, we're getting thunderstorms in the summer. And this is actually a thunderstorm with a death on the beach in Hermosa Beach, California. I mean, this is nutty. We had basically the same thunderstorm hit somebody over on Catalina Island who was golfing and then kill somebody on the beach. So lightning injuries are huge, massive, direct high voltage, direct current high voltage. We're talking 50,000 volts. The thing behind your house is 7,000. This is 50,000 volts. So when you get hit by lightning, it is a massive amount of electricity that goes through you. Burns are very common. Trauma is very common. And it basically hits, remember, direct high voltage current, direct currents that hit you, what happens to your heart is you go flatline. Right? You go flatline. It's a blast because if it hits, it causes this blast kind of phenomenon, so your eardrums get ruptured. It is a huge deal to get hit by lightning. It is enormous. So the burns are extensive, often a lot of tissue damage. Yesterday on a golf course, there was actually a lightning injury, but they were smart. They got under a tree, and they all got injured when the tree got hit by lightning, and they got hit by all the parts of the tree. So a lot of things can happen. You also, when you get hit by lightning, you depolarize everything in your body all at once. You depolarize everything, including your irises, and your pupils become completely unreliable for as long as 24 to 48 hours. They get completely unreliable because your iris gets paralyzed. Your diaphragm gets paralyzed, which turns out to be a problem. Because if I get hit by lightning and I have an arrest, I'm going to be flatline and my diaphragm is paralyzed. Okay, I'm out, I'm dead. But not everyone stays dead who's been hit by lightning. And what tends to happen is your heart recovers first. So they'll be flatline, and then they'll start to get a rhythm, and the heart will come back. The problem is your diaphragm doesn't. So now it's like a terrible insult to injury deal where your heart is back, but you're now hypoxic, apneic, you're not breathing, and you end up dying basically now a respiratory death. You end up dying a hypoxic death. There's a guy in one of the courses here a couple courses ago came up and told me about a priest who had been at a golf course. These happen a lot at golf courses. Had been at a golf course where several people had been hit. He happened to be at the golf course, went to give last rites to these people who had been cardiac arrest. The paramedics had the monitor on one of the guys. And he flatlined, the guy wasn't breathing, they were bagging for the guy, and the priest did the last rites thing and stood up, and the monitor went, boop, boop, boop. He's like, ooh, I'm good. But the heart's back, the lungs aren't, so you need to breathe for these people. Hypoxia is what ultimately kills them if they end up with this kind of deal. They all end up with problems down the line. Just know, they all end up a little wacky, they all end up with cataracts, they all end up a little loopy down the line. And if a woman is pregnant and she gets hit by lightning, the baby doesn't do so well. About half of them will die. Lightning injuries, when people get hit by lightning or even near lightning, the moisture on your skin, if it happens to be in your pores, which is where they happen, it's where that's where your sweat glands come in, is where your hairs are, you'll get these things, these little punctate lesions from lightning injuries. And this is somebody who actually had a hit. They got hit with lightning. So this is the burn that can happen with lightning. Now we're going to kind of switch a little bit and get into all the nasty, horrible things that evil, terrible people can do. One of which is radiation exposure. So we're going to talk a little bit about sort of weapons of mass destruction kind of deal, the first of which is radiation. I don't want you to waste any brain space on this when it comes to radiation except two concepts. One is, if you are exposed to radiation to the degree that it will kill you, fast turning over tissues are what get damaged. And what early on will tell you, you got a massive dose of radiation. So they will have desquamation. So their skin will peel. They'll get desquamation. That's the classic sort of Hiroshima picture of the girl running, with her skin basically peeling off. You'll get desquamation. You will get nausea and vomiting because your GI tract turns over really fast. So you'll get nausea and vomiting from this exposure as well. And then the other part of you that tells you you are dead is your lymphocyte count. If within basically the first 48 hours, your absolute lymphocyte count is basically under 300, no matter how you feel today, it's game over. So the only thing I want you to remember about radiation, don't waste any other brain space, is rapid turnover tissues will show you early on what's wrong. So they'll have skin peeling and GI stuff, and the lymphocyte count will give you prognosis of whether somebody's had a massive lethal exposure early on. So don't waste any other brain space on that. Chemical and biological weapons are another story, and I don't think they'll ask any questions on this, but one of the things for us in real life is that we're the canaries in the mine. Right? If there is some terrible thing that happens out there with some sort of biological chemical weapon, we are the people, pre-hospital folks, and we in the EMS system are the people that will see it as it happens and perhaps become victims to it as it gets brought to us. So let's talk about the weapons themselves and sort of the characteristics. So if I were a really bad person, oh, by the way, if you're interested in this stuff, this kind of stuff has happened a lot in the United States. Las Vegas tends to be a hotbed for this. The FBI has caught many people here with plotting to do bad things to people while they're in Vegas. There's all kinds of arrests that have happened here. In fact, I was kind of reading about it. It's fascinating. So I was up there Googling my computer, ricin, and Googling, toxins, and I kept thinking, if they're watching me, somebody may be knocking on my door any second now because I've been Googling all this stuff. But the reality is if I'm going to be an evil person, what I want to do is I want to have a toxin or an infectious organism, but a toxin that either, if I want to wipe out the whole room, I want to do it quick. And probably the quickest way to do it is neurologically, is to basically make it so you can't breathe or move, right? That'd be the quickest way to bring you all down. If I could do something that paralyzes you all right now. So that's where things like botulism come in. Botulism toxin will paralyze you all right now. If I want you to have a pulmonary death, I'm going to give you one of these organophosphates, and I'm going to drown you. I'm going to give you an organophosphate. And if it's a biologic agent, and I want to be more evil than just killing you, I want you to take it home. I want all of you flying back to all these different places in the country. I want you to take home an infectious organism that will kill you, but is also very infectious to somebody else and kill them too. So it makes sense when you think about the kinds of chemicals that get developed and the kinds of biologic agents that get developed, why they are used. It makes sense. So it all is logical. It's all these evil things. We've had it in this country and it's been big news. So anthrax, which you heard about from Stuart, anthrax, if you go to the 9/11 Memorial Museum, which is unbelievable. I highly recommend it. It's remarkable. There is a wall that they have that has basically, it's a quilt. It's this gigantic quilt that has pictures of every single victim of the 9/11 World Trade Center deal. But it also, they gave a tribute on that. This is part of that quilt, that a tribute to the 6 people who died of the anthrax, basically domestic bioterrorism event, where anthrax was mailed to Washington, D.C. to Tom Daschle's office. And 6 people ended up dying of domestic terrorism, anthrax. So it absolutely occurs, and it's occurred in this country. I am not going to spend time on anthrax because you heard about it a little bit from Stuart. You can look at this if you're interested. I am not going to spend time on plague because same thing, Stuart talked about this, and all of these are organisms that make very good sense to use as a biologic agent because they work beautifully. And the same thing with smallpox. I'm going to skip smallpox because you're going to hear about that from Peter tomorrow, so I'm going to skip that a little bit, tomorrow or the next day. I do want to spend a little bit of time on the aerosolized toxins. So this is something that Billy talked about. He didn't talk. He talked about the organophosphates. This is the botulism toxin. So botulism toxin is a very stable toxin, and it can be inhaled, and I can put it up here in the air system here. And I can blast it into this room, and you all can breathe this. And what will happen is it binds to your preganglionic neuromuscular junction, and you can no longer move. So you end up paralyzed. But all you are is paralyzed. And when you start to get paralyzed, what tends to happen first is double vision. This is the same botulism that you get with people who get wound botulism. It's similar to the way the babies present with botulism, but definitely like wound botulism. Double vision first, cranial nerve stuff, and then I can't move and I can't breathe. But none of the other, you don't get killer bees, nothing. It's not doing anything but blocking your muscles. There are other ones that are also like ricin. Ricin's been in the news. Has been used and sort of implicated in places around the world for domestic terrorism in other countries. So ricin is another one that could be used here without question. And then there's other chemical weapons that are out there. The vesicants were used in World War I primarily. Mustard, so if you go back to those World War I novels, there are descriptions of mustard gas. And mustard gas was devastating for all the troops in World War I. It's heavy, it smells terrible. It kind of just creeps around along the ground, and it goes down into where all the sort of troops were hanging out down in their bunkers down below, and it would basically cause they're called vesicants. It causes vesicles, right? Causes big blisters everywhere it touches. It blisters your eyes. It blisters your mouth, all of your skin. It was a big cause of blindness from World War I, was these, not large necrotic blisters. This is the kind of thing that wouldn't be used, I don't think, in any domestic terrorism, but there are other versions of it, things like phosgene that Billy mentioned, that you can see just out in sort of silos, etc. The nerve agents have made the news because they have definitely been used. So they were developed in World War II, and these are the things that Billy talked about with the cholinergic syndrome. These are the things that basically are cholinergic toxicity generators. So they get the killer bees, which is what kills you. You drown. You drown. But you also end up with the sludge, the diarrhea, salivation, urination, lacrimation, the whole thing. Fixable, absolutely fixable with the 2-PAM, with the atropine first and then the 2-PAM combo, the pralidoxime combo. But this is definite. This was what was used in Japan. So it was 25 years ago in Japan, in Tokyo, they released this on the subway system. And it sickened hundreds of people, and I think it killed 62 was the final count. They finally, all of the people in this particular cult were put to death about a month and a half ago. It was 25 years of this going on, but they released this in the subway in Tokyo. So this is something that can definitely happen as a domestic weapon. All right, I'm depressed. Let's skip that. Let's move on to fight bites, because we've seen a gajillion of these, right? This is the, dude, I just hit a wall. Well, if they come in looking like that, you didn't just hit a wall. I'm sorry, I did not just fall off the turnip truck. You did not just hit a wall. You have to assume that that's a fight bite, which is basically hitting somebody in the mouth. By the way, with fight bites, this is not an exam. My personal recommendation is x-ray them. I've now had no less than half a dozen, one just recently, of the fight bite that was otherwise okay, it just looked like it was infected, that had an entire tooth in there. An entire incisor, the entire tooth of the person they hit was in there. So it might be worth an x-ray just to check it out. The mammalian bite, it's all on this slide. Dog bites, cat bites, and human bites. Cat bites are not worse than dog bites. It's the same organisms. It just gets penetrated deeper because of the pointy teeth, the canine teeth of the cats. It gets it all in deeper. Pasteurella is just as common in dogs as in cats. It's just in cats it gets punctured in deeper. The worst person to bite you is a person. Okay, not a cat, not a dog, as a person. You have an organism in your mouth called Eikenella corrodens. That tells you all the garbage that happens to be in our mouth. The good news about all of these is that the treatment is the same. It's dogmentin, catmentin, humanmentin, augmentin. It's basically amoxicillin, clavulanic acid. It works for all human, it's great. It covers even the Eikenella corrodens. It's fabulous. So you don't need every single bite treated, but any bite that looks infected do. And there's a sort of, if it's a human bite and it looks remotely like it's getting infected, it's worth treating because it's devastating if you get it from a human. Now, one of the things that is kind of cool about bites, it's actually not really a bite. Cat scratch disease. It turns out it's cat scratch disease, not cat scratch fever. This is basically Bartonella. So it's an organism that cats can have in their saliva. And you do not have to be scratched to get it. All you need to have is an open sore on your own skin and touch a cat that you can pet them even. You can just pet them or have them lick your finger, and Bartonella can get in your system. And what it does is it infects there and crawls up the lymphatics of wherever it is that you get the inoculation, and it causes lymphadenopathy in the area that drains that area. So I had cat scratch disease, whatever, years ago, and I had a gigantic lemon-sized lymph node in my armpit. Gigantic. And everyone assumes that it's lymphoma, right? It's this gigantic lymph node. And if you don't have some sort of trigger to know it was a cat that did this, it doesn't have to be a scratch. Remember, it's just touching their saliva through some sort of opening in your skin that can be, and it's anywhere. I took care of a kid who was getting worked up young kid, little like 6-year-old, who was getting worked up for lymphoma because she had a big lymph node in her posterior chain. You're not supposed to get lymph nodes in your posterior chain. That's like a scary, bad thing. But it turns out that she kept talking about Snowflake. Who's Snowflake? Well, Snowflake is her new white kitten who slept on her head every night in bed. So she got her inoculum up here on her scalp. She got gigantic lymph nodes in the back of her head because that's where she had cat scratch. It was awesome. No lymphoma, cat scratch. And it goes away without treatment. It's fine. So it's just kind of a one weird thing that you may see, but it's mistaken for lymphoma. Rabies is a thing they like to ask questions on, so put an asterisk on this. A couple things they like to know is like what kind of animal causes rabies, and basically the biggest sort of worry animal in the United States is bats. Most of you who are around in areas where there are bats know this, but raccoons, fox, and skunk definitely can cause it. I live in an area where there's lots of raccoons and skunks, tons and tons, so they kind of monitor them for rabies. It is not something that we have domestically acquired cases in the United States. It is extraordinarily rare in the U.S. to have domestically acquired cases. Where they're acquired, for those of you who like to travel, so it turns out that Asia is rampant with rabies. If you work in Asia, you'll take care of patients that have rabies. It's not at all uncommon to see that. And it's because they don't immunize their dogs. And a lot of dogs are running around just everywhere. And we all love animals, right? So you go pet a dog and the little puppy nibbles on your ankle. Well, how cute was that? Except they just nibbled in some rabies into you, and now it's crawling up your nervous system. And it crawls up your nerves. It does it a centimeter a day, and it can take a while. So you may not even remember getting nibbled on by the puppy in Thailand when you start to get hypersalivation and you start to get episthetonos and you get agitated. That's the symptoms that you get when it's finally reached your brain. And once it's in your brain, it's kind of really a game over deal. What you really want to do is vaccinate. So what you're going to do is do post-exposure prophylaxis. Those of you who are around bats know you do this all the time. You're going to give basically an IV sort of immunoglobulin in combination with the actual vaccine series that starts today, and then you follow up with a couple more shots. This is worth kind of poking on, looking at this slide. They kind of like this topic. Now snakes, Billy was talking a little bit about snakes. The two big categories of snakes in the U.S. that are toxic are the rattlesnakes and the coral snakes. And the coral snakes is that red on yellow Chilophylla, red on black venom lac. So that's the sort of dictum. And those of you who live where coral snakes are aware of that. I live in rattlesnake territory. They're all over the place where I live. So rattlesnakes are interesting. So they have a thermal sensor that they'll know that you're there. They have a thermal, and like Billy was saying, they warn you. They like, dude, get away. The rattle is going, they're looking at you. They tell you to go away. Again, testosterone and alcohol tends to lead to rattlesnake bites because most people will pay attention. It's like, okay, they don't want me here. You got to stay away from the rattlesnake. I have a friend who told a story of a guy who was at his friend's house. His friend had a rattlesnake. He was drunk and he leaned over the little sort of tank that the rattlesnake, and he was basically got bitten on the tongue. Because he was look at the rattlesnake, he went, blah, 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 blah. And the rattlesnake basically came up and just bit him on the tongue. You don't want to get envenomated on your tongue. Trust me, it's not a good thing. Now, if you get bitten, 1 in 1/4, so 1 in 4, is a dry bite. So you don't always get envenomated when you get bitten. The venom, what it does to you if you do get bitten, though, is it causes local tissue destruction. So you end up with hemorrhage locally, blister formation locally, local tissue destruction, swelling, etc. And systemically, you have coagulopathies that basically develop. So you get increased prothrombin time, etc., prothrombin levels, and you end up basically with coagulopathic problems. You can have capillary leaks systemically, you can get hypotension. So if you get badly envenomated, you can have problems, but I will tell you, it is not usually lethal. It usually makes you pretty sick, but it is pretty rare to have a rattlesnake kill you. What you do for this, I used to have this kit, these like snake venom kits, because I grew up where they were all over the place, and so we had this kit. We'd go hiking carrying this kit, which had a tourniquet, and see that little thingy in the front? It's this. I love this thing. See that thing right there? That's a little suction thing. You were supposed to basically make a little cut and put a little tourniquet on, and then put the suction thing on, and use this pump and suck out all the bad venom. And or if you watch John Wayne movies, you take out your big knife and you cut across that and you suck on it. You put your mouth on there and spit out the poison because you're like John Wayne. Well, none of that works. Not one little bit of that works. Tourniquets don't work. So all sucking it out does is gives that person Eikenella from your mouth, so that doesn't work. That's no good. None of that stuff works. What they recommend you do, I love this. What they recommend you do if you're out hiking and you get bitten by a rattlesnake, what they recommend you do is, first of all, take your phone with you so people can find you. So you have your little GPS-y thing. But they say, lie still and stay calm. Really. I just got bit by a rattlesnake. I'm in the middle of flipping nowhere. You want me to stay calm? I don't know. But it makes some sense to that. Antivenom is what you're going to use if you really have a bad envenomation or a significant envenomation, which is defined by local symptomatology. So if somebody develops some ecchymosis locally, and it's usually not too long, it's usually within the first hour, they'll get something that says, oh no, they got envenomated. They'll get blistering, they'll get ecchymosis, they'll get swelling, they'll get pain. It can progress, and if there's any coagulopathy, they also need to have antivenom or any instability of their systemic effects. 2 types, you don't need to know that, just know when to give it. So antivenom works. Know that it doesn't tend to kill you, but it can make you pretty sick, and that's why the antivenom is recommended. So if they gave you this picture, would you give that person antivenom? Yeah, they have evidence of they've been envenomated enough to get bleeding, pain, and swelling. Would you give that person antivenom? Of course you would. So that's the kind of thing, they're not going to ask you how much antivenom or which one. They're going to want you to know when you actually give it, when you actually give the antivenom. Now, coral snakes are a little different. Coral snakes, it's not Apapidae, it's Elapidae, family Elapidae for this. And these bites basically are uncommon. So it's rattlesnake, 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 and then a couple, areas where there's coral snake bites, but they're not that common. They're not super aggressive. Rattlesnakes can be pretty aggressive. And this toxin isn't so much locally toxic, it's neurotoxic, and it doesn't cause problems right away. So if you get out, and it's like, I can't remember, it's red on yellow kill a but there was this red and yellow snake that bit me. I waited a second, it seemed okay. Walked a little ways, seemed okay. Went home, seemed okay. And then you end up with neurologic stuff. So down the line is when coral snake stuff causes trouble. And it can actually cause respiratory failure. It can cause basically complete respiratory failure. Altered mental status, neurologic, paresthesias, motor function problems, cranial nerve problems. It can truly cause complete respiratory failure. There is antivenom for this, but usually it's just supportive care that takes care of these folks. And again, not usually lethal unless you wait too long in these. So that's the coral snake. Spiders are everywhere, and this year they've gone crazy where I live. There's spiders everywhere, and the 2 toxic spiders we worry about are black widow and brown recluse. Black widow is everywhere. So black widow you find all across the country, and it tends to dry kind of places like wood piles. It likes that kind of place, and it is aggressive. A black widow spider will come at you. It is aggressive. It's that beautiful deep, deep black with the hourglass on her belly. That's a red hourglass. They're beautiful, but they will come at you. And when they bite you, you know you've been bitten. It hurts right away. And what's weird is it doesn't do anything right away to you, but one of the things it can do is cause what looks like a pseudoperitonitis. It causes abdominal pain, and people will get this sort of rigid belly thing where you think they have, ruptured appy or something peritoneal going on. It's basically related to the toxin. It doesn't kill you. The only people it might kill are little tiny kids, but it doesn't kill adults. It just makes you pretty miserable. And there's not a lot of great treatment for this. Pain control if they're having a lot of abdominal pain, maybe ice, maybe opioids, all this other stuff, and nobody really knows what to do. But you just support them, make them comfortable, they're okay. Brown recluse is well named. So it is a reclusive. It doesn't want to come after you. It wants to hide. It likes the same kind of places that the black widow does, but it's primarily found in the south, basically the southeast is where most of it's found. We don't usually find these in California, not up in the Pacific Northwest. You're going to see this basically in the southeast. And this spider, when it bites you, you don't know you've been bitten. It doesn't cause something right away. But what it will do over the course of hours to a day or so is you'll get this volcano-like lesion. It has this sort of necrotic thing on the top that will hollow out, and it ends up looking like a volcano. And what's happening with the toxin in your body is you're having all these hematologic things. It's sort of like the kid that gets meningococcemia and they start to basically clot off bits and pieces of their extremities like that happens with the meningococcemia. It's a similar thing with this toxin. So they get like tiny microvascular clots that go away and then bigger clots that go away, and they end up losing limbs. They can end up losing limbs on this. So if it's a brown recluse, the initial bite, you won't know you got bitten because it doesn't really hurt, but you'll see this in a little while. That thing in the middle erodes out and you end up with this called the volcano lesion. It can progress and end up with things like this, and you can end up with some basically a small vessel clotting disorders that can have you losing bits and pieces of yourself. Now, when it comes to Hymenoptera, the other kind of biting things that can happen out there, bees, wasps, and ants, the Hymenoptera group are the stinging ants, the wasp, and the bees. If you die of this, you are not dying from the toxin from what stung you. You're dying because you are allergic And a single sting can kill you because you have the whole IgE-mediated anaphylactic thing. So deaths from Hymenoptera stings are virtually always because you have an allergic reaction to that. EpiPens are what you need to be carrying around. This is usually quick within a short amount of time, sometimes really fast after the sting. And that's a true, honest-to-God anaphylactic shock. The actual bee itself, the Hymenoptera, their toxin is poisonous to you. It's just there's a little tiny, tiny bit of it, unless you happen to get into a group of Africanized honeybees that are basically pissed off. If you get stung with over 1,000 stings, which is my idea of hell, if there's like a circle of hell for like, that is just awful, this idea of 1,000 stings, that's enough toxin to actually cause some toxic problems for you, toxin problems. The Africanized honeybee is not more toxic per se, it's just matter, and it's in a gang. So it'll gang up on you, and just a whole bunch of them will sting you. We had a 94-year-old guy in Redondo Beach, where I live. He was basically knocking some stuff and trimming some trees in his yard, and he disturbed a big hive of Africanized honeybees, and he had over 1,000 stings. Poor guy, 94 years old, survived it. But that's, again, you don't die of the bee sting per se. If you have that many, theoretically, it can be lethal from the bee sting per se. So this is what that poor baby looked like. This poor guy who got stung everywhere. There's all these, and you need to pluck all of these things out. These stingers, you have to pluck them all out. This slide and the next one, these two, are summary slides for you on which kind of infections can be transmitted by either mosquitoes or ticks. If you want a summary, it's just one place. You can asterisk these two, because they tend to like questions like, a tick bites you and blah, blah. Which of the following infections could be transmitted by a tick? They may ask you, so it's something to be aware of. We're going to go to the ocean and wrap. So marine envenomations, so most of in this time in the United States, marine envenomations don't kill you. They can hurt you, but they don't tend to kill you. It's when you travel abroad that you end up with the sort of Australia, where a lot of them happen to be, or you lionfish that are down there. That's when you tend to get the envenomations that kill you. But you certainly can get boxfish, box jellyfish, which aren't very many here at all. But if that gets you, you're going to die of respiratory arrest. That's what kills you. Most of the time, though, if you happen to hit a jellyfish or you happen to hit a man-o-war while you're out swimming or in the Caribbean, what they have the reason it hurts so much is they have these, they're brilliant. If you look at them under an electron microscope, they're called nematocysts. And they look like little tiny guns. They have this pointy thing on the end that they basically deploy, and it basically shoots the toxin into you. But when you brush against it, not all of them deploy. Not all of them actually release the toxin. So you can have a bunch of these still on your skin that you haven't had the toxin get into your skin yet, which means that it's very important how you get these off. You don't want to rub, because that will just activate them. That will just basically have them release the toxin. You want to take basically your room key here or a credit card and scrape them off. You want to basically scrape these things off so that they don't release in there. Don't scrub them. What will deactivate the toxin is variable depending on what it is you get stung by, but general rules are things like vinegar might help, hot water might help. What is probably a good rule to follow is don't use fresh water, use salt water if it's something that's out of the salt, which is these are all out of salt water. But in general, these don't kill you, they're just really, really uncomfortable. Coral cuts are coral is a living creature, a beautiful, fabulous, gorgeous living creature. If you get scraped on coral, if you have a coral cut, it is highly likely to get infected. In fact, very likely to get infected. Not right away if you get a coral scrape, but if you do get some sort of coral injury, be aware that if the turn looks like it's getting infected, odds are it is. If it's itchy, use antihistamines because it can cause that. But if it looks like it's infected, it's skin flora you're going to cover for infection. Stingrays became very famous when Bill Irwin died because he had the Crocodile Dundee guy from Australia. He died because basically he got killed by a stingray. Now what's interesting is he didn't get killed by the toxin of the stingray. So stingrays themselves, in their tail, they have a toxin in their tail that they can actually whip it around and poke you, and you can get the toxin. It's really painful if you get this toxin. It causes basically like an antabuse reaction. You get flushed, you get diarrhea. It's an antabuse kind of like reaction. That's if you get envenomated. What he died of was a direct cardiac injury. That thing whipped around and took that tail and basically stabbed him in the chest. And he died from a direct cardiac, like getting stabbed in the heart injury. That's what ended up killing him from this thing. It wasn't the actual toxin itself. If you do get basically poked by, or you get poked by one of these things, you first of all have to look for, they often will break off bits of their tail. So you have to look for spiky bits in there. So you may have to x-ray or ultrasound to get it out of there. And if it's painful, you're going to soak it in super hot water. That tends to deactivate this thing, so super, super hot water. Clean it like crazy, these tend to get infected. All right, last, I think, 2 slides. Vibrio vulnificus is an organism that used to be kind of interesting and a rare thing, and it is not rare anymore. Vibrio vulnificus is seen in brackish water, so it's seen in basically where salt water and fresh water kind of blend, and it's an organism that tends to grow there, and it likes warmer water. So as things are getting warmer, we're seeing more and more. It is in areas where the water has been measurably warmer. So what's happening is it tends to be people who get cuts on their hands who work with things like shelling oysters. And it's often in people with liver disease. And what they get is necrotizing fasciitis. Raging necrotizing fasciitis. It's like, why would this person have neck fash? I mean, they just were shuck on oysters. What's up with that? Well, this course 3 years ago, we gave the course. I got an email 2 weeks after this, the last one of these 3 years ago, of a guy who said, I'd never heard of it before. I came back to work. Within days, I had this guy come in who was classic. It was exactly what you talked about at the board exam. I talked to the surgeons. They didn't know what I was talking about. I pushed, and he saved the guy's life. So no, Vibrio vulnificus is more and more. In fact, the CDC is following some cases because there are more and more of these happening. Really problematic with people with liver disease. And then the last couple weird things you can get from marine stuff. Erysipelotrix is fish handler's disease. This causes plaques on people's hands. You may see this in people that do work with fish a lot. Mycobacterium marinum, that's if you happen to have saltwater tanks at home. That's an acid-fast bacillus. It causes granulomas on your hands. And Eromonas is a freshwater thing that causes cellulitis and GI stuff. We have all the manure done. We are now going to go on to the Q&A if you want to stick around. We are a little bit ahead of time. Yay. Hopefully get you out at some decent time.
Yay!
All right.
Hi, Diane. I need to bring chairs
Hey,
up
Stuart.
there.
How are you?
Great.
There are no chairs up here?
We're going to bring some chairs up. You got both? Okay.
We'll start with cardiology. Thank you. Oh, okay. And can you move that thingy? We can't see.
Oh, the thing in front of the...
Are you going to do this off your phone? Yeah. Oh, you're so evil. I went big. But you got me all inspired. I went techno instead of paper. So I usually do this with paper, and I got all inspired with Stuart last time we did it because he did it off his phone. So I brought my iPad. We'll see how this goes. All right, guys ready? All right, let me get the thing. Do you have the thing?
No, I don't. Where's the thing?
There we go.
We need the thing.
The thing. We
The
need
thing.
the thing. Okay. A 58-year-old woman presents with sharp, non-radiating pain. She has multiple cardiac risk factors and a non-specific ECG. Her heart score is 4. Which of the following is the most reasonable course of action for evaluating ACS? Do you admit her and get her a cath? She's not that sick, right? It's sharp pain. Yeah. Do you discharge her with outpatient follow-up in 1 week? That sounds a little far. Her heart score is up a little bit. That's a little, I'm not sure that's safe. Do you get serial troponins and then basically discharge her after they're negative? No. Do you rule out the patient for an MI and then put her in OBS and get a stress test? Yes. Heart score of 4 is basically puts her in the OBS unit. You don't have to do anything crazier than that.
Ask you a quick question.
Yeah.
They never ask about the pattern of chest pain, that stuff, chest pain.
Just repeat the question.
That chest pain that's been all day, 4 days, all day.
So he's asking the question, what about the pattern of chest pain? What it's been? I've had chest pain since 1952. It hasn't changed one tiny little bit.
I mean, but I have routinely have patients that come in and they say, I'm sure. Are you sure? Are you positive? Yes, it's been there all day, all day now for 4 days.
Right. So I think the heart score trumps that. So if the heart score really is 4, and you've gotten the ACS, you really felt that ACS is something you needed to address, you were really convinced that's where you needed to go, then I think you're stuck with what the heart score
And the
is.
heart score wouldn't be 4 unless there was something on the EKG,
Right,
or
you
right.
have
So there'd be
some-
something else that
there's
would be
something
worrying
else
you
that would
other
get it
than
to
that
a 4.
history, right? Yeah,
Yeah.
totally. The history wouldn't do it, right? That history wouldn't do it.
Right.
For questions 2 and 3, we have the same question. A 45-year-old male presents with sharp chest pain and diaphoresis. He has a prior history of stroke and diabetes. An ECG obtained demonstrates ST segment elevation in V1 through V3. Which of the following ECG signs strongly suggests STEMI rather than pericarditis? So ST segment elevation is concave upwards, that sounds like pericarditis. ST segment depression in the inferior leads, that sounds like reciprocal
That's
changes. So
reciprocal, right?
that sounds like the right answer. And the other one has to do with you should see changes in the ECGs. And that 2/3 thing is interesting. That's more to do with right-sided
Right-sided
MI,
stuff.
right? Yeah.
So this is the reciprocal jazz.
Reciprocal
now the
changes.
same guy, right? The previous question, he's presumed to have a STEMI. Which of the following is the best choice of medication regimens? Now I'm going to back you up a minute, because if you look at his history, so we'll go through all of his history. He has a history of stroke and diabetes, and then he's had this chest pain. So keep that in mind when we go through the list of options here. So aspirin, clopidogrel, nitro, and TPA. Well, the first 3 maybe make some sense, but I'm not going to lice this guy. I want to
Right.
go to the cath lab. Cath lab's better for him. Aspirin, prasugrel, and enoxaparin. Ooh, I just remember there's something with prasugrel in somebody who's had a stroke. I'm not supposed to do that in somebody with a stroke, which also takes out number 4, or D, right? Takes D out, which leaves you then just with aspirin, ticagrelor, and unfractionated heparin.
Right on.
Ticagrelor.
Yeah,
Boom.
if you could pronounce it, you're good,
I
man.
just, I can't do
I can't either.
I can't
A
pronounce that one.
55-year-old male presents with chest pressure and diaphoresis and vomiting. His ECG is shown below. Which of the following is most likely? Which is the most likely artery involved in this case of ACS? So they're telling you that it's an acute coronary syndrome.
he's got
And Diane is
something
pointing
here.
out she's got depressions inferiorly.
There we go.
And what else
then,
can you show me?
Oh, something. Oops, hang on.
And then you've got
What's up
depressions.
there?
You've got and then so you've got depressions all over. And then,
Depressions are everywhere, but
right?
then
everywhere.
boom, what's
but
there?
AVR is elevated. In the scenario of acute symptoms that sound like an MI, and they're telling you ACS, and we know that that's a left main obstruction until proven otherwise. So that's
Done.
a
So
big thing.
diffuse stuff with AVR up, that's basically left.
Very
main.
important pattern.
72-year-old male presents with chest pain. ECG shows a 3rd-degree AV block and ST elevation in 2, 3, and AVF, so inferiorly. The patient is hypotensive, has JVD, and clear lungs. Which is the best treatment? So first of all, which arteries involved? 2, 3, and F? It's the right
Inferior,
coronary artery.
right
It's inferior,
coronary.
right? So it's the right coronary artery. The right coronary also perfuses the right ventricle. So that hypotension problem, maybe his right ventricle is getting infarcted. So how do I fix that? IV fluids. I fill the tank. Okay, none of the other jazz is what I do. I fill the tank.
A 56-year-old male was sent to the ED from a health fair when his BP, that's your clue right there, right? He was
Health
just
fair.
at a health fair, and his BP was noted to be elevated. His current BP is 190/115 and is asymptomatic with an otherwise normal exam. The best course of action, as you know, as we all know, is you don't go crazy, you don't start immediate lowering of the blood pressure. You can reassure that patient he can follow up with his primary care.
Done. 64-year-old patient presents with chest pain and shortness of breath. Physical exam shows JVD and RALS. He has dyspnea and a grade 5/6 holosystolic murmur radiating to the axilla. His ECG shows an acute inferior wall MI. So I've got a guy with acute MI who's basically in pulmonary edema. Chest x-ray shows that pulmonary edema. What is this patient's complication of his MI? Which of those things did he get? Did he dissect? Did he have a septal defect? Did he rupture his chorda tympani? Or did he have pericardial effusion? Yeah, he ruptured his chorda tympani, right? That's that
Tendony.
murmur.
Yeah.
Yep, or chorda
And
tendony, not timpani. Timpani, that's your ear, whatever. Okay, got it. Sorry.
You're really in trouble.
So my tongue is infarcting.
Questions 8 and 9 are the same one, same scenario. 70-year-old patient presents with shortness of breath, dyspnea on exertion, orthopnea, PND. That sounds like failure, doesn't it?
Yeah.
Symptoms have rapidly progressed over 6 hours. BP is 170/100, heart rate 89, respiratory rate 24, and his pulse ox is 93. He's got crackles on both bases. What's the best way of reducing his preload? And Amo was very good about that. Morphine is out. Nicardipine and nitroprusside are afterload reducers.
Yeah.
It's the nitroglycerin is the preload reduction.
Exactly. Now, same guy who's got acute pulmonary edema. What's the single most effective acute therapy for the patient who presented with that acute pulmonary edema? What's the most effective, single most effective? Which of those? Is it a drug or not a drug? It's not
Yeah.
a drug. It's not invasive ventilation.
Okay, this is for questions 10 and 11. A 48-year-old female with a history of pyoendocarditis requiring a valve replacement presents with fevers and a loud waxing and waning systolic murmur heard at the left lower sternal border. She admits to continued injection drug use. I mean, what are they not telling you here about this woman having endocarditis, right? This sounds like endocarditis. I'm really concerned about it. And how do I find it? Auscultation, heaven help you.
but it's an electronic.
Oh, it's electronic. Okay.
So
Well, unless it thinks for me, then it's not going to. Combination of lab tests, 2 sets of blood cultures, no way good enough. You must look at that heart valve with the transesophageal echo.
Echo. So that same patient now, which of the following is the best medication regimens for her? It's like, oh my God, I just don't remember. I know that though she might have staph, so I think Vanco's a good idea, so I'm in there. And I know that she's got a valve, and with a
Mechanical
valve,
valve.
I need to add something, that rifampin thing. So the only thing listed there that has Vanco and rifampin is C, so the cefepime must also be, again, use your logic to this, and the answer to that is C.
For questions 12 and 13, a 30-year-old previously healthy man presents with dyspnea and orthopnea. So a young guy. He's slightly febrile, and he's tachypnic, and he's tachy, and yet his pressure is on the kind of low side, right? On the chest X-ray, he's got cardiomegaly and mild evidence of CHF. Troponin is mildly elevated. What's the appropriate next test? What do you think he has?
What's wrong with him?
What's wrong with him? Young guy didn't seem to paint a picture
Big
of risk
heart,
factors. They got
never been
suddenly
sick.
a big heart and failure. We're thinking about myocarditis. We're
Right.
thinking about maybe you got a viral infection that causes. And it's really important not to take folks like that, even though they've got a positive troponin, straight to the cath lab, because he doesn't need a cath. He's got a diffuse global process in the heart. You need to look at the heart, and only if you see that it's something different than global dysfunction from myocarditis are you going to take a patient like that to the cath lab. So once that echo is done, everything follows from there.
Right, so if we have this guy, what's the most, that particular patient, what's the most important treatment? Put him on ECMO, give him steroids, intubate him, give him amiodarone, heparin, or just support him? All you can do is support him. I wish there were magic, there just isn't.
And then transplant, right, is
Yep,
the
if it's
ultimate thing
bad.
for folks like that. A patient presents with a blood pressure 260 over 150. Is that high? And ripping pain from his chest to his upper back. Does that sound like dissection? Okay, I think we got dissection here. We got a real one. Which of the following agent is the best choice for reducing this patient's blood pressure? Okay, and so we've got a bunch of agents here. And just the general principle here is that if nitroprusside is on the menu for a hypertensive emergency, that's probably what they're getting at. And the other drugs here are not IV titratable agents that are
Right.
going to intimately allow me to adjust this
His
BP.
blood pressure,
So
right.
nitroprusside is the right answer.
Right. 74-year-old male presents with an acute onset of mid-abdominal pain that radiates to the flank, and he's hypotensive. So old guy, flank pain, low blood pressure.
does that sound like?
So what does that sound like to you? That's a ruptured AAA, right? That's bad news. So what do I do? I don't want a CT. I don't want a renal. No. I need him to go to the operating room. So I'm going to call a surgeon and say, please come in and take this patient away.
A 22-year-old male college basketball player presents after a syncopal episode that occurred soon after getting out of bed. And that's important because when I think of a basketball player collapsing and a cardiac thing, I think of exertional syncope with cardiomyopathy, with a hypertrophic cardiomyopathy. And yet this is just something that happens when he's just getting out of bed. And then I look at the EKG and I see almost classic ST sloping, and she's beautiful,
little
Diane, thank
jazzy
you.
stuff
That ST segment
there.
that goes
What
down
is
with an
up with
angle. And so
that?
I know that that gentleman needs an EP study like Amal told us, and it needs an AICD if it's positive.
There we go. That's Brugada.
Oh, yeah, we didn't even say what it was. It's Brugada. Yeah, that's Brugada.
Patient presents with regular narrow complex so it's regular, it's narrow, it's a tachycardia at 150. Okay, so I know it's narrow and it's regular and it's fast. His blood pressure is fine, so there's nothing crazy I have to do, and he has a delta wave on one of his old EKGs, so he probably has WPW. So your initial reaction is to freak out, right? Oh my God, WPW, and he's fast, but he's regular and he's narrow. So, which is a reasonable treatment? Adenosine, metoprolol, procainamide, or any of those? Any of them if it's regular and it's narrow. However,
a patient presents with an irregularly irregular rhythm with QRS complexes of varying width. And this is the chaotic, scary-looking thing that Amal was describing. The ventricular rate is crazy, greater than 200, and he's got a known history of WPW. So this is basically that scary AFib with WPW, which degenerates to death if you don't fix it. And the key thing to remember is that procainamide is the only drug. I mean, the best way to treat these people is to zap them, of course. But if they ask you about a drug and they don't offer electricity, procainamide is the only drug that doesn't exacerbate the conduction through the accessory pathway.
Right.
Everything else is really going to harm this patient.
right. And if you want to just in your real life default to procainamide for either situation, you've got your bases covered. 48-year-old male with a history of cardiomyopathy presents stating he's had gradually increasing soreness at the site of that AICD that was placed 6 months ago. The site looks fine. What's the best method to evaluate if there's anything wrong with that site? So do you get blood tests? Do you get an EKG? Do you basically call in somebody to interrogate that baby, or you do ultrasound? You would do an ultrasound. You worry about a pocket infection.
That's the hot pocket, right?
The hot pocket.
Yeah. A 55-year-old female had a V-fib arrest in a restaurant. Unfortunately, on the actual test, there's no one reading.
No.
There's no one like reading over and over the clue element. Bystander and EMS interventions were successful in regaining pulses. So we've got ourselves a Roski situation, probably without Romfy because she's not responsive. So typical situation, she's intubated. Which of the following represents the best set of post-arrest goals for this patient? A, initiate hypothermia protocol, activate the cath lab only if the patient wakes up. I mean, she ain't waking up. We're going to have to take her to the cath lab without her waking up. And so this second one, B, looks like that's a good answer. I want to get her to the cath lab. And the thing here, just to back up for a second, is that if it's a fairly young person with a witness V-fib arrest, it doesn't really matter what the EKG shows. I'm going to give that woman a chance because we know that those post-arrest EKGs don't necessarily show the STEMI, even though sometimes there is a complete occlusion. And so if they look young and there's otherwise not a stage 4 cancer patient, we're going to take them to the cath lab and cool them down.
Right. Okay, so that's the end of cardiology. I think pulmonary is next. So flip to your pulmonary pages. Set up over there. Okay, here we go. Pulmonary. 75-year-old man presents with sudden onset pleuritic chest pain and shortness of breath after a 10-hour intercontinental flight. So he has what? He has a PE. I wish it were all this easy, right? He has a PE. So what do I order? What's the next test? What's the most appropriate test? A D-dimer might be helpful. A venography might be helpful. What are you going to get?
What are you going to do?
What are you going to do? You are going to get a CTPA. You don't want a dimer in this guy, right? He's too high risk. All it's going to do is lead you astray if it's negative. So
sometimes you just have to do what you know to do in real life. Yeah,
go for it.
Exactly.
And do it.
A 35-year-old woman presents with a sudden onset of dyspnea. She has a history of similar episodes corresponding to her menstrual cycle. Interesting.
Dun,
that
dun,
might be
dun.
that might be that catamenial pneumothorax we talked about. Breath sounds are diminished on the right. Heart rate 123, respirate 32. BP is low. Pulse ox is low, so she qualifies for tension pneumothorax. What do you do about tension pneumothorax? You do a CT? No. You tube them? Not if they're not while they're dying. You don't tube them. You decompress them. And so C is definitely the right answer. Thrombolytics, I don't know about that. We can't even discuss that.
No. 65-year-old male presents an exacerbation of COPD, and his ECG shows an irregular tachycardia at 130 with a normal blood pressure. When you look at that ECG, the PR intervals and P-wave morphologies are variable. So what's the most appropriate treatment for this dysrhythmia? First of all, what's the dysrhythmia? It's basically MAT, so multifocal atrial tachycardia. So how do we fix that in somebody who has lung disease? Do we give a drug? No, we actually treat the lung disease, which is the way you treat multifocal atrial tachycardia.
All right, a 64-year-old patient on dialysis presents with pneumonia. He was given levofloxacin orally at his MD's office, but he has since decompensated, necessitating hospital admission. Which additional antibiotic would be appropriate? And so this is really off that sort of tiered slide that we had with the pneumonias. So we know that this is a patient that's a dialysis patient. We know MRSA is a big concern. We had that right on the slide, and we add Vanco.
Cover MRSA. Patient with AIDS presents with a cough and fever. His CD4 count is 100. His blood pressure is lowish, 102 over 55. His respiratory rate's 24. Heart rate's 110, and he's hypoxic to 89%. His chest X-ray shows bilateral interstitial infiltrate. So what's the organism? That's pneumocystis. So if I treat pneumocystis, I know that I need to use Bactrim, so trimethoprim sulfa. So I'm good there, but do I need anything else? So is it B or C? Do I need to add prednisone? Do I need to add a steroid to this guy? Well, with that pulse ox, you do. So that pulse ox kind of clinches it for you. So your initial choice of drugs is going to be basically trimethoprim sulfa and prednisolone.
Characteristics of PCP pneumonia in patients with AIDS include which of the following features? CD4 greater than 200, au contraire, right? It's the opposite. Increased LDH. I told you they'd never give you a PC question with a normal LDH. So B looks good to me. Maculopapular rash and normal blood gases, no.
Nope. 78-year-old female presents with a cough for 4 hours after choking in a nursing home. On chest exam, there's mild wheezing and scattered rhonchi. Chest X-ray is normal. Pulse ox is fine. Which is correct? Antibiotics are indicated immediately. For somebody who might have aspirated, no, you wait. Chemical pneumonitis causes the initial symptoms. Well, that makes some sense, right? I've got acid in my stomach, all kinds of things that could do. Maybe that's it. Normal chest X-ray, if it's normal, there's no aspiration. Well, we know that's not true. It takes a while. And presentation is most consistent with PE? I don't think so. So this is basically chemical pneumonitis.
This is great. A 45-year-old male presents in January with a cough, rust-colored sputum, but they forgot to tell me that he had the single rigor that woke him up at night. So I don't know. This is strep pneumo. It's right off of our classic table.
Which of the following is true regarding tuberculosis in a patient with HIV/AIDS? The chest X-ray may be normal with a CD4 count of under 200. Well, that sounds kind of right? There's not enough CD4 count, so let's see.